You know me well. We're just going to wing it and see what happens.
Sounds like a plan. I like those plans.
Mary's laughing because she knows it's true.
And a one and a two.
Okay, we are now streaming live. So hello, everyone. I am Representative Liz Linehan, co-chair of the Committee on Children. I'd like to call this, there we go. I'd like to call this public hearing to order. Today, we are going to be hearing two bills, Senate Bill 2 and House Bill 5001. First, I'd like to start by thanking our staff who has done just a tremendous job of putting this together. It's a joint public hearing with two committees, the Public Health Committee and of course the Committee on Children. And so there was a lot of work that went into it, and the staff in many aspects are the bosses, and they have asked me to read a few things so that our participants are aware, and then we will go into welcoming remarks. So this public hearing is streamed on YouTube and CTN. As folks join the Zoom meeting to testify, our clerks will rename you with numbers and titles. Please do not make changes to the names they assign you. You will remain in a view-only mode until your turn is coming soon, when you will be promoted to a panelist. When our clerks make this change, a pop-up box will appear, and you need to accept the change in order to be able to turn on your microphone. If you do not accept the panelist notification, you will not be able to speak when called upon. Please wait until the chairs call on you to testify before unmuting yourself. If you join the meeting using a phone or iPad without a Zoom account, you will probably show up identified as your phone number or a name like iPad2 or Mike's iPad. Please correct your name in order for the clerks to recognize you from the registration list and put you in the meeting to speak. If you are promoted to panelist and leave the meeting missing your turn, you may not have the opportunity to testify again in this hearing. And after you have completed your testimony, you will be removed from the room and are invited to watch the proceedings via YouTube or CTN. And that is for our panelists. And as always, just a reminder to legislators, especially our folks on public health are used to this, but it might be new for children's. We do ask that legislators, because we have such a long day, there are over 250 people signed up, and it's important to hear from them. We are asking that legislators limit one question each and try to do your best to refrain from editorializing. With that, I am going to just give a quick welcome and say, I'm so glad to be here. This has been a work in progress for us for many months. There was a bipartisan working group to work together on 5001, and I thank that working group, and I know Representative Exum is on the line here too. I'd like to thank her for being such a great partner in this. And we're going to hear from a lot of people. And I just need to be clear, not only to my colleagues, but to everyone who is going to testify. We recognize that the bill that was put online, 5001, was a work in progress. And we look forward to hearing all of the testimony today. But certainly there are going to be things that people testify about that are actually currently in the newest draft, which is not put online. So we may be reminding you of that and hear feedback based on the newest draft that will be available to legislators soon. And I wish everybody a good day and a lot of listening. I'd like to now throw it to my amazing co-chair, who also happens to be the co-chair of Public Health, so double duty today. Senator Anwar, would you like to say hello?
Thank you. Good morning, everyone. Thank you, Madam Chair. Today, we are going to be listening to the community and the experts on SB 2 and 5001. Both these bills are a labor of love, and from all the legislators, we have put our heads together. We are showing our love and our compassion and our responsibility to for the children of Connecticut. I just want to make sure that we put the two bills in perspective. These are bills where I would, in simplistic terms, say that SB 2 is a bill that is a primary prevention bill, which means that it is going to focus on fixing aspects of our state, which are going to allow the wellness and well-being of our children and also raise healthy children in the early stages and, of course, moving forward. And then 5001, which Representative Linehan has alluded to, is a bill which is secondary prevention and tertiary prevention to look at how we can address the workforce challenges, but also look at payment-related reform and plug the holes of the continuum of care that exists in children's mental health and behavioral health issues. So we are all very excited to be here and hoping we will have constructive feedback so we can continue to improve these bills. And as we go on, there will be some questions about some of the bills we can probably clarify as they come forward. Thank you so much, Madam Chair, and we'll pass it back to you. Thank you.
Thank you very much, Senator. And normally we would ask Senator Kelly to say a few words. He will be joining us in a little bit. We just want to have everyone keep in mind that many legislators are in multiple meetings and they will be in and out throughout the day, but all written testimony is provided for every legislator to read through, and everybody's input is certainly important in this bill. Representative Steinberg, would you like to say hello?
Hello. Good morning. Very excited to finally be here today, having participated in the really remarkable efforts of so many people that Representative Linehan has alluded to. We legislators would like to believe that every bill we pass into law is important and will have a positive impact on people. I don't think there's any doubt about the legislation that you'll be hearing about today is perhaps one of the most important things we can do as legislators, particularly given all that we've learned from the pandemic about the challenges to obtaining quality children's mental health in general, and the various gaps in our shredded healthcare safety net that need to be addressed, particularly workforce issues. These bills are not finished works. They are not necessarily the end all be all. There's other legislation that will touch on this, but taken together, they offer a comprehensive approach to not only dealing with some of the short-term immediate crises we have, but to craft an entirely new paradigm for dealing with mental health in the state for the long term. At least that's our aspiration. So we're very eager to hear from everybody today. There are a lot of different perspectives. Most importantly, hearing from programs that are successful on the ground that may be things that we can look to support as we go forward. But I just want to say that this is more than a marker. This is a significant effort and a sign of our commitment to the children of the state of Connecticut that we're going to do something about the crisis we have in this state. Thank you, Madam Chair.
Thank you very much, Mr. Chairman. I really appreciate those words. Senator Wong, would you like to give some opening remarks?
Thank you, Madam Chair. I am eager to begin on this important public hearing. You can tell by the sign up that it is an it's an issue of strong interest in addressing our current mental health crisis, particularly affecting our children who have struggled for the past 2 years. This is kind of exacerbated by COVID, but it has always been an issue, and mental health parity in medical services is one that has no partisanship. So I'm glad and grateful that we're addressing it in a bipartisan House and Senate basis. So I'm eager to begin. Thank you very much, Madam Chair.
Thank you very much, Senator. I really appreciate those remarks. This has been going on for quite some time, and it's high time we get to fixing it as best we can. Senator Summers, would you like to offer some opening remarks?
Certainly. Good morning, everyone, and thank everyone who has signed up to speak today and everyone who is here at the hearing. Children's mental health is a big public health issue. It has been boiling for quite some years, and we have tried to make some intentional changes, but over the last 2 years, we have really seen the public health need come to a crisis standpoint, almost a catastrophic standpoint. And I am really eager to hear what the citizens have to say. We as legislators sometimes think we have all the great ideas, but really the ideas come from you all. And I'm really looking forward to your input. We understand that there is a lot of gaps within our continuum of care for mental health in particular. I think that some of the bills you're going to hear about today have touched on many of those issues, but it's very, very important that we hear from you. I know that I've heard from family members and mothers in particular that have struggled finding care for their children. Unfortunately, they didn't make the sign up, so I'm encouraging everybody to read the testimony that's been submitted because it's critical that we get this right. So I'm ready to get going. Thank you all for being here.
Thank you very much. And then for our final opening remarks, I'd like to ask Rep. Pettit, who has been instrumental in this process as one of the members of the working group, and we've worked very closely on this. Representative, are you with us for some opening remarks?
Yes, ma'am. I think we have a lot to go through. I hope the people that testify will make concrete suggestions so that we can take things out, add things to this bill that will make it better. And though this was precipitated by a crisis in children's mental health, this will impact mental health at all ages in terms of some of the changes it makes. So it should have a positive impact on the mental health of people from 2 to 92, so to speak. So thank you very much.
Thank you very much, sir. And also just do a quick announcement here. Representative Pettit brought it to my attention that some people are looking for the latest draft. I want to be a little bit more clear on that. It's still with LCO, so there's really nothing to share at this point. But everything that we hear today will actually be included in that, and then hopefully come out with a draft that is well-rounded after the public hearing. And with that, then I believe we shall begin. May we please have our first person coming to testify, and that would be Senator Martin Looney. Senator, are you with us?
Yes, I am, Madam Chair. Good morning. Can you hear me?
Good morning. We can. Good morning.
Excellent. Well, good morning, Representative Lenahan, Senator Anwar, Representative Steinberg, and all of the members of the Children's and Public Health Committees who are assembled here this morning to consider the important legislation, Senate Bill 2, House Bill 5001. I wanted to commend everyone who has been involved in the collaborative process to this date, working on these bills, which are critically important. We all know that children's mental health has become an accelerating crisis over the last 2 years of the pandemic. It was a pre-existing crisis, excuse me, but it is now even more urgent and has come, I think, now to the center of public attention in a way it had not come before. And I'd like to testify on Senate Bill 2, an act expanding preschool and mental and behavioral services for children. And we now are seeing escalating needs around mental health and childcare, which impact the well-being of children in our state and need to be urgently addressed. And also, we know that when children have adequate and appropriate mental health and behavioral health services, their overall mental health improves. There is a greater sense of nurturing and confidence and less fear, alarm, and sense of isolation. Last year's Senate bill working to address children's health and well-being launched a task force that worked to make recommendations on how the state can improve the lives of children overall. And are hoping that the legislation this year will implement some of those recommendations. Senate Bill 2 addresses several areas of concern, one of which is childcare. In Connecticut, we know the childcare centers are suffering. They're struggling to keep their doors open. They're losing staff to higher paying employers, and they find themselves closing classrooms that they can't afford to staff appropriately. And this hurts the children, it hurts the childcare workers, and it also hurts the parents and the guardians, of course, who are left to scramble to secure replacement services and worry about the adequacy of those services once they find them. Senate Bill 2 seeks to provide that support that child care centers need to retain staff, keep classrooms open, promote the highest quality education, and ensure that our state's child care is reliable and safe. Another area where we know our children need additional support is direct mental health care, of course. And although last year, Senate bill made some strides in improving mental health resources for our state's children, the work is not done. This year's bill adds critical measures to provide immediate relief for children and their families as they navigate mental health and behavioral health concerns. We all know that access to appropriate counseling and care for children outside of the school setting is often very difficult to do. There are not enough providers accepting insurance payments for mental health, especially that's true for children. There aren't enough child psychologists and psychologists and psychiatrists and other mental health providers who are willing to see children. Sometimes we see access now is based on wealth. There are far too many providers who only accept cash and don't accept insurance at all. And insurance reimbursements, we know, are also very, very low where they do exist. And in many cases, the providers feel that it's too much of a hassle to even accept the insurance reimbursement when it's such a small percentage of what they charge. And this is something we have to directly address. And The bill that we're looking at, Senate Bill 2, we hope it will include PsyPact language, which is an interstate compact designed to allow licensed psychologists to practice telehealth visits across state boundaries without necessitating that a practitioner become licensed in every state. And this measure will be helpful in all corners of our state, but especially in our rural communities where resources are particularly inadequate to meet increasing demands. The bill also would add a module on mental and behavioral health for certification of coaching in our state. We know that school coaches have direct and significant contact with the students whom they coach, are important figures in shaping their lives, their attitudes, their approach to life, and this will help address the needs of student athletes. Senate Bill 2, we hope will also increase funding for mobile crisis response.
Senator, I'm
Yes.
sorry, the 3 minutes is almost up. If you could summarize.
Yes, I will.
Thank you.
Which we expect that a DEMIS report from January 2022 will report on crisis response in Connecticut. And we're also looking to expand funding for youth service bureaus, of which there are 103 in the state. That's an important area of contact. And also want to launch the Children's Behavioral Health and Prevention Cabinet, which would develop a community council to put together all of the legislatively authorized bodies that advise, consult, or make decisions to the children's behavioral health system. So we also know that Senate Bill 2, and I'll summarize with this, contains a variety of services that are needed, several drug abatement recommendations, provisions to access to opioid antagonists in schools, provision for access to menstrual products in schools, funding for youth service bureaus, and it will genuinely impact the lives of our state's children by providing resources and services that are both urgent and essential. I thank you for the work that has already been put into this and look forward to the end product. Thank you so much.
Thank you very much, Senator. I appreciate your leadership on this. It's wonderful to hear us all really on the same page about what we need to do in order to protect our kids and get them the help that they need. Senator Anwar.
Thank you so much, Madam Chair. I just wanted to thank Senator Looney for making this one of his top priorities and staying on top of this bill along with Senator Duff. Both of you have shown immense leadership and guidance through the process and making this a priority. So I wanted to just personally thank you for that.
Thank you, Mr. Chair. And we know that your work has already been significant in the early shaping and mapping of the content of this bill.
Thank you. Representative Steinberg.
Thank you, Madam Chair. Mr. President Pro Tem, I want to thank you as well for your caucus's commitment to making this a priority bill. And I want to also thank you for making mention of PsyPact as one of the critical pieces. We have been looking at reciprocity across the board. And I want to assure you that we have already seen legislation coming from the governor's office, which explicitly focuses on physician reciprocity. My only concern is that we have shortages across the provider spectrum, particularly with nurses, and I hope we'll be able to find a way to deal with reciprocity issues with them as well. But again, thank you for your focus on anything we can do to improve access for young people and people of all ages in Connecticut.
Thank you, Mr. Chairman.
Thank you very much. And are there any other questions? Seeing none, thank you very much, sir. We appreciate your time.
Thank you so much, and look forward to all of the information that will be gathered as a result of this hearing today. Thank you, Madam Chair.
You're welcome, and absolutely. Thank you, sir. Next, I'd like to ask Senator Formica, followed by Senator Winfield.
Thank you and good morning.
Morning.
Senators Anwar, Kelly, Wong, and Summers, Representatives Steinberg, Lenahan, Pettit, and Dauphiné. I want to thank all of you for the opportunity to testify on this critical issue of mental health and the need to enhance access, services, and to support for Connecticut and Connecticut's children. At a time when mental health disorders are increasing at an alarming rate and the COVID-19 pandemic has worsened stressors such as social isolation, economic insecurity, anxiety, fears of infection, financial hardship, we must all act together to support all people's access to mental health, support initiatives. It's encouraging to see every caucus in the General Assembly in agreement that we must act and offer ideas to move forward. That will make for better solutions. With that, I ask the Children's Committee and Public Health Committee today, as they work together to develop the best policies to support Connecticut residents, to consider the proposals offered by Senate Republican leaders in our Better Way to a Healthy Connecticut plan to address the mental health crisis and provide support to children, mothers, families, and the mental health workforce. I believe you all have a copy of that report. We have shared a copy of our detailed proposals with the committee and stand ready to join our voice in including proposals that would focus on healthcare rather than just sick care, and to increase access to mental health care by removing barriers to early intervention, support the mental health workforce and encourage recruitment of top talent to provide quality care and meet demand, address the youth mental health crisis and help families navigate and access what can be life-saving care, improve screening and support for maternal mental health, as 1 in 7 women experience perinatal mental health complications, and it is estimated that 50% of women that are depressed remain undiagnosed during and following pregnancy. The mental health crisis we're facing today is not new, and families are struggling. I asked the committee to specifically consider the following concepts from our plan. Expand coverage for mental health care professionals. The proposal would recommend requiring state Husky program expand the professionals that qualify for reimbursement to include a licensed social worker with a master's degree who's working under the supervision of a psychologist or licensed clinical social worker. Make telehealth permanent. Support the mental health workforce by establishing a tuition reimbursement program for mental health providers who commit to practice in the state for a period of time. Mental health availability for children. This unimaginable pressure on the system and capacity issues just cannot be ignored. To address the need for acute mental health care.
Excuse me, Senator Formica, if you could please summarize. Thank you.
Thank you very much. To develop a plan to increase treatment opportunities for children suffering and involving all stakeholders in the process. Social media impact study, a family care coordinator that we think would work together with families and would be school-based. We are big proponents of school-based health centers and encourage that expansion. And then I spoke earlier about maternal mental health and doing some things there to focus on moving that issue forward. So thank you for the opportunity to address the committees this morning. And I look forward to seeing what your good work develops and being able to support this on the floor. Thank you, Madam.
Thank you. Sure. Thank you very much, Senator. And I want to actually thank you for bringing up maternal health. There was a study done about a decade ago that showed pregnant women who experience multiple bouts of short-term stress during their pregnancy are more likely to have children with schizophrenia, believe it or not. They followed a group of women who were pregnant in Canada through an ice storm, and then followed those families for years after, and found that they had those children had a higher incidence of mental illness, including schizophrenia. It's actually a fascinating read. If anyone's interested, I'd be happy to share the book. And so I appreciate you bringing that up. Senator Wong.
Madam Chair, if it's okay, I'd like to defer to the Senate Republican leader and the ranking member of the Children's, Senator Kelly, to go before me. Madam?
Absolutely. Thank you so much. Hi, Senator Kelly. Welcome.
Good morning and thank you. And thank you, Senator Formica, for presenting our better way to a healthy Connecticut. The good news here is that every caucus at the Capitol recognizes the importance of mental health, the critical need to expand the services that people so desperately need and remove impediments that are before us. And I think our plan looks at that. I think everybody's got different ideas. I think that's the best news here, is that we're coming at this all from different perspectives, but we have good ideas. Maternal mental health was just such one of those ideas that as everybody comes to the equation, they bring their perspective and sometimes new creative ideas that other caucuses haven't seen. So I do thank you for taking time to spend it with us here, Senator Formica, and for your service to the state of Connecticut on behalf of all our people. I do look forward to working across the aisle with all stakeholders to make sure we get this right. I think our people here in the state of Connecticut, particularly our children, deserve good quality and accessible mental health services. That's our goal, and I look forward to achieving it. Thank you.
Thank you, Senator.
Thank you very much, Senator, and thank you for working with us. I just love having you as our Senate ranking member on kids, so thank you so much. Back to you, Senator Wong.
Thank you, Madam Chair. Just a couple questions. I recognize that the Senate Republican Better Way has mental health, workforce development, telehealth. I think that parallels, but there's some innovative aspects of it. Obviously, the children's mental health is an important issue when 1 in 4 youth experience symptoms of depression, and 1 in 5 youth experience symptoms of anxiety. But that being said, you're also looking at mental health across all spectrums, as Representative Pettit said, from 2 to 99. Can you elaborate a little bit more about the focus of not just youth and children, even though they have been devastatingly impacted, but mental health solutions across the whole spectrum?
Well, thank you very much. I say, as I get closer, I think we could even go beyond 99 there, Senator Wong. So, but, you know, we're looking to expand access, and by increasing the opportunities for more professionals to be involved in Connecticut and service the needs of both children and people through mental health, we think that would go a long way. You know, to begin the process of having enough qualified people to manage, you know, this, or to help to manage this problem.
Thank you. And you're absolutely right. 99 and beyond. I think everyone's mental health is critical. Now, can you elaborate a little bit more on the maternal mental health, as the good Madam Chair emphasized some of the data points, but the real devastating impact that is also unsaid in regards to maternal mental health. What are some of the solutions that you're providing here and really addressing it and bringing it out to the forefront?
Well, at this point, Connecticut does not currently require education for providers for PMADs as other states do. And, you know, this proposal recommends that Connecticut require training, education, and implement successful education models that have been effective in other states. Also, it recommends that Connecticut implement a patient education system similar to what is required in New York State, in which hospitals and birthing centers provide new mothers with information after they deliver. And, you know, this is an important issue. I, as a parent of 4 children, experienced some of this. And as I welcome my new grandchild in here, I'm also being mindful of what is going on here. And I do support Representative Linehan's comment that, you know, this is an issue that we must really work hard to at least increase the awareness of.
Thank you. The last question I have is there is a part of our proposal that talks about social media impact study, the impact of social media, TikTok, Facebook, all the arrays that I'm not familiar with. Can you talk a little bit about addressing that issue in regards to the proliferation of real impact on children and just the general society of social media?
Well, we know social media is and online information, you know, has been increasingly expanded during the pandemic when people spent more time at home. This
proposal includes evaluation of the impact on social media on the mental health of students by establishing study on 2 schools that are substantially similar in student population size and makeup, where mobile phones are prohibited in one school and not in the other, just to kind of see what would happen as we evaluate and compare the number of issues experienced by students at each school and perhaps draw some conclusions. It's an important issue, and I'm not sure that the study has ever really been there and here in the state of Connecticut, and this might be an opportunity to have a good collaborative look on some of the issues here.
I appreciate that innovative thinking, because you're right. We've heard so many stories about the negative impact of social media, but we really have had no impact study or metrics to be able to measure what it's really doing in impacting people. So I appreciate the proposal in addressing that issue, at least to start thinking about it. So thank you, Senator Formica, and thank you again for the indulgence, Madam Chair.
Yes, thank you very much. And just a reminder that while this was absolutely important questioning, and we need to hear all this, that we do have over 200 people. So we want to do our best to try to limit ourselves to one question as best that we can. Senator Summers.
Yes, good morning. Thank you, Senator Formica. I just had a question, if you could expand a little bit, because I think it's an important point that we get out. On the ability to have someone with a master's degree in social work be able to be reimbursed by insurance, because they currently are not, and to allow for them under supervision to help decrease the line that we have waiting with husky patients needing clinical services, but we are not able to make their match when we have many social workers with master's degree ready to do their work under supervision, but they're not able to do that because insurance will not reimburse for their care. Could you speak to that a little bit? That would really help decrease the line that we have of children and adults waiting for services.
Well, thank you, Senator. Thank you for your good work for a long time in this capacity on health and mental health. And I think you summarized it, by asking the question. We need to increase capacity and availability of mental health treatment. And by requiring the state Husky program to expand the opportunity for professionals that qualify for reimbursement, we think that would give more people on the ground to handle more problems. And we don't think it's going to be a very expensive program, and it would remove significant barriers by adding more professionals to the process. And I thank you for your support and initiative on that.
So just one more quick question. I want to be sensitive to everybody waiting to speak, but I do think 2 other important aspects are the family coordinator that is based in the school that can help connect the acute side to what's happening in the school that could be paid for out of COVID money that we're getting here in the state of Connecticut. And also a chance to look at the Department of Public Health's decision when they open school-based health clinics. They have to have the acute side, all the medical side. And I think that we should empower them to be able to open school-based health clinics that are just behavioral health and mental health focused. Could you speak to those 2 things quickly? And then I'm done with my questions.
Well, the family care coordinator would be school-based and would work with recovery and professionals that would help navigate the system. And, we all know the school-based health centers have been very successful. And I think, most of us on this Zoom today support the expansion of school-based health centers. And so by increasing all facets of the problems that people face, both physical and emotional and mental, we will be better serving everybody in a more well-rounded way. So we think the family care coordinator is just one piece, but a very important piece that would work to support school-based issues for kids.
Thank you very much, Senator. A couple of things for you, Senator, before we let you go, is that I have received a couple of text messages asking for your plan. The members I know of the Children's Committee have not received that. And so I don't know if members of the Public Health Committee have, but if that could be sent out to everybody, I know that they would like to read that. The licensure and the reimbursement for Masters of Social Work, that actually is included in 5001. We believe, as the authors of this legislation, that was extremely important as well. And additionally, 5001 does also include the addition of a trauma coordinator through the State Department of Education, who will work to train people on trauma-informed practice, and can also actually fill the role of some care coordination if the State Department of Education feels that that is appropriate. Representative Steinberg.
Thank you, Madam Chair. Just to touch on the point you just raised, the Public Health Committee did receive a copy of the summary of the Senate Republicans' plan. Not only have we read it, we've incorporated it into some of the work we're doing. For example, we recently raised a bill to establish a working group to study the expansion of mental health resources to children. This came directly from their recommendations, and certainly has informed a lot of the thinking that we've talked about in our committee. We'll make sure the Children's Committee has that document as well.
Thank you very much, Mr. Chairman. And I see that Senator Kelly has his hand raised. Is that new? Oh, you're muted, Senator.
Thank you. Yes, I just wanted to also mention that whether members of the General Assembly or for the public at large, they can access the report online at betterwayct.com. That way, anybody that wants to read the report can do so. Thank you.
Thank you very much, Senator. And just a reminder, as we are now 40 minutes in and just on our second speaker, that we do want to try to limit one question for everyone. We have well over 200 people. We're up to over 250. We want to make sure that on a Friday evening, we don't lose people to come off. We know that everybody here wants to get their information in and out. So with that, I'd like to ask, please, Senator Winfield to come testify, followed by Mayor Bronin. Senator.
Thank you, Matt.
Thank you.
Senator Winfield, you're muted.
Senator Winfield, I'm sorry, sir, we cannot hear you. You're muted. There we go.
Oh,
thank you. If you would begin
you.
Again.
I should know better. Good morning, committee. Good morning, chairs and ranking members. I will say that despite Representative Pettit's reminder to try to bring concrete suggestions, I'm probably going to just try to remind us of not forgetting about the way this issue works in certain populations. I'll take you back to February 11th of 2018. That's the day my children were born. That day, like many people, my children were handed to me. I could not take them. The reason stems from a lot of things that happened in my childhood that happened in particular communities. And as I read both bills, which I am signed on to as a co-sponsor, I have a concern about not whether or not people have access and a lot of the stuff that the bills deal with, but issues that are, even touch on what you were talking about, Chair Linehan, the fetal reprogramming issue that happens when we think about maternal mental health. I think about epigenetics that we don't necessarily talk about. I think about the types of trauma that show in certain communities, and whether or not, even if we build a system as we're talking about, it will actually be responsive to the issues of particular communities. And I know that this is a great opportunity, and I want us to be very much aware that though we might be dealing with trauma, we might not be dealing with trauma in a way that's going to be giving us the best outcomes for all communities. And that is of extreme importance to me. When we talk about issues like Senator Moore has been talking about a lot in the last year of gun violence, for instance, right? Part of why you're seeing that is because of the way that trauma manifests itself in certain communities. And so when we say this is not a crisis because it's been ongoing, it's more than that. For some communities, it's just normal to have mental health issues. It's just normal for us to pass trauma along. And yet the science and the way that we operate has been slow to actually recognize. I mean, those schools that we send kids to that are supposed to be as safe as their communities are not as safe because we send kids into schools where many of their peers have the same trauma that they have, where they return home or go to school, and whichever place they go, it's there. It's complex. It doesn't end. And the types of responses we have aren't always able to deal with that. And so I'm just here to admonish us to remember that as we're doing this, there are communities that will not respond to what we think of as the normal issue of trauma, because that's about an event or an instance. And what there is trauma that persists for life. I also want to say thank you to everybody who's worked on this stuff, because it's critical. I want to give a special shout out to Rep. Exum, who's been talking to me, because I can ask a lot of questions and she's been very patient. And I will, as you know, if you know me, I will be very much a part of sticking my nose in where it kind of belongs, but not directly. I will stop there. I know we have a lot of people. I just wanted to remind us that good solutions that will touch a lot of people don't always touch the people who may have these issues every single day, no matter what we're doing. So there you go.
Senator Winfield, thank you so much for your testimony. And I want you to know that over the years, I've heard you on that. And so I've brought that with me through the Children's Committee for the past few years. And one of those things has manifested itself in 5001, where we're looking at the great work that you, I believe, have done regarding truancy. And that you made sure that truancy was not a crime, and that any child who is truant hit that truant threshold and went to the youth service bureaus instead. This bill actually moves that one step forward. And what we are looking to do now is anytime a child is hitting that truancy mark, that number of days absent per week, per month, whatever that is, that instead of just sending them off to the youth service bureau and assuming it is a behavioral issue, instead now through this legislation, we are saying that when that happens, you automatically have to have a school counselor, a school psychologist, or a school social worker sit with that child and the family. And from there, you need to determine, is this indeed a behavioral issue that needs to go to a certain set of clinicians, or is it a true mental health issue that needs to go into greater care and make a better referral? So instead of just automatically sending them in one direction, we are now making sure that we are getting closer to what the issue is so we can find that child help. We have said consistently through this process, both Senator Anwar and I have been kind of, I say, screaming at the top of our lungs that school refusal is much different than just deciding not to show up for school that day because it's a behavior issue. And school refusal is one of the very first signs of trauma in a child. And so we are looking to get to that by ensuring that anybody, any child who is school maybe truancy actually gets quick help and in the correct manner. And so I hope that that goes towards part of what you're talking about, Senator. Do you feel that that might be at least getting towards the mark?
Yeah, I just want to say really quickly, what I'm saying here is not to suggest that the bill doesn't do any of what we need, right? From my perspective. I read both bills and I think they are great. It's the reason I'm signed on. I'm just here to say that the manner of treatment is not always the way that we normally treat it. It's like anything else. When race or ethnicity is implicated, there are policy prescriptions that have made dealing with the issues of those particular communities different than the model we use. And so I just want to remind us of that to make sure that as we move forward, we are thinking about it and it gets put into the policy that the state of Connecticut has, because it would be a tragedy to be here with this opportunity to finish. And if those same communities are sitting there saying, we have all of this access now, but I can't get out of that system what I need.
Right, and thank you for that, Senator. And we will very much appreciate your ongoing input and looking at what we're doing and making sure that we're on the right track. So it's not sticking your nose in it. It's actually really, your input is extremely important to us. So thank you very much. Senator Anwar.
Thank you so much, Madam Chair. Thank you, Senator Winfield, for this important part. We have looked at data, and then there's a lot of scientific information about the generational trauma from the Holocaust survivors and their families. And there is clearly insight into the trauma survivors and the next generations. And it sort of continues on, as you alluded to, in epigenetics. And geneticists have started to look at this. And from a practical point of view, you're absolutely right. I think that the social workers, physicians, entire spectrum of care for children's care and behavioral health need to have this insight to understand that what they may be dealing with may not necessarily be the immediate experience of that child, but would experience of their generations before. And this is something that hopefully we'll learn more in the coming years, because science is now moving in that direction, but at least we can't wait to put love, care, and compassion and understanding for our children going forward. So very insightful and very, very useful. Both you and Senator Moore are just amazing to ensure that we remain focused on some of these aspects. Thank you again.
Thank you.
Are there any other questions? Seeing none. Thank you, Senator. We appreciate your time and your input.
Have a great day.
You as well. Next, we have Mayor Bronin. Mayor, are you with us?
I am. Thank you very much, Representative Linehan, and thank you to you and your fellow co-chairs of the joint committees for the opportunity to testify today. I first just want to commend the committees for their work on these proposed bills. These are well-considered, well-designed bills that will make a huge difference, and I'm deeply grateful on behalf of the City of Hartford, deeply grateful for your work. I wanted to highlight three areas where I hope that the committees together might consider making additions to the bills that are under consideration. I think these bills do an extraordinary amount to increase and improve mental health supports in the school system and in other institutional settings. Those supports are desperately needed. It is also important, I think, to recognize that some of the highest need youth are not sufficiently connected to those institutions, including schools. And in particular, want to focus on the need to invest more resources and more focus on mental health needs of young people who are justice involved. We often talk about that need in the context of the criminal justice system. I think it's appropriate to talk about that need in the context of a broader bill tackling mental health crisis in our state. When a young person is engaged in criminal activity, it is very often a manifestation of deep unmet mental or behavioral health needs, exposure to repeat trauma. We know from numerous studies that the number of adverse child experiences for those who engage in criminal activity is off the charts. And we know from studies that have done, including by the Office of Child Advocate, that many of the young people who are justice involved or are in detention centers have themselves expressed an urgent need for treatment and trauma-informed care. So the first request is that as part of this bill to tackle mental health, that the committee resource a much stronger effort inside youth detention centers, including Manson and York, to fund comprehensive mental health supports. The second is to recognize that when those young people are not in detention, that they are still in need of coordinated, comprehensive support. And that support, in theory, should be coordinated by the youth service bureaus and by the juvenile review boards. Unfortunately, those entities are inadequately resourced. As an example, the Youth Service Bureau in Hartford, which a few years ago assumed responsibility for truancy response from DCF, is funded only with $150,000 of state funding. So substantial responsibility was transferred to local youth service bureaus without the resources to do that care coordination. The same may be said of juvenile review boards, which play a vital role in connecting young people who are desperately in need of that care to that coordinated care. And finally, believe that there are models such as Hartford's Youth Service Corps that demonstrate an effective means of connecting young people, including juvenile justice involved, DCF involved, and homeless and truant youth, to not just mental health and coaching support, but also a path to see a career and a plan in front of them. And we would ask that the committee strongly consider substantially increasing funding to youth employment programs that are not geared just at a summer job, but at that foundational skill building, trauma-informed support that I'd be happy to talk more about our Youth Service Corps and how that delivers that. But we think that would be an appropriate mechanism to replicate statewide and to expand here in our city. Grateful again for the chance to testify and happy to talk in more detail about any of those suggestions. But thank you again for the tremendous work that the committees have done.
Thank you very much, Mr. Mayor. We appreciate you taking some time to come here today. I just want to point out that our Representative Exum has recently brought up the issue of trauma and mental health care in the Department of Corrections, and we will absolutely be working on that moving forward. We have a question for you, it seems, with Representative McCarty. Hi, Representative.
Hi, good morning. Thank you, Mayor, for being here this morning to offering your testimony. And I really appreciated your remarks. I want you to know that. But did you submit to the committee the program on the Hartford Youth Services so we can see it in greater detail?
Thanks very much, Representative. I will submit a written testimony today. I have not yet submitted the written testimony, and I'd be happy to include as an addendum to that detail on the Youth Service Corps and how it works.
Thank you very much. Thank you.
Thank you, Representative. Are there any other questions? Seeing none, thank you very much, Mr. Mayor.
Thank you very much.
Thank you. Next, I'd like to ask, please, for Mayor Simmons to join us.
Good morning, everyone. Good morning, co-chairs, ranking members of the Public Health and Children's Committees. Wonderful to see you all virtually. Miss getting to be with you on Hartford, but great to see you virtually today. My name is Caroline Simmons. I am the mayor of the city of Stamford, and I'm here to testify in strong support of House Bill 5001, an act concerning children's mental health. I'm here today in full support of this bill because, unfortunately, as we all know, we are in a mental health crisis. 1 in 6 Connecticut youth experience a mental health disorder every year, and these statistics were pre-pandemic. We all know that this pandemic has only exacerbated the mental health challenges that already existed. And while fortunately we're finally turning a corner coming out of this pandemic, we cannot ignore the long-term impact that COVID on our children, physically, mentally, and emotionally. That is why I'm here today to testify in strong support of this bill that would bring critical mental health resources to youth and children across our state, and want to thank the Public Health and Children's Committees for leading on this important initiative. Every day as mayor, I hear from residents in Stamford about mental health challenges. I hear from parents, I hear from students, teachers, nonprofit leaders, and community providers across our city. That is why over the past several weeks, we have launched several efforts, including the creation of Mental Health Resource Hub, with tools and resources to support those in crisis in our community. And we are also forming a Stamford Youth Mental Health Alliance, a coordinated effort that will engage municipal leaders, Stamford Public Schools, community service providers, and the broader population to increase awareness and response to the mental health crisis, with an emphasis on service, care coordination, prevention, and early intervention. I'm proud to support HB 5001 today because this would support collective work of municipalities across our state towards addressing this issue in a comprehensive way. By streamlining the process and eliminating barriers to hire more mental health professionals, we can begin to address the shortage of mental health professionals in our state. And I applaud these committees for incorporating innovative ways to recruit and retain the current mental health professional workforce, including the scholarship program for applicants for licensing, the Mental Health Care Provider Loan Forgiveness Program, and the Child Psychiatrist Grant Program. We need this multi-pronged comprehensive approach to improving the behavioral health system for children, and I believe this bipartisan bill takes great steps towards achieving this goal. I urge the committee to support HB 5001 so we can improve the lives of children across our state. And thank you for the opportunity to testify today.
Thank you very much, Madam Mayor. It's really fantastic to see you here and to hear all the great things that you're doing in the city of Stamford. I will say I am not surprised because I know you well, and it's obvious you're doing a great job. So thank you very much, Madam Mayor. Are there any questions? Seeing none, because you were so comprehensive, I think that's all. But thank you very much, Mayor, and it's really great to see you.
Thank you, Madam Chair. Wonderful to see you.
It's so nice to have old friends come back. I would like to ask, please, for Frank Fortunati, followed by Commissioner Durantes.
Good morning. Thank you, Representative Linehan and Representative Steinberg, Senator Anwar, and to my own representative, Representative Kennedy. My name is Frank Fortunati. I'm the Deputy Chair of Psychiatry for the New Haven Health System. I'm also a child and adolescent psychiatrist, and I've been practicing in Connecticut for some 20 years, and I'm happy to speak with you today on behalf of the Yale New Haven Health System in support of House Bill 5001, and like others, applaud the committee members for taking such a strong interest in improving children's behavioral health in our state. I have submitted testimony, and I will summarize as best as I can. Throughout our health system, our emergency departments from Greenwich through New London are frequently filled with children and adolescents who are brought to us by caregivers and others for acute evaluations. In most cases, these patients do not require inpatient hospitalization, but their stay with us is longer in the emergency department than necessary because frequently outpatient services are not immediately available. Other times they need more acute outpatient services or more intensive outpatient services, perhaps things like PRTF, psychiatric residential treatment, or intensive outpatient programs that are also not available. And then only about a third of those who actually come to the emergency department are assessed as needing inpatient hospitalization, but they end up waiting sometimes for days to be hospitalized because an inpatient bed is not immediately available, often because those who are in the inpatient units are waiting another step down level of care. Last year, there was about 900 additional days that children alone spent on our psychiatric units because they were cleared for discharge, but waiting for a lower level of care that was not immediately available. And this continues throughout the year. It's not just during COVID or during Omicron, as I know all of you know. House Bill 5001 is intended to improve the gaps in available mental health services for children. And I'm especially appreciative of the inclusion of the reimbursement for collaborative care management codes, providing reimbursement for the collaborative care model, which is an evidence-based model for treating anxiety and depression in the primary care setting, we think will help a great deal. We're appreciative of the workforce initiatives, sections 5, 45, and 46, offering assistance to bring more folks into the workforce. Though we feel we must also examine and look at improvement for reimbursement for behavioral health services. Improvement for reimbursement will help attract people to the behavioral health field in the first place. Additionally, we urge you to increase investments in existing community and hospital-based outpatient services to help build capacity and help manage the long wait list for these crucial services. We also urge you to expand in-home respite care services. Section 44 of the bill requires DCF to establish an in-home respite care program for parents and guardians with behavioral health needs.
Excuse me, Mr. Fortunati, the 3 minutes is almost up. If you would summarize. Thank you.
Just another point, and thank you very much. We urge for the state to provide in-home respite services of the families, also for geriatric patients as well. But as you deliberate over these proposals, we'd like to emphasize the importance of investing first in existing community and hospital-based outpatient behavioral health services. Our children and families need immediate access to these services. Thank you for your time and consideration. I'm happy to answer questions if anyone has any.
Thank you very much, Dr. Fortunati. It has been, we're really focused, as you can tell in this bill, on those programs that you're talking about, especially in intensive outpatient programs and partial hospitalization programs and other programs meant to keep children at home while helping them heal. I think that there is a misconception out in the public regarding inpatient hospitalization, and that I think people who maybe don't know about it believe that it's a lot like going to the hospital for surgery and then you're healed for the surgery and then you come home to convalesce. And inpatient, as you know, sir, is not like that. It is a stabilization method. So I appreciate your testimony about strengthening those the intensive outpatient programs, because I believe that that is where we're really going to see the most help for people. So I do appreciate you mentioning that. I think especially coming from you, that's going to strengthen what we've been saying all along. And is there anything, just very briefly, is there anything that you felt that we've missed regarding strengthening IOPs and PHPs? Is there anything that you think needs to be thrown in there that you don't see?
Well, I do think, and this is going to sound odd coming from someone who's representing the hospital system, but reimbursement is critical. This past year, in New Haven alone, we lost 5 very experienced LCSWs skilled in dialectical behavioral therapy, DBT training, to school systems. And while it's great to try and license and get reimbursement for MSWs, so folks earlier in their career, it takes a while to build the skills that are needed to work with some of the individuals that we're seeing on an outpatient in an outpatient setting. And I think that's, we need to retain folks who we've taken years to train and have become quite good. The social workers we've lost are excellent, but they were essentially becoming burned out and attracted to better salaries and summers off. And we need to do more to retain folks like that.
Thank you very much for your input. We have some questions. Representative Pettit.
Thank you, Dr. Fortunati. My question revolves around the issues of your perspective on whether our bigger problems are supply of mental health providers versus network adequacy. There's not adequate people in certain plans to do the care, or whether it all relates back to reimbursement. So overall supply, network adequacy, and reimbursement. Thank you.
It's a great question, Representative Pettit. In my opinion, it relates back to reimbursements. I had a private practice for years, and in my private practice, I did not accept insurance, and now it's the reimbursement is just not adequate frequently to allow folks to accept insurance more widely. And I know, I have one patient who I just recently, who I've had since he was 5. He's now 23. I'm trying to help him find another provider now as I'm stepping out of that. He could call his provider network, and the person I referred him to, the insurance company said, "Oh, he's not in panel." But I spoke to that person. He said, "Yes, I am, paneled with that insurance company." So, there is issues with the provider networks for sure, but I think it does goes into reimbursement. And a point I've made as a father with young kids, who are now in their young 20s, but when looking at careers and what to go into, when you look at what an LCSW can actually earn and try and survive now in the state of Connecticut, it's, and the amount of skill it takes to do what they do, I think reimbursement plays a large role. I think we're not incentivizing our young folks to go into psychology and social work roles in the state. And for me, it comes back to reimbursement.
So to flip it, a quick follow-up is, if we improve reimbursement, do you think there would not be a supply issue? Or do you think a supply provider issue would still remain?
I think it would remain for some time, but I think eventually it would improve. I think it's, we have a lot of catch up to do, but I think eventually it would improve.
Thank you. Thank you, Madam Chair.
Thank you very much. And just a reminder that there is a provision in 5001 that looks at reimbursement and how we can move forward with that in a way that is practical and gets to the end result. It's one of those long-term priorities. Senator Anwar.
Thank you so much, Madam Chair. Thank you, Dr. Fortunati, for the work that you do. My question is, let's say that the workforce issues are addressed, and do we have enough beds and the geographic distribution of those beds? Because the hospitals will still need some beds from the increasing in the severity that has been seen. I know we're trying to plug all the holes, and if we fix all of those, there are some voices that have suggested that we'll still need 30 or so beds across the state, and then right now the other is that they are at the larger hospitals. We need geographic distribution to spread it around. Any thoughts on that?
In my opinion, I think you're right, Senator Anwar. I think we do need more beds. The exact number, I do not know. 30, sounds perhaps about right for children and adolescents. Maybe not quite that much. But I do think we need more beds. What we've done at Yale New Haven is we've flexed our beds with our young adult unit and our adolescent unit, so that some of the older teenagers might be able, 16, 17 years old, could be on a unit with young adults, 18, 19, 20 years of age, so that we can have more adolescents to come in, and that worked for us for a few years back in 2016 and 2017. It's no longer working for us, and we still have kids who wait. So I do think we need more beds. One of the issues, though, with geographic distribution is that we also need expertise, and Connecticut geographically is not such a large state that to travel a bit. I know it might be a hardship for families at sometimes, but you also you need expertise, and you want an experienced child and adolescent psychiatrist working with. If it was my kid, I would want an experienced child and adolescent psychiatrist working with them, and it might be hard to provide that in all areas of the state. We're not such a large state that I think we could have relative geographic distribution, but not necessarily in every locality or every corner of the state.
Thank you so much. Thank you, Madam.
Thank you, Senator. Representative Steinberg.
I believe Representative Kennedy had her hand raised first.
Oh, I'm so sorry. On my screen, it looks like it's not even there. So I apologize. We'll go to Representative Kennedy.
Thank you, Madam Chair, and thank you, Chairman Steinberg as well. I just wanted to say a quick hello to Frank. Thank you so much for your testimony, for your insightful thoughts. Really appreciate you being here today.
Thank you, Representative Kennedy.
Thank you. And again, I apologize for that, Representative. With your light background, I just couldn't see the hand. Representative Steinberg.
Thank you. Yeah, it happens. So it's going to be a long day. I wanted to follow up on the line of questioning Representative Pettit started with you with regard to the number of beds. We've had some conversations with the Office of Health Strategy, who states that the general impression is that we are overbedded in the state of Connecticut, and that there have not been any requests from any of the hospitals for expansion of the number of beds that they would use in this area. Yes, as you described, switching in and out beds that are staffed appropriately for mental health happens in the system. But there seems to be a disconnect between what I've heard you and others state and what OHS's experience has been in terms of requests for additional beds. Could you comment on that?
Yes, Senator Representative Steinberg. If I could be blunt, to expand a mental health bed, a behavioral, a psychiatric bed that meets the standards that we need it to meet to make sure it's ligature resistant and safe, costs approximately $125,000 per bed. The Commonwealth of Massachusetts recently did address this and their shortage by providing hospitals with the capital that's required to expand and to cover that cost. If we were to try and take an existing medical surgical bed and convert it to a psychiatric bed, it would cost approximately $125,000 per bed. And so that's a huge ask. And with reimbursement, there's not, it's not viable. It's not feasible. So that's perhaps, I would suggest, perhaps that's why there's no request coming through to expand the number of psychiatric beds.
Thank you for that. I just want to make sure that's what I had heard from you. This is really a matter of the cost of maintaining such beds rather than anything related to certificate need at this point of time. But to your point, the order of magnitude of maintaining such a bed is significant and a burden on our institutions. So thank you for that clarification. Thank you, Madam Chair.
Thank you very much, Representative. And are there any further questions? Seeing none, thank you very much, sir. We appreciate your time and your input.
Thank you.
Now I'd like to call, please, Commissioner Durantes of the Department of Children and Families. Commissioner.
Thank you very much, Representative Linehan. Senator Anwar, Senator Kelly, Representative Dauphiné, Senator Wong, Representative Steinberg, Senator Summers, and Representative Pettit, and distinguished members of both the Committee on Children and the Public Health Committee. I'm Vanessa Durantes, the Commissioner of the Connecticut Department of Children and Families, and I thank both committees for the opportunity to comment on HB 5001 and Senate Bill 2. The COVID pandemic has exacerbated what we know as an emerging behavioral health crisis in children. Isolation, disruption in learning, family stress, reduced economic stability, food and housing insecurity, and the lack of access to timely community-based supports has resulted in a demand for services that have exceeded the workforce capacity. In the interest of time, my testimony has been submitted in writing, but I will summarize some of the highlighted portions to leave time for questions. During this time, we have established a dashboard that creates real-time daily capacity of mental health inpatient beds across the state. We have expanded care coordination services to connect families to community supports and alleviate their need for emergency department intervention. We have awarded grants to offer 24/7 mobile psych intervention across statewide boundaries, and we published a resource guide for families to detail services available to them by region and how to connect with them using the connectingtocare.org site. The Department of Children and Families is statutorily mandated as the lead agency for behavioral health services in Connecticut, and the department also provides the coordinated oversight and funding for a broad array of community-based mental health services designed to assist children, youth, and their families with a large array of psychiatric and substance use disorders. The administration of these programs and support of these services has been guided by the Connecticut Children's Behavioral Health Plan, which the department developed in 2014 in consultation with providers, advocates, and families with lived expertise. The governor has proposed several bold investments in children's behavioral health, many of which are included in or complementary as provisions of HB 5001. Building upon funding allocation and the adopted fiscal year, the biennial budget and the proposed budget of 2023, the budget includes approximately $26 million in additional funding that will allow for 4 urgent care centers and 4 subacute crisis stabilization centers to be established. The governor's proposed budget also increases the 24/7 mobile crisis intervention services. Crisis supports to schools and police departments are also included in that expansion. We also recommend evidence-based prevention services and the Connecticut Family First Prevention Plan as it is imminently being approved. Operationalizing the vision of this legislation and the success of this work will be grounded in well-trained and a sustainable workforce, which we've heard a lot about today. The governor's budget proposes enhanced funding to build the healthcare workplace pipeline. Under the Office of Workforce Strategy, another $20 million is recommended for scholarship for in-demand programs of the healthcare field, and $35 million is proposed to support faculty recruitment for such programs. It's also critical.
Excuse me, Commissioner Durantes, your time is almost up. If you would summarize. Thank you.
Absolutely. So if I look to summarize, also HB2, the workforce incentive found in sections 1 through 3 include the waiver process, requiring careful discussion and consideration. Section 9, DCF oversees the access mental health, and we're looking to be included in any discussions of expansion of that. DCF would also like to be included in the development of policies and procedures and standards for mental or behavioral health calls made to 911. And also the respite issue that was mentioned earlier is a commonly raised discussion for families across our state. We'd like to be a part of the discussion related to that. And thank you for the opportunity to just kind of pull together these collective efforts for allowing us to present to you today. And I also would just like to thank all of the forums that were held ahead of time to really get to the crux of the children's behavioral health crisis and working in a bipartisan effort to be able to stabilize families. Thank you.
Thank you very much, Commissioner. And, I'd like to extend that thanks to you as well. What some people may not recognize if they're not on the Children's Committee, and since this is a joint hearing, we've been working together for a long time on this, and a lot of these proposals, you absolutely have had input and helped us shape it, and we look forward to continuing that. I do have I know that a bunch of my colleagues are going to have questions, so I'm not going to belabor everything. I just want to ask you to specifically focus for a moment on these walk-in urgent care centers and subacute stabilization care. We have heard, and I think that the general refrain is that we need more beds, we need more beds, we need more beds. And we've heard that there are some problems, there's some expenses with that. But the truth of the matter is that you've been working on that for a while now. And I think it's important for not only my colleagues to hear about what's in the pipeline, but also for the people watching at home, if you can tell us what DCF has on tap and what your timeline is for that.
Absolutely, Representative Lenny, and thank you for the question. So what you're referring to is the urgent crisis centers and then the accompanying crisis stabilization beds. So we have looked up across the service array, looking to fill those gaps that you heard many of the folks that preceded me in testimony talk about. In our effort to really right size or use underutilized capacity within the system and increase capacity to assess children that have more of an acute need. We looked across the country and saw the service type of an urgent care. So what you will hear is the urban crisis centers being piloted, first with 1 unit, and then the governor's budget includes the funding for 4 additional units, or 3 additional units. And what that is meant to do is not only divert children from going to the emergency room in the first place, but also act as a place where families can go in their communities to get the type of acute care that they need. So I have members of my team here that can talk about the timeline, but I wanted to be able to describe what that urgent crisis center model looks like.
Right, and if you could call up the members of your team, I think that this is really important because we're going to have a lot of legislators asking if we could particularly put funding in for beds, and so I want to go to that point of beds, right? So when we hear beds, we think long-term. And again, like I had mentioned earlier to Dr. Fortunati, there is also some confusion that inpatient hospitalization sometimes is believed to be a cure when in fact it's not. It's also a stabilization, and the real work begins at home. And so if you could, I don't know who you would like to ask, but if someone could tell us where the additional centers are going to be located, so that hopefully it answers the question of whether or not it's going to be accessible across the state, and then again for the timeline.
Certainly. And so there's 2 questions in that, what I just heard you say. And the first I would defer to Commissioner Gifford related to the inpatient bed capacity and what we've been able to do related to that. Commissioner Gifford is also on and can speak to that. I don't know if she's been made a panelist yet, but in the interest of time, if she hasn't, she can speak to.
I think we have her next, Commissioner, and we'll ask that, but I'm specifically talking about the urgent care centers that are under DCF.
Certainly. So the first one is being developed, and the RFP has not been put out yet in terms of where it will be located. But one of the part of the questions that we have been fielding is really trying to have the proximity of those to a hospital that treats children and their emergency needs in those specific communities. But because the RFP has not been distributed yet, it's hard to kind of speak to the exact geographic location so as not to influence that procurement improperly.
But the idea is that this needs to be accessible to everyone around the state. And I just, and if you could just clarify for everyone that these are not centers that are specifically for children under DCF care. This is for children out in the community. It's community-based. It's anybody who needs it, correct?
Absolutely. Right.
Great. Thank you very much. And I will now ask some of my colleagues to ask questions. And we're going to start with Senator Anwar.
Thank you. Hello, Senator.
Thank you so much. Thank you, Commissioner, for all the work you and your team do, especially in the last 2 years. You have been doing God's work. So thank you for all of that. And also thank you for helping us through the various challenging parts of the current bills. Commissioner, the question I wanted to ask you was, is there a way to access data about the various places where there are waiting lists and based on not only Medicaid, but also different insurances. So there is some transparency and direct dashboard based information to see what's missing, what's not, and then can that be publicly available? So we can have a feedback loop and have a mechanism to address that. Any opportunity for that?
Yes, sir. So throughout the crisis, through collaboration with the other health and human service state agencies, as well as the Connecticut Hospital Association, we have stood up the dashboard to really understand what is the utilization during those surges in the fall and the spring. And part of the proposal in the governor's budget is to make such data available that's public facing in a way that de-identifies particular children, of course, but that data in terms of being collected right now is something that we have been doing now for probably about 2 or 3 months to be able to really refine and get that data to an accurate way. And then the next iteration of that should be public facing.
Thank you so much. Thank you, Madam Chair.
Thank you, Senator. Representative Exum.
Good morning. Thank you so much, Madam Chair. Good morning, Commissioner. Good to see you.
Good morning. Likewise.
I just would like to ask a question. Earlier, we've had a couple of times come up issues around trauma. And I understand the DCF has an urban trauma program, but I don't know a lot about it. So if you could please give us a little bit more information about that, I'd appreciate it.
Thank you, Representative Exum, and thank you to Senator Whitfield for raising a very important point that my team, particularly my clinical team, has been working on for quite some time. And that is this understanding of, internalized behaviors with children that sometimes manifest as suicidality and externalized behaviors that sometimes will show up as delinquency. We recognize that the children's behavioral health crisis is an opportunity for us as Connecticut to address the full spectrum of children's behavioral health needs and where trauma fits along that continuum. So there are family crises that we know that have a root of trauma. And then we also know from a systems perspective that there's community or racialized trauma. And we have partnered with an exciting initiative related to urban trauma that I believe will speak to exactly what Senator Winfield was talking about. And I'd like to call on Deputy Commissioner Michael Williams to talk about that particular model from DCF's perspective and what we foresee happening with that. Deputy Commissioner Williams.
Thank you, Commissioner, and good morning, everyone. We're very excited to now have implemented a performance improvement center out of New Haven through the Urban Trauma Institute, which is an exciting group of folks who have brought to Connecticut. It's not evidence-based yet, but it's definitely on its way, an approach to intervene in communities and have a treatment intervention solely based on urban trauma. They have developed the model and they will be implementing the model. They will develop our network, and we're targeting communities where trauma exists more than others to stand up treatment providers who will work with this model and deliver these clinical services based on the urban treatment model. Tim Marshall, who's our mental health leader in DCF, is responsible for the implementation, and he's on now, so he can tell you where we are by way of implementation. Tim?
Yes, good morning. We are very close to going to procurement for a number of the urban centers in Connecticut for purchasing the service embedded in agencies that exist in those urban settings now. And so we will be going to procurement very soon.
Thanks.
Thank you very much. And
Thank you for the question.
Thank you very much.
Thank you, Representative. It should be noted that Representative Exum has done such an amazing amount of work on this bill. And so I'd like to just take a second, Representative Exum, to thank you for your time, your service, and really just for being you. Next up, Representative Zupkis, you had your hand up and now you no longer do. Would you like to speak? You're all set?
Yes, no, I'm not. Thank you. I don't know
Okay.
how it went down. Thank you, Madam Chair. I have quite a few questions, but I will keep it to one. I do thank you for what you're doing. We all know that mental health is a huge issue. I think it has been for a long time, not just in children, but in adults. And so thank you for doing what you're doing. But my question is, as I go through, I'm not sure that I have the latest version, but the language that I have, how many additional staff, if any, are you going to need to implement these programs?
So each one of the service types that was mentioned has a very specific calculation related to FTEs or full-time expenditures for each of those. And so we are trying to be very thoughtful along the service continuum, understanding the workforce crisis that cuts across a lot of the functions that we talked about here today. So specifically under the urgent care, or are you looking for FTEs for all of the services that we have, so I can make sure we get the right response to the question?
I mean, just in general, as I look at this, I see money and no money is going to have to be put into it. And so I'm just curious as I go through and I see different, costs for things that is related just to DCF. I was just curious. I don't have specifically, but when you look at this as an overall picture, what are you estimating how many people that you're going to have to hire and what is going to be the cost in general as the whole program, all of the programs get put into place?
Mm-hmm. And so if I understand the question correctly, what we have been able to do is really examine the utilization of the capacity of existing programs and scale those back. If we saw 2 or 3 years of underutilization in a particular program, we targeted those particular areas to be able to free up some of the resources that we have. We've gotten also some federal money that will help support a lot of the ideas that we have, along with decommissioning some of those underutilized service types, as well as in the governor's budget to be able to enhance that. So we can get to you the very specific breakdown of how much of a workforce implication it is, because each one of them has a specific number of FTEs for specific functions.
I would greatly appreciate that. And I appreciate, really trying to look at it from a perspective of utilizing what we have and who we have, the resources already. That's important. But again, I see these things and it's, certain hiring staff to do certain things. And so, yes, I need that, please. I'm sure maybe other people might be interested in it. So I would like to know exactly how many people will be hired and what is going to be the additional cost, whether you hire new people or we use the resources we have. What is going to be the cost for DCF to implement what is being asked by the legislature for you to do?
Thank you so much, Representative. And DCF would not be delivering the services, but the RFPs that will be put out to community for bid would include those FTEs. So we will get that information very specifically to you.
Thank you.
Thank you.
Thank you very much, Representative. And I just wanted to point out for your benefit, Representative, that in this bill, it also includes a program, first of its kind in the state of Connecticut, that would have some students who need to have clinical hours. We would require those clinical hours within those walk-in urgent care centers and subacute stabilization centers so that we can kind of work two aspects at the same time. And that is not only a cost saving measure, but it's actually also for the benefit of the children to keep hopefully it's going to work to keep people in the state and doing work. So
And building
that's
that workforce capacity. Yeah.
Yeah, I do appreciate that. But and again, but as I read through this, I see, you know, fees here, you know, we're going to waive some fees for certain folks and all of these things. So there is a cost.
Right.
And so I really want to know what's the cost for the whole package. But
sure.
Since the commissioner was in front of us, that was my question.
Understandable, and keep in mind that the fiscal note will alert us to that. But I also want to caution everyone that we can't look at this just as cost. It has to also be viewed as an investment in our youth.
Understood completely. Okay. Thank you.
Sure. Representative McCarty.
Thank you very much, Madam Chair, and welcome, Commissioner. Just very quickly, I know DCF had a program called the Short-Term Family Intervention Treatment, which was eliminated, that went throughout. Since we're talking about filling all the gaps, I'm just wondering if you could clarify quickly whether the urgency, the new urgency centers, will that fill that gap in your opinion, or will there still be some areas that the the family intervention treatment plan had in its makeup? Is there a difference between the two? And
very much. Thank you so much, Rep. McCartney, for asking that question. And there very much is a difference. What you are referencing is our SFITs. Most people refer to them. You gave the full proper name of that particular service type. And that is a perfect example of an underutilized service type based on the utilization that we saw over the last 3 years. The other thing that we also noted is that in some of the SFITs that did have waiting lists and continually had kids in them, had expanded beyond their service scope. And so when you heard Dr. Fortunati talk about using specific beds for specific types of acuity with kids, SFITs are not ligature free. They are not the types of places that should be used to be able to treat the clinical needs of kids. And so what started to happen is that SFITs were supposed to be kind of a 2-week respite for parents to have their children in a community-based setting, and the family was to be involved in kind of having the child come back. What it morphed into was a place where children stayed well beyond the 2 weeks and were maybe waiting for a higher level of care, which they weren't scoped to do. So I can answer the question from the fiscal perspective with utilization, but we can also answer it from whether or not that's the service type to meet the acuity needs of the children that we have.
Okay, thank you very much, Commissioner.
Thank you very much, Representative. And I didn't ask that question because I saw your hand up and I knew you were going to ask that. So thank you very much. Representative Pettit.
Thank you, Commissioner. If this was spoken, I had to step away to another meeting for a few minutes, so I hope I didn't miss this. The governor's proposal for the Children's Behavioral Health and Prevention Cabinet, of which, as I read it, you as the commissioner would be the cabinet chair. Can you just comment on how that would impact the implementation of this bill? Would it be helpful? Would it be confusing? Can you just comment on that in general?
Absolutely, Rep. Pettit. Thank you very, very much for that. And in my trying to be brief in the testimony, I skipped over the chunk that really specified the benefit of having a children's behavioral health cabinet. Right now, we currently have a children's behavioral health advisory board, and we recognize that attention to the throughputs of the system really could use additional enhancement, and that's where the cabinet comes from, along with the accompanying consumer counsel that will advise the cabinet from a user perspective. So, looking at our providers and our hospitals and parents with lived experience, the cabinet would be the one to be enhanced, to be able to look at all the throughputs across the system. And then the council could, hold the cabinet accountable from the user perspective.
And any additional cost, or would essentially people be continuing in their positions as most of the people are already working for the state?
I don't foresee costs at all, except for the fact that I often get concerned about families with lived experience who join panels and join commissions, and they're not compensated for it as we are, because it's in our professional capacity. So if there is a cost, it would be minimal, but that would be to be able to help support any parent with lived experience. And I know you all are going to hear probably from quite a few of them over the next few hours of parents who've experienced just, frustration with the way the system is designed right now. So, I don't believe that there should be any additional huge costs associated with that, except for thinking about how we can compensate that.
Thank you.
Thank you.
Thank you, Representative. Representative Welander.
Thank you, Madam Chair. Good morning, Commissioner.
Morning.
Thank you for sharing all the information that you have so far today. And there's so much wonderful work being done in this bill. I was wondering, though, one of the things that I'm very excited about is the anticipated rollout of the 988 system, which is the for those who don't know, the new number for the National Suicide Hotline, Prevention Hotline. And it is going to make it a lot easier for people to access the care that they need in moments of crisis. I was wondering if you could expand just a little bit on that and the agency's role in that, and what we can make sure we're anticipating all of the parts of this process, because it is a large rollout. It's a national effort, and make sure that we are best prepared as a state.
Representative, thank you very much for raising that. That is also, the excitement is mutual. We often regularly partner with the Department of Mental Health and Addiction Services, and this is an area that we're already in partnership with. The Suicide Advisory Board, one of the tri-chairs is the director you just heard from DCF, Tim Marshall, who has really spearheaded DCF's efforts to scale up and be ready for the 988 implementation. Tim, do you have a brief synopsis to respond to the representative's question about where we are in terms of our readiness to implement?
Yes, thank you for the question. So July 16th of 2022, nationally, there will be a soft launch of the 988 system going live. There will not be a large public announcement because the federal government made a decision to stand up all of the activities for 1 year before they do a huge publication. And so we've also been asked as a state not to publicize the 988 going live until next year for that more full launch, if you will. DCF partnered with DEMIS. DEMIS was the lead applicant, and we had a planning grant for the last number of months, 9 months total. It's just coming to a conclusion. SAMHSA, the federal government substance abuse and mental health service administrator, hired a private company called Vibrant, and they oversaw every state in the country had a planning grant. We had to put into all of the all the activities that needed to occur. In summary, what was really going on in that is to be sure, like 911, when you call that, you might be calling for fire, police, or EMT, and that similarly, not every single mental health call needs the same thing. And so the coordinating hub, if you will, that is the best practice that is being promoted, would be the mobile crisis system. And within the context of the mobile crisis system, either through a telephonic stabilization or telehealth, or through a face-to-face, that a mobile crisis assessment would lead to a direct linkage to whatever the need is. So if it needs to be a place to go, a bed, as we've been talking about, that would be available. If it was a lower level of care of an appointment in the system, that linkage to that referral would happen rapidly. And then finally, similarly, do you need mobile crisis, or do you just need somebody to talk to? So they've been building it as somebody to talk to, somebody to respond to you, and or a place to go. And so those components have been what we've been focused on, and both DCF and DEMIS have been using some of our available funds to build the infrastructure. So for example, mobile crisis, both on the child and the adult side, moving to 24/7 is a critical step for that to be available at any time during the 24-hour day and every day of the week. So we just concluded that. We have an application pending now for the next step for every state, which will be an implementation grant that we are submitting. And then again, DEMIS is the lead. And then from there, we will move towards implementation communication. And a lot of that is, again, the infrastructure behind the scenes to make sure calls are forwarded properly as rapidly as possible to all the different service departments in the system. Thank you.
Thank you for all of that information and that summary. I'm looking forward to this moving from a soft launch to a full out support system. I think it's going to be instrumental. So thank you for your time.
Agreed. Thank you very much.
Thank you very much. Are there any other questions? Seeing none, thank you, Commissioner. I look forward to working with you moving forward. I just want to put a bee in your bonnet and let you know that we will, I would like to, moving forward, look at the SFIT program and see if what capabilities it has to turn into possibly an IOP program, so we can move that forward. I know that you weren't prepared for that, and it's just a question I'm asking out of the blue. So we could do that moving forward, but just if you could keep that in mind, because I'd love to see that happen. It looks like Representative Exum has a question. Go ahead, Representative.
I am so sorry to break what we're trying to do here with one question, but I did want to ask about the, just circling back to the urgent care centers and the RFP, the timeline piece. Do you have a sense of when that RFP will go out?
I do. Melanie, our CFO, can you comment, or Tim, on the timeline related to the first urgent crisis center? And then, you know, obviously the three others will follow, but what is the timeline on the first?
Yes, we are just finishing up the final draft of the procurement process. So again, similarly to the other that was mentioned, we will be going to procurement within weeks.
I could just add, Representative, once we have that first RFP on the street, the other three centers that the Commissioner was referencing after July 1st, it'll flow an awful lot more quickly because that RFP is already written and the service model is already designed.
Okay. Thank you so much. I'll ask more questions about this offline. I don't want to hold things up, but thank you very much for that.
Thank you, Representative. I don't see any further questions. So, Commissioner, again, thank you for your testimony today. It was really very, very helpful. Next up,
thank you so much.
Our pleasure. Next up is Commissioner Gifford from the Department of Social Services. Welcome, Commissioner.
Thank you very much, Representative Steinberg and Representative Linehan and Senator Anwar, distinguished chairs and ranking members and committee members of Public Health and the Children's Committee. I am Deidre Gifford, Commissioner of the Department of Social Services, and very pleased to be with you this morning to offer remarks on these bills. Just very briefly, before I speak about some specifics and also some follow-ups to what we've heard this morning, just to set the landscape. As you may know, in 2020, the Department of Social Services provided through Husky and CHIP coverage for almost 300,000 children in the state of Connecticut. We cover about 36% of children in our state, and about 20% of them received some mental health service in state fiscal year 2020. So a very large number of children are served through the Husky program, as you hear from providers. And we did, for all the full array of services, including very intensive services all the way to outpatient treatment, we did in calendar year 20 spend approximately $224 million total on children's behavioral health services in Husky. To comment briefly on a few specific sections, if I might, in 5001, we have submitted written testimony to the committees, and I would refer you to that, but I just want to highlight a couple of things. First of all, in section 10, which extends the requirement for DSS to cover a number of telehealth providers, we would be interested in speaking further with the committees about the list of providers that are covered in that section. We fully support an extension of telehealth for behavioral health. That's not a question. There are a number of other providers listed in that section that we would like to discuss further, which traditionally would involve a face-to-face visit with the patient and some hands-on interaction. In section 37, which establishes a grant program to cover off-label prescribing not otherwise covered by Medicaid, and services, in-home services in particular, I believe, not otherwise covered by Medicaid. We do have some concerns about that grant program. In particular, who would be setting the criteria for what would be covered under that grant program, and how would it affect the integrity of the medical oversight that we have well established in the Husky program. We also wonder whether it might disincentivize commercial insurance from covering some of those things, knowing that there was an alternative state funding mechanism. So very much look forward to further discussion on that section. In section 66, which talks about the collaborative care model, we are very, very supportive of physical and behavioral health integration in Husky. We've been working on that through our PCMH Plus program and are going to continue to work on that with the Office of Health Strategies. But we did want to propose some alternative language about the reimbursement model. Right now, there's some language in there that talks about separate reimbursement. And we think that may be a little bit too restrictive and would like to offer some alternative language.
Excuse me, Commissioner Gifford, but your time is almost up. If you please summarize. Thank you.
Thank you. I will do. With respect to the inpatient bed expansion, I'd be happy to take questions on that. We have already, in response to investments that have been made, we have already seen some significant expansion in inpatient beds over the last few months. And the governor's proposed budget includes, as you know, $15 million for a bed expansion at CCMC. So happy to entertain questions there. And finally, I did want to thank Senator Winfield for his comments. And remind all of us that last year's budget and this includes funding for a universal home visiting program and a community health worker program that is specifically aimed at the issues of maternal mental health. Under this program, which will be piloted in Bridgeport under the leadership of OEC and Commissioner Bai, every single woman who gives birth in the state of Connecticut, beginning in Bridgeport and hopefully expanding, will receive 3 home visits from a nurse. Screening for mental health issues will be part of that. We also have in the governor's budget funding for all of our maternity coverage to begin to include doula coverage, which can also help us screen for and address issues of mental health and substance use in pregnancy. And finally, specifically to Senator Winfield's comment about particular communities who may not have access to services, we are focused on building out a community health worker program in partnership with the Department of Public Health and some of their CDC funding that will have individuals from the communities and as community health workers assisting women who have recently given birth and their families to make sure they can access the services that they need, have trust in the system, and establish communication between their providers and them. So with that, I will stop and happy to entertain your questions.
Thank you, Commissioner. There are some questions. Let me start with one. And again, thank you for your very specific concerns and recommendations, and we look forward to seeing the language that you will provide. With regard to your statement about providing nurse visits, up to 3 visits in an early intervention, which is really wonderful, are you confident that the state has requisite nurse resources to meet that kind of program?
Excellent question, Representative Steinberg. And I think, I don't know if Kelly Marie Valeris is testifying this morning, but the governor's budget proposes very large investments in the healthcare workforce, including new faculty, which, as you know, has been a real limitation in the number of nursing students who can get admitted to Connecticut programs. So there's an investment there in faculty. There's also some loan forgiveness and scholarship, as well as, I think very importantly, some work around career laddering, so that, for example, individuals who work in a health-related field don't have to start from square one when they want to go on to get an LPN or RN credential. So it's a long answer to your question. Obviously, we have a nursing shortage, but we are working hard across all of our agencies to make investments to address that, Representative.
Thank you, Commissioner. Yeah, we're struggling with that too, trying to figure out if we can do something about nurse reciprocity. Haven't quite figured it out yet, but thank you for highlighting that. Senator
Yeah.
Anwar has a question.
Thank you, Mr. Chair. Thank you, Commissioner, for your testimony, and thank you for the work that you have been doing in the last 2 years and even prior to that, and also the priorities that the governor has made with the investments that we have just been talking about this morning as well. With respect to the beds, one of the questions was that is there opportunity for geographic distribution of the beds, and is there a number that you have assessed as a priority? And then a second question I wanted to ask was, in our conversations with a number of causes of how we reached here, amongst the various reasons, one is that the commercial payments have not been at par for the behavioral health area and the mental health field, but also the Medicaid payments have been a little behind and they have not increased. Is there a benchmark? Is there a strategy that we make sure that the payments remain at par with some of the other states and we continue to invest in this very important and difficult area and in challenging financial times, at least in the past and in future too, potentially?
Excellent point, Senator. With respect to the geographic distribution, you heard Commissioner Durantes refer to the dashboard that we have been working with DPH and CHA, the Hospital Association, on. I get that in our inboxes now every single morning and lets us know how many children are sitting in the ED waiting for an inpatient bed and where they are. What we have noticed is at times of the greatest peak, we seem to have many challenges in the greater Hartford area, and that's where we have seen bed expansions. So we've seen expansions at Trinity, at the Institute of Living, at NACHOG, and at ECHN, and then the proposed expansion at CCMC. You heard from Dr. Fortunati that the ED at Yale New Haven is also often challenged, but we have not yet had a hospital there respond to our incentives around expansion. With respect to rates, we did, Senator, and it is included as an ongoing expenditure in the governor's proposed budget, we did significantly increase our rates in Husky to hospitals that expanded their inpatient child psychiatry. You heard the request for infrastructure dollars to cover the costs. What we heard from the hospitals who have expanded was that delta we provided was sufficient to help them meet the capital costs to a great extent. So we are encouraged by what we're seeing. There also is proposed in the governor's ARPA budget money for the Office of Healthcare Strategies to look at a benchmarking between coverage in commercial plans. And we comment on your section, I believe it's section 65 in 5001, that speaks to the benchmarking that you're talking about, and DSS is supportive of carrying out such a study.
And thank you so much. Thank you, Mr. Chair. Madam Commissioner, I just wanted to make a statement. While the four caucus have been working collaboratively to make sure we take care of our children, we have truly found partners in every commissioner, every agency, and the governor's team as well. So it's beautiful to see that the entire state is coming together to take care of our children. And thank you for your testimony and your work.
Agreed, and happy to be part of the conversation, Senator.
Thank you, Senator. Totally agree with that sentiment. This has been as bipartisan can be, and everybody involved. Chair Linehan.
Thank you, Mr. Chairman. And hi, how are you, Commissioner? Thank you for being here today. I do have to apologize that I briefly had to step away because, like many of us, we have children home today from school, given the weather, and 8-year-olds really don't care that you have a job. But so I did miss part of your testimony, and I did kind of hear that there was some questions regarding the off-label drugs. And so if you could just briefly explain what your concern is, or if you're not sure what the purpose of that is, and then I can answer that for you and for the members of the committee.
Yes. So Representative, as you may know, I'm sure you do, that there is a requirement in Title 19 of the federal Social Security Act, the Medicaid program, under the Early Periodic Screening and Detection and Treatment Program, EPSDT, that requires Medicaid already to cover all medically necessary services. That is in part why you see such a broad array of services provided in children's behavioral health in Husky that are often not covered by commercial insurance. And it's because of the foresight of that EPSDT provision that requires us to cover that. So we already are required to cover medically necessary medications and treatments. And we don't necessarily distinguish between on the FDA label when doing that. However, we do have a pharmacy oversight and medical oversight process, both through our own pharmacist and chief medical officer at DSS and through our administrative services organization. And there is prior authorization under certain circumstances. Our concern about this grant program is who would be the body that would be making the decisions about what would be approvable under that grant? And would that body be reversing the medical oversight that already exists in the Medicaid program and the coverage decisions that were already made? And the second concern we articulate in our testimony is not directly related to DSS, but more general, which is if this grant program covers services that are not covered by commercial insurance, does that provide a perverse incentive in some ways for commercial insurers to not be pressured to if it's appropriate, cover those services because they know that this grant program exists?
Okay, and thank you very much for that. I do recognize that those may be some issues. We thank you for bringing them up, and we will absolutely convene the working group to work on that. I guess, you know, here's my problem with that, though. Here's my issue, and if you have a creative way to solve that, I'm more than open to hearing it. But when things aren't covered, and having a grant program helps the children, right? Because we know that they may need these things. It puts us in a position where we say, okay, so if it may have this unintended consequence, what happens is these kids still aren't getting coverage for what they need, right? And so there's got to be a way that we can write this where it doesn't do that. We just need to put our collective heads together and make sure that happens. But, you know, there are so many medications that were at one time not covered or considered off-label. And so we need to really look at that. And what we did here in this legislation is we took the statute that requires coverage in other places, for instance, cancer, for cancer treatments, and applied it to mental health treatments. And that requires us to say that mental health is a chronic, debilitating disease. It is. It absolutely is. And that is where we have to have them mirror that, because yes, cancer is chronic, debilitating, and life-threatening. So is depression, especially in our children. So we're seeing suicide rates through the roof. And look at our LGBTQ kids who, even though we look at the overall suicide rate, we know that those kids are at least 4 times more likely to have a plan to implement suicide than their peers. So we have to really, I understand the caution. But when there's caution, it doesn't mean we shouldn't do. It means that we have to be prepared for all of the ifs. And so this legislation really needs to do that. So I want to put a call out to everyone. Let's work together to find this. Because, you know, I'm looking at the list of off-label drugs that from a pediatrician. And we know that Lamictal is an anti-seizure drug, but it works wonderfully in bipolar for kids. Lexapro is an SSRI, which is, it hasn't been approved for kids under 12, but it's being used. Zoloft at one point, or actually even now, is not approved for kids for anxiety, but it's often the first line medication. So I get that those things now under what we've got in Husky are actually being paid for. But what about the future drugs? What about things that are coming along? Science is moving along, and we need to remember that we're not just writing legislation for today, we're writing legislation for tomorrow and beyond. And so I look forward to continuing this conversation because your input is going to be greatly important. But this is one of those parts of the bill that I think is really, really important, and we just need to figure out. So thank you very much, Commissioner.
You're welcome. I agree with your sentiments, Representative, and look forward to working with you on the language.
Thank you.
Thank you, Representative. You can see the many complexities of what we're trying to deal with today, which leads to a lot of granular conversations. Seeing no further questions, thank you, Commissioner. We're counting on your active involvement going forward and that of your staff. We are now more than 2 hours into our hearing, so with my regrets to Commissioner Russell Tucker, we're going to be shifting back and forth from the public and officials at this moment. First up is number 32, Ron Edelman. So let's be clear what we're going to do here. If you want to give testimony, you have to accept the panelist request that you get on your screen. It's the blue button. Go to the blue button and make sure you hit panelists so that you can be promoted. So to be clear, we're going to have Ron Edelman followed by Commissioner Russell Tucker and then number 33, Mark Jaffe, I believe. Welcome, Mr. Edelman.
Good morning, distinguished members of the Public Health Committee and the Committee on Children. My name is Ron Edelman, and I am the president of the Connecticut State Medical Society. On behalf of the physicians and patients, thank you for the opportunity to provide this testimony. We commend the Public Health Committee and the Committee on Children for putting forth this bill. The mental and behavioral health of our children is of paramount importance to our state. We have submitted a written testimony, but I will highlight just a few key points. The bill begins to confront the issue of lack of in-network psychiatrists and other mental health care providers by requiring studies to see what payment rate would increase and provide more providers to participate in insurance networks and in Medicaid. Medical Society would strongly recommend, in place of the surveys, amending Connecticut's network adequacy statutes to require health insurers to have more psychiatrists and mental health care providers in their network. Mandating a denser behavioral health network will ensure greater access to these much needed services. The fact that health insurers in Connecticut have such a small network of psychiatrists indicates inadequacy of Connecticut's network statutes. In order to truly tackle the mental health care of our state children, we must have more psychiatrists and mental health care providers in network. We implore these committees to work with the Insurance Committee to address this problem. While the extension of telemedicine protection in this bill are welcome, both patients and physicians would like to see the telemedicine become permanent. Telemedicine has become an important part of our healthcare system, and rather than continually legislating extensions, it would seem prudent to permanently enact these statutes. Section 45 of HB 5001 creates a mental health care provider loan forgiveness program. Connecticut currently ranks 47th, yes, 47th in the country in retaining the physicians that we train here in our state. Loan forgiveness for psychiatrists is a good start on the path to helping our retention issues. We hope that the loan forgiveness would be extended to all physicians in the near future. We stand ready to work with your committees to pass legislations that will benefit the mental health care for all of our Connecticut children. Thank you so much.
Thank you, Doctor, for your testimony today, and my apologies for not recognizing your education and experience. You made a lot of important points. Let me just focus on one before I hand it off to Representative Pettit. clearly telehealth is an important section of this legislation. We are obviously inclined to make telehealth permanent, but as you are aware, much of our ability to do so is predicated on CMS working with us to assure that we have both appropriate coverage and reimbursement, at least for those who are under Medicaid, which we know is a large part of our vulnerable population here. But we certainly want to take you at your word, and we will be talking and have talked with the chairs of the insurance committee to see what we can do on the private payer side. I just also want to highlight your point that we need more high-level psychiatrists to be willing to take something beyond private pay if we're going to address this problem. Way too many of them only accept effectively cash on the barrelhead, and that is indeed part of our problem. Representative Pettit.
Thank you, Mr. Chairman. Thank you, Dr. Edelman.
Thank you.
Just want to continue on that theme. Same thing I asked Dr. Fortunati and Chair Steinberg was talking about from your point of view, from the medical science point of view, in terms of psychiatrists, is the issue provider supply, network adequacy, or reimbursement, or some combination of the three? What do you think is our biggest issue in terms of having an adequate supply of providers overall?
There's a combination of all three. Obviously, for psychiatrists to stay in network, there should be adequate compensation for them by the insurers. So that's important. The other thing is to keep the physicians that we train in Connecticut in our state. And that is something that we need to work to make it more friendly environment for the physicians to practice in our state. So there are a number of things that can be done. That loan forgiveness is a major initiative, and I encourage the legislators to look at loan forgiveness for all of the physicians, because today we are talking about child psychiatry, but tomorrow we will talk about another specialty and another shortage and another shortage. We need to address that in the base.
Thank you. My follow-up would be if you could list your top two, we talked with colleagues, what would be the two most important things to make Connecticut more attractive for people to stay here post training? What would you list as your top two incentives?
One would be the loan forgiveness, and the other one would be a change in the liability for physicians, so that become a more friendly environment for practicing medicine.
Thank you. Thank you, Mr. Chair.
Thank you, Representative. And again, thank you, Doctor, for your testimony. As we will be saying to a lot of people who are going to testify today, we continue to need your active involvement as we try to fine tune some of this language, and particularly as we have to make the tough decisions on how best to allocate our limited funds for the greatest return. So again, thank you for your testimony today, and we look forward to further conversation. Now we're ready to go back to Commissioner Russell Tucker. Our apologies for keeping you waiting. It's going to be a long day, so welcome, and looking forward to hearing what you have to.
Thank you, Representative Steinberg and Senator Anwar, Representative Linehan, Senator Kelly, Senator Wong, Senator Summers, Representative Pettit, Representative Jaffe, and members of the Public Health and Children's Committee. I'm Charlene Russell Tucker, Commissioner Designate of the Connecticut State Department of Education, and I'd like to offer testimony today on HB 5001, an act concerning children's mental health. This is a topic of the utmost importance, given the effect of the pandemic that it has on our children over the last 2 years. And as you know, this is an area of work that has been a priority for the department even prior to the pandemic. We enthusiastically support the attention being given to address the well-being of our students and staff, and respectfully offer comments for your consideration. I will highlight just a few points because we've submitted extensive testimony, and then certainly we'll be here. I have staff with me as well, so we can take your questions. Section 17 of the bill, the department currently collects the data outlined in this section, which includes social workers, school counselors, and school psychologists. And additionally, we request removing the requirement to calculate student to social worker ratios as any comparison between districts or other professional staff levels would not align with our position on allowing school districts to hire and retain the appropriate student support staff according to the needs that's presented in their context in their districts. Sections 18A, B, and C should also include school counselors and licensed marriage and family therapists. And the grants establishing this and the following sections are certainly not included in the FY 22-23 budget. And as such, the agency would also require additional staff and support at 1 FTE to actualize and implement the grants. Section 19 refers to providing grants to institutions of higher education. And as you know, that is not under the K-12 purview oversight, so would certainly recommend that be moved from the bill for implementation by the Department of Education. We also address in section 22 in our testimony the strategies that we've employed to address the issue of truancy based on truancy intervention models, which were required of us under 10-198E. So ask you to take a look at that as well. Representative Lenihan this morning talked about the trauma coordinator, which is required to be employed by the department, which we certainly support. This again is not in the budget, so would need to be thinking about that. Additional training for our school staff is listed here. And we also ask for that to be looked at so we can avoid any redundancies for additional training as existing training address trauma as well be incorporated, for example.
Excuse me, Commissioner Russell Tucker, but your time is almost up. If you please summarize. Thank you.
Thank you very much. My last comment is around the additional needs assessment that's required under section 27, which is what we would plan to implement in the grants anyway, and so would not be needed to be listed here separately. Thank you for considering the recommendations we have outlined here in our written testimony, and we stand ready to work with you as the proposal moves forward. We certainly appreciate, again, all your hard work in putting this together and look forward to answering your questions. Thank you.
Thank you, Commissioner. Clearly, the Department of Education is going to play a very important role. All the focus we've had on using health centers as a point of contact, early identification, intervention is absolutely essential to our overall picture. Representative Pettit has a question.
Thank you, Mr. Chair. Thank you, Commissioner. Just to follow up on your comment on section 22, are you saying that 10-198 makes section 22 unnecessary in the current bill concerning truancy?
Thank you, Representative. Right, in section 10-198 required the department to develop a catalog of truancy intervention models, which we've done and are also implemented and really implementing with fidelity. We're focused on early identification, even before we get to students being identified as truants. And that is work that we've been doing and will continue to do with fidelity for implementation locally.
Thank you. Thank you, Mr. Chair.
Thank you, Representative. Senator Anwar.
Thank you, Mr. Chair. Thank you, Commissioner, for your testimony, and thank you for helping us with the bill as well. Commissioner, I wanted to seek your insight. There is a concern that has been raised to expand the school-based healthcare centers, but in some of the schools, there's not enough space, and the thought was that maybe initially there should be behavioral health focused only school-based healthcare centers rather than the traditional definition of school-based healthcare centers. Any thoughts on that?
So thank you, Senator. The school-based health centers play a vital role and one of the levers that we're looking for to support districts as well. And so I certainly support, certainly looking to see what we can do for spaces so they can be the full complement of support. However, if that's where we start, I think that's a critical need for the behavioral health services. And so we'll certainly look forward to having further conversations if we need to start there as such a critical need. We're really working with our districts. Some of them have already made investments as I've mentioned in the past. And so having this as a place to support them further, I think would be extremely important.
Thank you so much, Commissioner. That's very helpful. I think it's not in the current bill, but I know it's in SB1, something to that effect. But thank you so much for that, your help and guidance for that.
Thank you.
Thank you, Senator. Representative McCarty.
Thank you very much, Mr. Chair. I'll be quick. Welcome, Commissioner, to the committee. And I, for one, working firsthand with you on so many occasions, know your dedication for the mental health training in our schools and making that a high priority. I was just curious, Commissioner, as we go through with our PD development and training of our teachers and the staff, could you comment on how you think we could reach our parents? I know you're very attuned to parental engagement in our districts, and how can we get the mental health, the appropriate trauma-informed practices to our parents as well, because we'd want that to continue outside of our schools as well. If you could just give that some thought as we go forward.
No, thank you, Representative. This is so key and so important that we're reaching families and using every tools and every means necessary. As you've heard me speak about our Commissioners Roundtable for Family and Community Engagement in Education, that committee, we meet regularly. We have folks who are connected there who are trusted messengers to parent groups and organizations, and so we continue to hear from them, and certainly would be happy to engage them to learn further. How do we get authentic parental voice, and how do we share information with them authentically? And I know we have lots of organizations in the state that can help us to do that. We encourage our districts to make more robust those communication networks. And I'm so pleased that some of them have already invested in building on the work that they're doing locally, so we can use those as outlets as well. So we continue to work with you on how we can make sure we have a really solid communication network and pipeline directed to families, either through our schools, I say in addition to our schools, but also through organizations that are working in community and working directly with our families.
All right, and thank you very much for bringing that up, because I know the regional behavioral health organizations have a lot of programs with trauma-informed practices. So thank you for making that comment. Thank you for the opportunity to speak.
Thank you, Representative, for that question. Representative Welander.
Thank you, Mr. Chair. Thank you, Commissioner, for being here today. I wanted to just touch base on Section 22 that you were referring to, that the truancy intervention models that you say the SDE already has in place a certain practice. I was wondering, could you speak to what is already in place, and does it actually set off a process of providing emotional, behavioral, mental health services and supports for the children and the families? Because I think I want to make sure that the intentions of what we put forward are matching up with what is actually happening right now.
Thank you, Representative Welander. And I'll begin to talk through that. And I'll also ask John Fasanelli, who oversees that work directly, who's also online here, that he can add information there as well. And so, correct. So we've developed, again, in response to previous legislation, truancy models and strategies that we have available. And we've been working with our districts to implement based on the levels of truancy in their particular school districts. And so within, there's individualized strategies that are utilized. So first, the students would be certainly identified. We have models that are behavioral health support models that are a part of the guidance that we provide. Screening for early childhood trauma is a part of the strategies included there as well. Check and connect, trauma-informed initiatives are already there. We also have initiatives to address students based on their race and ethnic background, right? To make sure that there are programs there as well that are culturally sensitive and responsive. It also includes initiatives around restorative practices. But the concept here is that no two children are the same. And so the idea here, you have to understand exactly what the issues and concerns are for the individual student to then determine the array of supports and services and connections necessary to individually intervene and support. What are the in-school supports? What are those that may be external to the school that you also need to make sure that's a part of the connections that's being made. John, what am I missing? If you can just add to that for the representative, that would be great.
Thank you, Commissioner. You certainly didn't miss much. I think the idea here is that we're working with districts with high rates of truancy and high rates of chronic absence, not to wait until that 4th absence in a month and not to wait until that 10th absence in a year, but to intervene early. If you start to see a student who's missing, the first Monday of the month, when you start to see that, the intervention needs to start there. And it starts with engaging families. It also engages the teams on the school level around behavioral health support, school counselors, school social workers, and all of those, to take a look at what that is. It also, we start to look at things like transportation. Is the transportation an issue? Is the student missing because of inclement weather, because they live close to the school and they're not, and they're walking to school and they're not coming in inclement weather? Are there some changes in their housing stability? We look at all of those things. So we sort of look at a whole child approach to support that work. And part of the work that we do is certainly offer to them some of those truancy intervention models that the commissioner mentioned, but creating one specific behavioral focused truancy intervention model and suggesting that all schools need to do that. What we need to do is make sure that the implementation of whatever they're doing aligns with the work that they're already doing and supports that work and doesn't take away from initiatives and work that's happening to support their students.
Thank you for that information. It sounds like there's a good foundation there, but potentially some more work needs to be done to help support our students and their families navigating some tricky times. So thank you.
Thank you.
Thank you, Representative. Representative Zupkis has a question for you, Commissioner.
Thank you, Mr. Chair. Good morning still, Commissioner. I have a comment and then a question, and my comment is I would appreciate the same information that I had asked from the Commissioner of DCF as to how many, what I'm looking at, you're going to hire a trauma coordinator and all of these. So how many people would you be hiring to make this piece of legislation be effective? So if you could please forward that, that would be wonderful. Thank you. My question is, also when I'm looking at like section 22 and 25, and it talks about creating these different programs or developing these procedures, are you going to have possibly some of the schools involved, like someone that's in it at a school, or maybe a parent or other community people, or is it just going to be your department?
Thank you, Representative, for that question. In developing guidance at the State Department of Education, we have a proven method to make sure that we engage as many stakeholders as possible in the development of any of these initiatives and guidance documents. So absolutely, we invite schools in, school staff in as appropriate to make sure they're providing comment and feedback. We also learn where their best practices, where are there programs that's already implemented that are best practices that we can learn from. And so that will all be a part of it. Hearing families' voice, critically important, and families who are representative of our diverse community within our schools. So making sure we're hearing from families of students with disabilities, making sure we're hearing from families across the different demographics, all critical part of that. Our educators who are in the classroom, making sure they're implementing the array of support services staff that we often reach out to would certainly be a part of that. And also stepping back and looking at our states, other states, and look at programs that may already be implemented. As you can well imagine, in the issue of behavioral health supports, we've got a lot in our mailboxes and knocking on our doors for lots of organizations who are developing programs and initiatives, and we're vetting those and having those conversations as well. And last but not least, my motto here is not about them without them. We hear from students. And so we have ways to make sure that those directly impacted have voice and agency in anything that we're developing. So be assured, it is just a part of the way we do business here, is that we need to have as many voices at the table as possible. So the product, and not only the product, the implementation can be done in an impactful way. A good guidance, even great legislation doesn't get you to that end. It's a part of the process, but everything lives and dies on the implementations in the implementation space and implementing with fidelity. So absolutely.
Thank you. I appreciate that because I even know in my district, we've had some big problems with mental health and unfortunate situations that have ended up fatal. And my district looks very different from other districts, whether it's New Haven. I'm close to New Haven, but we look very different than New Haven. And I would encourage, let's get a whole broad perspective. So I appreciate you doing that. That would be great. Thank you.
Thank you.
Thank you, Representative. And good point, Commissioner. The best legislation is only as good as its implementation. And we should be considering the students are stakeholders in this and make sure that we have their input. That's a great point. Representative Exum.
Thank you so much, Mr. Chair. Good to see you this morning, Commissioner. I just have a question around Section 17. I just want to be sure that I heard you correctly. Were you interested in omitting that section around the student ratio, social worker, student social worker ratio for the schools to be reported?
So thank you, Representative Exum. Good to see you again. I think the language as written right now is about establishing or at least checking on the ratio of social workers to students. And what we're saying, let's not just focus on social work, the social worker. There's an array of support services staff there. And we have, we collect information right now on the numbers of social workers, the numbers of other support staff, counselors, psychologists, and we have that information available. That is why we know, for example, that since the pandemic, there's been an increase in hiring of these staff just based on data that they've provided to us. And so we've always made the case that instead of saying to district, you must hire a counselor or you must hire a social worker or you must hire whatever we label, that we say to them, right, you need to assess the needs that you have in your locality, as the representative just mentioned, and then determine the staffing that you need to address the needs as they present themselves in your individual districts.
Absolutely. I think that's what we're trying to get to when we look at the language that we have around what schools are able to provide. To look at the grant program is saying, hey, look at what you need. Do you need trauma-informed specialists at your school or behavior techs versus counselors, social workers, and not trying to say what each school will need, but in fact, have the local school boards be able to make that determination. So this is just saying that this is too tight, the language that we currently have. And okay, I just want it to be really clear that I understood that because it's certainly our intention to be broad and inclusive. Thank you so much. Good to see you. Thank you so much, Mr. Chair.
Thank you, Representative, and for all your amazing work on this. I don't see any further questions, Commissioner, but we reserve the right to talk to you again real soon. So thank you for everything you've provided today. We will now return to the public. Mark Jaffe is up, and then for officials, where will be Executive Commissioner Veltri from Office of Health Strategy. Welcome. We can't hear you yet. If you could try again to make sure your volume's working.
Can you hear me now?
That's what we need. Thank you. Please proceed.
Okay. Good morning. My name is Mark Jaffe, and I am the CEO of Children's Learning Centers of Fairfield County, CLC. Thank you for this opportunity to testify today on SB2. I run the largest nonprofit early childhood education center-based program solely focused on early childhood education in Connecticut. We serve 923 children ages 0 to 5 in 8 centers in Stamford. We have 220 employees enabling 1,600 parents to work. We have a 9-figure economic annual impact. A high-quality early childhood program critically includes social and emotional development. Addressing mental health issues for children ages 0 to 5 is far more effective and far less expensive than any time thereafter, and we're doing it as we speak. Partnering 10 years ago with Yale Center for Emotional intelligence, we created the Pre-K Ruler Program. And now, in a groundbreaking partnership with Columbia Medical School's Nurture Science program, we're focusing on emotional connection between a parent, mother, and her child, resulting in dramatically improved children's behavior and less depressed mothers. Our study had statistically significant results with large effect size. Now, in COVID, doing the work virtually, which, if successful, may allow an inexpensive and scalable model. The problem is our industry is on the verge of collapsing, so may not be around to continue this work. And let's talk hard numbers, our economic reality. It costs us about $16,500 per year per student in our school readiness program, which critically is 51 weeks a year, 10 hours a day. By 2023, that $16,500 will increase to about $19,000. The driver minimum wage increase, which we support. It was $9.15 an hour in 2015, and by next year, $15 an hour, a 60% increase in 8 years. Our largest revenue stream is our per child reimbursement, which was $8,900 in 2015, and in 2022, still $8,900. So unfunded mandate, wage compression, no ability to hire talent. There are over 1,300 job postings on Indeed for early childhood educators. Now, we have multiple revenue streams, but they total about $14,000 a child, which leaves a $2,500 per child deficit. It means that we have to raise annually over $2 million a year in the private sector to break even. Next year, over $4 million, and we can't do it. Now, I know you have lots of...
Excuse me, Mr. Jaffe, but your time is almost up. If you please
Yes.
summarize. Thank you.
I know you have lots of calls on your capital. The ROI on ECE is better than any other ed program, 13% per annum. Now, Representative Sanchez is introducing a bill for $700 million. It's part of a multi-year $2.5 billion ask. My ask is merely $55 million. We need the per student reimbursement increased to $14,500. Now, it clearly doesn't address the overall and larger systemic underfunding, but does plug an immediate hole. The consequences for not responding to this industry crisis is its implosion, tens of thousands of folks unemployed, 100,000 plus parents withdrawing from the workforce, and Connecticut plunged into a recession. And I thank you, and I appreciate your service and your listening.
Thank you for your very candid, if blunt, warning to us that we better get it together. Rarely have I heard 55 million referred to as merely, but I guess it's all relative in the scheme of things. I know we would benefit if you could provide us with the data that supports your ROI argument. I think it would be very helpful for us. To your point, the earlier we're able to intervene effectively with children, the more we save in the long term. So we take your point, and you're certainly telling us a story that we've heard often enough from nonprofits that they're struggling right now. So we take that very seriously. Senator Anwar has a question for you.
Thank you so much, Mr. Chair. Thank you, Mr. Jaffe, for your testimony. And working on the SB2, we recognize the fact that this industry is truly at the brink of a collapse. And this is one of the first building blocks for our economy. If the parents of young children are unable to work because they are unable to get the childcare because the childcare centers are just going out of business left and right, they will not be able to work and be a part of our economic opportunity. So we are hoping to have some emergency grants. We are going to work with the Office of Early Childhood to be able to address for the wage support. The federal government and the Build Back Better did not happen. That was going to be a very critical piece, but in the absence of that, we need immediate support like yesterday to save as many of these as we can. And we are hoping that we will be able to get appropriation for this as well, because this will require funding and I truly appreciate your testimony and look forward to getting some more numbers like Chairman Steinberg had suggested as well. We appreciate your testimony.
Well, thank you, Senator, and we appreciate your support.
Next up, we have Representative Kavros DeGraw, followed by Representative Comey.
Thank you, Chairman Steinberg. And Mr. Jaffe, great to see you. Thank you so much. I appreciate that you're here today testifying, and I certainly echo Dr. Anwar's concerns. I was wondering if you could just tell us, briefly, some of the interventions that you're talking about that you do in terms of children's mental health under 5, because I'm not sure people are aware of the types of things that you are engaging these kids with.
Well, so there really are several. I alluded to work that we did starting 10 years ago with Yale Center for Emotional Intelligence, and they have a tremendous program, which I'm sure you're familiar with, called Ruler, and that was targeting K through 12, and we adapted it with them for pre-K children, and it's embedded in our curriculum. All of our staff are trained in it, and it really does help both teachers and children to recognize, understand, and label their emotional state. The work we're doing more recently with Columbia Medical School is hugely exciting because that's actually not cognitive based. It's based on the autonomic nervous system, our biology, and the gut. And it's 2-generational. And so the results that we have seen are children through calming sessions, their behavior becoming significantly improved, and the mothers are becoming less depressed. So we think that that's a very exciting work. And then I would say in general, and again, we're a large center, we actually have nurses and family social workers on staff. And so we can intervene early on when we see dysregulated behavior. We can work with fellow agencies to refer for children who are more challenged in that regard.
Thank you so much, because it's so critically important that we are addressing this, as you said, as young as possible, because it really does lead to better outcomes and the more focus that we have on that. So, when I think about your CLC centers and others like them, I mean, it's not just what's going to happen to our economy if we don't have these childcare centers, if people are unable to work, but it's also the direct point that you just made in terms of making sure that when dysregulated behavior is seen, that it's addressed at an early age. So thank you so much for your testimony today.
You're very welcome. Thank you.
Thank you, Representative. Representative Comey.
Yes, hello, Mark, and thank you so much, Chairman. I was wondering, I want to thank you for your candid description of what's going on in the marketplace, and we've never appreciated the situation more than we have now. I'm wondering if you could share. I believe it was Representative Steinberg who discussed that grant funding would be available for some of the needs. Can you discuss a little bit about what happens with grant assistance when you receive it from the state, as far as timing and specifically meeting the long-term needs of, the sustainability of your programs and how that impacts directly?
Yeah, well, and first I'd like to say, and I think Senator Anwar referenced Build Back Better, and I think we were all excited about that, and I think we were all in some ways dependent upon it, and now we obviously have to readjust, because even if the childcare portion of Build Back Better passes, I will tell you it is likely to be too late to help many programs that are really now on the ropes. So now, again, we're a large center. We were supported by a PPP, but I think you may know some of this. 63% of programs in the state are running at a deficit. So they're gonna sink very soon. And 89% of programs have classrooms that are closed because they don't have sufficient staff. So when we see increase in funding, I mean, it basically goes to teachers' salaries and it goes directly to programs. In the state, I believe the average teacher's salary is $26,000 a year. Now, again, in my bluntness, right, the person who takes out my garbage gets paid more than this teacher, who, again, unlike public school teachers, they're 51 weeks a year. So, we're talking about living wages, and the wage compression that we're seeing really is dramatic. We can't compete with Amazon, who's paying a college graduate $19 an hour and a $3,000 bonus. And so there's a rippling effect from systemic underfunding. I'm not sure if I directly answered your question, but.
Okay, thank you.
Thank you, Representative. Senator Kushner.
I'll be brief, but I really do appreciate your testimony here today, Mark. I'm very familiar with the teachers, as you know, at your center. I've known them for 20 plus years, and the work that is being done in Stanford is wonderful and is so important. And so, but it is extremely alarming to know that all of this is in jeopardy. So I just wanted to give a shout out to you and the work that your teachers are doing.
Thank you. Thank you. Yeah. And by the way, kudos, because they are heroes. COVID hit in March and we reopened in April because the largest employer of our parents is Stanford Hospital. And so nurses couldn't go back to work if their children didn't have childcare. And so we opened in April, and we've been open ever since.
Thank you for that. Thank you, Mr. Chairman.
Thank you, Senator. And again, thank you for your testimony and particularly your candor. We need to hear the urgency of the circumstances if we're going to devote the adequate resources. So again, thank you. We're going to return to officials with Executive Director Veltri from OHS. And then next for the public is Patrice Farquharson. When we get to you, Patrice, I do note that you're in the room, but you have no visual. If you're interested in doing that, you might want to check to see if you've entered appropriately. Otherwise, we're glad to have you testify not in camera. Welcome, Executive Director Veltri.
Good morning, Representative Steinberg, Senator Anwar, Representative Linehan, Senator Kelly, Senator Wong, Senator Summers, Representative Pettit. Just an honor to be with all of you today, chairs, rankings, and all the members of the Public Health and Children's Committees. I'm Vicki Veltri. I'm Executive Director of the Office of Health Strategy. Before I really begin, I'd like to ask the committee to please promote my Deputy Director to a panelist at this time, if you can. She's here to join me, Kim Martone. I'll try to be brief since you do have our written testimony. We're commenting on 3 sections today, sections 36, 64, and 65 of House Bill 5001. Section 36 proposes to exempt the establishment of new mental health facilities and increases in licensed bed capacity from the CON statutes. We really respectfully request that the committee reconsider this section for a few reasons. They're in our testimony, but one, there are already a significant number of exemptions to the CON process for mental health facilities, including those licensed by DCF, among many other exemptions in the statute. So the majority of those that come to us are for-profit mental health facilities. CON process is already set up to allow notice to affected parties of an opening of a facility. It gives notice to neighbors, competitors, and potential patients and staff members. And adding a new reporting requirement that doesn't get to that kind of notice, I think would be duplicative and require additional staff time for us. Importantly, an operator of a facility really can't enter an agreement to take the insurance or Husky until they're up and running. So without having some kind of requirement ahead of time that or approval that they must take insurance or Husky in a review process, they could be up and running and never take either of those kinds of insurances. The other thing I want to address is, I know you talked, Commissioner Gifford talked a little bit about the hospitals, and Frank was on here for Yale. With respect to hospitals, hospitals do not need a certificate of need to repurpose beds for mental health purposes, as Commissioner Gifford noted. We have seen several hospitals, particularly in the Hartford area, do that. So that's something we wanted to make sure you understood. You know, we only really approve transactions for behavioral health facilities after we do a thorough review. And oftentimes we have to condition these facilities to take in-network, not just insurance, but in-network insurance and Husky. So without a kind of process to do that, I don't know how you would do that and have a facility ensure it takes it without going through the CON process. Finally, there's nothing in the proposal that has any consequences for any providers who fail to take in-network insurance or Husky, or provide any consequences for a failure to report on their activities. And the reporting is kind of ambiguous on what reporting on care for patients means under the bill as proposed. We know there are concerns about CON timeframes. The governor's budget has added 3 positions to CON. We think that will substantially reduce any kind of backlog. But while the need for mental health services is great, we really don't think we can sacrifice the quality, safety, meaningful access review that we do through CON to expand those facilities without some more review. Finally, on sections 64 and 65, where there's the intention of the committees to have a study on behavioral health parity and access parity, the governor has included $200,000 in the proposed midterm adjustments of coronavirus state fiscal relief funds to have OHS fund a comprehensive study for private insurance coverage of behavioral health services. As you heard from Commissioner Gifford, we would be working with DSS and CID on this study to help inform coverage and payment across payers and to try to address the issues between public and private coverage. So we would welcome discussion with the committee on that, those 2 sections of the bill, to see if we could align what the governor.
Excuse me, Ms. Veltri, your time is over. If you could please summarize. Thank you.
Good timing, because I'm actually done. I want to thank you for letting us testify today, and we're obviously happy to answer any questions you have.
Well, thank you for your testimony, and we're obviously very pleased to hear that the governor is aligned with our efforts, both in terms of providing you adequate staffing to meet your often prodigious CON workload, and also to do the study we need to for going forward in an effective manner. That's really important for us to hear. And certainly we want to engage with you to make sure we get a lot of this right. One quick question before I hand it over to Senator Anwar. You made mention of consequences, and certainly we want to have teeth in our legislation so that everybody involved plays by the rules. What do you envision by way of consequences if we're going to make this work?
Well, so let me answer the question. I'm going to be a lawyer for a second. I'm going to answer the question I wish was asked. So, so how things work right now is when people come through the CON process, and I will say, I know the CON process can be lengthy and arduous, but that's by design in some ways, because we want to do an absolutely thorough review on these facilities. And at times, CON has actually discouraged some questionable players from coming into the Connecticut market. But what we do is we tell every one of them, you will not come in here unless you take Husky, unless you are an in-network provider with a carrier. And that just doesn't mean being in network. It also means accepting patients. So you can be, credentialed to be a Husky provider. You could be credentialed to be on an insurance plan, but never take a patient. So we condition all of those things and make the facilities take that. So you'd have to have some kind of consequence for not enrolling in network agreements as an in-network provider, not just out of network, because that's not really insurance in my thought process. And Husky is the same thing. So we have the power with CON to hold people accountable if they don't meet those conditions. We can, there are penalties, there are things we can do to assure their compliance. I can't do that now in this legislation. So you'd have to have some kind of penalty with that. But Representative Steinberg, it sort of goes back to what I said before. Do you want a facility up and running and then say to them, oh yeah, we'll just report to you that we're taking, yes, we agree to take Husky. Yes, we agree to take, insurance, and they don't follow through. So we might have a facility here that's never taking Husky or insurance and has never been reviewed for their quality. And that's my big concern here. So I don't really see an alternative. And although we're obviously willing to keep talking with the committee about it, but I don't know how you put a facility in place with a promise to take Husky and insurance. Like we need them to have agreements before they start operating. You
raise a very good point. Obviously, there's a little chicken and egg going on here, but if we do not get them to participate, then we're not meeting the need. So we look forward to your input on how to craft this such that the conditioning is appropriate and that nobody gets off the hook.
Yeah,
Senator Anwar.
Committee.
Thank you so much, Mr. Chair. Thank you so much, Ms. Felty, for your testimony and the work that you and your entire department does. I wanted to share a perspective and share my concerns with you and anyone else who's watching or willing to listen to my concerns. Look, let's say you get the 3 positions that are there, which the governor has said yes to, which is excellent news. It's one of the most important news because you've been understaffed for quite some time. But if you look at the timeline for the DAS to get the positions, we'll be lucky if we see anybody in there in 6 months' time, at least based on the other openings that have not been filled, and that's an issue within itself. And then if we are going to reduce the CON process from 1 year down to 8 months, that is still too much for the children and adults who are waiting. We are in the midst of an opioid epidemic, which has not stopped. It's actually increased in the last few years. And we have now a behavioral health epidemic as well. There have been studies that have shown that the states which have CON and the ones who do not have CON, the health outcomes are no different. And now there's another study which shows that the mental health issues are beds and support that's available is 20% less in CON facilities, CON states. So between the lack of enough resources in your department and the number of people who are coming in, I almost feel that if we legislatively require the new entities, at least for behavioral health, to follow the guidelines, and if they are not for profit, they follow the guidelines, we should probably bypass them because there is a need in the outpatient and inpatient setting. So this is part of that that wheel that is not turning in the continuum of care, where, for a lack of a better word, the bureaucratic processes are killing new people coming in from taking care of our children. So I know we've had these passionate conversations. We're trying to fill in the blanks, but I feel that we could do better because the children are hurting. That's the issue. And the adults are hurting, and the opioid epidemic isn't getting any better.
That's for sure. We're both passionate about the issue. And, many of the legislators on the committee today may not know that I used to be the healthcare advocate for the state, and I spent significant amount of time. In fact, we helped get the Mental Health Parity and Addiction Equity Act of 2008 passed by the United States Congress. And this was a huge issue for us. For all of my time at OHA, mental health parity was probably our #1 issue, and we've worked on it forever. So I come to this discussion with that background. And I agree we need more capacity in the system, but there are many, many, many exemptions to the current process, including most nonprofits, school-based health centers, facilities run by the federal government, any nonprofit set up to work for a state agency or that is licensed to serve a state agency. There are many, many exemptions. Unfortunately, there are actors who have taken advantage of the opioid crisis and the mental health crisis to try to set up shop in Connecticut and to treat only a certain cohort of patients and to never take insurance. And that doesn't improve access to me. That just helps people who are rich enough to afford the service with no kind of quality oversight of the management of the facility, the records of the owners in other states, which sometimes have been very suspect. And there's no way to review that if you let them go outside of this process. So that's my concern. Having said that, that doesn't mean we can't sit down and try to figure out if there's some kind of compromise here. But I do think that's a very major concern of mine. As a person who really believes that we need more capacity in our system, I still have that concern. So I do think it warrants a lot more discussion. I don't think it's as simple as just saying CON is the issue. And I know you've cited these studies, but I have yet to see them. So I would appreciate, obviously, I'd appreciate you sending them to us so we can see them. But I do have these concerns. And I think as a state, you want capacity, but you want the right capacity. And you want quality providers. You want safe providers. You don't want providers that you don't need. You want providers you do need, providing the right kinds of services in the right locations with no concerns about their records or anything like that. So that's where we're coming from on this.
Thank you so much for your response. And Mr. Chair, if I may have a just follow-up comment, it's going to be short. In your list of priorities, I would just say timeliness would be a priority. Responsiveness should be a priority. And we should say that for an illness that is impacting and hurting our children, waiting for 1 year to get a facility as a bare minimum should not be acceptable to any one of us. And maybe we should say, hey, we'll do this in 2 months, made amongst the different priorities between the various things that people are hurting with. Let's do this in 2 months' time and make this a priority. If you can come to that, we can live with some of the oversight that you make a good argument for. But waiting for as long as we have is a non-starter for the children's well-being. So I'll just stop here. I truly appreciate you coming in and speaking and always being available for listening to my complaints and concerns and thoughts and being a therapist for me at times. But thank you.
Thank you, Senator, for expressing that. We could probably spend the rest of the day just talking about CON, but we do have over 200 people.
Yeah, and we're happy, obviously, Representative Steinberg, Senator Albert, everybody on the committee, obviously happy to keep working on the issue moving forward. We get the concerns. I think I've said to all of you, I'm as frustrated too, which is why we're so grateful to the governor for including those staff in our budget. But we are really close to winding down any kind of backlog in CON. That said, we're still open to obviously continued discussions about it. So thank you.
Thank you. Moving along, we're going to go back to the public. Patrice Farquharson. Patrice, we still can't see your picture, but if you're okay with that, we're okay with it too. Then we're going back to the officials and Commissioner Giutani from the Department of Public Health. Welcome, Patrice.
Thank you. Yes, I'm sorry, my camera's not working, so I'm okay with that. But thank you for telling me. So members of the Public Health and Children's Committee, thank you for this opportunity to testify on SB2. My name is Dr. Patrice Farquharson, and I live in West Haven. I have been the executive director of the West Haven Child Development Center for 40 years. The center serves 156 children from 6 weeks to 5 years. We've been in operation since 1978 and received child daycare funding, school readiness funding, a variety of additional grants, and we have a partnership with United Way of Greater New Haven to serve 16 early Head Start families, the only one to serve early Head Start families in West Haven, and the only one to serve infants and toddlers on a sliding scale in West Haven. So there's, as you know, there's a growing awareness among the general population that social determinants of health not only affect physical, but also mental health outcomes, especially in early childhood. Social determinants, particularly those that lead to toxic stress, can stunt a young child's brain development and therefore impact their long life health. At the West Haven Child Development Center, we have understood the importance of offering mental health programming to our families. The West Haven Child Development Center offers a comprehensive program recognized by the American Academy of Pediatrics as a medical home implementation model, whereby the professional resources of the teacher, the social worker, and the nurse work together to provide a support system for children. These professionals work together to provide health services, including mental health screenings for individual children, and provide information to parents about healthy practices. The Child Development Center emphasizes preventative care, which has been proven, as you know, to be less costly and more efficient than corrective care. This health collaborative is designed to fulfill our mission of providing comprehensive services to the families we serve. Our goal is to provide the continued comprehensive services to assure the optimum growth and development of the children in our program. We strongly believe in our approach to early childhood education. To continue this approach, we need to be able to compensate the teachers at the same level as the nurse and social worker. Esteemed members, we will not address nor improve mental health outcomes for children if we do not make the necessary investments in those at work tirelessly to provide healthy environments where children spend their formative years. I am here speaking to you today as an early childhood center director. However, I have been a professor of early childhood education for over 20 years. I know firsthand the difference knowledge has in creating quality environments for children. The teachers at the center are highly educated, but like me, they must work 2 or even 3 jobs to be able to financially survive doing the work they are passionate about. Many leave the field, and as a colleague had mentioned, to work at Amazon because they will be paid $19 an hour and receive benefits. Many leave for the public school because we cannot compete with a shorter workday, a shorter year, and summers off. We need to build up the systems of support that recognizes early childhood educators as the skilled professionals that they are. This year, we need a $700 million down payment on what should eventually be a $2.5 billion system that would enable parents of the 170,000 children under 5 to find high quality, affordable early care and education in the setting of their choice. In this system, we will be able to attract the best and the brightest to the industry. Additionally, we'll be able to maintain the vast knowledge, competence, and experience of the existing workforce that can create the environments for young children that will promote good mental and physical health. Thank you for your time
Dr.
and consideration.
Farquharson, your time is almost up. If you please
I'm all
summarize.
done.
Thank
All done.
you.
Thank you.
Thank
that
you.
was my last sentence.
Oh, good.
Well, thank you for your testimony and for being right on time. Certainly, I think everybody on this call would agree that we do not pay our teachers adequately, and we want to attract the best and the brightest. It's one of the most highly regarded professions, yet we do not compensate them for that. I would suggest a $700 million price tag, maybe gulp. Perhaps there's some way for us to accomplish at least some of that with a little bit more modest number, but we certainly take your point. Are there any questions or comments? If not, thank you for taking the time to testify today. We are very concerned about our ability to meet the needs of the education programs here in the state. So thank you.
Thank you.
Next up, we have Commissioner Giuttani from DPH, followed by Megan Villanova from the public. Welcome, Commissioner.
Thank you very much. And good afternoon, Senator Anwar, Representative Linehan, Representative Steinberg, Senator Kelly, Senator Summers, Senator Huang, Representative Dauphinais, I hope I pronounced that correctly, Representative Pettit, and distinguished members of the Children's and Public Health Committee. Thank you for this opportunity to testify today, and DPH is very supportive of the overall concepts that have been outlined in House Bill 5001. And what we have identified at DPH through this pandemic is the incredible mental health burden that this pandemic has placed, particularly on children. And I think that this framework that you have outlined is incredibly important to increase accessibility and to promote awareness about behavioral health and substance use in children. And what became clear as we started seeing increased number of children in our emergency departments is the access to inpatient behavioral health hospital beds and the shortage that does exist in our state. And DPH is incredibly focused on healthcare quality and safety. That is our number one mission in regards to behavioral health. And of course, licensure of practitioners as well. So in that regard, one of the things that DPH did in working with our other sister agencies was to obtain hospital data on bed availability. And this included emergency department bed availability and capacity, the availability of inpatient beds, and programs for children and adults with behavioral health issues. And in collecting these data, we were able to monitor shortages and participate in an incident command structure that was coordinated through the Connecticut Hospital Association, and then assist with hospital diversion requests as well in terms of emergency department patients to help facilitate movement of children from emergency departments to inpatient beds to prevent overcrowding in particular emergency departments. And what we hope to do going forward is, continue to work with all of you on expanding licensure reciprocity for behavioral health licensure categories and revise laws related to temporary permits for recent social work graduates. So overall, I just want to say that we look forward to working with the Public Health and Children's Committees to refine this legislation and work with you on the exciting programs identified. Thank you.
Thank you, Commissioner. And we truly appreciate the department's willingness to contemplate some ways in which we can streamline some of the licensing certification processes. We do not ask it lightly, recognizing how important it is to make sure we feel that those who are providing services to our citizens can do so in a safe and quality manner. But you're as aware as we are of the crisis we're facing and how important it is for us to get a little creative in figuring out how we can address the workforce needs. So we very much look forward to partnering with you to fashion a process that gives you confidence that we're continuing to honor our high standards. Senator Summers has a question.
Yes, good morning, or I guess good afternoon, Commissioner. My question is if you would be able to share the data that you have collected with the committee, that would be helpful on the bed availability and being able to help without, excuse me, from the emergency room to inpatient placement. I know that many of the people in my district have, that you may hear testify today, have really suffered in the fact that there is no access to healthcare for mental health issues in children, and therefore the child ends up in the emergency room, which we could avoid if we had some access to healthcare. And there has not been an availability of placement. They've had to go out of state for placement. So I think having that information that you just spoke to sent to the committee would be very, very helpful. I know that I have made calls on behalf, I've had physicians make calls trying to find placement for children in Connecticut, and at times in Eastern Connecticut anyway, it is an absolute desert. So I would love to see that data that you have. It would be very helpful. Thank you.
Thank you for that question. And so just to clarify what I was specifically referring to. So there was no specific reporting structure about behavioral health bed capacity, but because we were getting requests for assistance with diversion from emergency departments, we worked with CHA to stand up a reporting structure of daily behavioral health bed capacity in the state. And so at the moment, what we are getting is a daily report on the number of children and adults who are in emergency departments, and then bed availability that is coordinated through CHA. And because of the incident command structure that CHA has, they then work with the various hospitals in terms of who has bed availability and where patients that may be sitting in an emergency department waiting for an inpatient bed would potentially be able to be transferred to. And this has helped us in terms of being able to understand what is needed. And as Commissioner Gifford and Commissioner Durantes have touched on a little bit so far, there has been an increase in beds, not through CON, but as has been described, really through repurposing in some ways of certain beds. And so there were 17 beds, to my understanding, from working with the other agencies, of adolescent beds that have come on. But despite that, in the last several months, we still do see problems. And I agree with you that it is the throughput from all the different areas of healthcare services and behavioral health that can be provided in the outpatient setting to try to prevent children from ending up in the emergency department. But that is where we stand in terms of that data.
Great. So would you be able to tell us, for example, what the bed availability is today? Are we still continuing to track that? I'm not putting on the spot
Yes.
right now, but like today you could be able to tell us.
Yes, and I can tell you just for an example, roughly, that, over the last week, we've had, somewhere between 30 to 35 adolescent children in the ages of 13 to 17 who have been waiting for inpatient beds in the state. And we've had probably in the order of, 3 or 4 beds available on any given day. So every day that changes. And that is what the incident command structure is working on, to be able to, try to optimize placement of children who are waiting for those beds. And we're feeling it most in that adolescent age group. So we do have data on the various different age groups, but this is what we're working with CHA. And that just gives you a general gist of where things have been.
I appreciate that, because the wait time for care in our area sometimes is weeks lounging in an emergency room. So I just think it's great that you're tracking that. We can hopefully, I know you said it would help you understand what is needed. So I'm looking forward to getting those recommendations from DPH on what you think is needed. So thank you for your time today.
Thank you.
Thank you, Senator. Senator Anwar.
Thank you, Mr. Chair. Thank you, Commissioner, for your testimony, and thank you for the work you and your team do every day. Commissioner, I wanted to share a couple of thoughts. In the process of looking at these bills, we had a meeting with the Connecticut Hospital Association. And one of the anxieties that they have is that if they were to increase it, any of the hospital increases their beds, if they increase their mental health beds, they're sort of stuck with them in case they our needs change. Well, that would be a good problem to have, if the needs change, and they would have to keep those beds at all time available. So if there's a flexibility built into adjusting those beds, because sometimes the medical issues increase and sometimes the behavioral health issues increase, having that flexibility would reduce the anxieties in this investment, because there is a heavy investment in the personnel as well as in the space. So that was one of the issues that I think that was brought up. The other issue is for inpatient eating disorders in the state of Connecticut. I think it's a regional issue. From what I gather, the closest place now is Colorado for an inpatient eating disorder issue in this region, which is something that we as a state can do better. If you can help us with some of these things, that would be great. And I have one little follow-up as well, but might as well just put it right down. The 30 bed is what I've heard is the need for our state. And you sort of alluded to that as 30 people are always, at any given time, there are 30 children waiting approximately. If you can comment on that too.
So thank you for those questions, and just make sure I answer each of them. I'm going to take your last one first because I want to just clarify what I was saying. So what we've found, and I've learned this also through Commissioner Durantes, is that there are seasonal surges that we see with children's behavioral health. It seems to happen around the beginning of the school year, around October, and then usually another time around March. This is what she has experienced for a very long time. And so the numbers I was sharing about in the 30s is from this last week. If you look at the holiday time period, there were only a couple of children and there was no waiting period for any inpatient beds. So I just want to clarify that 30 people in the emergency department is not at any given time. There are times when there's no wait. I know that's hard to believe, but there are times where there's, or very limited wait, a couple of days. Not that that's really acceptable to be sitting in the emergency department for a couple of days, but that number of 30 is not a consistent number. So I just want to say that, as we're approaching the end of February, heading into March, this is what I think we're starting to see is the surge. And I will say that when this first came to my attention in the fall, there was a period of time when we were looking at, almost 50 children waiting for inpatient beds. So that's just to give a range of where things stand. Now, in terms of what is needed in the state, the flexibility around medical bed versus psychiatric bed. Some of that I, would also work with OHS to be able to see, what the flexibility is there. And I will ask for some input from one of my colleagues who's on the line as well, who might be able to speak to that, Chris Andresen. And the other question you had was, what was the middle question? I'm sorry, I forgot the middle question, Senator Anwar.
Eating disorder.
Yes, I'm sorry, eating disorders, right. So I think in this capacity, a couple of the hospitals have looked into whether they might transition some of their beds to eating disorder. I also do think that the proposal that the governor has put forward for CCMC could be potentially instrumental in this way. We know that for psychiatric treatment, when there's any sort of medical component as well, we just don't have that capacity in the state. And I am definitely supportive of the idea that CCMC could become a place where this would be available to children in our state. And I do think that it is a real struggle for families to have their children going so far away, whether it be for concomitant medical and psychiatric care, or potentially eating disorders, which is something that could be evaluated as well, if that could be included as part of the CCMC plan. And
thank you so much, Commissioner.
Yeah, thank you. I don't know, Chris, I believe you're on the call as well. I don't know if you had any other comments or thoughts about specifically the issue of converting medical beds and surgical and psychiatric beds.
Yeah, I don't right now. I started a conversation with some of my colleagues in facilities, and this was one of the issues that came up. But at this point, I'm not sure how that happens within facilities. So, but we can get that information.
Yes, and we can get that information to you, Senator Anwar. I'm sorry to put Chris on the spot. He's more our practitioner licensing expert. But.
Thank you so much. Thank you, Mr. Chair.
Thank you, Senator, and thank you for your willingness to discuss that. It's an issue that keeps coming up. We're going to need your help if we're going to make sure that we have the beds where we need them. So thank you. I don't see any further questions. So thank you for your testimony today, and we look forward to talking with you very soon as we try to shape this bill up for passage. Next up is Megan Villanova, followed by, I believe, Werner Oyenadel from, well, that's a long acronym. In any case, Megan, welcome.
Hi, thank you. Members of the Public Health Committee and Children Committee. My name is Megan Villanova, and I'm a Master of Social Work student at UConn. I'm here to testify in support of the goals of House Bill 5001, an act concerning children's mental health. As a resident of Tallinn, I want to specifically thank my state representative and town council member, Tammy Nuccio, for co-sponsoring this bill. I'm interning at Connecticut Citizens Action Group, which is a statewide membership-based organization dedicated to actively engaging the residents of Connecticut to alter the relations of power in order to build a more just society. Within CCAG's education equity team, we have been working with communities around the state on their priorities and goals, and to ensure community feedback is taken into account as school districts and communities spend federal stimulus dollars. We have conducted a survey as well as meetings with these stakeholders, and time again, mental health has come up as one of the main things that we need to focus on. We found that 37% of people believe that social, emotional, and mental health of students and school staffs should be first priority in this spending. Many written responses included the need for more school social workers and counselors. It has become clear to us through these surveys and speaking with these stakeholders that when schools do have people in these positions, they are often overwhelmed with more students than they can handle. As stated in Connecticut News Junkie, less than 25% of elementary schools have a counselor, and the ones that do may be working with 400 to 600 students at a time when many of them need help. In the National Association of Social Work's recommendations on addressing children's mental health in Connecticut, they suggest that there be one social worker per 250 students. In our meeting of parents, teachers, and education advocacy leaders from across the state, we discussed how to move forward with our advocacy. Many people brought mental health up as a priority, stating that COVID has exacerbated these issues in children. The U.S. Surgeon General's advisory for 2021 stated that in the last few years, mental health has gotten worse for our youth, citing the weight of the pandemic and media to be contributing factors. Surgeon General Dr. Vivek H. Murphy recommended that our state government ensure mental health resources be available to our children so we can work together to avoid this potential public health crisis as a nation. Thank you for your time and consideration.
Thank you for your testimony today. You mentioned that the challenges of having so many students per counselor. Do you have any frame of reference? Is there an ideal target in terms of that ratio?
Yeah, so the National Association of Social Work for Connecticut has been, their recommendations on addressing children's mental health in Connecticut, they suggest that there be one social worker per 250 students.
That's still a large number, but maybe we can get closer to that. Thank you for your testimony. I don't see any other questions, but thank you for your patience, and we really appreciate your input in this case.
Thank you so much.
Next up, we have Werner Yanadel from the Commissioner on Women, Children, Seniors, Equity, and Opportunity, followed by Meg Scada, if I have that pronounced that correctly. Welcome, Werner.
Yes, I am here also with my colleague, Tomas Nuccio, and I would love if he could actually be given access to the room. I believe he's already here with us.
He is here with us, and I'm sure he can jump in as you need him.
Thank you. Dear committee co-chairs, ranking members and members of public health and children's committees, my name is Werner Ollanadel. I am here with my colleague, Tomas Nuccio, a policy analyst of the CGA's Commission on Women, Children, Seniors, Equity, and Opportunity. We are pleased to testify in support of Senate Bill 2 and HB 5001. For the record, our written testimony has been submitted. Both proposals discussed today would provide, if passed, a comprehensive approach to enhance mental health services, which encompass schools, healthcare settings, insurance eligibility, screening tools, and much more. Legislation which aims at dealing with the behavioral health crisis affecting children and families in our state. Thomas, will you further discuss?
In January 2022, the United States Surgeon General declared an unprecedented national youth mental health crisis, acknowledging the pandemic's toll on children. The Commission has hosted a two-part webinar series, which is focused on the firsthand lived experiences of children and their families who are experiencing long-term needs for mental health treatment and the necessity of passage of comprehensive mental health reform. As a result of these webinars and information collected by our subcommissions, we have identified children's mental health reform as a top priority. Today, we would like to emphasize just a few areas of importance in these bills. First and foremost, we must fully fund existing service array by funding outpatient and intermediate levels of care to create more access to mental health services for all patients. Additionally, we would like to emphasize the importance of workforce development in these bills, such as meaningful tuition reimbursement, grants, loan payment assistance, and cost of living increases, which will assist with the direct recruitment and retention of staff to help address behavioral health worker shortages. With that being said, I would like to turn it back over to my colleague Werner to discuss additional sections of the bill.
We also highly commend the new based state licensure fee scholarship included with preference to diverse applicants who are pursuing licensure in occupations that serve the mental health needs of children and adolescents. HB 5001 also creates a new statewide educational advertising campaign that will help promote the availability of all these new prevention services. A statewide campaign that we highly recommend must be drafted and delivered in a linguistically and culturally appropriate manner to help us reach out our most vulnerable populations in our state. In summary, the Commission urges the legislature to pass Senate Bill 2 and HB 5001, making sure the following concepts are included or at least considered. It is essential, number one, it is essential to invest in the workforce, expand critical services, and improve quality. Recognize that mental health is an essential part of overall health. Empower youth and their families to recognize, manage, and learn from difficult emotions. Ensure that every child has access to high quality, affordable, linguistically and culturally competent mental health care. Include or improve the collection of
Excuse me,
data on
Mr.
race.
Udell, your time is almost up. Please summarize.
Two more
Thank you.
bullets. Include or improve the collection of data on race, ethnicity, and language for those who are forced into psychiatric treatment to determine or confirm how large these disparities exist and how to remedy them. Support the mental health of children and youth in educational, community, and childcare settings, and expand and support the early childhood and education workforce. Finally, but not least, we need to address the economic and social barriers that contribute to poor mental health for young people, families, and caregivers. Thank you.
Thank you for sharing your insights. Obviously, you live in this space with these issues every day, so we very much appreciate your contributions to this, and particularly for pointing out how important it is that we communicate with everybody in the state and in a language in which they can fully appreciate. So thank you for pointing that out. I don't see any further questions, but we look forward to your continued input. I made an error. It will not be my last, but I skipped over number 36, Jose Sarmiento, for which I apologize. Meg will have you after the next public official. My apologies. So we will have Jose followed by Sarah Egan from the Office of the Child Advocate. Jose from Yale College Democrats. Bula Bula, it's all yours.
Hello. Good afternoon. My name is Jose Sarmiento. I'm a first year at Yale University, and I'm here today to express my support for Bills HB 5001 and SB 02. As a young person in Connecticut who regularly interacts and has interacted with other adolescents experiencing the issues meant to be addressed by these two bills, I wanted to give the committee some perspective into what this issue means to young people across the state and across the nation. Now, I feel that raw numbers and percentages too often obscure the truth and severity of an issue, its real impact and societal implications. So I've chosen to stray away from this method of evidence for just this first section of my testimony. And I want to start off with no numbers, no percentages, just stories and human experience from my very own teenage eyes. So I was 14 when I went to my first funeral. I'd only been in high school for about 4 months when I got the news that one of my friends had taken his own life. With no warning, this issue, which was once foreign to me, was now all too personal. Suddenly, the strange cuts on my friend's wrists had new meaning. The panic attacks, once jokingly referenced before assessments, now seemed to hide a much darker truth about my classmates, and my ability to shrug this issue off as some consequence of teen hormones was gone. Worse, however, was that I felt like I had no one to turn to. Sure, we had some mental health resources, but it always felt as though they weren't enough to truly attack the underlying issue. I mean, I showed up at school one morning and my friend was dead. That's how I learned how this issue works. There's no takebacks. There's no easy way to get rid of that pain by yourself. There's no way to reverse time and change the outcome. There's no definitive solution, just guilt and a cafeteria full of 14-year-olds crying because their friend was gone. So after years of seeing more and more friends suffer from specifically depression and anxiety, I've come to realize that there are many preventative measures that can be taken, and I can confidently say that the measures introduced in these bills are many of these. So later high school start times, for example, mentioned in HB 5001, is an extremely useful and necessary provision in Connecticut. I mean, right now, Connecticut is one of 4 states in the nation with the earliest high school times. The average high school start time across the state is before 7:45 a.m. And in comparison, California, which in 2019 set a higher minimum high school start time, starts no earlier than 8:30. Studies have shown a causal role of sleep in the formation and maintenance of mental health problems. So the benefits of this late start means that teenagers can get more sleep. So as it has such a foundational role in mental health, allowing teenagers to sleep may actually save lives. Other provisions like universal pre-K and increased pay for pre-K teachers targets many issues that are directly related to mental health, yet so beneficial in other ways. And I'm glad to see the creation of a new position, the trauma coordinator, solely focused on these issues, finally giving them the prioritization that they deserve. I mean, this issue deserves to be treated with the utmost respect. And honestly, I feel that it has been ignored for far too long. Children are suffering every single day in this country. And I mean, I'm one of them. My friend was one of them. My classmates then and now are some of them. They need help, and many of them are not going to ask you directly for it. So please help them while you still can. Thank you very much for your time.
Thank you so much, Jose, for your very heartfelt testimony. We truly appreciate it, and we cannot thank you enough. And I'm so sorry for your loss, but also we want to make you be aware that we are all in this together, and then we are here as the leaders to do our share. But thank you so much for that testimony. I will have Representative Linehan. She has a question or comment.
Thank you very much, Senator. And thank you, Jose, for coming and speaking to us today. Your input is so important and your perspective is so important. We did write this bill for you. Something that many people don't know is that this is a combo public hearing with the Children's Committee. And anytime we have a young person come and share their experience with us on the committee, the chairs of the committee do offer a special pin because we know how difficult it is to talk about these things, and we know how brave you must be to talk about this. So before you sign off, if you could reach out to one of our staff members, the email address, and let us know where we can send you that, because it is something very special that only a few people, we want to make sure that you get. There's nothing that we can truly do to thank you for your bravery, but this is something that the Children's Committee does offer to young people who testify. So thank you very, very much.
Thank you, Chairwoman Linehan. Representative Foster, please go ahead.
Jose, thank you so much. Thank you, Mr. Chair, for allowing me the opportunity to speak. Jose, thank you so much for testifying. I just wanted to say, as a member of this committee and faculty jointly appointed at Yale, Yale is very lucky to have you. Congratulations and good luck with your studies. I too lost a loved one very close to my family to suicide when I just started college, and it had a resounding impact on me in the years that came afterwards. And bearing your soul here today was really hard, but a lot of research scientists, those everything, because if we can't contextualize data in real life and real people, it becomes really hard for us to do this work. So like Representative Linehan and Senator Anwar shared, thank you so much for sharing your stories. Thank you for being here today.
Thank you so much. Thank you. It means a lot that I had the opportunity.
Thank you, Jose. And our next speaker is our Office of Child Advocate, Sarah Egan. Followed by the next person is Meg Scada. And so, Ms. Egan, thank you.
Thank you, Senator Anwar, and good afternoon to all the distinguished members of the Committee on Children and Public Health. This testimony is being submitted on behalf of the Office of the Child Advocate. I am Sarah Egan, and I run the state's Office of the Child Advocate. The obligations of the OCA are to review, investigate, and make recommendations regarding how our publicly funded state and local systems meet the needs of vulnerable children. And I too want to thank Jose for his powerful and brave testimony in front of this committee. And I think it's an appropriate place to start as I was thinking about what to cover in my now 2.5 minutes left of testimony. But the OCA, as many of you know, is also the state's co-chair of the State Child Fatality Review Panel. And it is my unfortunate role to tell you that over the last year, I have seen there have been more child deaths by suicide than I have ever seen since being the child advocate. This is my 9th year. There are 14 deaths by suicide of children, and multiple children as young as 11 and 12 years old, which is the worst outcome, of course, from all of the things that we are talking about today. But every single one of those deaths was preventable. And to contemplate the despair and the impulsivity and the developmental status of those children who are taking their own lives, and how much they and their families need us to make what I think other speakers have referenced today. And the main theme of my testimony is the need for transformational change out of this crisis. For our children must come transformational investment and sustainability and oversight of our children's behavioral health system. We have also seen unprecedented numbers of children homicides. I think this will be, also in my years as the child advocate, the highest number of child deaths by homicide, likely to be 20 in the last year, children ranging in age from 4 weeks old to 17 years old. A couple of other things I wanted to highlight for the committee today. Number one is, as we look at the array of services that children need, there are several groups of children that are chronically underserved by the current service array. And one of those groups is children with intellectual and developmental disabilities. You have my written testimony on that, but I want to be clear that the array of services we have today, including Medicaid funded services, are not available. They are not all available to children with intellectual and developmental disabilities. Not a week goes by that the OCA is not working with a family whose child is stuck in and out of emergency departments or stuck in an inpatient unit at Yale or somewhere else, who can't leave, who can't get what they need because they have an IQ under the age of 70. That is a huge problem for the state of Connecticut that cannot continue. But it leads into one of the other points that I also wanted to make is, why does that problem persist? We have been working on that for years and years. I participated in a subgroup of the MAPOC. I cite some of this in my testimony today, that in 2018 also reported out, this is a huge problem, these gaps in the continuum of care for children with intellectual and developmental disabilities. And I would submit respectfully to you that one of the reasons that that hasn't gotten better is because we do not have the right governance and coordinating structure to provide oversight, accountability, and to pull the initiatives that the state has around behavioral health together. And that problem also has to be addressed in these efforts to transform our behavioral health system. As we look at putting in resources.
Excuse me, Ms. Egan, your time is almost up. If you would summarize, thank you.
Yes, thank you. As we look at the transformational investments that the legislature is looking to put in here, we need to also think about what is the structure that is going to bring these things together. The data, everything from school-based mental health to community-based services, needs on workforce development, utilization, access, and outcomes, has to live somewhere in a public and accountable way, staffed and supported to inform investments and policymaking over time. So I say that with all due respect to the tremendous work that is underway in the state, but we need that robust oversight structure for this part of our healthcare system. Thank you very much for this opportunity to testify and for all your tremendous work tackling this important part of our healthcare system. Thank you.
Thank you so much, Ms. Egan. Thank you for your testimony. And we've had the opportunity to hear some of your thoughts on this very topic as well. Are you aware of the conversation that is happening about having a cabinet where all the agencies sit down and focus on the children's behavioral health, mental health issues? And do you think that should be able to help address some of these areas, if you will?
Yes, thank you, Senator. So I heard that today from Commissioner Durantes, and I know that there's been conversation amongst agencies and advocates about how to create a structure that'll work better. I haven't seen any language on that, so I'd have to, the devil's in the details on how that would actually work, who's part of the cabinet. And what they're producing, what they're asked to produce, what the mandate is, what they're reporting out on, right? It's all of that would be really, really important. Who participates, who doesn't. But structurally, I would say, and again, I offer this respectfully, right, to all the work that's being done. It would take a lot to convince me that a single branch governance structure is the right one for an area like this that is an essential part of public policy, and for which the legislature has a tremendous role in policymaking and investment. And I would point the committee, and I have this in our written testimony, to a behavioral health task force that was created a couple of years ago in Colorado by their governor to tackle some of the very transformative issues that our state is looking to tackle now as well. And that was an inside-outside structure to look at the very things that I think we are trying to understand better as a state and to inform their investments as well going forward. So, I have an open mind. I look forward to seeing what the proposal is, but my instinct is that it needs to be a multi-branch effort and not a single branch effort.
Thank you again for your comments. I just want to add the conversation that we are having right now at this moment is a conversation many other states are having. And it looks like the state of Oregon had come up with a plan where they are saying that there needs to be a behavioral health administration, a separate entity, just looking at that because it intersects with so many different components between DMIS and DPH and DCF and DSS and DDS for that matter. And as a combination of these, you need to have a separate agency assessing this, but if there is a cabinet where there's a conversation that happens and they're able to fill these blanks, there is going to be an opportunity, but we need to have a feedback loop to make sure it's working. And I think your office is well poised to be able to be part of the feedback loop, and then you probably should be part of that cabinet if there was a way to look at it. I'll share the language as soon as it's available. It's cooking right now, but thank you for your conversation and so much thought into what you share with the committee and the Children's Committee many a time. So appreciate that. I know Representative Zupkus has a question for you as well. Representative Zupkus, please.
Thank you, Mr. Chair. Hi, good morning, Sarah, or good afternoon. Nice to see you. And I appreciate your comments about, the problem persisting and really analyzing. What I'm interested in is looking at the programs that we fund now, and are they working or are they not? And if they're working, keep them. If they're not, let's stop funding them and do what's working. My other question, my question to you is, looking at this piece of legislation, we're creating programs to help with mental health, but will this get to the root of the problem? It's one thing to treat it and work on it, and it's needed, but we need to get to the root of what the problem is. And I heard you say, I believe in the beginning, that, suicides and all these issues have skyrocketed over the last couple of years. So why is that? What is the cause of it skyrocketing, number one? And number two, will this piece of legislation get to the root of the problem?
Thank you, Representative Zupkus, and always good to see you. I missed you from your days on the Children's Committee. Boy, I don't have the answer to question number one, and I've been asked that. That's the question, right? Is what is driving this increase in behavioral health acuity? Right? Because that's part of what we hear from families and providers. It's not just the number of kids seeking treatment, but it's that they're younger than they were and their level of acuity is increasing. And that's a trend that preceded the pandemic. So for example, suicide has risen in pre-pandemic to be the second leading cause of preventable death in children starting at age 10. Right. So that's a nationwide trend. So I think there are lots of things driving that. And I think that you're right. We have to get at those root causes of how we support children really from day one. One of the things I love about Senate Bill 2, though I know there needs to be more language put on there, is that emphasis on early childhood supports and some of the prevention work that has to happen. I think the provisions of the bill also that address integrated primary care, I would also classify as prevention work. But you're right that it's that prevention work is enormous and a huge part of what we have to focus on. I would add school to that as well. I mean, it is another area that I think needs transformational change to be able to support teachers and students at the levels that they need. I also echo your comment, Representative Zupkus, about needing more data about how services are accessed, how well they're working, and who benefits from them. I think we have a dearth of that data right now. We have some, but we don't have as much as we need, and it's not adequately informing the investment and policymaking process. And so that's part of what I would envision for a governance and oversight structure. Really needs to look at where are the dollars coming from, what are they funding, who's accessing them across payer systems and regions of the state, and are they working for children and families? And to your last question, I think there's a lot in this bill that while most of it comes from a treatment, these two bills, and most of it comes from a treatment lens, we need that. We do need, we need innovation, but we also need to fund and expand the service array that's out there in the communities, the outpatient clinics, the hospital beds. So we do need that treatment side, but thank you for your question, which I think highlights that prevention need as well.
So where would we get that data, number one, that we're talking about to see what's working and what's not? These things that are being created that are new things, don't some of these things exist already, or things that we have been working on already?
So to answer the first part of your question, the data on utilization and quality. So there's Beacon Health Options, which is under contract with DSS and DMS and DCF, would have, I hope I got that quite right, but they would have a lot of the data, particularly on the Medicaid side, right? But that's a big population in the state, of what services are being utilized. They would also have some quality performance data as well, though the scope of what they have, would have to take a look at. And then we have pockets of services that are considered evidence-based. Connecticut's actually a leader in the country in investing in evidence-based services, and a lot of credit to DCF and DSS for that investment, right? So we have that data as well. But I think we don't have the data at the level and breadth and ease of review that I think you would want to have, right? And we need to also integrate the Medicaid data with the data on the commercial and self-funded side, right? To see, because you don't just want answers about, I mean, the state can produce for you weekly how many kids are in the ED and who are Medicaid kids, right? But we need the whole other part of the picture as well. And I think integrating the data from, let's say, the Office of Health Strategies and their all payer claims database with data from the Connecticut Hospital Association and data from Beacon Health Options on the children's side is part of where we need to get to. So referencing Commissioner Durantes' written testimony, which I did review this morning, her vision for a cabinet that is looking at and producing public outward-facing data is really important. And I think that has a lot of value to it. And again, I look forward to seeing that language, because I think that has to go hand in hand with the kind of work that the committee bills are contemplating.
Thank you.
Thank you so much.
I would appreciate it if you would send me or the whole committee, really, that you know a lot more about this than I do. And so if you would send me what data would be greatly important and where to get it from, or to the whole committee, because that's something we as a committee should look at, in my opinion, before this bill, we put it into this or how to move forward with it. So thank you, and good to see you again.
Thank you so much for your questions. I was going to say Dr. Egan, Ms. Egan, would you be able to clarify? You're saying that the DDS clients are not Medicaid clients?
No. Many of kids who are eligible. I'm sorry, I just want to understand the question. Kids who are eligible for DDS.
You mentioned about the developmentally challenged children were not covered by Medicaid. So I wanted to clarify that a little bit.
Yeah, let me maybe I said that incorrectly, because I'm trying to cover so much so fast. The issue I was talking about there, Senator, is that kids with intellectual and developmental disabilities do not have the same access, not because they're not covered, right? Some are covered, but they can't access all of the services in the continuum of Medicaid funded services. For example, PRTF level of care, which is subacute, some of the intensive in-home services that are covered by Medicaid, not because they don't have the coverage, but because they have an intellectual disability and therefore are denied access. So for a very concrete example, it is not infrequent that OCA will be called when there's a child either stuck in the ED, right? And kids with IDDs tend to stay the longest in emergency departments, days, if not weeks, because they don't have the same access to services in the community or to subacute settings. So if a child just this last week that came to OCA's attention, who's been in and out of hospital inpatient, is recommended for step down, or what we call PRTF, or subacute level of care, which would be, a bed in a subacute facility. There is no subacute, and I'm going to use that term because people are more familiar with it. There's no subacute facility in Connecticut that includes a couple of state contracted and 2 state run that will admit a child with intellectual disability, particularly one, let's say, with an IQ under, let's say, 65 or 60. They won't. Children have no access to that. From a residential treatment perspective, there's one provider that takes children with IDD. So we do consistently continue to see children be rejected from settings or from certain services because of IQ or an ASD diagnosis. I raised the Medicaid issue there because I think that's also, to be frank with you, I think that's a legal problem for the state of Connecticut as well. But it's certainly a service delivery problem.
Okay, so I'm just trying to think, does this need 3-4 people to be in the room to fix this, or do we need to put it in writing in a legislation?
Well, I wish it only took 3 or 4 people in a room. I would like to see the legislation specifically reference that. I mean, to the extent that there's going to be dollars for behavioral health urgent care, dollars for PHP and IOP, dollars for, I would like to see language that specifically says that dollars have to be allocated to ensure access to chronically underserved populations, including children with IDD. And I would add to that justice involved children as well.
Okay, this is very helpful. I think the other things, the dollars are there and that they are part of the bill, but I think it's worthy to try and see if there's an opportunity to improve on the bill a little bit. And the earlier question that were raised, whether we are putting new programs in, actually, no, we are enhancing the programs because the needs have increased. So just so that there's no confusion for anybody listening in, we are not creating a new machinery. We are strengthening the machinery that has been there, except that the machinery has these areas where there's not been enough investment in it, and then those parts have to be improved. And that's what the bill is basically doing in a very simplistic manner, but it needs tweaking in some of the areas that you have alluded to and beyond. Thank you so much for your testimony. And every time I hear, I feel I'm smarter than before. So thank you.
Thank you. Thank you, Senator.
And the next person we'll have public, and then we have somebody from the leadership of our state. So I think the next person on our list is, I saw the name earlier.
Meg
Well,
Scott.
I'll just read it then. Meg Scott. Yeah. Meg,
Yes, here I,
go ahead,
hi,
Meg.
good morning. Here I am. That is quite impressive testimony from Jose and also from Sarah Egan. I come to you this morning. It's an honor to be here. I am a representative for CABE, the Association of Boards of Education, and I'm also a member of the Board of Education in Portland. I represent 150 school districts that are members of CABE and thousands of students. And I'm here to speak to you as someone who has been working with children all of my life. The bills before us today represent comprehensive efforts to address issues of mental health in our schools. And in my work with the board and the community, I feel that this is critically needed for building the capacity of personnel, programs, and community resources. My recent work in youth services and the Juvenile Review Board have demonstrated that adding counselors and social workers without additional funding to create programs and community resources will impact the mental health of our students and will also impact their academic life. CABE supports the use of statewide surveys to determine employment of social workers and understand district needs. The timeline should be sooner rather than later if we do end up with a survey. The establishment of a grant program for hiring and retaining student mental health specialists based on need is also important, and hopefully that would be a benefit available to all districts, particularly rural districts that have a greater need and less money for that. School counselors do not come under the definition of school mental health specialists, but they do play a role in recognizing the needs of students, and CABE would certainly advocate for assisting districts in hiring more school counselors. CABE supports the establishment of a grant to districts for school-based delivery of mental health services, including trauma-informed practices. In developing school mental health services, districts can save money for expensive out-of-district placements, keep students in school with their peers, and then ease reentry into mainstream classes. Youth services and juvenile review boards were given the responsibility to handle truancy issues in their local school districts. Referrals can be made by schools and parents, and we need a comprehensive plan to move the schools to make those referrals, provide the resources to assist schools, parents, and students to identify the reasons for truancy, and have the resources bring the students back to pursue their education. Punitive measures will not work with the need for alternatives for solving the truancy problem. The timing of the Department of Education to create a truancy intervention model by 2023 and boards of education to create their own policies would seem not well timed, and we would urge that that date be reconsidered. Establishing a peer-to-peer mental health program for staff and school resource officers to be trained and would be available and be beneficial to have more students for grades 6 through 12 gain confidence and skills in managing their own mental health.
Excuse me, Ms. Scott, your time is almost up. If you could.
Okay, I'll
Thank
go.
you.
Yep, school specialists also should be available, and funding should be included for that. I would go further to request that the committees re-examine some of the previous legislation in 2021, the social emotional learning and restorative practices legislation, and also school climate. These are practices that have been on the books, and I believe that funding may not always be available, but I believe that they serve the purpose, and I'd like to see the framework built on those previous legislations. So thank you for your time, and thank you for your time.
Thank you, Ms. Scott. And I have Representative Carpino who has a question or a comment.
Thank you,
Oh,
Mr.
yes.
Chairman.
Go ahead, Representative.
Hi, Meg. Thanks for being
Hi.
here.
Yeah, you're welcome.
I just have one question for you, since you indicated you were here in your CABE capacity. Has CABE, I always get concerned when we have to legislate things that can be done on their own. And what you see before you is a bill that many people have worked on, which is, why I think we're all very proud of where we are now.
Oh, it's a wonderful
way to go.
Yep.
So has CABE, it's a very simple question, has CABE tried to do the social worker survey, for instance, on its own? CABE has tremendous resources. Have they done that? And what are the results if they have?
We do have tremendous resources, and we do surveys of our districts from time to time. I can't speak to whether or not they've done the social worker survey, and if that would be helpful to these committees, we would be happy to take that on. I know we're looking at excessive cost surveys right now in districts to discuss that at the Education Committee. We do have resources to do that with our 150 district members. So I would suggest that I will talk to Patrice and to Robert Rader, and we'll see what we can do to get that data for you.
Thank you. And I appreciate that. My point only being is sometimes we don't have to wait for legislation when we have avenues available.
Yeah, and I agree. The thing is that schools do so many data collection reports to various and sundry committees. Sometimes we just add more bureaucracy. I personally, for speaking for me, the survey would be helpful, but I think we already know that we need more social workers and more mental health workers. Opening that up would certainly allow us to do more mental health work in the schools. But the problem is that we know the problem. We just don't have the community resources. As somebody pointed out, in Eastern Connecticut, it's 3 to 4, 5, 6 weeks before somebody can actually get to a counselor. And if they don't have cash and the insurance doesn't cover it, what do you do then? And I think that's a big part of the problem. We can throw more money at more personnel, but if we don't have the resources in the community and the programs, how do we fix it? If a kid is truant and there's transportation issues or mental health issues, what do we do for that child to bring them back into the school to the school setting? This really is a very large problem. And when I sit where I sit at the Board of Ed, when I've been in the school system, I see how things work. And I do see the trend upping more behavior that starting at kindergarten is really upsetting. I think, we're doing a lot of different things. I like the idea of bringing all the mental health services together to talk and have a cabinet discussion on a very big level, to a global level, to look at this.
Thank you. With 2 kids in the schools, I see it every day, particularly after the masking with the increased needs. And I agree with you. And I've been saying this for a while. I think one of our major issues is the lack of providers and the lack of providers to treat our students, regardless of what program they're in. Thank you, Mr. Chairman.
Yeah, that is part of the problem. Summer employment, keeping these kids busy. There's a lot of things that go into the mental health of students as well.
Thank you so much. Can I clarify something too quickly?
Sure.
In my conversation with some of the groups, it was suggested that some school systems do not share their social workers or counselors with youth services bureaus. Do you have a pattern or a position on that?
Well, I was luckily appointed to replace somebody who retired in the Youth Service Bureau in Portland. So in July, I started and immersed myself in it. And we hired a wonderful young man who's now the administrator. I'm this consultant. What I saw was a breakdown between our schools and the Youth Service Bureau in our town where referrals were not being made. We've now bridged that conversation. And so we're not sharing counselors at this point, but we're sharing conversations. And we've had 2 or 3 circumstances where students have been referred to the Youth Service Bureau and the Diversionary Board. And it turns out that it's not just a truancy issue. It's not just a they got caught vaping or whatever with substance abuse. There are mental health issues involved. And it has taken us a while to find some community resources, and that's what's lacking. And if the school, in our school right now, has an SBDI grant to look at the diversionary initiatives that the school has, are they doing enough? And that is a year-long study that will take place, and hopefully we'll understand the gaps that the school has. I think we need to look at what we've mandated youth service bureaus and diversionary JRBs to do and make sure that they're funded in a way and make sure that the information is there for schools to use those services, because that is a community resource. And that's just one small part of it.
Thank you so much for your testimony. We appreciate your words. And the next person on my list is Commissioner Bai, but I also have Mayor Elicker, but I wanted Commissioner Bai's permission to take Mayor Elicker before I bet Mayor Elicker has to oversee some cleaning up in
that's fine.
New Haven.
That's fine.
Okay,
Go ahead, Mayor Elicker.
Thank you.
Thank you, Senator. I hope you mean snow cleaning up. There's a lot of snow cleaning up going on here. Thank you, everyone, for giving me the opportunity to testify today. And it's always inspiring when I hear so many people come out and share their own personal stories. I just wanted to, in particular, thank the Public Health Chairs Steinberg and Abrams, and the Children's Committee Chairs Linehan and of course Senator Anwar, and ranking members and the members of the committee. On behalf of the City of New Haven, I'm here to testify in strong support of both Senate Bill 2 and of House Bill 5001. As we all know, Connecticut's young people are really struggling right now, and the impacts of the pandemic have been severe and, of course, exacerbated a wide range of existing conditions that affect the child's success and their well-being. And while the impacts have surely been felt statewide, they've not been felt equally. And our young people deserve an environment and an ecosystem of programs and opportunities and support that address the underlying factors that impact their physical, mental, and emotional health. They need to be tailored to the individual's needs and targeted to those who need them the most. I think the goals set out in SB2 and the provisions detailed in HB 5001 are both laudable and vital to improving mental health landscape for our young people. In particular, the provisions would allow municipalities like the one I represent, New Haven, to receive grants to hire more social workers and school psychologists that are desperately needed. In addition, the efforts to expand healthcare coverage to mental and behavioral health services will help create that ecosystem of support that I talked about. And the investments to build up our mental health care workforce is essential for the success of this initiative. I also believe that these pieces of legislation can go even further. Mental health is, of course, about clinical supports, but there's a wealth of evidence that underscores that positive engagement with peers and mentors, involvement in productive activities, and a sense of purpose are also vital to one's mental health. There's no dedicated, consistent state funding system for after-school programming, so that over 200,000 young people in our state go without trauma-informed strategies can be implemented not just in our schools, but in our engagement with justice-involved youth. And employment and summer opportunities can be dramatically expanded with more resources to municipalities and nonprofits to build upon that work. We're doing that in New Haven using some of our American Rescue Plan funding and our own general funds. Our investment in young people, however, must be more significant and must be long-term. So I'm hoping that we can work together with the state legislature to strengthen the supports that we provide for our young people. And thank you so much for your time.
Thank you so much, Mayor Elicker. Thank you for waiting and in your testimony. Anybody has any questions? I just wanted to thank you and all the other mayors who have come up and shared the concern locally, where it's much more near to your towns and the cities where you're hearing directly from the parents and in the school system. So thank you again for your words today and your testimony.
Thank you, Senator.
Okay. Thank you. And the next person on our list is Dr. David Johnson, followed by Commissioner Bai. Mr. Johnson. Sorry.
Welcome, everyone. I wish to thank the chairpersons, ranking members, and members present today for the opportunity to speak in favor of HB 5001 and SB 2. I'm David Reed Johnson, and I'm a licensed clinical psychologist. I earned my bachelor's and doctoral degrees in psychology from Yale and have been on the faculty of the Department of Psychiatry at Yale since 1981. My early career was at the VA Medical Center in West Haven, where I worked with Vietnam veterans who had PTSD. And since 1997, I've been the co-director of the Post-Traumatic Stress Center here in New Haven. I've written over 150 peer-reviewed articles and chapters and 8 books largely on trauma. For the past 15 years, I have been the chief executive director of the Miss Kendra programs, a preventative trauma-informed socio-emotional intervention for students in kindergarten through community college in Connecticut and in 15 states throughout the country. I strongly support HB 5001 and SB 2 in their expansion of resources and funding for mental health services. The mental health needs of our youth were at high levels prior to COVID, and the past 2 years have significantly worsened their social, emotional, and cognitive health. In our surveys of thousands of public school students in the New Haven area over the past 10 years, we have discovered these alarming results. 43% say they've been depressed in the last month, 40% experience severe anxiety, 35% hopelessness, 38% have experienced emotional abuse, 48% have witnessed domestic violence or abuse of their siblings, 58% say they are unable to concentrate on their studies in school. In the early results coming from our current surveys, these numbers have risen due to COVID, another 25%. Here is the essential point. No longer are mental health needs contained in just 5 or 10% of the student population, where individual counseling or therapy could address the problem. With 30 or 40 or 50% of our children requiring some degree of support, we need to provide a comprehensive public health approach to the problem that utilizes what are known as Tier 1 interventions, emphasizing prevention and early identification. These services can be less intensive, therefore less costly, and less reliant upon experts. Such interventions include, number 1, comprehensive screening for trauma, toxic stress, and psychological symptoms. Number 2, educating not only the teachers, but also the students about toxic stress, trauma, and mental health. 3, rapid access to basic counseling support and triage. And number 4, empowering students to contribute to these efforts through peer-to-peer counseling groups that can become vocational pathways in college. Connecticut is blessed with a strong network of state agencies and nonprofit organizations that together are capable of putting the intent and funding of these bills to work for the benefit of Connecticut's youth. Thank you for your bipartisan support for this bill, and thank you very much.
Thank you so much, Dr. Johnson, and thank you for staying within your 3 minutes. And I have already Dr. Pettit with a question. You're muted. Yeah.
There we go. Thank you, Mr. Chair. Thank you, Dr. Johnson. Just to maybe reinforce is that, so you're saying that you believe that primary prevention could be more cost effective than after the fact interventions, and perhaps done by people that are already in place. And I'd like to expound on that and have one quick follow-up.
Great. Well, absolutely. One counselor for a year costs minimally $5,000 at Medicaid rates. You heard from other people about $16,000 per student per year. Then if this would be okay if we had a small number of students in Connecticut, but we're looking at a much larger issue. And so to be honest, we are never going to have enough money to be able to do it with social workers, psychologists, and counselors. We need to be looking at seatbelts rather than complicated surgeries when people get into car accidents. Our country and our policies have been to wait until the kids break down and then to provide more expensive services that we, as you've heard today, don't have the money for, don't have the personnel for. The preventative services are in the order of $50 to $100 per year per student, and requiring often no additional staffing, using teachers, just being trained, etc. So I'm completely in support of more of people like myself, but it's not going to work. It will not be a solution. And we need to be able to look at new models of prevention. There are many out there, but they just don't garner the same kind of support that emergency services and higher level intensive services get.
Beautiful. Thank you. No follow-up then. You covered it. Thank you.
Thank you. Thank you so much, Representative Comey.
Thank you. Thank you, Dr. Johnson. It's good to see you.
Yeah,
I
good
know
to see
you.
you.
I know how much great work that you've done here in the New Haven area and out into the outskirts of New Haven. Can you and I really love how you do work, the teachers and the staff, and everybody's trained in a full with a full understanding of your program. Can you discuss, can you share how broad your program is being instituted across the state and probably across the nation, if I remember correctly?
Well, thank you very much. I mean, the basic concept of the Ms. Kendra program is to basically to empower not only the students, but the teachers and the entire staff of the school to engage with a school-wide approach, a tier 1 approach to the problem that we're all facing, which is basically the toxic stress that the kids are walking into the school with every day. Whether or not it's traumatic or just simply unhappy homes filled with tension due to financial problems, arguments, and sometimes lack of resources. These things are directly impacting the executive functioning of the kids because their worries are real. They're worried about their parents and they're not able to focus on the schoolwork. So it completely undermines the entire operation of the education system as well as their mental health. And so our job is to basically create an openings for the kids to express their worries from kindergarten on and for everyone, so that we can identify kids who have serious worries well before they've broken down into symptoms that require medications, diagnosis, hospitalizations, and all these intensive services that are critically needed. But the more that we attend to them, they keep coming, and we're doing nothing to slow down the pipeline.
Thank you very much for coming today.
Thank you.
Thank you. Thank you so much. And we'll probably, some of the people will follow up with you and then get some more insight. Thank you for your testimony. We truly appreciate you. Next is Commissioner Bai. Commissioner Bai, I'm so sorry to delay you a little bit today, and I so much appreciate your time. Thank you.
Of course. Thank you so much for having me. Good afternoon to the committee leaders and committee members, all of you putting in such important time here. I can tell long before today. I'm here to testify about SB2, Enact Expanding Preschool and Mental and Behavioral Services for Children. My name is Beth Bai. I'm the Commissioner of the Office of Early Childhood. We understand that the intent of this bill is to expand early childhood education opportunities for all and to provide appropriate funding levels and supports for the current system that faces mounting challenges, as you've been hearing this morning. This is a goal of Governor Lamont and the OEC. We share that with you. We know that the current childcare and preschool system leaves many families and young children without the high quality early childhood services they need that you're hearing about today in terms of a prevention strategy as well. You support parents and kids from the beginning. And we know that early childhood programs are struggling to survive post-COVID. High-quality early education opportunities help build young brains and provide critical learning tools for later education in life. Childcare is a critical part of workforce and economic development infrastructure. Think roads. Families rely on childcare to work so they can provide sufficient income to support their household. OEC has been working closely with other states, think tanks, early childhood organization, and even the White House to stay tuned into federal legislation. The current draft of a federal bill that's meant to provide federal relief for childcare is designed to build a state and federal policy that makes childcare costs no more than 7% to any family. It would provide universal preschool to communities as well, using the existing infrastructure and expansion as needed. Governor Lamont has urged President Biden to prioritize childcare as they look to pass pieces of Build Back Better. He met with him as recently as last month and urged this. The scale of the supports needed to address the national childcare crisis and the childcare crisis in Connecticut requires a federal scale of response and federal funding. OEC is working on several fronts based on that federal bill to plan for a more universal approach to early care and education. We're working to better understand the fiscal implications of a universal approach to high quality care that pays professionals and staff who work in early childhood a professional and living wage. We've been looking at the structures of early care and education programs and systems that work in Connecticut and other states. We know, like you all do, that ARPA, CRISA, and CARES, all those federal funds were meant to be a temporary fix for childcare, and that the field requires systemic improvements. While we support this focus in the Senate bill, we continue to believe that federal legislation and funding is imminent. We want to be sure that any steps we take in Connecticut from a policy and budget perspective align with the federal funds and accompanying rules. As I said, we speak weekly to folks in DC, and we really look forward to collaborative efforts this session to move Connecticut's early childhood education system out of crisis and onto a sustainable path. Also, OEC recognizes the vital importance of the mental health bill before you. Young children and their families need significant support in this area as laid out in the governor's budget and with the attention of this legislature. OEC strongly believes that high quality early childhood services and family supports can help prevent later behavioral challenges. OEC currently oversees home visiting, which provides clinical level supports for young children and families through programs like Child First. And we provide clinical level supports to children, early childhood programs, staff, and families through our early childhood consultation.
Excuse me, Commissioner Bai, but your time is almost up. If you
okay, I'll wrap it up.
Thank you.
I'll close by reminding folks, because there have been proposals before you, that we're working with DPH, DCF, DSS, and the Office of Health Strategy on a universal home visiting program with community health workers in Bridgeport to pilot what it looks like for all children and families to get off to a good start. There will always be needs for mental health supports for children and families, even with high quality early intervention and prevention efforts. So it still requires your focus, but we believe these early interventions can make a big difference. Thank you so much for your time and attention.
Thank you so much, Commissioner Bai. Commissioner Bai, here's the challenge. The timeline for the federal funding is unclear, and has been a possibility that it may not even happen. And every single day, there are childcare workers who are leaving their job, and the childcare centers are closing almost every day. And we will not have enough, and they will move on to other areas. So there's this gap that is getting created as a primary prevention and a support for the children would be lost. So the state will have to intervene at this time. We'll have to change some of the other priorities to put resources here. And if the federal funding comes, we can reassess and realign ourselves. But this is the challenge. We have systems drowning right now.
Yes, and I think, Senator, that's exactly why you put this bill forward. And the governor is committed to making sure the child care survives. He's allotted and got the federal dollars out very quickly. We agree with you that it needs attention, and we agree it needs, both focus from the governor's office and the legislature to prioritize what has to happen. And we get new information every week. We were hoping something would pass in April, and now it looks like it could be later. And we'd love to set up a way to keep you apprised with what we're hearing federally and what the different requirements are looking like federally. We keep adjusting. And I think we're going to have to do that dance together and make sure we support childcare. And the governor's committed to that, as are we at OEC.
Thank you. Thank you, Commissioner. You will always find us as a partner in this dance. And with that, we have my co-chair, Representative Linehan.
Thank you very much, Senator. Hi, Commissioner. How are you today?
I'm great. How are you?
Well, we're still kind of at the beginning of a long day, but we're learning a lot here, and that just brings me really to one big question for you. Am I remembering correctly that through DECD at the beginning of the pandemic, the state offered loans to businesses, correct? To kind of get them through, and some of those may have included childcare centers. Is that right?
Yes, I know they offered some loans, and they were to all kinds of businesses. So some were childcare. We had some specific funds, but DECD had others, and PPP had others, and some providers were very resourceful.
And so one of the things that really concerns me is that we are always kind of teetering on the edge of childcare centers closing. And when they close, then parents can't get back to work. I mean, you know the whole deal. I don't need to tell you. So I guess my question is, we've been trying to see if we can get some information. When I say we, I mean the Children's Committee, regarding how many childcare centers still have outstanding loans to the state. And we've been unable to get that information. And so I'm going to ask now if you could help find that out so we can determine, if there's something that we can do as a legislature to kind of work to keep these people open. I also see that has been trickling down, unfortunately, to what we are paying people to work in childcare centers. There was an advertisement for an early childhood center in my district just the other day on the internet that says that they're going to pay $14 an hour. And I was very shocked by that, that we're talking about caring and educating children. So any information that you could get for the committee, that would be fantastic. And then we could take a look at maybe something that we can possibly intervene and help.
We are happy to do that. And I will tell you that I got my start in politics at a worthy wages march 30 years ago, that childcare has been the lowest paid profession in Connecticut and the country for well over 30 years. So as you say, it's too bad. And now it's reached a total crisis with the workforce issues.
I agree. Thank you very much, Commissioner.
Yeah, thank you.
Thank you, Representative Linehan and Senator Haskell.
Thank you so much, Mr. Chair. And excuse me, I'm sorry. Commissioner Bai, it's so good to see you.
Good to see you, Senator.
I wanted to follow up on something that you mentioned, which is universal home visits, and give you an opportunity to discuss that further as potential to incorporate into legislation. Could you talk about the benefits of that program, and if you would, why universal is necessary? I think there are some of us in the legislature who see a zero sum or a limited pot of resources and think that we ought to be directing it most towards those families who need a helping hand. However, I think I remember from our previous conversations that the universality of such a program is critical towards destigmatizing care and assistance in the early days. So I just wanted to give you an opportunity to discuss that program further.
Sure, Senator Haskell, thank you so much for that question. The universal home visiting is designed to be just that, universal. It's a light touch program, but it can have long-term savings. It's known to save, like it reduces emergency room visits by 40%. It reduces referrals to DCF by 40% or to child welfare agency, the Family Connects model that we're looking at. The idea is that every baby born gets a check-in, and for families that don't need much help, they get one check-in from a nurse visitor. If they need more help, they can get up to 3 visits from that nurse home visitor. And then if they need even more help, there's a community health worker. We have a lot of programs in Connecticut for families and young children, but they're very difficult to access, especially we're finding for moms who have new babies. So for example, WIC usage was down during the pandemic and SNAP usage was way up. So mothers having young children we're just unable to access those incredible resources for nursing, et cetera, in those first days. And Commissioner Durantes really talks about how important it is to destigmatize home visiting, to destigmatize that sort of check-in for a family. And, you know, as she says, you never know who needs that support. We may make assumptions, but there are all kinds of families dealing with challenges and a whole lot of pain and heartache that can be avoided with just some simple parenting tips, maybe other sort of interventions supporting emotional health. And my guess is everyone on this call now, you're all listening to testimony about children's behavioral health. There's no one that thinks that that has an income limit, the people who need children's behavioral health. In fact, when I was in your position, Senator, the families most affected were those sort of in the middle that didn't qualify. Their insurance wouldn't cover it and they didn't qualify for Medicaid. And so what we're trying to do, you know, the governor wants Connecticut to be the most family-friendly state in the country and draw those young families who can live everywhere. You start with the great paid family medical leave that you passed, you do universal home visiting, and then access to high-quality early childhood services. That's really getting a family and child off to a great start. And I have to give Commissioner Gifford credit for when the governor said do something groundbreaking. She thought, we've got to start early. We do all this work when mothers are pregnant, then they have the baby, and we're done. And in fact, that is when you can really ward off some challenges early. So thanks for asking. And I'm really grateful to my other commissioners. I may be the face because we'll be putting out the RFP, but it's very much a 5-agency effort.
Thank you so much for that.
Next.
Thanks, Commissioner, and thank you, Mr. Chair.
Thank you, Senator.
I have Senator Julie Kushner, and I also wanted to use this. If somebody else can share it for a little bit, there are votes in appropriation. They won't be able to keep the votes open, so I may have to jump to appropriations for that. But Senator Kushner.
Thanks, Senator.
Please continue, Senator Kushner.
Thank you. And I too have to jump over to appropriations, but I think this topic is so big and so important. And, you know, I appreciate, Commissioner, that we're very lucky to have you there because you have been in this arena for most of your adult life, if not all of your adult life. And I really appreciate your mentioning the worthy wages fight. And, you know, of course, I met you more than 2 decades ago in the same struggle. I just am really concerned, and I think that it's been said by other colleagues that we all would love to see universal pre-K. We would love to see it supported by the federal government, but it feels like we've been saying this for decades. And we still are in a situation where childcare workers are earning minimum wage, and we're having trouble keeping up. Our centers are having trouble keeping up with minimum wage. And so I just wondered if you could elaborate a little bit on what you think the solution is coming from the state. And I appreciate everything you've said already on the topic, but it really is about how do we make, it's one part of the equation is how do we make it affordable for families, and the other side of the equation is how do we make it live, you know, a living wage for the people who work in childcare.
Absolutely. For the people that work in childcare, I think, as you say, it's really systemic. We were able to get one-time funding out to childcare workers through the employers with the relief funds, and we know that was helpful. We've been able to get some funding out directly to workers who have early childhood degrees. But the business model, the market is broken. Parents can't afford to pay what it really costs. And so basically the workers subsidize the parents and the businesses who they work for by taking lower wages. So the answer really is in the rates and trying to figure out how do you get to that. You know, Senator, I was talking to someone today, and when we talk about manufacturing job, everyone gets excited because they pay a good wage. And we always say that for every manufacturing job, you create 3 other jobs because of the effects of that. But for childcare, for every childcare worker, you're supporting 10 other workers if they're a preschooler. And for every infant and toddler, you're supporting 4 workers with a childcare job. And there is a real workforce crisis right now. So I think we have to, you know, our hope was with the federal funds to really look at the rates that are being paid. But I know the advocates are asking for other items, but the governor and I will continue to look at this and work with you all in the legislature to think about what are the most important first steps we can take while we wait for federal funds. The real broken market is the infant toddler care, because the programs can make it with preschoolers, but then they use those seats to subsidize the infant toddler seats, which have twice as many staff. So it's all broken, but particularly Connecticut is overbuilt by 37,000 preschool spaces. So something about that market's working. We're underbuilt by 50,000 seats for infant toddlers. So 50,000 families need infant toddler care, and we don't have seats right now in Connecticut. So my thinking is starting there with what can we do with that part of the system that's so, weighing down a lot of the other parts of the system.
Thank you. And I do feel great comfort knowing you're in this job, because we know your heart is in it, and you're a wonderful leader in this industry, but the challenges are immense. But thank you. And thank you, Mr. Chair.
Thank you, Jill. And I just have to say, we met. I mean, that's how we met when you were organizing in Stamford and I was working to try to get the wages up. So thank you for your work in this area, because you've been a champion for childcare workers too.
Thank you.
Thank you, Commissioner. We're glad to have you where you are, though when you drop a number like 50,000 short.
50,000 short.
Long way.
And I'm happy to share that report with the committee. It's a recent report.
Thank you again. I don't see any further questions. Thank you for your patience today and for testifying and for staying involved as we try to get this right.
Yeah, thank you so much. Thanks for all your leadership on these issues. It's been wonderful to listen in today and hear all the testimony.
Thank you. You're invited to stay the next 12, 14 hours or however long it takes. Next up, we have, I believe, Eileen Costello.
Good morning or good afternoon. It's tough following Beth. She's such a great and eloquent speaker. I'm lucky enough to work in a school readiness program. I oversee the school readiness funding that comes to the city of Danbury. So I'm very familiar with the funding issues and what's been going on. I call this like the perspective from the boots on the ground. I'm speaking on behalf of the 10 programs that we fund in the Danbury area. So investing in early childhood programs just makes great economic sense. Beth was talking about for every one worker, you have 10 families that can be in the workforce. Our early childhood programs save school system thousands of dollars in early interventions. They prepare children for school success, and they connect families with much needed community resources, including what I've been listening to all morning, a lot of mental health and behavioral supports as well. Our early childhood programs help families in Connecticut with their young children remain in the workforce. Their child is in a licensed, safe, nurturing educational setting. And our state-funded early childhood programs, such as school readiness and child daycare centers, are required to go above and beyond to exceed licensing standards, have highly qualified staff, and achieve accreditation by the National Association of the Education of Young Children. So our programs are high quality. The commitment to quality is admirable, but it also costs funds, and yet the state payment is not commensurate with what is being asked of these programs. State-funded early childhood centers have not had an increase in funding since minimum wage was $9.15. The current rate of $13, which is becoming $14 in July, is causing our programs to run at a deficit. The staff who have remained working in early childhood since 2015, while still underpaid on average, will receive about a $10,000 increase by this July, but the state has not increased the payments to the programs where they are employed, which is causing a lot of other issues to evolve. The state legislature approved the increase in minimum wage, and the legislation for school readiness programs defines the current reimbursement rate. These actions are causing a failing system. If our childcare system fails, so does our economy. We need your help to rectify the problem. The current reimbursement rate, I'm a math person, so I always go with this, is $89.24 for year-round 10-hour-a-day minimum programs. Works out to about $3 an hour. As I've joked around, I think I made more babysitting in the 80s than people are getting paid today. Without state funding, many of our low and middle income families would not be able to work. Unlike privately owned businesses, state-funded centers cannot raise their rates. They're required to use a sliding fee scale, and the programs mainly serve working families across the state. 60% of our children minimally need to be under 75% of the state median income. So you can see that we really are working with low-income, middle-income families. And then early childhood programs, which I think is really important to note, we employ over 30,000 people in the state of Connecticut. We're a very large industry, and it's mostly women. And many of these women work in our state-funded centers. We cannot afford to continue to pay our staff on the reimbursement rate that the state supplies. We're almost creating our own circle of poverty for the women who work for us. I'm asking you to specifically increase the funding for our state-funded centers for school readiness and CDC to a rate of $10,000 per child this year and $11,000 in 2023. While this will not fully cover the cost of care, it's a step in the right direction. It'll help start our programs from closing and keep our staff employed. Without a significant increase in reimbursement rates, many of our centers, who again, I say are serving our working families, will have to close. And as Senator Amwar stated, we cannot wait for the federal government to bail us out. We don't know how many months that will take. And then when it comes, when will the money come? How long will it take for us to have a system in place? We're talking a year or two. We need our Connecticut legislators to take action now for this issue that's been ignored for far too long. Thank you.
Thank you. Help me with the math here. You said $10,000 to $11,000 per student. How does that translate on a statewide basis? What do we need to ante up?
You know, that I don't have the exact number, how many across the state, but just in Danbury alone, we have 345 children that are funded through school readiness. We could easily have 500 children funded through school readiness because we have a need. But just the $1,000 increase per child would be life-changing for these programs. It would just help offset when a minimum wage is increasing. It would help offset the deficits that they're carrying.
Thank you for that, and thank you for your passionate involvement. You bring us a perspective we need to hear. We have a couple of questions for you, Representative Comey, followed by Senator Kushner.
Sure.
Thank you so much. Hello, Eileen.
Hi there.
So you mentioned you really talked to the school readiness funding stream mostly. I'm wondering, I assume you also take care for kids.
Yes.
Children in that program. What role does the Care for Kids play in funding the school readiness pre-K programs, and how does that work in relation to undocumented parents?
Well, a couple of things here. When school readiness was first funded, it was supposed to be a three-part funding. One from parents' tuition, which is based on a sliding fee scale, and parents can pay as low as $8 for a full week of care. The second was a Care for Kids payment for all the working families that were under 50% of the state median income, and the third was the state payment. Unfortunately, and I'm speaking more from Danbury, but this is an issue across the state, we have a lot of undocumented families that don't qualify. We have a lot of people that work cleaning houses and landscaping, et cetera, that don't have that proof of income. But more than that, we have a lot of families that are afraid to apply for Care for Kids because, you know, word is that if they're taking some type of government subsidy, if citizenship comes up, they won't be able to access it. And so there's a lot of fear among the parents that we're serving that Care for Kids is not something they want to be tracked in. So I did some estimates. I have 275 families in my school readiness programs who are eligible for Care for Kids, and we have 54 families that are receiving it. So that's only 20% of the children that are eligible to receive that payment that are actually receiving it. So that's the deficit that programs are seeing. They're not able to get 80% of their families on Care for Kids that are eligible. So one of the funding streams is totally broken. The parent fees is unreliable because, you know, it really goes by the family income. And across the state, we're seeing a lot more single parent homes. So therefore, you know, you're having a family of 3 with maybe an income of $32,000. So their parent fee is, you know, $8 to $15 a week. And you just can't run a program on that unless the state subsidy is brought up a lot higher to cover those deficits.
Thank you, Eileen.
You're welcome.
Thanks for being here.
Thanks.
Thank you, Representative Comey. Senator Kushner.
Thank you, and I'm so sorry. I now have to go vote in another meeting, but I just wanted to say, Eileen, I know the work that you're doing. I've been to the centers. I see how important and valuable this work is. My question to you is, how do you do it? You reported on what the increases have been and that you're not really making it. So how do you make it happen?
Well, I will tell you that this year, our program's been forced to make a lot of hard choices. They used their stabilization funds and any grants that were available to cover their payroll. They didn't fill open positions post-COVID. They closed classrooms. So some programs that have 5 classrooms, they can't afford to hire more staff. They've closed a classroom. They've closed the infant toddler room where it's 1 teacher for every 4 children in order to keep open a preschool classroom that's 1 teacher for every 10 children. So economically, that's the choices they had to make. They didn't give any raises to staff that weren't making minimum wage. So we've had staff that have not had any pay increase for 2 or 3 years. And, you know, they served less children, and then they changed their hours. Many of our programs were open from 7 to 6 to accommodate working families. They cut back from 7 to 5, and then that knocked out some of our working families who couldn't make it work with the hours that the programs were open. So we're hoping to go back to 7 to 6. We're hoping to reopen any classrooms that have been left empty this time and fully take all the children that we can possibly take. So that's how they've been making it meet. And it's just, you know, they're teetering on the edge, and we see it every day.
Well, I'm glad that you gave us that explanation, because it's really important that we understand that this is really day to day at this point. And we already knew that we weren't serving enough families that are in need. And now we're finding it even harder to serve those that we had. And so I appreciate everything you and all the people who work in this field in our area do for our community. It's tremendous work. It's so valuable, and the kids are the real beneficiaries of all of your efforts. But it's unbelievable what you go through to keep these centers open. So I'm hoping that we as a legislature can prioritize this and make it work a little better. Thank you.
Thank you so much. And I do want to say, for those here who are here for the mental health issue, I kind of was jotting down all the things that we do in early childhood in Danbury. We follow the pyramid model, Cephals, and all our state-funded programs. All the staff have been trained. We partner with ECCP and Families Network, which is a home visiting program. And we offer a program called Positive Discipline. It's a parent education program that talks about relationship building and behaviors. And we offer it in English, Spanish, and Portuguese. So, I mean, early childhood programs are a great beginning for a lot of families, and we offer a lot of resources. So we work hand in hand with families to make sure that they're getting all the resources that they possibly need to make their family life easier at home. Thank you.
Thank you, Mr. Chairman. I really appreciate the opportunity to engage with Eileen. She's always so helpful to us.
I totally agree. Now go vote and get us a ton of dollars for our needs and appropriations.
I voted in the middle of all that very quickly.
It's amazing how we can multitask here. But Eileen, thank you again for everything you added to our insights. I don't see any further questions. Next up, we're going to go to Provost Lejuiz. I probably pronounced that horribly, for which I apologize, and I'm sure you'll correct me. Followed by Miriam Johnson. Welcome, Mr. Provost.
Thank you all for having me here. Distinguished committee members, I'm Carl Lejwe, the provost at UConn. I'm also a professor in the Department of Psychological Sciences and a clinical psychologist by training. My work is focused on adolescent risk-taking and mental health. One of my goals today is to support HB 5001 and SB 2. At UConn and UConn Health, we are very much in support of the current provisions, including efforts focused on expanded school-based mental health services and efforts to develop a system-wide trauma-informed care training program, faster pathways to licensure, temporary licensure for newly graduated providers, and licensure reciprocity, as well as expansion of loan forgiveness for trainees and provisions for providers who were not native English speakers. A second goal of today is to indicate the important role that UConn and UConn Health can play as a partner in the successful implementation of these bills. By the numbers, I want to share 4 important facts. First, our graduate and professional programs at UConn and UConn Health support over 600 trainees in social work, clinical psychology, school counseling, and psychiatry at any given time. Second, students in these programs are responsible each year for over 300,000 clinical hours across the state, from Hartford to Waterford, New Haven to New Britain, Wilton to Torrington, and points in between, with particular attention to marginalized and low-income communities. Third, these services impact tens of thousands of children and adults receiving school, individual, and group-based mental health services. And this includes psychological testing, behavioral interventions, family caregiver intervention, and psychiatric medication-based services. And fourth, our data indicate that each year, several hundred of our graduates stay in Connecticut. There's no shortage of students who want to be in our programs, but because of resource constraints and the challenge in terms of student debt for these students, we are limited into the number of students that we can have in these programs. There are many ways in which we can be a partner, in addition to being able to expand the number of students that we train with more resources. These include being able to shorten time to degree, implementing alternative approaches to delivery, such as telehealth, upskilling, training for existing practitioners in areas where they don't have expertise, and expanding the communities in which UConn and its students offer direct services. In addition, there's several goals of HB 5001 where we can be a strong partner, and this includes evaluation of barriers and challenges, further expansion in the number and range of school-based mental health services, further expansion and support of family and caregivers, and from something I've heard a lot today, conducting studies to provide needed data as part of the programs within HB 5001. So in conclusion, we offer our expertise to the committee and to you as you continue to refine the bill. Attached to my testimony is a PowerPoint slide deck that we've developed for the bipartisan working group that provides details about what we offer at UConn currently and what we'd be able to potentially offer as a partner. Thank you for the opportunity, and I'm happy to take any questions.
Thank you, Provost Lejwe. If I got that a little bit better this time.
Perfect.
Thank you. With practice, I can do many things. UConn has already been a good partner to these committees and those working on this bill in helping us understand the academic pipeline, so to speak, and the challenges we have before us. Do you have a sense, broad side of a barn, what's the average student debt for those going through this program? How daunting is it for us to try to ameliorate those costs through forgiveness programs or the like?
It really depends on which program a student is in, but I certainly know that for our psychiatry residents, and then also particularly for our social work students, and particularly for the latter, the social work students, the opportunity to make enough money to be able to pay off those debts. The amount of debt may not be as much, but the dauntingness of what it means to be able to try to make up that amount is really, our Dean of Social Work has indicated we could really expand the number of, not just the number of students interested, but many students who themselves come from marginalized backgrounds, who speak multiple languages, who bring a level of diversity, who are just not choosing to be in that field right now. So I will definitely get you real numbers for this, so you have that. But what I would say is it is definitely limiting some individuals' ability to enter this workforce, and I think it's also holding back the diversity that we could possibly have.
Thank you for that. One quick follow-up. We've also had some conversations about the need for faculty to teach these students, and we realize that is another potential bottleneck. What's the best remedy to make sure that we have qualified people to teach the programs that we've been talking about?
Well, the good news is that for all of these programs, when we open up positions, we have many, many more applicants than we can possibly hire. And I didn't mention this, but several of these programs are within the top 20 and the top 40 compared to other public universities. So it's incredibly desirable. If we can expand the number of positions, we can hire amazing faculty who are both contributing to a research base, but more importantly for this committee, absolutely increasing the number of students that we're able to generate.
Thank you. That's very encouraging, and we'll see what we can do to make that happen. I don't see any further questions. Again, Provost, thank you for your time today, and we look forward to continuing to engage on the serious pipeline issues we're still trying to fix.
Thank you all. And I just personally appreciate how much this committee is put into this and what I've seen so far of the bills. So thank you very much.
Thank you very much. Next up, I believe, is actually number 41, Doris Maldonado Mendes, followed by, one moment, please, Ava Bermudez Zimmerman. First up, Doris.
Buenas tardes, Senator Abrams, Anwar, Representative Linehan, Steinberg, and members of the Children and Public Health Committees. My name is Doris Maldonado. I'm a Latina mom with disabilities residing in West Hartford, and I'm here to testify in support of SB 2 and HB 5001. As a co-chair of Keep the Promise Coalition and statewide bilingual health information specialist in CHW for PACT, I commend this legislature for considering my children, our children, those in foster care, and throughout the lifespan from prenatal to aging with disabilities. A promise was made by this government in '99 to invest in community services and mental health services so that young and aging would become integral parts of society. It still doesn't exist. 22 years later and 5.9 million COVID deaths worldwide, increasing beds would have confined my 16-year-old son, possibly in restraints, in the middle of surviving a false negative test, symptomatic epileptic type C residuals, burying his last grandparent, standardized testing, college applications, and suicidal ideation. My twins have been forced to achieve despite a socioeconomic systemic failures to succeed. From birth to 3 and 15 years in educational systems, they've had over 48 specialists to support IEPs, over 10 diagnoses, including ASD. Since arriving in my life as 9 months, identified as typical children, I've had to seek resources to fill educational voids with over 55 providers. Our story fails in comparison just to desperate stories from the families I serve. We're no longer 1 in 5 or 4 or 3 or 2, we're 1. Serving many state and national boards for youth and disabilities, I was recently suggested to resign because I present as a frustrated parent, not celebrating the small wins of aesthetics, which, while the leading minority group, Latinas in Connecticut, suffer digital divides and so much for telehealth. Where does a caregiver seek help with overflowing specialist wait lists, avoiding mental health parity? Forced to make ends meet with unreliable housing, health, and transportation to get from one side of town across the state and then back to see a second provider all in one day so that our child's absences at school are not regarded as neglect. Not frustrated, but despair. I am now mourning my twins. After 17, my 17-year-old ran away to another state to escape COVID restrictions and grandiose ideas, and the other one on his 18th birthday because I limited social media. Failed prevention because they presented well as the marginalized of the marginalized. Prenatal care, infant mental health, youth mental health, lifespan mental health. Where are the partnerships and communities for Black and Latina students who are more than likely to have their behavioral health criminalized? When will equitable community and school-based services be provided by Medicaid for just children with invisible disabilities, intellectual and developmental disabilities? Will you keep this promise? Thank you.
Thank you for your testimony, for all your hard work in this field and your clear passion for the subject. You don't strike me as somebody who's going to back off regardless of what pushback you get. So we really very much appreciate it. I don't see any questions for you, but thank you for your testimony today.
Thank you.
Greatly appreciated.
Thank you for your work.
Next up is Ava Bermudez Zimmerman, followed by Cindy Jackson.
Let's see if I'm on camera. Right, nope.
You were there for a moment. What happened?
Looks like she's gone for a second.
That was the briefest testimony we've had. Cindy, why don't you go and we'll see if we can get Ms. Bermuda.
Am I there?
Oh, sure. She's back. Okay. All right.
I was being promoted as a panelist and I was in limbo. I was in a black screen. Good afternoon, Senator Anwar, Representative Linehan, Senator Abrams, members of the Children's and Public Health Committee. Thank you. I want to start with thank you for raising Senate Bill 2. My name's Ava Bermudez Zimmerman. I am the CSCA SEIU local childcare director and organizing director, and also our local is a proud member of CCFCT, Childcare for Connecticut's Future, who I'm representing today in my testimony as the coalition co-chair. CCFCT's mission is to restructure early education in Connecticut so that parents can find high quality care that is affordable in a setting of their choice that will ensure childcare providers to be well compensated in order to have a stable and skilled workforce. Senate Bill 2 is a step forward to getting that done. There is no right path on how to fix the early education system, but there is also a lot of feedback that we've gotten from parents on what we can do to focus on those changes. The same way as there's no path to fix a broken system, there's also no right path onto parenting. What we do know with early education and the system is that it was broken long before the pandemic was there. And I've heard testimony, we've all heard testimony from Eileen, from others speaking on that reality. Currently, Connecticut is ranked sixth in the country for unemployment with 110,000 job openings and 50,000 infant toddler slots that are not in structured care. So what do those numbers tell us? They tell us that one clear detail is there, that their jobs are available, but something's holding those parents, those workers back from being able to fill those positions. I'm not going to go into a long list of theories as what's going on with the workforce. I'm here on early ed. What I could tell you without being an analyst or going into theory is that we don't have to be experts to know that any parent who works needs childcare. Could it be a grandparent? Could it be structured care? Absolutely. At the end of the day, we know that the structured care that's available in Connecticut does not work. If we want to support the workforce here in Connecticut, we need to make sure that providers stay open. During the pandemic's first year, 30% of the workforce was gone. Many of them weren't able to reopen. They were forced to find other employment outside of the field due to lack of payment, due to lack of structure and support systems that were just not there for all of early educator providers. Most of the educators are getting paid minimum wage or up to $14. You've heard testimony on that. Center and home-based providers who have salaries to retain their own staff are not able to get those wages up to where they need to. And a lot of the providers depend on state, federal, and grants to sustain their programs. And then you're also looking at a significant cost from the parents' end. So when you don't have enough for making sure that that structured care is available, and when you're looking at parents who are sacrificing and nickel and diming to pay for childcare, it creates this broken system. The emotional toll affecting the system in the area, the stress on the parent who can't afford it, the stress on the provider who can't afford having a child attend for free, the stress on the assistant who makes minimum wage. We asked that Senate Bill 2 secures $700 million. I know Representative Steinberg, you were in shock and awe when you heard that number, but that truly is a number that we need to help the crisis right now. It's not, long-term, this is just for this year. So I wanna thank you for your time. And the last little tidbit I wanted to add, Representative Steinberg, when you asked Eileen Costello, how much would it how much would the cost of care be for the state legislature to fulfill universal childcare? It's $2.5 billion. So right now we're looking at 21,000 early ed providers. You have, like I mentioned, 50,000 children in unstructured care, an additional thousands of children who are in structured care. 2.5 billion is the realistic number to have free, affordable childcare, universal childcare for everyone. But this year, the first stepping stone is at 700 million. I'll open myself up for questions, and I have data and citations in my written testimony that I will be submitting. Thank you.
Thank you for that wonderful testimony and for making us blanch once again in terms of what we really need to do. This is a national crisis with daycare. We must do better than we are. Our system is not enabling parents to participate in the workforce, let alone take care of our kids. There's so much we need to do. As daunting as many of these numbers are that we've heard today, we need to recommit ourselves to find a way to do a lot better than we are. I'll just leave it at that. Thank you. I don't see any questions.
Thank you.
I think we're all apoplectic at this point, but we will continue on. I'm going to hand off now, I believe, to the Children's Committee Vice Chair, Mary Wielander, and all yours.
Thank you, Mr. Chair. We are going to be hearing next from Cindy Jackson, who's the Executive Director of Children's Therapy Services, followed by Angela Russell.
Good afternoon, Senator Anwar, Representative Linehan, Representative Steinberg, and members of the Public Health and Children's Committee. Thank you for the opportunity to provide testimony regarding Senate Bill 2. My name is Cindy Jackson. I am chairperson of the Interagency Coordinating Council for Birth to 3 and Executive Director of Children's Therapy Services, a state contracted birth to 3 provider. I'd like to thank Representative Linehan for her leadership on this issue and also her role as serving on the Birth to 3 Interagency Coordinating Council. I'm here today to testify about the impact of the lack of resources and the pandemic has had on children and families in our Birth to 3 program, especially those with social emotional needs. Over the last 32 months, there has been 26,275 total referrals to Birth to 3, and 7,446 of those referrals have included social emotional concerns for infants and toddlers. That's about 30% of all referrals. As Commissioner Bai referenced in her testimony, Birth to 3 is one of the OEC's state-funded programs that plays a critical role in delivering services to infants and toddlers who have developmental delays. Birth to 3 can change the trajectory of a child's life and decrease the educational and behavioral costs by identifying the delays early and providing the appropriate developmental and behavioral supports to the child, as well as supporting the family. However, we have been faced with many challenges over the years, the 2 greatest challenges being the lack of state funding and our workforce issues. For funding, Birth to 3 rates and general administrative payment per child has not increased since 2015. We were greatly impacted fiscally during the public health emergency because Birth to 3 is a fee-for-service system. So even though we quickly moved to remote services and then back to in-person services when safe, programs experienced a major decrease in billable services due to combined issues of decreased referrals and an increase in cancellations due to illness, quarantine, and family stress. This level funding and decrease in billable service has caused instability in Connecticut's Birth to 3 programs. In a recent survey, 40% of Birth to 3 programs said they would be forced to close or significantly decrease capacity if funding does not increase in the next fiscal year. The general administrative payment per child, which is $100 per eligible child per month, which accounts for the indirect service coordination activities, and that hasn't changed since 2015. But the time and resources to coordinate services has increased as family stress and therefore needs have increased. We work with families to connect with the community, to access childcare, emotional behavioral supports, housing, transportation, and the list goes on of their needs. But these services, as we've heard today many times, are very limited in many communities, and therefore the service coordination time increases as we try to help the whole family, not just the child in birth to 3. In regards to workforce, one of our birth to 3 responsibilities is to identify and diagnose toddlers when
Hey,
they're
Ms. Jackson, if you can sum up, please, your 3 minutes is up.
autism. This requires licensed social workers, behavior analysts, speech pathologists, teachers, occupational therapists, and physical therapists to really develop an appropriate program. Because of the shortage, results are for longer wait times for assessments and decrease in more intensive services. The expertise we need in meeting the social emotional needs of infants and toddlers is a critical element. So we need a workforce. To conclude, 2 immediate solutions might be to increase our monthly general administrative payment to programs so we can meet their service coordination and direct service needs, and also to develop a state loan forgiveness program for staff working in birth to 3 and review personnel requirements and regulations that add staff burden and negatively influence recruitment and retention. Thank you so much to consider these recommendations and for all you do to support birth to 3 and infants and toddlers. Thank you.
Thank you, Ms. Jackson, for your testimony today. I'd like to recognize Chairwoman Linehan for comments.
Thank you very much, Representative Wieslander. Hi, Cindy. How are you?
Good. How are you?
I'm well. I just wanted to thank you for bringing this perspective. I just think the Birth to 3 program is amazing, as you know. And so I thank you for all your work. I just want to triple check that you have also submitted written testimony.
Yes, we have. I have.
Okay, great.
Testimony. And if
yeah,
any
that's going to
other
be important.
information is needed, I'm more than happy to meet and submit other testimony or data.
We will certainly reach out. Your expertise is very important and greatly appreciated. So thank you very much.
Thank you.
Seeing no other questions, thank you so much for your time for being here today.
Thank you.
Up next, we have Angela Russell will be testifying, and I believe followed by Deneen Lewis.
Yes, good afternoon, members of the Public Health and Children's Committee. My name is Angela Russell and I reside in New Haven. I am grateful for this opportunity to share my testimony and earnest support for SB2, which will be one of many beneficial investments the field of early childhood need in order to address and improve mental health outcomes, not only for children, but I believe that parents and providers will be benefactors as well. Undoubtedly, for many parents and providers, it has been a continual back and forth struggle to balance caregiving responsibilities in regards to children and other parts of their life. And when it comes to them finding and providing the best child care option for everyone involved, they all echo similar experiences I had as a parent of 5 children, 2 with disabilities. As I ponder what I believe would be the most important words to share today, I became flooded with memories of how difficult and stressful it was for me as a parent who wanted those caring for my children to be appropriately cared for. And as a provider, how I could provide the best quality of services that meet the holistic needs, spiritual, mental, emotional, social, and physical of every child, their family, my family, and myself. Sadly, those feelings of frustration still ring true 20 years later. And even with the resources that we as parents and providers have received thus far has been greatly appreciated, the struggle to provide the best version of a well-resourced system of early childhood will continue without the necessary investment in the space where children spend an enormous amount of their day during their formative years. There's much more work that as providers, we have been entrusted to complete. And I believe with the help of every esteemed member of these committees, we will be able to build up our system of supports that make the provision of quality early care and education accessible to whoever needs it, when they need it, wherever they choose to place their children, and enable us to attract and retain experienced and compassionate providers that will tend to the holistic needs of all children, all families, and as well as our families. Remember, we are one word away, and that is yes, that will guarantee a $700 million investment so we can continue doing what so many children and parents rely on us to do. Be ready, willing, and able to meet their needs every day, every way that matters most. And I'm fully aware the task set before you today is not an easy one, because in addition to being a parent and provider, I am also a former politician as well. So thank you for your time and consideration.
Thank you so much for your time here today and your service. And as a former employee of a child care center, I understand how hard it is, the work, and how important it is. So thank you for what you're doing every day. I don't see any raised hands. So thank you for your time and sharing your insight.
Thank you.
You're welcome. Up next, we have Deneen Lewis, followed by, I believe, Bruno Lieto.
Good afternoon, members of the Public Health and Children's Committee. Thank you for the opportunity to testify in SB 2 and HB 5001. My name is Deneen Lewis. I am the Director of Equity and Collaborative Action at Norwalk Acts. Norwalk Acts is a collective impact partnership that brings people, organizations, and systems together in a structured way to achieve social change. 90% of children's brains are formed by the age of 6. This fact by the Harvard University Center on the Developing Brain highlights the critical importance of high-quality early childhood experiences, which has the ability to alter the trajectory of children's lives. We need to make high-quality childcare affordable and available to every Connecticut family. Due to the pandemic, childcare providers are closing their doors due to lack of funding to sustain operations. Teachers, who are primarily Black, women and other women of color, are leaving due to low wages. Parents are leaving the workforce and lack the ability to pay more for childcare. Children entering our school systems are lacking necessary skills. Please invest $700 million this year as a down payment to fix childcare in Connecticut. Overwhelmingly, evidence suggests that children and young adults are struggling with the need for mental health support and strong social emotional skill development. As highlighted within our local Norwalk data in 2021, 39% of Norwalk students in grades 7 through 12 reported symptoms of depression. Disaggregated data also identified subpopulations of young people who identify as LGBT+, female, living under financial stress, Black, as well as other groups of young people more likely to report even higher rates of depression. This not only speaks to the need for youth to have increased access through funding to support more support staff, but I would also like to recommend that there be additional incentives for recruitment and retention of support staff of color, in addition to continued and consistent professional development for all support staff to best work with diverse populations. There are glaring inequities on who can access mental health services and who is providing care, with racially and other marginalized people not highly represented in the mental health field. We need culturally sensitive and responsive support staff who are relatable to young people and the needs of the community, and their ability to connect with these young people are of critical importance. Collective impact is rooted in the belief that no single entity alone can create large-scale, lasting social change on its own. And we recognize and encourage continued dialogue to ensure that SB 2 and HB 5001 equitably addresses the needs of Connecticut's children and youth. Thank you for the opportunity to speak, and I'm open to any questions you may have.
Thank you so much. And I see Representative Linehan has her hand raised.
Thank you very much, Madam Vice Chair. Thank you very much for being here today to talk about this. You've hit a spot that is really close to my heart, and that would be equity for LGBTQ kids to be able to have clinicians who they see themselves in, who basically understand what they're going through. And there has been some back and forth between legislators talking about how important that need is. We all understand the need for equity in other areas, but can you just discuss briefly exactly how important is that for LGBTQ children to have clinicians who identify as such?
Absolutely. I'll be submitting additional data with my testimony, but what we know based on our local data, even when we're talking about those subpopulations who are reporting higher depression, those who identify as LGBT plus are at a rate of 79% experiencing depression. And then when we also have asked a question related to suicide, those who identify as not straight are also the highest risk group. So fortunately in Norwalk, we have the support and assistance of our local regional LGBT plus center, but we know that there are other resources that would greatly benefit, especially this demographic in addition to others. So really just wanting to make mention of that because we know that there are significant populations that are affected deeply by the mental health condition currently.
Thank you very much. And just to throw something else in there, that we always talk about minority teacher recruitment, which I think is so extremely important. But my only criticism of that is that LGBTQ teachers were never included in that. And it's really important that our kids, that they can recognize themselves in their teachers, in their clinicians, and that they understand that there's that connection there. So thank you very much for your testimony today.
Seeing no other questions, thank you so much for bringing all of these important points to our attention. And I think we will move on next to Bruno Lieto. I hope I pronounced your last name correctly. I apologize if I didn't, and please correct me. And followed by Antonia Edwards.
Good morning. Oh, good afternoon to everyone. Thank you so much for putting in so much time, because this has been a long day, I'm sure, for all of you. My name is Bruno Lieto. I work at West Haven Child Development Center. I've been there for almost 3 years now. I work in a birth to 3 room, and I'm just here to kind of, I'm not going to rehash all the numbers because you've heard them enough times today, but I do want to just emphasize the work that we do in these early childhood classrooms. This bill is also about mental health, and we've implemented a lot of policies like conscious discipline to help these kids develop these skills to identify and process feelings that they'll be using later on in life. So not only is it important to put funds into the system for children 13 and 18 and teenagers that are struggling with mental health, but it's also important to help stop struggling early on. So support from birth to 3, like Deneen, the previous speaker said, the brain develops 90% by age 6. If we can help them build these strategies and these methods to manage emotions, it makes them more comfortable later on in life to talk about these emotions and process them and seek out help if they need it. And it's something that most people are struggling with now, especially due to the health crisis. And it's put a lot of extra stress on the teachers in the rooms, because anyone who's worked in a classroom knows that your job doesn't stop when you clock out at 4:30. Working in a classroom requires so much extra effort after hours. And if teachers are required to work 2 or 3 jobs in order to make ends meet, it's harder to put in that effort to help kids get what they need. I've been lucky because my salary is a little bit higher, but I've also taken on administrative work in order to help our center keep functioning. So and I still struggle to make ends meet between rent and car payments and loan payments. So any support for early childhood education is support for not only us as educators, but also the kids and the families. But thank you.
Thank you, and thank you for illustrating so well the connection between care and the impact on families. I don't see any questions, so we'll move forward. Thank you again for your time here today, Bruno. I'd like to have Antonia Edwards speak, followed by Howard Savronski.
Good morning, everybody, and good morning, Madam Chair. I'd like to, afternoon, I'm sorry. I'd like to say thank you to Senator Armour, who I personally work with, Ms. Tammy Exum, who I've heard so much about. I want to give a special shout out and thanks to Senator Kelly, Senator Summers, Senator Wong, also Senator Formica, and also the staff that works directly with Senator Kelly, which is Nicole and Jason. And the reason why I mentioned them is that I'm here today to speak about my grandson who died as a result of the inadequate services in the mental health services here. This took place in 2020. I've spoken and I've testified about this and racism as a public health crisis last year. So my testimony is the same because nothing's changed. So I don't want to get into the long background as a result of it. My testimony is there. I've convinced my daughter to speak today. So this will be the first time she's publicly spoken about this tragedy. So her name is Antonia Edwards. She's 165. She'll be speaking about her personal experience. So I just want to go back and talk about solutions. And I also want to commend you guys for this comprehensive, collaborative, bipartisan effort to make this happen. I've been asking for this for the last 4 years, and I sit on several boards. I sit on Children's Behavioral Advisory Board. I'm also a part of Connecticut Council Development Disability, DCF RAC, DCF Review Panel. And I've been in Connecticut hitting the pavement, trying to understand and be able to navigate the system here in Connecticut, and immediately found out that there were holes. I would have never thought in a million years that my grandson would die as a result of that.
2 in the morning.
That's crazy.
Excuse me. I would never thought as a result of that my children would suffer or be directly loss of life as a result of it. So this is my grandson, Devon Edwards. Because of a mental illness situation with my granddaughter, my daughter and I were begging to get services and we were denied. And I want to bring back something that Senator Winfield spoke about, and he politically, tried to ease this into conversation, but I'm very direct. We have got to get rid of the racial disparities in Connecticut. We were racially discriminated against. We had implicit biases and racial biases. We had preconceived notions brought against us. And that's why the services weren't provided. We need, number one, expert providers that specifically understand mental health. And I think that Dr. Fortunati spoke about that, and also Dr. Almaden. Also, one of the biggest things that I asked for, and I've been asking for, is standalone urgent care mental health facilities. I've seen this operate in other communities, and I think it will be very advantageous for us to do so here, because also you get rid of the stigma of the emergency rooms and the inundating of it. One of the other biggest things that Representative Petit spoke about, he asked the doctors what were their priorities. So as a community person, a parent, and also somebody who works in the community, the priority is expert doctors who are culturally competent, who aren't racially biased, who understand people in the underserved communities. We have a chronic underserved community situation here. And in the Black community, I can personally speak of, we have taboo. We don't talk about mental illness. And we're definitely not going to talk about it if you're constantly calling DCF on us. So DCF has a high rate in our community.
Excuse me, Ms. Edwards, can you please sum up? Your 3 minutes are over. Thank you.
I'm almost finished. So DCF has a high rate of unfounded phone calls that are called on parents in the Black community, unlike the other Connecticut. So I'm just asking for people to take this serious. I'm really appreciative of the fact that we've come this far. One of the biggest things I'm going to ask for also is a family coordinator or liaison. Parents do not have anybody who can advocate on their behalf when they're in the emergency room or any parts of this whole system. And it has to be somebody who's non-governmental. So I think that by listening to to the Better Way program that was proposed by Senator Kelly, that's one of the biggest things that's needed in the community, to have parents, to have somebody to be able to liaison on their behalf. It's very cumbersome and very complicated for parents to understand what services are available and what their rights are and how to legally get this stuff done. So I thank you for listening. Again, my daughter, Antonia Edwards, will be coming on. She's number 165. Please allow her to explain to you guys what it means to lose 2 kids within 24 hours. I thank you for listening to me.
Thank you so much for being here. And I think I speak for everyone. I'm so sorry for the loss that your family has faced. But thank you for sharing that with all of us.
No problem.
Representative Cabros-DeGraw, her hand raised.
Yes, thank you so much. And I am on the Public Health Committee. I think you remember I spoke with you last year.
Yes, you did.
Yes. When I hit that button on SB1, you were definitely on my mind. And I remember you saying that your granddaughter was discharged early from a facility, and that you think was
6 times, 5-6 times. And guess who's in there now? And without, I'm not the type of person that speaks negatively to anybody. We're just very confused as to how she can be cured in less than 2 years. So something needs to be put in place. It should be, if somebody has a mental illness, let it be the mental illness and let's get it cured. Juvenile justice or being arrested shouldn't be a part of that. And I'm just making that clear, that we have to put stuff in place. This child was sick for 3 years prior to this, begging for services, constantly kicked out of the hospitals in the middle of the night in the parking lot, racially discriminated. Our backgrounds were researched by clinicians, not by DCF. They felt like we were too intelligent. We spoke too eloquently. We were too versed in medical. So, something had to be wrong. We're making stuff up. And then to have these kids' accounts coded Mound Sound syndrome by proxy was a slap in the face. And so that's what actually happened. And thank God, Senator Kelly and his staff seen every piece of document, every video, every picture that was drawn, the demonic stuff that was being said, and everything that she told the doctors and told us that she would do, she ended up doing it. She ended up killing my grandson. So I'm really passionate about getting this corrected. And as I said in the press conference with Senator, I could walk away, but I'm not walking away because I want to correct it. I don't want this to happen to another parent, another caregiver. I want it corrected on my watch because I feel like I put enough time into Connecticut for all the volunteer work that I do. Everybody knows who I am. And so if I give my free time to understand and learn the system and help other people, my grandson shouldn't have died. So since he did, I'm not mad, I'm not angry, I'm just hurt. And I just want this not to happen to any other parent. And I don't want people to whitewash the racial discrimination that happens in Connecticut because Antonia suffered it directly. And my heart hurts because of that, because I fight for everybody. And so for me to have to experience death due to racial discrimination is really bothersome. And I want that part corrected immediately.
And if I could just ask one question, when she was discharged, was there any outpatient service plan that was put into place?
No, every time she was presented to the ER, and other parents could probably testify this, if the child doesn't present as being homicidal or suicidal, even though we have a video saying that right before it happened, that they run around the house chasing us with knives, drawing in the coffin, the ER was like, well, they're not doing that now, so you can go home. And so if you don't want to take the kid home, more Black people are like, okay, let's call DCF. Why? We're telling you it's an endangerment. It's not that we don't want the child. We're telling you that there's an unstable situation. So you have to look at the fact that there's a cultural incompetency factor, that there's always something wrong with Black people when they say that they don't want to bring their child home. But I see plenty of white people dropping their kids off with suitcases because they need respite. That has got to change. Black people and minorities have to feel comfortable telling you that there's something wrong. And that's why I ask, why can't Black parents be mandated reporters? If I say something's erratic with my child, I don't want to be scrutinized. I don't want you to look in my kitchen cupboards and looking for something that's not there. The child is dysfunctional at this point or at risk, and I'm afraid for them and I'm afraid for me. So that's what happens in our community. And there's so many Black people, and probably Black and brown as well too, who don't come forward because of this discrimination. They know that they're going to be insane scrutinized. They know the DCF is going to be called. So I don't want that for them. I want them to feel comfortable presenting what's not right or what needs to be done for their children and not be scrutinized and not be discriminated against because of a preconceived notion, because of a non-cultural doctor that's seeing them who has some preconceived notions about Black and brown people.
Thank you very much. I'll let my colleagues ask their questions.
Thank you so much.
Thank you, Representative. Senator Kelly.
Thank you very much. And Antonia, thank you very much for sharing your story. We understand how difficult that story is, but how necessary and how critical it is to changing the system for all the reasons that you state. There are many, but unless we have conversation and discussion about it and understand what has transpired, we can't fix the system going forward. So thank you very much for sharing your story with us. I think it's poignant and it's important and it's being heard. Thank you.
Thank you. I just want to make sure that if I don't tell my story, nobody knows it happened. And that's what's been happening in Connecticut. People don't tell the story because they're frustrated. They don't think anybody's going to listen to them. And so I'm just not going to allow that to happen. I don't want this to happen to any other family. And that's from the bottom of my heart. That's why I do this.
And thank you.
No problem.
Thank you, Senator. Representative Exum.
Thank you so much, Madam Chair. And thank you so much, Ms. Edwards, for coming forward. I know, I hear your pain and I know how difficult, I can imagine how difficult that is. And I have to say that I am so glad that you're not walking away, that you are using your voice in this way and you're being heard. And yes, for my part in this, I just want to mention that having culturally competent expert providers that really understand is really important. That's a piece of prioritizing that voice when it comes to looking at service providers and incentivizing and prioritizing that, because it is important. And there are biases that come. And sometimes that is not heard or recognized, but it has a lot to do with the outcomes that we see. So I think that's important. And when you mentioned the standalone facilities, I don't know if you heard earlier that there is a push. Did you hear that with DC?
I was so happy to hear that.
Yes.
I did.
Yes, and I think that will be tremendous, and that will go along. And that is something that we're going to look at. They said in a couple of weeks we should see RFPs going out. So
Marshall mentioned. Yes, I did. Yes, thanks.
Yes. And then the piece around the liaison, that coordination piece, that is critical, because parents need to know the thing that happens. You're exactly right. You're in the emergency room and they say, okay, I'm clear, but you know the problem isn't cleared at all. And you need someone in there to help link and give that support in the home. So that is something also that for me is critically important, that we're also putting into this bill as far as having programs and services to support, and so that people can be able to get them regardless of whether or not your child has Medicaid services or not. Everyone should have access to that. And so I just want to let you know that we can't change what happened in your circumstance, but we try to put in place measures that prevent other kids and families from going through what you're experiencing. So thank you so much. I appreciate you.
This might change for me. And so what I think that having a family coordinated liaison is so important, because that trickles over into PPT meetings. In Massachusetts, we have this. I'm from Boston. Here in Connecticut, there's nobody that represents the family. You're given a list of acronyms, you're given a list of places, resources to go to. And even when you call 211, which is, I love 211. However, it's very intimidating to somebody who just doesn't understand all our acronyms, doesn't understand the different services. There should be somebody there that represents or protects the family interest. And it should be somebody non-governmental. And that's one thing that, even though I was that for my daughter, they didn't really respect me because I was a natural resource. It's something that should be mandated and respected in that position.
Very good. Thank you. I appreciate it.
Thank you, Representative. Senator Huang.
Thank you, Madam Chair. And Ms. Edwards, thank you so much for your passion. I'm truly sorry for your loss.
Thank you.
You standing up and speaking for your loved ones. Unfortunately, in this case, it's of a tragic loss, but I want to applaud you because you reflect of so many caregivers and grandparents and parents that are speaking up on behalf of their children and are passionate and will not be dissuaded. And it is the voice that you give. It is the difference that you're making for us to be here today. So I just want to simply thank you and your tireless effort in advocating for all parents and caregivers that are fighting for their loved ones. So thank you for the great job and the passion that you bring to it.
Thank you. I want to make sure people understand, I truly understand that mental illness is an equal opportunity to disable. I don't want anybody to think that, you know, saying I'm choosing one side or the other. I'm just saying that my experience as a Black person and a Black family in Connecticut was totally different from that of somebody from another culture. And I know that for a fact, if I went through that with all my knowledge and expertise, other people are too. I talk to other people that are in domestic violence situations with their kids and kids with their siblings, and people don't speak up because they don't want to risk the fact of going through this, scrutiny. And it's really sad. So people think domestic violence is man and woman or intimate partner, but no, it's actually kids and family and moms. This really happens when your child beats you up or your child smacks you or your child, has a tantrum or meltdown. Parents are embarrassed. They don't want to say anything. They don't want to face the fear of being scrutinized. And then to do so, and then have DCF called and DCF is not horrible, but people don't know that because it's used as a threat and an instrument. And it's not right. It's not right at all. And so that's why I'm here to speak up to say, listen, I'm not better than anybody else. I'm knowledgeable. I sit on these boards, but guess what? It happened to me. And I'm not going to rest until we resolve these issues and until we make a difference for people in the community who don't know what I know. And so that's why I do this. So my daughter's going to come on. She's 165. She has never spoken to anybody publicly about that. She did talk to Senator Kelly's office. She felt comfortable doing that. So please just allow her to speak and get it off, because this is probably healing for her as well too. I told her it's time for her to talk about it and be a spokesperson for other parents so they can understand what it's like, to have gone through this and learn from it. And that's what we're here to do. We're trying to make ourselves available for people to learn so that they don't go through the same thing we went through. So
I appreciate you sharing that so others will not suffer through that. And it's also important that we talked about mental health. It also reaches out in so many different aspects of our society and life. And in this case, the discussion about domestic violence, which is so important to address. But again, thank you very much for your time and your voice for others.
Thank you. Thank you for listening. I really appreciate it. Thank you for your heartfelt condolences.
Thank you so much. Just echoing what everyone else has said about taking the time to share and have these harder conversations with us. And please let your daughter know that we are here to listen and to learn from all of the experiences. So she shouldn't feel worried or nervous, but I really thank her in advance for her bravery for sharing.
She's been pacing back and forth all morning. Am I up yet? Am I up yet? She just
It'll
wants to
be
get
a
it out
little
now.
while.
Yeah,
It'll be
I
a
think
little
it's gonna
while,
be
but
Thank
I'll
you
look
guys
forward
for
to it.
Thank you.
So much.
Have a great day. Bye-bye.
Well, thank you. Next, we will hear from Howard Savronski from Connecticut Children's, followed by Carl Scheissel. I apologize if I mispronounce anything.
Hi, can you hear me? Great. Thank you, chairs, members of the Public Health and Children's Committee. Thank you for the opportunity to testify today on such a critical issue. My name is Howard Savronski, and I'm the Chief Behavioral Health Officer at Connecticut Children's Medical Center. As you know, Connecticut Children's is the state's only independent children's hospital focused exclusively on the needs of children. We're also the state's largest provider of pediatric emergency behavioral health services. Today, I'm offering my support as well as some additional feedback regarding HB 5001 and SB 2. Please note that in addition to speaking in front of you today, you'll find that I also submitted more detailed written testimony to the committee. I'd like to begin by first applauding lawmakers for prioritizing children's behavioral health this legislative session. The legislation is historic and represents a significant effort to improve mental health care for children and families. Although highlighted during the pandemic, providers and families will tell you that the pediatric behavioral health crisis existed long before we ever heard of COVID-19. Immediate short-term and long-term solutions are needed to address this crisis and ensure that families across our state are able to access the appropriate level of behavioral health care for kids when they need it and where they need it. Currently, there are significant workforce shortages affecting every professional discipline that makes up the pediatric behavioral health system. The state must address this critical issue and develop a robust behavioral health workforce pipeline that includes all disciplines with a focus on diversity to ensure that we meet the needs of all families across the state. As much as additional beds and programs are necessary to treat the growing pediatric crisis, there must be trained professionals to staff these beds and programs. Connecticut should be proud of its EMPS program that has played a significant role during these past 2 years. We're pleased to see the additional investment proposed for EMPS and the requirement that DCF administer an EMPS data repository. We trust that DCF will use this data-driven approach to track program utilization and performance to ensure that all staff are deployed in the most efficient way in response to peak hours and to those communities in greatest need. As pediatric providers, we recognize that mental health care is an integral part of a child's overall health. The state must support more innovative policies that lead to a comprehensive and integrated behavioral health system. Adopting collaborative care options, as well as addressing insurance practices, will help advance integrated care in Connecticut. We must do all that we can to pursue insurance parity and address current insurance practices that interfere with access and delivery of effective mental health care. As state leaders, you have a tremendous opportunity before you to think boldly and transform the way we support kids and families in Connecticut.
I'm sorry, Howard, if you can finish up, please.
Sure. The proposal in the bill to add membership to the existing implementation advisory board should be enhanced to also require, as a deliverable, a proposal of how the state should structure its leadership and oversight of health and well-being for children. We urge legislators to require a proposal from the implementation board by December 22nd, 2022, calling for the development of a children's cabinet or similar oversight structure to broadly focus on improving the health and well-being of children in Connecticut and foster accountability, transparency, and innovation through child-first policies. This proposal could then be enacted in the 2023 legislative session. Ensuring that all kids have access to services and supports will take our collective leadership and investment to make these interventions impactful and sustainable. We look forward to continuing to work with our state leaders on this endeavor. Thank you.
Thank you so much for your continued advocacy and highlighting the needs that we have to take care of our kids. Representative Pettit, you have your hand raised.
Yes, Madam Chair. Thank you. I've asked this question before to a few people. I wondered your response. We got some good testimony from Dr. Johnson about primary prevention, and I wonder your thoughts on that. And secondly, the question of, since I assume you're at some level involved in the recruitment of people to remain in the state, what do you think are the top two priorities in terms of incentives to get people to be trained at places like Yale and UConn and through other programs to remain in the state?
Yeah, thank you for those questions, Representative Pettit. Primary care is a key element of any delivery of care to kids. They are the primary providers of healthcare and the largest number of people who prescribe medication for kids with behavioral health problems. If we're looking to expand our workforce capacity and provide true integrated care, and to be able to intervene early in a child's life, a focus on integrated primary care is essential. We also know from all the research that it takes about 7 years from the time a child is first screened and diagnosed until they can receive appropriate mental health care. So if we can enhance and support pediatricians' ability and confidence in dealing with behavioral health issues in their practices, we can better identify, more quickly identify, more rapidly get these kids into care, and hopefully alter a negative trajectory and improve health outcomes for these children as they grow older. And I applaud the legislature to include various components of enhancing primary care in this bill. And I think that will go a long way. Connecticut Children's has experience over the past 2 years. We have a clinically integrated network of pediatric practices, and we've provided them with a 9-month training program specifically for behavioral health support to train and to enhance pediatricians' capability and confidence. And I think if you ask your pediatrician if they were trained to provide behavioral health care, many of them will say, I became a pediatrician because I didn't want to become a psychiatrist, but being a pediatrician, I become a psychiatrist. And many of them don't feel that they have the equipment and the training and the skills needed. So it's incumbent upon us now, recognizing this crisis, to be able to deliver that support, both in terms of education, consultation, such as Access Mental Health, and creating a greater flow of into our mental health support systems. Now, in terms of recruitment and retention, what we're in the process of a major recruitment effort as along with everybody else. What we're finding is that the marketplace has dramatically changed over the last 2 years. And I've been in the field for a very long time. And when I started 100 years ago, there was a shortage of child psychiatrists then, and it's not gotten any better. What we are finding is that that folks coming out of medical school with training at that level can name their own price, basically. So we have to really look at the current market, what the demands are, and how do we remain competitive because we're competing with every state around the country. So that's one issue. And the other is that we really have to look long-term in terms of creating a pipeline of professional growth and opportunity for not only physicians, but nurses, social workers, all of the different disciplines that contribute to the behavioral health workforce. And as early as starting with high school kids and educating them and showing them that there are opportunities in going into healthcare that they may never have considered before, and to provide incentives such as loan forgiveness, tuition reimbursement, to help with the tremendous financial burden that is often placed on people who want to commit their professional careers to providing care to kids and families. We all know how people are struggling with paying off college loans. We also know the amount of loans that a physician has to repay coming out of medical school, fellowship, advanced training, and it makes it unworkable for so many people to even remain in the field. So we need to have a broad-based approach to find ways of maintaining competition, or being competitive in terms of salaries, but also finding ways of creating that pipeline.
Thank you, sir.
Thank you. Senator Anwar.
Thank you so much, Matt. I just wanted to thank Mr. Savronski for guiding the committee and all of us through the entire process. Your experience and your availability has truly helped us shape these bills and hopefully help the children when it passes through all of its phases. Thank you again for being here today.
My privilege, really.
Representative Linehan, Madam Chair.
Thank you, Madam Vice Chair. Hi, Howard. It's so nice to see you. Thank you for being here. I feel like we see each other all the time now. But I wanted to take a minute to say thank you very much for your guidance to our committee, not just in this legislation, but over the years. We've been working together for quite some time now, and I really do appreciate you. I just wanted to ask you if you could briefly, for the benefit of the committee, explain how CCMC, or Connecticut Children's now, has created this protocol where there is suicide screening to all children who enter the ER, regardless of why they've arrived. And if you could tell us what your findings have shown.
Sure. So I think we all recognize that suicide is sometimes that people quietly suffer with depression and thoughts of hurting themselves. And about 4 or 5 years ago, the Connecticut Children's instituted suicide screening in our emergency room for all children ages 10 and above. That's for kids coming in with a broken arm versus kids coming in with an eating disorder, or kids coming in, with other kinds of medical conditions. And what we've uncovered is that kids do suffer silently, because the rate of positive screens have been gradually increasing over the years, to the point where we've recognized that suicide really is, or it validates the fact that we know that suicide is a major public health concern, not only for kids who are coming in an acute mental health crisis, but for kids who otherwise would never have revealed their thoughts of hurting themselves had we not asked. And let me just say that what it also demonstrates is to challenge the myth that if you ask a kid of whether or not they wanted to kill themselves, it's going to encourage them to do that. And we know from years and years of experience and research that that's just not true. And in fact, the suicide screen, which is very direct, it's 4 or 5 questions, have you thought about hurting yourself? Do you feel that the world will be better without you? Do you have a plan to kill yourself? Has revealed and allowed children to express these deep feelings, never before asked, because most parents, I'm a parent, it would take me a lot of courage to go and ask my child those kinds of questions. So there's a lot of value we've seen around the country in doing these kinds of screening, and we are looking at expanding it throughout the hospital, and we're seeing a broad effort nationwide to institute some form of suicide screening at all levels of contact with children. We're involved, we're with Bradley Hospital in Rhode Island, and they have a major suicide initiative with the schools, where they're training teachers and school personnel to employ the same type of screening that we're doing in the ED in school settings, so that we can be more diligent, more proactive in identifying kids early on before it gets to a crisis that unfortunately will lead to an unfortunate outcome.
Yeah, and I know those questions that you asked during the screening, and even hearing you say them out loud, it was like a punch in the gut, and I could see all the faces of my colleagues, and I recognized that I was not the only one on this call that felt that way. I believe that the numbers were over 20% that screened positive for suicidal ideation before the pandemic, and then rose even after that. And so my follow-up question, and my last question for you is, so there are only a few questions. This screening really doesn't take long. Do you find that it has been a burden to the physicians in the emergency room to ask these questions?
First of all, they're designed to be administered by non-medical personnel. So it's usually a nurse that administers it. And we have a two-tiered screening process. So if the child screens positive, but has no plan, does not appear to be at risk, then we will provide one level of intervention. But if the child seems to be more acutely depressed and suicidal, an additional screening is done to further delve into what is going on with that child. And that's done by a licensed clinician, either a psychiatrist or a social worker. So there are measures in place to address both the level of acuity that is determined at the point of initial screening.
Great, thank you. It sounds to me like these are really important screenings to be done in every emergency room setting and in every pediatrician's office setting. So thank you very much, sir. I appreciate your time.
My pleasure.
Thank you, Representative Linehan. I 100% agree with wish we could expand these, the questionnaire, the screening, because it is so important. And just wanted to thank Howard for mentioning the very important point of asking the questions doesn't lead to an action. And in fact, asking the questions can prevent an action. So thank you for making that very clear. Representative Exum.
Thank you so much, Vice Chair Wielander. And so good to see you, Mr. Savronski. You have been invaluable. I just want to echo what was said earlier. A part of this process, your willingness to assist and to provide resources, just your knowledge through Connecticut Children's. And one of the things that I wanted to ask you about after listening earlier to Ms. Edwards' testimony is around the care coordination piece. And if you could speak a little to what the care coordination piece looks like and how you might choose, how you might want to enhance that, or any plans around enhancing that piece would be appreciated if you could tell us a bit more. Thank you.
Sure. Yeah, thank you, Representative Exum. Good seeing you again.
I know,
again. Yeah, we're very fortunate. We've got a fairly robust care coordination department at Connecticut Children's. We were funded many years ago under a federal grant. So we provide care coordination to our kids who are coming in with medical conditions, but we also have behavioral health care coordinators that are working in our emergency room that were funded through another grant that we got. And we are firmly committed to providing that level of support to families. One of the, I guess, the most universal characteristic of the behavioral health system is that it's totally fragmented. And even the most sophisticated, well-educated, well-financed family will find it overwhelming to try to figure out how to get from point A to point B. So this has nothing to do with anything other than the system being so overwhelming and recognizing the needs for all families to need help, and to get families to raise their hand and say, we need help. because it is very frustrating. The care coordination we provide is family focused. And to Ms. Edwards' point, we try to address the individual needs of a family rather than just making a general referral. Oh, your kid needs mental health care. Well, here's the name of the local clinic. We try to get to know the family, what their unique needs are, and then really help direct them to what might be the most responsive and the most culturally appropriate service available to them in their community. And I think that's really critical. There's been a mounting effort nationwide to promote care coordination. Right now, care coordination is not reimbursable. And I know this is not necessarily an issue that comes under the scope of our state legislature, but it's something that I think we all need to raise a voice for in our national conversations, that we need reimbursement for care coordination in order to really make the system work for kids and families and for adults. Doesn't end in childhood. The systems are fragmented, they're difficult to navigate, and anything we can do to help folks navigate the system would really improve access and outcome.
Absolutely. Thank you so much. And I'm glad that you highlighted that it's not reimbursable, but that it is something that's being viewed right now on a federal level, because that to me is a really big part of what's missing, is that link.
Correct.
Is that child is leaving, and in that spot where they're not stable, the family is really uncomfortable bringing the child home, but not sure how to really connect with the proper resources. And then of course there's a wait time, even when you do connect sometimes to the resources. So,
Correct.
Okay. Thank you so much. And I will continue to see you.
Very well.
I appreciate all of your support. Thank you.
Thank you, Representative. Representative Zupkis.
Thank you, Madam Chair. Good afternoon. And you may have answered this question, I just didn't hear. When these questions are asked to kids, are parents given the answers? Are parents in the room when these questions are asked? How is it handled with the parents?
We try to do it privately with the child, but if the parent insists on being there, the parent's allowed to be in the room. And your parents are always involved in any of the outcomes of any medical tests. So yeah, the parents are, because ultimately we have to develop a safety plan for these kids, which has to include the parents, especially if the kid is being discharged back home and there's some question of their suicidality and they don't need to be in hospital. Then there has to be a very honest and direct conversation with the family about, do you have guns in the home? How do you secure medications? How do you make sure there are no sharp objects? What's a safety check of the child's bedroom? Things that parents don't often think about in terms of providing a safe environment for their child that may be at risk. So the parents are always involved, and they may not be present during the initial screening, but they're brought in with the results. Yeah.
Great. I'm glad to hear that. Thank you. Because as you said, it's very important that I know if it was my child, I would want to be involved, because we're all in the best for our children. And so I would want to know what they're being asked, what were their answers. I would want to be a part of it. Thank you.
Thank you, Representative. Representative Cavister-Graw.
Thank you so much, Madam Chair. I'm so grateful that we're talking about this, and I'm going to share this with permission of my now adult child. I was one of those parents who had to find the courage to say, have you thought of harming yourself, and do you have a plan? My child at the time did say, yes, I have thought of harming myself, but lied when we got to the do you have a plan question. Right. So I want to just put that out there, because for parents who are able to, gather the courage or have that little niggling voice in the back of their head saying, you better ask some questions here, something's really going on, I think it's important to put that out there. I know you're on the hospital side. I guess my question is, and I know that some do and some don't, is this the sort of thing that you would, say want to see at routine, as a routine mental health screening in pediatric offices, sort of as, I believe we've talked about that. But, you also referenced in terms of having that plan of, securing guns or knives or pills or whatever it might be in the home to help cut down on the incidence of suicide. You know, is that the sort of thing that you hope is happening outside of the hospital system to hopefully help prevent people from getting as far as you?
Yeah, you know, it's what we've heard over the year. What I've heard over the years, even before I came to Connecticut from docs, is I'm afraid to ask because I don't. Once I ask and get a positive response, I don't know what to do. So I'm better off not asking. So I think we have to appreciate that and really build the necessary supports around our pediatric practitioners so that they feel not only comfortable, but confident that they have the tools in place to be able to effectively respond should they screen a child and find out the child is suicidal. And I'm talking about, you know, right now, if that emerges, the immediate reaction is send them to the hospital. And the question is around, you know, I've been very involved with the urgent care planning, and we have to find other ways of managing behavioral health crises without having a knee-jerk reaction to send kids to the ED, which in many ways is more traumatic to them than the actual underlying problem that they have. So I think that, yes, pediatricians should be considering suicide screening, but it has to be done in the context of making sure they know what to do once they have a kid that presents with that kind of need. You know, okay. I hope that answers the question.
No, it did, and I thank you, because I think that that's, you know, in the case of who sees them more often, or you know, and obviously the parent normally would be with most kids at their pediatric appointments, et cetera. So just having that space for both the doctor and the parent as well. So thank you so much. I really appreciate it.
And a lot of it, you know, just depends on the age of the child too. You know, all this gets modified based on developmental stage, and what you do with a, you know, a 9 and 10-year-old, you're not going to do with a 16, 17-year-old, right?
Right.
So.
Yeah. Thank you.
Thank you so much again for your time and your help on all of this. I'm new to the committee, but really enjoy working with you and learning from you, and for highlighting the need for continued care and coordination across the board.
Well, we're thrilled to be part of this process, and whatever we can do to support this, we're here to help.
Thank you. All right, seeing no other hands, I am actually going to pass the meeting over to Senator Kushner and continuing to listen. Thank you.
Thank you, Representative Wiehlander. And next up, we have Carl Chisel, number 52.
Thank you, Senator Kushner, Representative Steinberg, Senator Anwar, Representative Linehan, Senator Abrams, and all the members of both committees. My name's Carl Schissel of the Connecticut Hospital Association. I'm also a tri-chair of the Children's Behavioral Health Plan Implementation Advisory Board. Thank you for making children's mental health a priority. CHA's written testimony is available for your review. There is much for hospitals to like about House Bill 5001, coverage of collaborative care management, workforce provisions, telehealth extensions, expedited licensure provisions, increased access to care, reimbursement rate and parity studies, and the prior authorization provisions are all excellent. Thank you very much. I wanted to give you a snapshot of what's happening in our emergency departments today. Between February 1st and 24, the number of children in emergency departments who were evaluated and awaiting placement in inpatient care grew from 26 to 38 patients. During that same period, there were roughly 3 inpatient psych beds available for each day for these children. Yesterday, there were 38 stuck children in our EDs waiting for inpatient psych beds. Where were they? 18 were in Connecticut Children's, 5 in Yale New Haven Health, 4 in New Vance Health, 4 in Eastern Connecticut Health Network, and the remaining 7 in other hospitals around the state. I wanted to mention this as well. There were also 60 adults awaiting inpatient psych care in our EDs yesterday. 31 were in the Yale New Haven Health System, 9 in Hartford Healthcare, 7 in Middlesex Hospital, 5 in Trinity Health of New England hospitals, and the remaining 8 in other hospitals. My point is, while we're talking about a bill that's focused on child's mental health, this is a lifespan crisis and a statewide crisis. So with respect to House Bill 5001, we're going to ask you to consider 5 additional improvements. First, please offer direct operating and capital assistance to any hospital that is willing to dedicate additional space, equipment, and workforce to eliminate growing wait lists for inpatient psych beds. As was mentioned earlier in the hearing, Massachusetts offered hospitals a one-time supplemental payment of up to $150,000 for each new psych bed and a temporary supplemental payment rate of $330 per day for new child and adolescent care provided. Perhaps Connecticut could make similar investments to resolve the crisis. Second, and as you've heard a lot today, please direct additional resources to partial hospitalization, intensive outpatient, community programs, and home care for both adolescent and adult patients, including Medicaid rate increases. Third, we support the
Carl,
temporary
can you
waiver.
finish up, please?
Oh, absolutely. Third, we support the temporary waiver of the CON process, but we'd like you to clarify that a CON will not be required to repurpose or eliminate a bed added pursuant to the waiver. Fourth, please consult with our emergency department physician directors as you require DPH to develop a pediatric behavioral health screening tool in Section 38 of the bill. And then finally, as you implement in Section 44 efforts to establish in-home respite care services for parents or guardians of children, think about the need for such services for our adult and geriatric patients as well. Thank you for the opportunity to speak to you today, and I'm happy to answer any questions you might have. Thank you.
Thank you for your testimony. I see a couple of hands, and hold on one sec. I apologize that I didn't see the order in which they went up, so I'm just going to start from left to right and go with Representative Carpino.
Thank you, Senator. Carl, it's good to see you. I just have a certificate of need question for you. And if you can't answer this, if you could direct me to the best person who could. I agree with you wholeheartedly about the shortage of beds for the pediatric as well as the adult population. And I'll be honest, I don't know anyone who disagrees. But we didn't suddenly come upon this problem. This has been a long time coming, and something that many parents and family members who've needed services have documented. So I appreciate the leeway in this bill with the certificate of need issue, but have any of the providers or institutions in the state of Connecticut tried to build additional capacity for inpatient beds and actually run into a certificate of need issue? I just want to understand if there were specific issues in the past that we should make sure we solve with this particular piece of legislation to the inpatient bed issue specifically.
Right. Thank you for the question, Representative. And I'll put it this way. We're in a crisis situation, and I understand the need to take action quickly. And it's a crisis that's been a long time coming. I've been on chairing the advisory board since 2015 in the aftermath of the Newtown tragedy. So the pandemic has exacerbated and made these problems worse. As I think about the need to rapidly bring online additional beds and space and things of that nature, there are delays and expense that are associated with the CON process. And I know Commissioner Veltri spoke earlier about steps being taken in her office to sort of address those issues. But I can tell you that these impediments to quick action does disincent facilities, to go down that road. So I think there's a lot. So fortunately, more resources in OHS to help administer the CON process, I think, will help address the backlogs. But there are also some procedural measures that can be taken in the CON process to expedite it and ensure that, hearings occur efficiently and expeditiously, and that decisions are made real quick. I can remember a time 10 years ago where there was a deemed approved clause in the state statutes, which required OCA at the time to take action within a certain time parameter. And if they didn't, the application would be deemed approved. It was quite an incentive to get the department to do its job. And sometimes I think maybe we ought to bring back the deemed approval in order to create some real consequences for the agency if they don't do their job in a timely fashion. Thanks for your question.
And I appreciate the answer, and maybe we could take this offline because I want to be respectful to the other 200 people who want to testify, but I'm looking to see if there are any specific hurdles and requests for pediatric or inpatient beds that hit a particular hang up to make sure that we solve them. Thank you. And thank you. I think Madam Chairwoman, thank you.
Thank you, Representative. And next up is Representative Pettit.
Thank you, Madam Chair. Carl, thank you very much for your very specific recommendations. I don't want to spin a lot of wheels on CON, but as I understood what you said, the issue from the hospitals is the back end of CON. If they open up beds and want to decertify beds, you don't want that to be a hindrance on the back end as opposed to the front end. And as you probably know, OHS has got the money now for 3 more staffers for CON.
Yeah, thank you. We're looking forward to some improvements there. And, I'm not aware of any existing hospitals that have been thwarted in their efforts to add beds, but there have been some inordinate delays and complications associated therewith. And we're in it for the long haul. So we're happy to work with you and OHS to make process improvements. Very much committed to that. Thank you.
And I assume there's much more physical space. Today's numbers, we got to nearly 2,000 during the peak of Omicron, and now we're down to 235. So that's 1,700 plus beds cleared out over the past month or so. So I assume that's been a big help. I realize the med surge versus psych beds are different issues.
Yeah, very much so. Dr. Fortunati testified earlier about the cost of sort of creating an inpatient psych bed. The story's different depending on what part of the state or which hospital you're talking to. In some places, it really is a space problem. They would need to make a capital investment to repurpose space and bring in the facilities. And the regulation and oversight of psychiatric beds, all appropriate to manage things like ligature risk. They do create some very real expenses in terms of trying to create the space and bring in the equipment to accommodate psychiatric patients. And I can tell you for the record, hospitals are willing to do it. They just are having trouble affording to do it at the moment. And I can say in some hospitals, there are practical space issues, and in others, it's more, and frankly, as you all know, the overriding issue is workforce at the moment to get the staff to populate these beds. But I know you all are taking steps to help us in that department too, and I appreciate that.
No, agreed. I assumed you implied that there's a number of places that could open up beds right now, but they cannot recruit the nurses, the psychologists, the psychiatrists, the psych APRNs to staff the bed. So anyway, appreciate your very specific recommendations. Thank you. Thank you, Madam Chair.
Thank you. Next, I'll recognize Madam Chair, Representative Linehan.
Thank you very much. I appreciate that. I appreciate you being here, Carl, and lending us your insight. I just, as one of the main people writing this bill and putting it together, I have consistently struggled with the idea that inpatient beds are somehow going to solve this problem. I don't see it. And earlier in your testimony, and I recognize that we're all coming from different places. And so what you're looking at is you see that there are people waiting for these inpatient beds. However, and something I mentioned earlier in this public hearing, in terms of inpatient beds, those are not cures. They are stabilization methods, and they are typically when you someone needs that stabilization, maybe needs medication, and needs to formulate a safety plan to go home. And once they go home, that's when real psychiatric care kicks in. I speak to parents all the time who say that their child never even has therapy when they're in an inpatient care. It's really about stabilization and then creating a good environment for them to go home to. So the numbers that you gave, saying that all these people are waiting for these inpatient beds, I struggle to believe that these are people who in no way, shape, or form can possibly be safe at home. And I can't help but think that that's because we don't have, not that we don't have enough beds, but because we don't have enough of the partial hospitalization programs, the intensive outpatient programs, and all of those things that allow, and we're talking about children here, right? That allow children to go to school, be with their families, but still get the treatment they need and have the safety plan. So if we're looking at this bill holistically, and we're going to put money where it's most important to put that money, I recognize maybe beds might be part of it. We heard the $125,000 per bed, but don't you agree that it would probably be better if we were to create more PHPs and IOPs, and then we wouldn't need those beds at such a high cost?
So I recognize that it's the battle of competing goods. You know, there's so many good ideas and things that need to be done. And I wanted to sort of offer my perspective on this in response to your comments, Madam Chair. There's a crisis that's happening right now that needs to be addressed. And so for us as CHA to come before you and say, here's what we're seeing in our EDs in this moment. There are people who need inpatient psychiatric care, and we're having trouble getting them placed from our EDs into that care. That's a phenomenon that's been happening, let's say, over the past 4 months and needs to be addressed. And so we're inviting you to help us help those patients. But it all falls into the context of the continuum of care. And I agree wholeheartedly with you and applaud the efforts that you're making as a legislature and the governor, to his credit, to address pre-hospital, in-hospital, and as you were saying, post-hospital. Because what we really want are people living in recovery or living in a way that allows them to manage whatever their behavioral health disorder is in a way that allows them to be productive and live happy lives along with their loved ones. So it becomes, you know, the decision that you all have to make. How do you apportion, you know, the limited resources you have at your disposal to have the greatest impact? And I think investments in pre-hospital, like in Senate Bill 2, in schools and things, are terrific. What I'm here to talk about is what's happening in hospital. But you also heard me testify that we wanted you to help us out and our fellow community providers with the post-hospital stuff. And it isn't all hospital-based IOP or PHP programs. It is the home care program and the in-school program and the after-school program. So we just want to make sure that, you know, we're trying to do our best to solve the immediate crisis and sort of address the wait lists where they are. And the wait lists are, as I described, in the inpatient setting, but also in the post-hospital outpatient setting, as you accurately point out. So I'm hoping there'll be something in this bill for everybody to help us address the crisis, but also do system improvements to ensure that we're not in this situation again. So thank you for raising the spectrum of care as a priority. I appreciate it.
Sure, thank you. And I just want to throw the last thing in there before I pass it back is that, you know, you keep referring to partial hospitalization or intensive outpatient as post-hospitalization. And I can say from a parental perspective that there have been many times that those things are actually pre-hospitalization and they are keeping kids out of the hospital. So, you know, and I will still struggle to believe that those large numbers of people waiting for beds are people who can't partake in those instead of going to inpatient care and still be safe. So, so I'm going to still struggle to get over that hump, but I recognize where you're coming from and I appreciate your testimony. So thank you so much. Back to you, Madam Chair.
Thank you, Madam Chair. And next up, we have Senator Anwar, also Chair of the Children's Committee.
Thank you so much, Madam Chair. Thank you, Mr. Schissel, for your testimony. Truly appreciate it. I have a couple of questions I wanted to clarify, if I could. And actually, one question and one comment. The question is that we heard from Commissioner Veltri or Vicky Veltri, and then we hear from you, and it's almost like we need to figure out how to reconcile the perspectives. And I think we're trying to reconcile it with the legislation. But it seems that when you talk to Office of Health Strategies, it appears that CON is not as big of an issue, but when you talk to the hospitals and the fact that all the people who want to come and take care of our patients here, they are feeling the barriers are so significant, they might as well go somewhere else. So I'm trying to navigate what is the way, and then are there models that are in other parts of the country that have helped take care of the children's behavioral health needs in some of these situations?
Yeah, thank you for the question. I'll say it this way. One of the things I liked about the CON waiver provision in House Bill 5001 was that it just eliminated, the potential for additional cost and delay in trying to quickly respond to the crisis, that I was referring to earlier with respect to inpatient psychiatric care. And of course, our recommendation is to essentially treat it as a crisis measure. I know it only spans a period of a few years, but the idea under our current CON statute, at least the way we're reading the bill, while you could add beds pursuant to the waiver, once the crisis is over, and perhaps there's the possibility of repurposing those beds, that you'd have to get a CON in order to make that change. That's something we're sort of asking to be clarified. One of the things I also wanted to say is that with respect to beds, there are some substantial differences between a med-surg bed and different types of psychiatric beds. And so, we hear conversations a lot about how we have too many beds or we don't have enough beds, and there's short-term, intermediate term, and long-term beds. And what about the beds? And I'm not a clinician, so I tend to focus on where the wait lists for services. And if there are people waiting for something, then maybe that's where we should try to direct our immediate attention. And so I do tend to try to focus explicitly on this current ED, I'll say, backlog. And if we've got patients in an emergency department who are evaluated and are simply awaiting transfer into an inpatient facility, be it in the hospital or at Solnit South, it does tell me that maybe we need more beds. And our experience over the past 4 months, is that with respect to the demand for inpatient psychiatric services in this post-pandemic era, it's clear that we haven't had enough inpatient psych beds available in order to help the people who need our help. That may change, but in the immediate time frame, we do have an inpatient psych bed crisis here in the state of Connecticut. I hope that's responsive to your question, Senator.
Yeah, it is a tricky question, but I hear you. I mean, I'm even last night I received a text. Every few days I receive a text from a parent who's been waiting there for 48 hours for one of their child to get a bed. And so when you start to see what's happening, it gets still tricky. My thought is having some flexibility in the beds without the regulations, so that there is a changing, as we heard, that there's a pattern change of the number of children needing the inpatient level of care changes throughout the year. And then we have medical problems that change throughout the year as well. And there may be opportunities to flex them to be able to address these issues and cross-train some of the nursing staff, so we can actually be a little efficient in coordination. I wanted to make a comment, and if you would be able to take this back to the hospitals, if you could. There have been studies that have been done, which I'm sure are not going to surprise you. The physicians who are self-employed or employed by physicians are likely to stay in a community as opposed to those employed by hospitals. And that's the impact of the corporatization of medicine, where the physicians and the healthcare workers try to move on to other places or other states which are considered more physician friendly. So within those policy terms that we have to look at, the hospitals and the administration have to look at what they're doing by some of their management to impact the physician community, which is subsequently impacting the patient population. So I know you're aware of that data, I'm aware of that data, but that's enough that it's part of the problem. So if you can be part of the solution, we would appreciate that too.
Thank you, Senator. And, you know, I'd be remiss if I didn't mention, you know, Connecticut's relatively oppressive climate for medical malpractice as well. You know, we train some great medical clinicians in our state, and many of them leave because, you know, a variety of reasons, but one of them is from time to time does tend to be our medical malpractice environment. Just thought I'd mention that for the record, but I'll bring your comments back as well. Thank you, Senator.
Thank you so much. Thank you. Thank you, Madam Chair.
Thank you. And I now recognize Representative Exum.
Thank you so much, Madam Chair. Hi, good to see you, Carl. And thank you so much for your input up to this point. It just occurred to me something that feels like a little bit of a disconnect that is happening for me. When I think about hospital beds, the way that I've been referring to it in my mind, I've been thinking about people going, and in this case, we're speaking about children and youth, going to the emergency department and going in and waiting for a bed for stabilization purposes. That is not a place where they receive treatment as far as the types of treatment needed in order for them to become stable long term. And when we look at like the articles that people have noticed, it was in the newspaper where the children were lined up, you know, in the hallways because there weren't enough beds to accommodate them in the emergency department, which is different. And so what I think you're talking about is therapeutic beds. When we say hospital, they may be in different places. There are places that are, I'm just trying to get some clarification here. So I'm thinking about places like, say, IOL that needs more beds in order to have the type of treatment, whether it's intensive inpatient, whether it's partial hospitalization, whether it's running outpatient programs. So when you're speaking of beds, are you talking about beds in hospitals to keep people for treatment purposes or for stabilization purposes?
Right. So thank you for the question. You know, the emergency department is really intended to treat the emergent medical condition and, you know, stabilize the patient in that moment. When a patient is suffering from a mental health or substance use disorder, they will often require, you know, inpatient services in order to get them through that period and stabilize them. In those settings, you know, there is the full spectrum of behavioral health clinicians there. There's a chair of the psychiatry department. There are psychiatrists, LCSWs, social workers, and other individuals, you know, who can help treat that patient and help them, you know, meet their medical needs. Once the patient is sufficiently stable to effectuate a safe discharge from the inpatient setting, you know, that's where they're released, you know, with a plan, hopefully, that includes whatever regimes need to take place and whatever treatment needs to take place, you know, once they're discharged. But it's all about making sure they're sufficiently stable to live their life in recovery and manage, you know, whatever the disorder is. It's one of the things that differentiates traditional medical problems from many of these disorders. It makes them hard to treat because there are relapses and circumstances of life that come into play. Not every hospital in Connecticut, you know, has inpatient psychiatric services. Many, obviously the hospitals that I was speaking about earlier all do. But it is, in fact, an inpatient level of care that is different from what happens in the emergency department, and of course is very much different than what would happen on the outside. And that's where we're experiencing, the bottleneck. The pandemic has sort of exacerbated, some troubling trends before, and we're just seeing more patients with more acute disorders. People put off care and things got worse. Many of them have comorbid conditions where there are medical conditions that need to be treated as well. And in those instances, a hospital is probably the best place, for these patients. But I'd be happy to sort of outline sort of the different levels of care, for purposes of clarity. More than happy to do that. Thank you, Representative.
You're welcome, and thank you for that. I think that would be really important because I think, especially to people who are not as familiar, and there are so many pieces here, that they're reading about the emergency department having the weight. And that is not the place where the stabilization and the care takes place. That is where the stabilization takes place. And then there's a transfer somehow, whether you are transferred back home or whether you're transferred to a partial hospitalization or whether you're put in inpatient. And what you're saying is we need more beds that deal with the actual acute patient that needs a bed that is this $125,000 to outfit beds that aren't that type of bed. And but at the same time, we're trying to figure out if we need more places that hold people and give them the care that they need. That is an outpatient, inpatient. But I think the bed situation has become a bit conflated, that emergency department bed versus the in-care, the inpatient and partial hospitalization piece. And it just came to mind as you were speaking. So I just wanted to get your clarification, and I look forward to the further information you'll provide. Thank you so much. Thank you so much, Madam Chair.
Thank you. And I don't see any other hands at this time. So thank you for your testimony today.
Thank you.
Next up, we have Anna Witkowski, number 54.
Hi, can you hear me?
We can. Go ahead and proceed.
Okay. Hello, members of the committee. My name is Anna Witkowski, and I am the Chief Education Officer at Children's Learning Centers of Fairfield County, CLC in Stamford. My colleague CEO was on earlier. We do serve about 923 children ages 0 to 5 in 8 centers in Stamford. We are open 51 weeks a year, 10 hours a day, and we offer a holistic approach to serving our children, mental health and social emotional development being our highest priority. So thank you for the opportunity today to testify today on Senate Bill 2. All of the early childhood centers have been underfunded for a very long time. We know that it's a huge crisis in Connecticut, and early childhood centers are an essential part of Connecticut's infrastructure and well-being. This became crystal clear during the pandemic when many centers closed due to lack of funding or the inability to hire qualified staff. And it's something that we are still dealing with today. We are also dealing with the mental health consequences of the systemic underfunding. Children more than ever now are exhibiting challenging and dysregulated behavior. We are seeing mothers that are coming in that are depressed and are asking for help. There needs to be an increase in funding for early childhood education now. The early childhood educators, the wonderful staff that all of my colleagues have that are dedicated, don't earn wages that are comparable to public school staff. Childcare providers should be paid on the true cost of quality care. The current rate, again, has remained the same for years, $8,900 in 2015, $8,900 in 2022. Prior to the pandemic, CLC had a turnover rate with staff about 12%. Currently, we're facing over a 30% turnover rate. Hiring teaching staff has become nearly impossible because we can't pay the competitive wages. And what's even more sad and disheartening is that they leave the field altogether. So who are the ones that suffer? Children and their families. Children aren't attending the state-funded programs because these programs can't recruit qualified staff to maintain proper ratios. And as a result, we have classrooms that we can't open. Families need to go to work and are forced sometimes to leave their most prized possession, their child, with a neighbor or in an unsafe and potentially dangerous and isolated environment. And there are also
Anna, can you sum up, please?
There are also many families who can't afford the cost of early childhood education. It's tragic that during the most critical time of a child's development, especially social emotional development, we can't abandon them now due to chronic underfunding. So now more than ever, our children need us. So thank you, and I appreciate you listening.
Thank you, Ms. Witkowski. I don't see any hands, but I do want to say that I think it's disturbing after all these years of paying attention to this issue that things are not getting better. And in fact, from your testimony, we're hearing that they're getting worse. And so we thank you very much for this testimony today.
And I want to thank you, Senator, also. I do remember you coming down to Stamford, so I applaud your efforts. Thank you so much for all that you and everyone else does. We appreciate it.
That was 20 years ago, by the way.
Yeah, I remember.
Thank you. Next up, we have Christie Valka. Is Christie here? Number 55. I know I saw her before, I thought so.
No, I'm here.
But
thank you all for sitting through many hours of hearings with many hours to go. I would like to share my time with Tashiana O'Connor if she is still on, and if that's okay with all of you. She is also signed in as me, so you'll see another login under my name.
I'll check with the clerk if you could advise us whether that can be done. It's a little tricky when there are two people with the same name. I'm not seeing a response from our clerk. Maybe they're checking the waiting room. Why don't you begin?
Okay.
And if we can.
And I do apologize. We tried to contact the clerk earlier.
Okay, I do have a message that the person is in but hasn't unmuted. So I believe the person is here.
Okay.
So go ahead.
I am here.
Okay. Why don't you get started?
Okay, I'm
the other is here, but
can you hear me? Can you hear me?
Yes, but would you make sure to identify yourself for the record?
Yes, I'm Tashiana. I just want to start off by thanking the committee, co-chair, and members for the opportunity to testify in support of SB 2 bill. My name is Tashiana Alexandria O'Connor. I live in Waterbury, Connecticut, where my business is also located. I'm a child care family provider of TikTok around the clock 24-hour daycare. I don't know what happened. It went off. Okay. I came to Connecticut in 2008 to give my children a better future. I was offered a job that paid me $60,000 a year. As a mother of 8 children, 2 whom are currently serving this beautiful country, I got a job offer for $60,000. I realized how difficult it was to pay for childcare on a $60,000 salary, with my husband and I making total of $90,000 a year. I decided to get that education, open my own family childcare setting, and cater to nurses, mothers, both morning and afternoon shifts. I currently charge under price, and I do not charge parents the Care for Kids the fee that Care for Kids provided. Care for Kids provide this fee, and Care for Kids give parents the ease to knowing that, you know what, I will help you out, but there are fees that parents are allowed to pay. I realize how expensive it is, so I want to be able to help parents, single mom and single dad who works as I just want to summarize everything. Single moms and single dad who work. And I'm going to ask you panelists that if you remember about your grandmother, parent, neighbors who make an effect and form and shape you into who you are today, who you become today. Those are the ones you're saying yes to with these bills. When you say yes to bill SB2, you're saying yes to your grandparents. You say children are the future. Our children are the future. Your grandchildren and children are the future. By saying yes to bill and provide more money for childcare, early childcare, mental health for our children, it makes them and shape them to who you are today. And that's what I have to say. I don't want to go into the whole thing. I want to make it small so Christine could have her time. And I just want to leave this with you, that remember who have that effect on you, who shaped you into where you are today. Who was your third grade teacher, your preschool, your neighbors? Who were they? And that's who you're saying that we shouldn't have to be here to beg for money to help our children. That should not be an issue. But you know what? Unfortunately, it is. Too long we stand back. And now we're here to stand for our children,
Thank you.
our
Your time is
future.
up. Can you
Thank
please
you.
summarize?
Thank you. Unfortunately, that took up all the time, but I do see a hand from Senator Anwar, our chair of both committees. So I'm going to call on Senator Anwar, and he may have a question for you, Christie, as well. Go ahead, Senator.
Thank you so much. Thank you for your testimony. And I think what you described is the story of not one, but hundreds of people in our state where childcare workers are leaving their jobs and childcare centers are just unable to sustain their capacity, which is actually the first part of the domino that is going to result in the workforce not being able to work. And you made it in your personal narrative helps us reaffirm our commitment as legislators to try to do the best to take care of our children and then create a safety net, a home away from home for the moments when the parents are not at home. So I truly appreciate your testimony and look forward to making sure that we collectively can do better to make sure that we protect your industry. And in future, we will have to readdress it completely, but right now we need to protect it. So thank you for your testimony.
Thank you, Senator Anwar. And I do want to ask Christie if this is the experience of most of the people that you're working with.
Yes, I represent All Our Kin. I'm the Vice President for Policy at All Our Kin. We work with about 50% of Connecticut's family child care providers. That's about 900. They take care of about 3,800 children across the state. This is absolutely the experience that they're having. Tashiana shared one story that is repeated over and over and over again. I want to go back to something that Commissioner Buys said 6 hours ago. She said, we have to fix the whole system and we have to start with the workforce. The request that you all have heard today for $700 million for the next year is to fix that first domino. It's to stabilize the workforce, $500 million to stabilize the workforce, and $200 million to make it possible for additional families to be able to access childcare, like the families that Tashiana spoke about. So yes, these are not isolated stories. What's extraordinary about the stories you're hearing is that the providers have taken a day off of work so that they could be here with us today. And we thank you.
Well, we thank you for your work, and we especially thank Tatiana and the other providers that you mentioned that are here today. And we recognize how important it is to hear from them. So thank you. I don't see any hands at this time. So I am going to move to the next person on the list. And is Eva Goldburn, I'm sorry, in the room? Eva? I see her on the list, but I did not see her on the screen. If you're here, Eva, please unmute yourself.
Good afternoon.
Here you are. Thank you. Go ahead, Eva.
My name is Eva Goldburn. Members of the Public Health and Children Committee, thank you for the opportunity to testify on SB2. My name is Eva Goldburn, and I live in New Haven. I have been a teacher at Hope Child Development Center for 10 years. I have 4 daughters. One is the director owner of the Hope Child Development Center. Another is the executive director of Circle. Another daughter is a freelance photographer, and the other daughter is the ethic counselor for the National Institute on Minority Health and Health Disparities. I am very proud of my children, and I am asked all the time by the old parents, what did I do right? While there is not one thing that I can point to, I can definitely say that creating a loving, nurturing, and stable environment for my children was the heart of their success. This was not easy for me to do when my children were younger. However, this is why I am able to connect, comfort, and support the parents who have to leave their children in my care at Hope. Many of these parents are new mothers, and I am the first stranger that they are trusting to take care of their babies. The majority of the time, it is the parents that I'm taking the most care of and providing guidance to. As new parents, I still have parents reaching out to me for guidance and their children and for advice, even though they are no longer at Hope and their children are grown. This is a circle of security that I help to create for families. As an early childhood educator, and I'm proud of the start that I have given to all the babies that I help to nurture over the past 10 years. Sadly, as I near retirement, I do not have a retirement plan that I can really rely on outside of Social Security and my husband's pension. These are not enough to support me. While I know my daughters are always be there to help me with my needs, the industry without these assurance. Many of the providers have no assurance on industry, on insurance. We need to recognize and honor the important role early childhood educators make to the development of mental health and well-being of children and families. This year, we need $700 million down payment on what should eventually be a $2.5 billion system that will enable the people who dedicate their lives to doing this work to not have to depend on the state for assistance when they retire. Thank you for your time and consideration.
Thank you, Eva, and thank you for your service. And your testimony was very touching. It reminded me of the people in my life who helped with my children when they were young and how successful they are. I always attribute to the teachers and the caregivers in their lives. So thank you so much for your testimony, and I couldn't agree with you more. We need to make sure you and the others in your service have adequate means. And so thank you for testifying. I don't see any hands, so I'm going to move to the next.
Thank you for having me.
Thank you. Next up, we have Jewel Clark.
Hi, can you see me, hear me?
Yes, we can. Go ahead and proceed.
Okay. Members of the Public Health and Children's Committee, thank you for this opportunity to testify on SB2. My name is Julie Clark, and I own and operate Cass Preschool and Childcare Center in Woodbury, Connecticut, which I began in 1989 in my living room as a single mother with 2 small children. We opened with an enrollment of 5 children, and today we care for and educate approximately 150 children from 3 months to 5 years old from Woodbury and the surrounding towns. In all of the 30+ years that I have been in business, I have never seen such a dire situation affecting parents, children, and caregivers. Early childhood education has always been a touch and go business with a myriad of regulations and parents' limited budgets. It has always been a career that attracted primarily women with a significant other in their lives that allowed them to work in a field they loved for a ridiculously small salary. I myself dealt with this situation by offering young mothers free childcare as well as their salaries, thus securing a loving and dedicated workforce that I could afford. Now, however, with the advent of COVID, not only are people opting out of this line of work and choosing higher paying jobs, and let me note that working in fast foods is a higher paying job, but those that have remained in the field are suffering a huge amount of anxiety and upset. Not only are the educators and caregivers having a terribly hard time, but so of course are children and families. I am encouraged that SB2 calls for additional funding to address this crisis. In general, the early childhood field's greatest challenge now is our inability to hire staff. A typical classroom at CAST has 2 teachers, a head teacher, and an assistant. I will emphasize that this is barely sufficient in a classroom of young children under the age of 4, many of whom require one-on-one attention. Due to this staffing shortage, we have been forced to close classrooms or have only 1 teacher in a classroom, or even of more concern is the fact that we are simply not able to give enough time and attention to a child who exhibits challenging needs or behaviors. All children, but particularly these children, are suffering during this difficult time. It is imperative that we stabilize the childcare industry. We need to provide our dedicated teachers and those young people who have ambitions to enter our field with salaries that will afford them a decent income, commensurate with the wages paid to early educators in public schools. If we lose any more of our teaching staff going forward, we will be unable to continue this valuable service that young families and our economy depend on. Many childcare businesses have already closed their doors. After 33 years, I am struggling to keep mine open. It is my understanding that this year we will need a $700 million down payment on what should eventually be a $2.5 billion system to enable parents of the 170,000
Excuse me, can you please summarize? Thank you.
under 5 to access free pre-K and high quality affordable childcare in the setting of their choice. In this system, our teachers and the childcare providers all over the state would be paid for the true cost of quality and the immeasurable service that they provide. Thank you so much.
Thank you, Julie. And I'm sorry I mispronounced your name, which is ironic, given that we share the first name.
No problem.
It is wrong on the screen. I do know how to say Julie. So thank you for your testimony. It was, it's really amazing the work that you've done. I don't see any hands at this time, and thank you for staying with us today and sharing. Next up, we have Myra Watnick.
Can you hear me?
Yes, I can. Go ahead. And
Okay. Good afternoon, Senator Kushner, Senator Anwar, Representative Linehan, Senator Wang, and distinguished members of the Public Health Committee and Committee on Children. Thank you for the opportunity to provide testimony today on HB 5001, an act concerning children's mental health, and SB 2, an act expanding preschool and mental and behavioral services for children. My name is Myra Watnick, and I am the Director of Rehabilitation Associates of Connecticut, one of the birth to 3 providers, serving more than 1,000 families each month. We actually have 2 birth to 3 programs. One specializes in working with children on the autism spectrum. The other works with children with any type of delay that qualifies them to receive services through the Office of Early Childhood's Birth to 3 program. In addition to speech pathologists, occupational therapists, physical therapists, and teachers, we have licensed behavior analysts who specialize in working with children on the spectrum and any child who has behavioral issues. We provide consultations, behavior plans, and a coaching style of interaction so that families can successfully model positive behaviors. We have licensed clinical social workers and a school psychologist who has specialized in working with the birth to 3 population. All of these individuals have multiple degrees and are experienced and highly paid. They are overworked and barely able to see all of the families who require their services at this time. The rest of the staff have asked to meet with the social workers as well regarding their own mental health during this stressful time. We are providing reflective supervision to our staff to support their needs, and we are not currently reimbursed for this staff support. Working remotely and working in the home and daycares has caused many problems for staff as they need to go back home or go to the office when parents are canceling last minute. And the children require many more behavioral services in real time. Meeting the demand for these behavioral interventions require additional staff that is so hard to find and keep in the system long-term. COVID-19 has made everything more difficult. Delivery of services in a timely fashion and meeting the needs of families in crisis. The pandemic has been 2 years of continuous trauma for children and families, and Connecticut must act now to meet the behavioral health needs of children for years to come. I appreciate the legislature's intent to do so. The mental health of families and staff alike and children's behavioral challenges is causing a heightened level of crisis management. Birth to 3 behavioral health service delivery needs to be expanded as we add home and community settings as additional test sites.
Excuse me,
Birth to
can you
3
please
does not have
summarize?
wait lists per se, but it takes longer from the day of intake to the start of services. We are looking for your support to increase interim gap payments to programs on an emergency basis. In addition, loan forgiveness for staff would go far for attracting much needed staff. Thank you for the opportunity to testify and for all the considerations. There are many programs that are considering leaving this year. We need to keep all of these experienced programs operational so there is adequate quality service delivery for the children and families in Connecticut. Thank you for listening.
Thank you, Myra, for your testimony here today. I don't see any questions, any hands up for questions. Just let me say that we appreciate the work you're doing and that you were here to inform us today. Next up, we have Virginia DeLong.
Good afternoon, esteemed committee members. My name is Virginia DeLong. I am the Director of Counseling and Admissions at Norwich Technical High School, but I come to you today in my capacity as the Government Relations and Advocacy Chair for the Connecticut School Counselor Association that serves over 1,400 school counselors across our state. I want to start by saying I've been listening to testimony since about 10 o'clock today, and it's very clear that our children are in a mental health crisis in the state, and that the magnitude of this system, because this is very systemic, that needs to be repaired and fixed and supported is a huge task that you have. And I thank you for addressing children's mental health issues this year in the legislature. I want to talk specifically about HB 5001, Section 18, where you list student mental health specialists and you neglect to mention school counselors. And I'm hoping that's an oversight, but in the event that it is because legislators do not understand our role or our education and training, I would like to touch upon that today. We have 6 counselor educator programs in the state of Connecticut preparing school counselors, and we have 1 in the works as an online program through Sacred Heart University to start this fall. Our school counseling graduate students take several courses through a KCREP accredited program, which is the gold standard of counseling programs. And they take courses such as counseling theories, counseling child and adolescents, counseling skills and techniques, assessment, group counseling, and on and on and on. They participate in a 100-hour practicum and a 700-hour internship with an experienced practicing school counselor as part of that program. School counselors are on the forefront of what's happening mental health-wise in our schools every day. Students spend 7 hours of their day in school with us. And it's important that we have the mental health staff to recognize what the needs of our students are when it comes to their mental health. We are working right alongside of our school social workers and our school psychologists to provide multi-tiered systems of support, MTSS, and school counselors really focus on that tier 1 preventative and intervention services to our students. Our social workers and our school psychologists, as well as school counselors, are then focusing more on those tier 2 and tier 3 intervention services. We're all making referrals to outside sources, which has been mentioned several times today, are at a huge deficit, especially in Eastern Connecticut, where I live. There are 4 to 6 month waiting lists to receive counseling services from an outside provider. So we need to have staff in schools that can help triage some of the mental health issues that our students are having, particularly focusing on some of those more minor mental health issues before they become full-blown mental health issues that do require outside sources.
Can you please summarize?
Absolutely. So what I am asking is, one, that the legislature look at revising the language on Section 18 and adding school counselors, but really thinking how we can work to support hiring more school counselors, social workers, and school psychologists in our schools through programs like this grant funding program that is mentioned in Section 18 of HB 5001. Thank you.
Thank you, Virginia. Thanks for being with us today and bringing that important point out. I see Chairman and Senator Anwar has his hand up.
Thank you so much, Ms. DeLong, for your testimony. This was very insightful. I do have a few questions because that's going to help me clarify. You know, there's some schools which are counselor heavy, some are social work heavy, and some are saying we need psychologists. And it's a mixed bag out there. What is the right answer? And it sometimes gets confusing.
Yeah, so I don't know that there's ever a right answer, so to speak. And I know that our commissioner, spoke earlier, education commissioner spoke earlier today about schools really needing to figure out what works best for them based on their population. The reality is that all 3 of us have incredibly high caseloads. I don't think there are any that within the state are really meeting our National Association caseload recommendations. But I can tell you that, there are situations like, for example, in my school, there are 4 school counselors, including myself as a director, and we have a social worker and we have a school psychologist. I definitely would love another school counselor, but I certainly could use the need for another social worker and school psychologist who can focus more on those tier 2 and tier 3 interventions with students, so that we can really focus on that preventative work at tier 1. So I wish there was a concrete, simple answer to your question, but the reality is, a rural school district versus an urban school district versus a suburban school district versus, a technical school versus a, traditional high school, like the needs of those schools are going to be different. So it really needs to be the school districts understanding the 3 roles and understanding the ratio in their buildings of what they need. But the reality is, regardless, you need to have all 3, because while we overlap in our social emotional services that we provide to students, we each have unique roles separate from that in the way that we serve students.
Okay. And within your membership, with the youth services bureaus, how many of you are collaborating with the youth services bureaus within the school systems?
I don't necessarily have a number or percentage, but I can tell you in conversation that a lot of us are collaborating with youth service bureaus. But I formerly worked in Lebanon, which does not have a youth service bureau. So you do have communities within the state that are not connected to a youth service bureau program. And I know the state is aware of that because I went to a meeting a couple years ago and they asked me where I was from. And they're like, oh, yes, we know you don't have one in the town of Lebanon. So I certainly think that where they exist, it's definitely a resource that we're using to help our students and kind of, take some of the burden off the work that we're doing in schools. But I think with anything, those connections can be strengthened even more so as we move forward in helping to deal with student mental health.
Okay, and Madam Chair, if I may, I just wanted to ask one more question. How much and how many of the counselors are using telehealth at this time, or using technology to connect with the students and communicating?
Yeah, so I think a lot of us are, maybe not as much this year as we were in the past year and a half, when a lot of us were fully remote or hybrid. With all of us being back in school, most of our services at this point are in person. But with anything, we've had to grow and adapt, right? You know, all of us have. And in one way that I think a lot of us have done that is providing that option to students who might be quarantined or unable to come to school for whatever reason right now. I know some of my counselors have used it with students as a way to connect and keep those students connected to school. So it's definitely still being used, probably not as great as it was in the past year and a half. But certainly, like everyone else, we had to learn to adjust and pivot and do what we needed to do to meet the student needs outside of this actual physical school building.
Thank you so much. I may have more questions, but I know my colleagues are going to ask those because we connect with telepathy. Thank you so much, Ms.
And thank you, Chairman Anwar. Next up, we have Madam Chair, Representative Linehan.
Thank you very much, Madam Chair. Yes, Ms. DeLong, I just wanted to let you know that indeed you were always meant to be included in the first draft. It was just that we tried to get it out as fast as possible, so it was an oversight. But I want to be very clear, it would be your group as well as other mental health clinicians that make sense in the school setting, right? So we're also talking about marriage and family therapists, licensed therapists, anyone who we think that the school district would want, which brings me to my next point, and then we'll move on, is that there are two sections there where you'll be added. The first would be in the grant program for the direct hiring. And then the second is there is another grant program for districts to utilize funding for creative services for mental health for kids. So that could be anything from continuing the LEAP program that was put in place, which for those who aren't aware of that, let's use Waterbury for an example. They instituted the LEAP program, and then they have counselors, social workers, and community members going door to door to kids who aren't coming to school, and they've had tremendous success, and they found that that really does work with mental health. So I just, for everyone watching, I want to be, I just want to know that we really know, understand, and appreciate the work that you all do. And we absolutely want you included. But there will be two spots so that districts can utilize that money. That's why it's a grant program, to say, these are the great things that we're going to do with this group of people, because that's what our district needs. So thank you so very much. We did say that at the press conference, but none of the press picked that part up. So thank you. Thank you so very much. And I'm sorry if we created some sort of panic within the crowd, but you're absolutely involved. So thank you so much. Thank you, Madam Chair.
Thank you very much, Representative. I think that I truly believed it was an oversight after the last 6 years of work we've done in talking to legislators, and we've actually pushed for a grant program was one of the ideas we had, because it has been successful in states like Colorado, who have been doing this for over 10 years and using a grant program to hire school counselors. So my hope is that this will be successful here in Connecticut, and the legislature will be thinking long-term on how to continue to fund a grant program for several years, because this crisis existed before the pandemic. It's been exacerbated by the pandemic, and I can tell you for certain, as a practicing mental health professional every day, that this is not going away anytime soon.
And we agree with you. And just as a quick follow-up, that is why in this legislation, the grant programs, there is a requirement that anyone availing themselves of these grants does need to provide data back to us, so that we can use that data to show members of the legislature that it is important to continue these beyond the grant program and look at it and its efficacy if it deserves to be a budget line item. So that's exactly why that's in there. So thank you very much.
Thank you.
Thank you, Madam Chair. Thanks for clearing that up. That was important. Next up, I recognize Representative Exum.
Thank you so much, Madam Chair. And I was about to say the exact same thing as Representative Linehan, because that was absolutely an oversight. So thank you for pointing that out today so we can have the opportunity to speak on it. But it made me think of another thing. I'd love your insight or your thoughts around, and it has to do with the reporting. Earlier, I don't know if you heard, we were speaking with State Department of Ed with the commissioner, and there's a place in the bill that asks for reporting of, now we will broaden it from social workers again to all types of behavioral health workers. And I'd love your thoughts about that reporting requirement, if you think that would be helpful for us to ascertain or not.
Yes, absolutely. And I'm glad that you asked about that. So that's something else our association has been pushing with the Department of Education. And while I can't say for certain it was because of our advocacy, I do like to believe it was because of the work that we've been asking for. So in the past, the way the school districts report the number of school counselors, psychologists, and social workers in a district has been in one lump group. So it was very hard to delineate how many school counselors a school actually had, or a district actually had, how many social workers there were, and how many school psychologists were. They were kind of lumping us all in together. And that's problematic because, as I mentioned before, we do similar work, we have overlapping work, but we also have very specific roles in how we work with students. So it's important that you're having all three of those in your districts. So my understanding is that we actually found out the other night that the Department of Education has said that going forward, starting this fall, I believe when the reporting occurs by schools and school districts, that it will now be separated out between the three groups. And I think that is imperative for so many reasons. It's important for school districts to be able to see that data, boards of education to look at that when they're making decisions about hiring, or in some cases, unfortunately, cutting positions in districts. It's important for legislators to be able to see that, to have a greater understanding in your communities where the money is going and how students are being supported and who they're being supported by. So we are absolutely in support of that information coming out, and we are very pleased to hear that finally, after many years, they're going to be delineating that data, so we can have a clearer picture of, where the supports are lying in our school districts.
Thank you so much for that. That's an important piece of information to understand, that having one lump data point is not the same as really teasing out the details. Thank you. I appreciate it. And thank you for all you do. I know this is a very trying time, and will continue to be, as you said. So hopefully there's some relief on the way. Thank you.
Thank you so much.
Thank you, Representative Exum. Next up, we have Catherine Scheinberg-Meyer.
Good afternoon, distinguished committee members. My name is Catherine Scheinberg-Meyer. I've been an attorney at the Center for Children's Advocacy for 12 years. And recently we founded our new medical legal partnership project at the Yale Child Study Center, which is the first children's behavioral health medical legal partnership in the country. In this role, I collaborate with mental health providers and I consult with the many client families who have health-harming legal needs. I'm here today representing the children in our state's poorest districts, the ones who are in schools with one part-time social worker for every 900 kids, the ones who are most likely to suffer from the challenges of poverty and environmental trauma. This is who Representative Winfield and Commissioner Durantes lifted up earlier in this conversation. And we are all viewing this bill through the lens of racial justice and equity. Our client stories are central in my remarks today, and two of whom have actually submitted testimony. I'm just going to highlight a few points. I'm going to focus on the school-based services, and my written testimony elaborates far more. So first, I just want to say, while Connecticut has been a progressive leader in some aspects of school discipline reform, the fact remains that children as young as 3 years old are still regularly pushed out of school. This means that schools cannot meet their needs. These needs, as we know, are often expressed as challenging behaviors, and they resort to calling parents to pick their children up early from school over and over and over again. And though state law requires this exclusion to be recorded as a suspension, many schools do not do so, which leads to inaccurate school discipline data, and this minimizes us understanding the scope of the problem here. If we want to keep kids in school and if we want to truly fight racial and ethnic disparities in school discipline, we have to start with investment in support on the ground. We have to expand the pool of caring adults available to provide trauma-informed restorative care to these children. These adults must be compensated fairly, provided with training and on-site coaching, and must feel supported by their school administration. That's key. And so this bill nicely outlines the variety of people that could fit this characterization. I want to also emphasize the need to dial into the existing local agencies that already have strong ties to the community. I also want to just quickly speak to Commissioner Russell Tucker's drawing attention to the fact that SDE has many very high quality, thorough trainings that they already offer. I think the problem is we don't always get the right people in the room for those trainings. And a lot of districts don't have the ability to provide the follow-up to make sure that things are really being implemented. So I want to just caution that while we continue to make sure that SDE is the expert on these areas, we have to make sure that there's implementation and follow through with what the trainings are providing. I finally just want to speak on the points earlier about the intervention measures for truant students. We all know that chronic absenteeism numbers are at an all-time crisis level. And while I'm strongly in favor of ensuring that we have the right school staff consulting with families, assessing individual student needs, I just want to make sure that we don't circumvent special education law, which already requires a prompt referral to a planning and placement team meeting for students who are expressing truant behavior. I just want to point that out because I would believe that'd be an unintended consequence. Thank you again for your time. I see a lot of friendly faces on this tiny screen. Like Ms. Goldburn who spoke earlier, I have 4 daughters at home today and it's chaos and mayhem. And I'm here to answer questions and collaborate more offline. Thank you.
Thank you for your testimony and thank you for managing so well. And your kids were so well behaved, we didn't even hear them. I don't see any hands, so thank you, and I'm sure they'll be in touch. We'll be in touch going forward. Thank you.
Thank you.
Next up, we have Ann Smith. Is Ann here? Ann, I see you. I see your square, but you can unmute, and if you want to put on your camera, we can see you then. I don't know if Ann stepped away from the computer for a moment. Sometimes that happens.
I did not step away. I am here.
Great. We can hear
paying
you.
rapt attention. And
Great. Go ahead.
So thank you so much. Thank you to the distinguished members of the Public Health and Children's Committee. My name is Ann Smith. I am the Executive Director of AFCAMP Advocacy for Children. We are a community parent resource center, and we are also a partner in the Connecticut Statewide Family Engagement Center project. And I have the privilege of serving as one of the tri-chairs of our Connecticut Children's Behavioral Health Plan Implementation Advisory Board. I want to thank the committee members for the work that has been done on Senate Bill number 2 and HB 5001. I'd like to testify in qualified support for those bills. I am encouraged by the fact that some of the recommendations that were made by the Connecticut Children's Behavioral Health Plan Advisory Board in its October 2021 report are reflected in some of the provisions, namely in taking a look at the recommendations that we made, number 1 and number 2, around ensuring that we have a robust oversight vehicle, because when we take a look at children's behavioral health, it is not one system, it is multiple systems. It is many, many. I refer to systems in the plural because there are currently more than a dozen state agencies that have some role in supporting children's behavioral health. And that doesn't include corresponding robust representation from other important stakeholders, from family members, from community members, and for those who are not professional providers, but yet are natural supports and community-based supports for our children. We continue to advocate for greater investment, cross-agency collaboration, and better coordination of services to mitigate the systemic impacts that contribute to the need for intensive and high-level inpatient services. Many of those impacts produce disparate outcomes for children of color and children with disabilities, such that any efforts to address children's behavioral health must include a focus on inequitable outcomes, particularly those interrelated with the education and juvenile justice systems. We're supportive of certain of the goals of SB 2 and HB 5001. I would like, however, to suggest a few areas where we might be able
sorry,
to
Miss
improve.
Smith. Your time is almost up. If you would please summarize, I'd appreciate it. Thank you.
I would highlight that in light of the changing demographics that we are seeing in Connecticut, it would be important for us to ensure that when we are addressing workforce development in the behavioral health fields, that we take every opportunity to make sure that we are providing an avenue of entrance for diverse cultural and linguistic practitioners and providers. And that's not always just licensed professionals, because there are those in our communities who are able to support our young people with services. They don't necessarily have to be licensed. And so where we do have licensure requirements, it's also important that we remove any of those intermediate licensure requirements that are not necessary in order to maintain the high quality of services that we expect our professionals to provide. We did not always have these intermediate levels. They are fairly new to the system. So taking a look at removing them, I would encourage the committee to do so. I have heard from, and you have heard from many of my colleagues today who have made representations and testimony that I would have loved to have provided, but I support them. I will support them to the extent that we are looking not only to address what is immediately a crisis, and it's a crisis that pre-existed the pandemic, but that we are also taking a look at what is the investment that Connecticut is willing to make into the prevention services that can keep our children from even having to be involved at the intensive levels of care that are creating some of the issues that you've heard today in terms of bed availability in hospitals and inpatient services. So again, I do applaud you for what you have done. I would encourage you to really give an opportunity to hear more from families, to explore where we can do some robust and innovative changes to ensure that even when children are released from intensive care and are returned to their home, that we have in place those kinds of community-based family supports that can help them to keep the children from relapsing and having to go back into intensive care. And then also in terms of the ED, I would really suggest—
But you have gone beyond the time quite a lot.
I'm sorry for that, but I have to say one more thing if I may, and it's just to consider that you could include family peer advocates to help families navigate the difficulties when they do have to take their children in for services. And thank you very much for accommodating me.
Thank you, Anna. Thank you for your really important testimony. I do, Senator Chairman Anwar has his hand up.
Thank you so much, Madam Chair. Thank you, Attorney Smith, for your testimony, and thank you for the work that you have been leading in the state for the past 7-8 years. And I can tell you, your group, if we were to put collectively the number of hours that you have been working to give advice to our state about protecting our children, maybe thousands of hours collectively with the group. And I can also tell you a lot of what we have learned is been because of the work that your advisory board has done. So your written testimony would be very helpful. Whatever you say carries a lot of weight for me and Representative Linehan. And what I will do is after this testimony, I will love to chat with you in detail, make sure that we download your wisdom, a glimpse of it, small amount, because we probably may not have the capacity to download all of it, but we would love to get some more insight to strengthen this bill even further, both 5001 and SB2. So thank you for your testimony. And if you want to use a little bit of the remaining time to complete what you were trying to say, that would be helpful.
Thank you so much, Senator Anwar, and also Representative Linehan, for those kind words. And yes, I would welcome that opportunity to follow up with you. Anything that I can do to be of assistance to help us to make this bill as strong as we can, so that it can provide the foundation for continuing to advance children's behavioral health in Connecticut. You mentioned the time frame over which we've been working. I think one of the things that I would like to share is that we have made progress. Yes, we have made progress, but we can never sit back and rest on our laurels. Not only that, but we are also charged not with just doing what's for the immediate crisis, but we know that we're going to have some effects of adverse childhood experiences going forward. What can we do now with this bill to lay the foundation for continuing progress for what we know is going to be needed in the future? So yes, I certainly agree and recognize the importance of many of our stakeholders around the crisis in ERs and in inpatient beds for our children. But I would encourage us to be thinking about what is it that we can invest in. And the thing about investing is you may not see immediate returns when you invest, but we're investing in our children and our families. If we don't do that now, 10, 20 years down the road, I won't be here to see that likely, but we're going to have today's children and families suffering because we didn't make that investment. So I thank you so much, and I will be submitting my written testimony, and I'm available to you and any of the members of the committee to answer your questions and support your work. Thank you.
Thank you so much. Thank you, Madam Chair.
Thank you, and thank you, Ms. Smith. I hope you're here in 20 years. I hope I am too. So maybe not in this chair, but certainly paying attention. Thank you so much. Next up, we have number 66, personal favorite of mine, my friend Daniel Pearson. Daniel, if you'll unmute yourself. I see him on the screen. I hope Dan is with us. Okay. So I don't know if we have a technical problem or if he stepped away for a minute. But if he did, we can come back to him to keep us moving along. I will go ahead and, oh, there he is. There you are, Dan.
Yeah, sorry about that. Working on a few other things as well. Thank you, Senator Kushner, and members of the Public Health Committee and Committee on Children. Thank you for giving me the opportunity to speak in support of SB2 and HB 5001. My name is Daniel Pearson. I'm the State Director for Educators for Excellence, a teacher-led nonprofit with nearly 1,000 members statewide that focuses on student equity and elevating teachers' voices in policy decisions. Today, I submit testimony on behalf of our members who are current classroom teachers and educators, and we are grateful that the legislators are putting together comprehensive SEL and mental health bills this legislative session, because the traumas of institutional racism, poverty, and violence, and many other factors have plagued our students for far too long. These challenges have gone unaddressed for years, and COVID has only exacerbated the mental health crisis our communities have already been facing. A continuous lack of mental health resources within our schools has proven to be detrimental to our students, and our youth will continue to suffer without comprehensive care and support to address these challenges. Social emotional learning and mental health practices are vital to student success. Without proper mental health support, trauma will continuously impact the student's ability to achieve academic success. Too often, our schools' answer to students who are dealing with trauma is to suspend or expel them, directly contributing to the school-to-prison pipeline that disproportionately affects Black and Brown students. Without the proper investment into mental health support in schools and the sufficient staff to run those programs, we will continue to neglect our most vulnerable students. To ensure our students are receiving the care they need and to prevent school staff from feeling overwhelmed, We need to prioritize proper staffing with manageable ratios and workforce development pipelines. If we are serious about addressing trauma and mental health issues, we need to make the proper investment into the mental health professionals who offer that wraparound service and support for our students. We applaud this bill's focus on creating sustainable workforce development pipelines for individuals to join the mental health field, but we need to further incentivize these individuals to specifically join our school districts and our school systems, as classrooms are typically the first places where students with trauma-related issues can be identified. There are many great ideas being discussed, but none of our innovative programs are going to be effective without sufficient personnel to execute on these plans. For example, the National Association of Social Workers recommends a ratio of 1 to 50 when social workers are providing services to students with intensive needs. But currently, however, many of our mental health professionals in our schools have workloads that make this ratio impossible to achieve due to their incredible workloads. And they honestly, what they do most of the day is perform assessments on students rather than building relationships and understanding the root causes of the students' challenges. So we need to ensure our students are getting the individualized care they need, and that our mental health staff have manageable workloads and ratios to effectively perform their jobs. COVID has exacerbated and brought to light the incredible mental health crisis that our youth are facing and have been facing for years. And we need adequate mental health support to excel in school, and teachers need robust professional development, focus on SEL and trauma-informed teaching to help lead these conversations and provide restorative practices within the classrooms.
Can you
Teachers are
hold
often,
on? I have to tell this guy. Hang on. I'm sorry, Miss.
Teachers are often the first to identify when students display challenges or signs of trauma, and they need the mental health support staff and resources necessary to provide these students with the help and assistance they need. Additionally, we need to be sure to incorporate SEL throughout the entire school day, not just in the classroom, but also the bus ride to school, the lunchroom, the after-school programs. Our students should be surrounded by SEL trained and trauma-informed adults. If we do not seize our current opportunity to increase these mental health resources in our schools, we're putting our students at an incredible disadvantage. And with the extreme differences and inequities between school districts, limited access to mental health resources is just another way that we further disenfranchise so many of our youth, primarily Black and Brown students and those living in poverty. We have the power to change this and ensure these students are receiving the care they need. So I urge the legislature and to ensure that there are more mental health staff in schools, provide more mental health resources to students, and equip teachers with the proper tools to serve their students emotionally. And that needs to start now this legislative session. I thank you and applaud the work that has been done and look forward to continuing these conversations throughout the legislative process. Thank you.
Thank you, Daniel. Good to see you. I'm going to turn, I see Representative McCarty has her hand up, so I will.
Yeah. Thank you very much. And I'll be very brief, but I just wanted to reassure Daniel and appreciate very much the remarks. And just to let you know that the Education Committee is very well informed about SEL, made it the #1 priority, looking at all of the mental health supports that are necessary. And this will be ongoing. We're in complete harmony with working with the Children's Committee and Public Health, but I didn't want you to leave, Daniel, without realizing that this is a #1 high priority in the Education Committee. Thank you.
Great to hear that. Thank you.
Thank you, Daniel. Now I don't see any more hands, so thank you, Daniel. Well, I'm going to turn this back over to Chair Linehan, and I will see you all later. I'll be here.
Thank you very much. And now I'd like to call please Shakila Bruno from Ruby's Little Gems.
Hi, good afternoon. I'm so sorry. I'm still at work with my children. So if you hear my kids in the background, I apologize in advance. My name is Shakila. First of all, thank you guys for the opportunity to allow me to testify on SB2. My name is Shakila Ruby Bruno. I'm a licensed child care provider in Stanford. I currently run an in-home daycare. I also have a group daycare in a center in Stanford. This pandemic has taken a huge toll on the mental health of all of us, including our children, especially the ones who were born during the pandemic. That's why I'm glad that SB2 calls for additional funding for programs through the Office of Early Childhood. As you all may know, childcare is facing a crisis right now. I am proud to be one of the most affordable daycare providers in my town and one of the few that are open 7 days per week with extended hours. I've worked the entire pandemic serving my daycare families and essential parents at CLC in Stanford. I see the huge need for affordable childcare in my community. 82% of my families receive childcare assistance from Care for Kids, and most of them still cannot pay their family fees. I currently have a long wait list. I wish I could expand, but the funding we get from the state barely covers payroll. With the minimum wage rising, I'm afraid that my daycare will not survive. Everything has gone up except for the amount the state gives us to provide quality childcare. We have lost staff to other corporations that are able to pay more. I'm working 50 to 60 hours per week covering classrooms, opening and closing my daycares because we're short staffed. Me and my fellow providers are all exhausted with the requirements. We need to stay in compliance and stay open and also be paid so little. We need to stabilize the childcare industry. We need to build a system of support that recognizes early childhood educators as the skilled professionals that we are. Thank you guys for your time and consideration.
Thank you very much, Ms. Bruno. And just a reminder that we are also, in addition to public health, we are the Children's Committee, and we often have children in our backgrounds all the time. So please don't worry about that. Thank you very much for being here and giving us your perspective, and also thank you for remaining open. I know that's difficult, and I'm sure everybody's taking what you said under advisement. But seeing no questions, we thank you, Ms. Bruno, for your time. You're very welcome, ma'am. I'd like to move on next, please, to Jan Ponson, and I hope I'm pronouncing your name correctly, from the Yale Child Study Center. Hello, are you there?
Yes, hi, this is Dr. Linda Mays. I'm speaking on behalf of Dr. Ponson.
Great, thank you.
Thank you so much. So good afternoon, Senator Anwar and Representative Linehan and Representative Steinberg, and also all the members of the Public Health and the Children's Committee. As I said, my name is Linda Mays, and I'm the chair of the Yale Child Study Center and chief of child psychiatry at the Yale New Haven Health System. And I'm speaking on behalf of my colleague, Dr. Ponson, and the Child Study Center. I'm really grateful for the opportunity to speak to the Bill 5001, and we've also given you written testimony. Just as a very brief context setting, the Child Study Center is a department in the Yale School of Medicine, and we provide clinical care to children from birth through young adulthood. We provide education and training in child behavioral health and conduct research. And we are the coordinating site of Southern Connecticut for Access Mental Health that you've been speaking about, providing behavioral health support for pediatricians. This legislation that you're discussing is enormously important. We can improve the continuum of behavioral health care for children from prevention to intervention. And we strongly support it, very strongly, and will be there right beside you. However, what we would say is that the efforts that are currently described may not fully meet the current complex behavioral and health needs of children, and are urging everyone to think about a continuum of care. So children that are suffering from the high acuity needs that we're seeing right now in the community, they require intensive in-community and outpatient services, as well as hospital-based or even prevention services. Those services are now, as you've been hearing, actually considerably overburdened and thus are hard to access. And it's a vicious cycle. It results in children going to the ED and hospital-based care, overburdening that system. But then those children, where do they go after they're in the hospital or in ED care? Where do they go? And that's where the outpatient and intensive care services have limited availability. The surge in mental health needs, as we've been hearing, has revealed weaknesses that are pre-COVID, but weaknesses across the continuum of service availability. Also, not only in the availability of services, but in the workforce, as you've also been discussing. So the number of children and families that we're seeing now are absolutely staggering across the state, but our referrals have doubled just for outpatient care. And because of the workforce shortage, we're strained, as is everyone else that you've been hearing, to meet the demand for these services. So for example, for the first time in our 100-year history, we now have a waiting list. And this is true across the state. And you've been hearing about people's challenges for access. Our waiting list goes between 3 and 4 months now. So here's what we would suggest to increase access to behavioral health care. The state must strengthen existing support for outpatient services as well as prevention, and also to improve reimbursement for behavioral health clinicians. Improving reimbursement is the way to actually strengthen the workforce. So we recommend a multi-pronged plan that supports this continuum of care. And we urge the General Assembly as well as the Lamont administration to consider the following: expanding support for existing outpatient services that include outpatient, intensive outpatient, and in-home programs for children and adolescents. To increase, as you are already considering.
I'm sorry, Ms. Mays, your time is almost up. If you please summarize. Thank you so much.
And then finally, the workforce development. The limiting obstacle for workforce development is the reimbursement for behavioral health services, and we urge you to consider increasing that reimbursement. So to conclude, please consider the continuum of care for children's behavioral health and buttressing this continuum. We are fully there to support you and want to work together with you for all of Connecticut's children. Thank you so much.
Thank you very much. We absolutely appreciate your time. I do want to just ask you rather quickly. First of all, your recommendations were put in the submitted written testimony. That's great.
Absolutely.
Thank you.
Thank you.
And in that written testimony, did you put in there that you see a need for us to fund increased bed space?
Bed space is important, but if you fund bed space, you still actually have to have services for when those children leave those beds to get in the community or outpatient. So we would support bed space, but again, thinking it's a continuum of care. Because if you've got more beds, but no resources for when they leave, we still have a fractured system.
And if you have more resources before they reach that highly acute level,
exactly.
You don't need to put them in the beds.
Exactly.
So, right.
Exactly.
I'm with you. Okay. Seeing no questions, thank you very much. We appreciate your time, and we really look forward to reading the expanded testimony. So thank you
so much.
Moving on, please, to Brunilda Farage, and then after would be Jennifer Doran.
Hello, good afternoon, distinguished committee members. Can you see me? I feel like my video
cannot, but we can hear you wonderfully.
That's odd. Let's see, 1 second.
I think if you can't get your camera started, please know that your testimony is still going to be impactful because we can hear you bright and loud and clear.
Yes, of course. Okay, so I will go ahead then. I'm Brunilda Farage, Vice President for Programs and Operations at the Community Nonprofit Alliance. The Alliance is the statewide organization representing community nonprofit providers, many of which deliver children's mental health services. And I may or may not be joined here today by my colleague, Ben Shakin, Director of Government Relations, who may be in the waiting room still. First, we want to thank the committee members and legislative leaders who have made it a top priority this year to address children's mental health crisis. These bills add several new services and programs to the system, which we provide comment on in detail section by section in our written testimony. But I'd like to take a minute to respectfully request that the committee consider bolstering the foundation on which mental health services are provided, a foundation based on community services that has eroded over time due to chronic underfunding. There's just no way to address the root cause of the children's mental health crisis without addressing the chronic underfunding of the existing services of providers. This issue must extend to the appropriations process and include increased funding. One example of what I'm referring to is the proposal to expand behavioral health assessments in pediatrician offices and schools. But once children's needs have been identified, children will need a place to go to receive that treatment. Without supporting community services at the same time, those children that are identified will just be added to growing waiting lists where they'll languish until there's availability. I also hope that the committee will include in future drafts of the bill a process for ensuring oversight and coordination of the system of behavioral health services. We heard mention of there being draft language to form such a body, and we welcome its development with input from the provider community. And then it's also important that we're making decisions regarding the future of behavioral health services based on adequate and relevant data. For example, in recent years, the residential capacity in the children's behavioral health system has been reduced substantially. The current year's budget closed several therapeutic group homes, and DCF is proposing to close SFIT next month, all while proposing to stand up 5 new short-term acute crisis centers with a residential component. DCF has reported that the programs were experiencing low utilization and children were staying far beyond the intended length of stay. But in speaking with providers, they report that lengths of stay were often extended beyond the proper length of time because children had nowhere to go from those placements. We've heard of children waiting extra weeks and months because the proper community-based services were not available to them. To us, this speaks to the need to bolster community services to ensure that children have access to all levels of care needed to meet their needs. We're also concerned that the justification for closing of existing programs is low utilization. We appreciate that utilization is one of several valid reasons to make programmatic changes, but it has so far been presented in the absence of other data. In this case, if the demand exists for subacute crisis stabilization residential units, why was utilization low enough to close therapeutic group homes and SFIT programs to begin with? Instead, these decisions should be made with a full understanding of the potential impacts of Connecticut's kids and the outcomes kids are experiencing in the behavioral health system, such as those listed in our written testimony. There's a lot more detail provided in my written testimony, which covers most of the section in detail.
Excuse me, Ms. Farage, your time is almost up. If you'd please summarize. Thank you.
Thank you. For the remainder of the sections, I will just refer to my written testimony, but I'll end by saying that as the statewide association representing nonprofits, I do invite committee members to come and meet with our nonprofit members. We have a dedicated children's division that meets monthly, and we would be more than happy to host you and provide you with some perspectives on this issue from the nonprofit lens. Thanks for your time. I really appreciate it.
Thank you very much. And you brought up several really fantastic points, and we will absolutely be looking into that. Seeing no questions, we thank you for your time and for being here today. And we will move on to Dr. Duran.
Hi, thank you so much. Thank you for having me here today. I'm Dr. Jennifer Doran. I am the current president of the Connecticut Psychological Association, and I'm here on behalf of the more than 2,000 psychologists we represent in our state. You've heard a lot today about the mental health crisis and the bill and why House Bill 5001 is so important. Obviously, we couldn't agree more, and I want to commend the entire group for everything that you are doing and for the focus on pediatric mental health this year, which is more timely than ever. We support so much about the bill. There are so many wonderful things in the bill: a trauma-informed approach, increasing the diversity of our workforce, increasing the number of mental health professionals in the state, increasing access to care. There is one very big problem that we are concerned about in Section 54. We have written testimony from myself and from several others in our organization, and you're going to be hearing more about it later today. There is a section that says that in order for a psychologist to receive a license in the state of Connecticut, they're going to be required to complete a training experience in a children and family setting. So we think that the spirit was likely very well intentioned, but child and adolescent psychology is a very intense competency that takes years of specialty and requires specialized education, right? So it doesn't make sense to mandate that any psychologist, and in fact, any psychologist who wants a license in the state of Connecticut has to do a rotation there. And in fact, could actually be very dangerous if someone doesn't have appropriate education and training, hasn't gone to a program where they learn about development and child and family issues. So I have many, many points supporting that in my written testimony, and would encourage you to please take a look, and we respectfully request that section be revised, and are happy to talk more about it in any way that is helpful. Just a few other points for consideration. We're so thrilled to see an extension of telehealth. We would also argue that that should be permanent. Telehealth is not going anywhere. We don't think it's going anywhere. We have enough science to know that it is effective and increases access to care. So, we would ask for that. Madam Chair, you have raised several times the importance of outpatient care, right? Not just helping people when they're in crisis. And I want to say 100% yes, right? We need more beds, we need crisis support, but you are absolutely correct that we can prevent people from getting to that point, and access to affordable and high quality mental health care at the outpatient level, at the partial residential level, right, is so critical to addressing the needs. I also want to say there was a talk before. Representative Steinberg talked way earlier this morning about urgency. And I want to share with you that the number one barrier that we hear about from our providers, and I attached survey data that I hope you will look at from more than 600 mental health professionals in the state on chronic systemic insurance problems. What we hear on the ground from providers is that is the number one barrier to access to care. And that's what our families are telling us. That's what parents are saying. It's taken me 6 months to go through the list of providers in network on insurance and find somebody who actually is on the list, right? So a very big network adequacy problem, and then who has openings, right? And by the time people come to our providers, they are so desperate. It's been months and months and months of trying to get care, trying to find a provider they can afford for their kids. That it's desperate. And yes, it's a crisis point, right? And we can afford that. So I'd ask you to look
Excuse
at
me,
the
Ms.
data.
Doran, your time is almost up. Thank you so much.
Absolutely. So I think we know, I think everyone knows the system is broken, that it's not working, and saw in the bill that there was a request to, study payment parity and insurance issues. Take a look at our data. I think we know enough to know that we need to make some changes now and some fixes now. And I will leave it there. Thank you so much for everything you are doing. CPA is always happy to be a resource. Reach out to us anytime. And thank you for everything you're doing to address child and adolescent mental health.
Thank you so very much. And thank you for your testimony, and thank you for the support. Let me just put your mind at ease at a few things. We recognize that was a drafting error about the licensure. And it's one of those where we went, well, we'll fix it in the next draft. It was never meant to be that. And this is just what happens in the short session, unfortunately. So that will be fixed moving forward. So please don't worry about that. And thank you for your support of the IOPs and the PHPs and those community supports. Very, very important. Glad we see eye to eye on that. We recognize very clearly that the payments are a huge part of it, the reimbursements. And I want to let you know that the study isn't to look to see if it's a problem. We know it's a problem. The study is really to say, how do we get there? Because it's such a complicated system, as you well know, and to make these drastic changes in a short session where we don't feel that we have a handle on what the ripple effects would be, it's a little daunting to do in just a short period of time. And so that study is really hoping to get us to a path forward rather than doing something that we think will work and have it turn out to not and cause more problems. So there are many things that we need to look at, and some of them might just require more time, but that part in this bill is to ensure that we do that and we do it right. So I just wanted you to know that. Are there any questions? Seeing none, thank you for your time, and I will absolutely look very, very closely at everything that you've attached to your testimony.
Thank you so much.
Thank you. From there, we will move on to Stephen Wanzak-Karp, and then after that, I believe we have Thomas Burr. Stephen, hi, are you with us?
I am. Good afternoon. First, we want to thank the committee and all the other legislators who really put a monumental piece of legislation forward, and we look forward to working on further drafts. One of the issues we looked at is, what is the shortage in social work, in the workforce? There are 12,606 licensed social workers right now in Connecticut. In the last 14 months, they've added about 1,500 licensed social workers. We know that there is a shortage in bilingual social workers and a shortage in men. We're not really clear whether there's truly a shortage of workers. What we do know, though, is there is a shortage of adequate compensation. When nonprofits cannot pay more than $45,000 or $50,000 for someone coming out of school, with a graduate degree and considerable cost from that program, from that degree, yes, you're not going to find people to work if you don't adequately compensate them. We are opposed to Section 2, where it would allow for certain social workers to practice under supervision without a license for up to 12 months. We do have a solution we'd like to offer to you, and that is there is a temporary license that currently starts the day you graduate. It's only good for 120 days. Nobody can get it the day you graduate, so you probably lose at least 30 days before you can get it. We'd like to have a temporary license of 180 days. We'd like it to start at the point that DPH issues a license. Right now, if you fail the exam, it revokes license. We'd like to have people be able to take the exam twice. So if they fail once, they still don't lose their license. We also would like you to know that DPH on our request is going to be seeking a permission to allow students of social work in their last semester to sit for the exam. And once they graduate, they could get the LMSW immediately. We noticed that the scholarship, the notion of a scholarship to help pay for the application fee. We appreciate that, but we think that's not really the problem. The problem is we have the highest licensing fees for social work by far in the nation. And we just issued a report, and there's a link in our testimony about that. Not only lowering fees would assist those who are entering the field, but it would actually do something for all the social workers who have been working for years. I think if there's one thing missing in this draft is not enough emphasis on what do we do for workforce assistance to those who are currently doing the work. There's a lot to helping people to bring people in. We need to recognize the folks who have been out there. One thing we could recognize is by lowering a license fee or making it biennial. We're one of only 6 states that has an annual license fee. We also think there needs to be consideration to paid mental health days for clinical folks doing behavioral health. We know students got 2 days in last year in a bill. Our folks need some breaks, and it really needs to be paid time. We're very excited about the integrated healthcare language that's in this bill, and we'd like to suggest to you to go a little further.
Excuse me,
Suggest that there be
Mr.
a
Carver,
pilot.
your time is almost up. If you please summarize.
Sure, I'll just
Thank
make this
you.
point. Thank you. We'd like to have a pilot project that would assist pediatricians' offices in the startup cost for having licensed social workers embedded and working directly in the pediatrician's practice. We said earlier that pediatricians don't want to be psychiatrists and they don't know how to handle it. Some of them don't even want to ask the questions. If you have somebody right in the practice who would be able to do that, we think that would be a tremendous move forward. But we do need some help, I think, to get some of the pediatricians to have some of the cost to get that started. We have pretty extensive testimony. Everything that's bolded is basically recommendations. And we thank you for your work, and we appreciate the opportunity to address the committees today.
Thank you very much for your testimony. Representative Pettit.
Thank you, Madam Chair. Thank you, Mr. Wajcik-Karp. 2 quickies, I think. The data at the beginning, the 12,600 or 15,000 licensed, how many of those people are actually practicing? Do you know right now?
We don't know exactly how many are practicing because DPH doesn't show that data.
Okay, same problem with physicians, hard number to come by. And secondly, the embedded social workers for pediatrics, do you think that could work more effectively, cost effectively from a telehealth point of view?
I think it could work effectively from a telehealth point of view. I mean, just as you have physicians that are providing telehealth services, they could also turn that time over to the social worker. So whether it's in person or by telehealth, I think the main thing is you have pediatricians have relationships to their children they're working with and the families. And when they give a referral, we know about 50% of the time people don't follow up with that referral. But if they have that connection where they can say, we have somebody can help you with this, they're right here, we'd like you to take a few minutes and meet with them, I think it would be a huge advantage going. And it's been proven where this is going on. It's really been evidence-based models and has proven to be very successful.
Yeah, I'm just thinking if you had fairly quick access via telehealth, a smaller number of social workers could cover more offices. And, no one practices like there may be a day where 8 people need services and then the next day nobody needs services. So it's hard to predict that. So, but thank you for those answers and your testimony.
Thank you.
Thank you. Representative Exum.
Thank you so much, Madam Chair. Good evening, or good afternoon. It feels like evening. Good afternoon. Thank you so much for your testimony. And I know that we've spoken. I just have one question around the temporary licensing piece. What would be your thoughts if we were able to do, just as you said, after the license is issued, having that extension instead of the 180 days that you were just mentioning, to having it for a year, extending it for a longer period of time?
So we think 6 months more appropriate. And a year seems like a long time to be practicing with a temporary license, but we're not saying that we would oppose it. We would prefer 180 days, but we're surely open to conversations that, what makes the most sense.
I'm curious if it was a 1 year and allowing the fail one time as opposed to 6 months and allowing allowing someone to take the exam 2 times.
So right now, if you have a temporary license, you fail the exam, they revoke your license.
Right.
We think that giving people a second try, some people just have difficulties taking exams. So we think to allow someone to do it twice, and the Association of Social Work Boards requires, except for certain circumstances, a 90-day period between exams. So you want to make sure you have enough time in the temporary license to allow someone to take that the second time. We do think if DPH gets the waiver that would allow students to take the exam in their last semester, first of all, we think those who pass it would surely be able to go into the workforce much quicker. But for those who don't pass it, it would actually be like having 3 tries, once as a student and then 2 tries as in the temporary license.
Thank you very much for that. That is also something that we have talked about and may be reflected in the languages we're working and moving forward about students having that opportunity so that they hit the ground running as soon as they graduate and we can have someone immediately in the workforce. And so thank you so much. I appreciate your input, your ideas. Thank you.
Thank you.
Recommendations.
Thank you very much, Representative Exum. And seeing no further questions, thank you very much for being here, sir. And I look forward to reading your testimony.
Thank you.
Thank you. Next, we have Thomas Burr from NAMI, Connecticut, followed by Andrew Feinstein. Mr. Burr.
Good afternoon, Representative Linehan and members of the Children and Public Health Committees. My name is Thomas Burr, and I am the Community and Affiliate Relations Manager at the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today regarding House Bill number 5001, an act concerning children's mental health. Note, your committee leadership should have already received many emails from our members this week reinforcing what I'm about to say. We gratefully acknowledge the hard work of the bipartisan committee that was instrumental in crafting HB 5001. It's a great start, and we feel the following items should also be included. Number 1, implement annual well-being checks for all K through 12 students and staff. Implement curriculum to address additional healthy school climate policies, such as requiring annual school climate surveys, social emotional learning, including instruction on building resiliency. Require age-appropriate mental health and suicide prevention education for students, teachers, staff, and parents, such as NAMI's Ending the Silence educational program. And it was really good to see Mayor Caroline Simmons on the hearing early this morning, as we are currently in the early stages of arranging the Ending the Silence training program with the Mayor of Stamford and her Superintendent of Schools. On a side note, in addition to Ending the Silence, NAMI Connecticut also provides free support groups and mental health education classes to parents of school-aged children. Continuing, expanding life skills education requirements to K through 12 students and make such training available to parents and caregivers. expand Medicaid billing to include school-based mental health services, including via telehealth, which should be extended permanently for all Medicaid eligible students beyond just students with an IEP, and ensure the state Medicaid program covers services delivered by school psychologists, social workers, and school counselors. Please note that the above recommendations were gleaned from the Hopeful Futures campaign's just released report, America's School Mental Health Report Card, of which NAMI is just one of many contributors. A link to the full report can be found in my written testimony, and note that the recommendations for Connecticut schools begin on page 39. One last thing. The COVID pandemic has taken a mental health system that was stretched to its breaking point here in Connecticut and broke it. It is important to recognize we arrived at this point because Connecticut lacks a vision and long-term comprehensive plan for the mental health of our residents. We have multiple state agencies providing services to different subpopulations, yet insufficient coordination among them. There is no statewide investment in mental health promotion and awareness or in primary prevention. There are radical differences in what individuals in the public and private sector can access. It is time for a statewide, multi-sector planning effort to create a long-term mental health plan with input from all stakeholder groups and particularly from the individuals and families most effective. As part of the urgent attempt to address the crisis we are in, please consider including funding for a comprehensive planning effort, if not this year, then next. So thank you for your time and attention. I will now gladly answer any questions you might have.
Thank you very much for your testimony. I just would like to say that I have recommended your classes to many, many parents. I am glad that you went to an on-demand system for some of them because the live classes were difficult. And so thank you very much for doing that. I think that makes a huge difference. Also, in that report that you sent, Connecticut is listed at number 8 for this year, but last year, I think we were at 27, I want to say. And I think that's indicative of the fact that when kids aren't in school, they're not getting the help that they need. And this legislation really seeks to build upon that. So it's nice to see that we went back up.
Yeah, and honestly, Representative Linehan, Connecticut has at various times been very highly ranked with our public mental health system, but it's not that we're that great. To be perfectly honest, as someone who's been in this world for 20 years, it's not that Connecticut has been that great. It's just the rest of the country sucks so badly. It's really the best of a bad bunch. And your bill illuminates all the things that we really need to do to make it a system that actually works well for people.
I mean, you're right. When you're right, you're right. And we're going to get over that hump. And I really believe that this bill, I'm going to quote Howard Savronski from Connecticut Children's, it's historic and transformative. And when this bill passes, we will see big things and we will continue to fine tune it and certainly taking your suggestions under advisement. So thank you for being here today. I
did hear Howard speak earlier, and he did touch upon what I ended my testimony with the idea of creating, some kind of an oversight or work group to address kind of a really getting things in a cohesive, comprehensive fashion, because the system is so fragmented and so hard to navigate. So I really want to echo it. I was glad that he brought it up and I wasn't just the only one talking about it.
And I will just give my colleagues a little bit of a shout out here. Representative Exum and Senator Anwar have been focused on this for weeks, if not months. And so this is already in process, and you will absolutely be seeing something greater come out shortly. So thank you very much.
And I look forward to that. And just one last really quick thing, the talk about parity. If anyone is interested, the Kennedy Forum has done amazing work on this subject throughout all 50 states. And they have all kinds of great information, sample legislation. So don't recreate the wheel on this. We have been stuck with this parity thing for way too long. And it's time to get serious about getting the insurance industry to step up and do what they should have been doing for the last 10 years.
Absolutely. So thank you very much.
You're welcome.
now we'd like to ask, please, Andrew Feinstein, followed by Leslie Blateau. Andrew, hi.
Hi, Representative Linehan. My name is Andrew Feinstein, and I'm Legislative Chair of Special Education Equity for Kids in Connecticut, a statewide organization of parents, providers, attorneys, and advocates working for excellent education for students with disabilities. HB 5001 is major and transformative, but I think we need to think even bigger. Look, the mental health issue has a pre, an acute, and a post phase. The pre and from my view, the acute phase has gotten most of the attention. We need to focus on the pre-stage and on the post-stage, and that's where Connecticut Public Schools play a huge role. Before going to that, let me give you one specific recommendation. Under the special ed law now, there's a designation called emotional disturbance. There are a lot of parents who refuse to have their kids designated because that's such an opprobrium term. Now, we need to change that, to keep the initials. We could talk about emotional disorder or social emotional deficit. The State Department of Education tells us that there have no opposition to that, but it hasn't happened. We've got to have that happen, and that's something that could be done in this bill. But on the thinking big part, we need a continuum of services in schools. We need continuum of interventions, which is known, under federal law as a multi-tiered system of supports. It's got to involve everyone. That means teachers and students, social workers and school psychologists, cafeteria workers and bus drivers, administrators and SROs, parents and community members. They all need to be equipped with the training they need to get the job done. Now, in designing such a multi-tier system of supports, well, first, for Connecticut's 2,205 school districts and 1,044 public schools, there's a wide variance. One size does not fit all. What we need is for the legislature to establish basic criteria that every school, not every district, every school needs to meet. In doing so, we have to keep in mind that a child's closest relationship is with his classroom teacher. And that's where the training needs to be. That's where the resources need to be. And in that regard, it is just an outrage that Bridgeport has 29 kids in a first grade class. A teacher cannot provide the sort of attention that a child needs. Something we could do is move towards capping the size of classes. The research is pretty clear that 15 is about the right number, but we'd have to go a little higher than that. But fundamentally, we need to establish a continuum of services. Teachers need a process to be able to remove a seriously dangerous or disruptive student from the classroom that does not result in depriving that student of education, counseling, and support.
I'm sorry, Mr. Feinstein, your time is almost up. If you please summarize, thank you.
Really, you've got a fast watch. We need to involve parents in the process. One big missing element is we need mentors in schools. I have, 3 colleagues later on the list from SEEK who are going to testify in specific areas of the bill. But my message is, let's do it right. Let's create the continuum, the multi-tiered system of support in every school in Connecticut so we can address the mental health problems of kids before they become acute and after the acute phase. Thank you very much. I'm sorry I spoke so fast.
No, thank you very much. I think you're fantastic. So I love hearing you speak, but I wanted to throw something out to you, though. I agree with you on the IEP and the emotional disturbance language. Problem is that's federal. And so we really can't change that as much as I would love to, because I do agree with you that parents balk at that. And that's really unfortunate, but that mirrors the language in the federal legislation. So, but I've got to disagree with you.
I've got to disagree with you on that. Look, Connecticut has its own system. For example, we call our meetings PPTs. The federal law calls them IEP team meetings. We are allowed to have our own vocabulary as long as the category fits the federal category.
Well, we'll look into that then. If that's the case, absolutely. I think we just haven't touched it because that because we were under that impression. But if we can change that, I don't really see any problem with that. And I do look forward to the rest of Seek's testimony with your colleagues coming through, because I know there's just such a great deal that we can talk about. So are there any questions? Seeing none, we'll move on, but we appreciate your time. Thank you. Oh, I'm sorry. I see now. Rep. McCarty, hi.
Sorry, Representative, that was my fault. I was a little late. I just wanted to bolster Attorney Feinstein's comments about language. And we have here in Public Health Committee changed language a number of times in the past to show sensitivity. And I think he brings up a very valid point on stigma. We need to destigmatize. And so I would support that language change, and I hope you will look into it. Thank you.
Yeah, absolutely. You know, as a parent who's been through the IEP process, that language was jolting. And so I didn't recognize that we could change it. Now that I know that we can, I think it's a great idea. Stigma plays a very big part in having our kids get the help that they need. So thank you to both of you for that.
And I want to thank you and Representative Exxon and the other folks who have worked so hard on this. This is really a major step forward, but let's do it right. Let's do it fully this time. Thank you very much.
Absolutely. Thank you so much. So we are now going to move on to Leslie Blateau, followed by Cephas Nolan.
Good evening, Senator Abrams, Representative Steinberg, and members of the Public Health Committee, Representative Linehan, Senator Anwar, and members of the Committee on Children. My name is Leslie Blateau. I'm a teacher certified in social studies and the president of the New Haven Federation of Teachers. I represent over 1,800 teachers, social workers, school counselors, library media specialists, school psychologists, and other education professionals who work with children in New Haven Public Schools. I'm writing and speaking to express my support for House Bill 5001 and Senate Bill 2. As we get closer to the second anniversary of the start of the pandemic in March 2020, such intense changes to our way of life have impacted many members of our school communities. As education professionals work to adapt and meet the needs of our students, we can continue to see increased stress, dysregulation, and disruptive behaviors in the student populations we serve. We know our students' needs are valid and complex, and we come to this committee to ask for support to meet students' needs and ensure our schools are the supportive and productive places we know they can be. First and foremost, we need more caring adults in our schools who can build relationships with students, earn their trust, and help them to handle the loss and disruption the pandemic has caused. Thus, the proposals to provide grants to hire and retain additional student mental health specialists and to provide school-based delivery of mental health services included in HB 5001 is necessary and welcome. At the high school where I work in New Haven, we see clear evidence of the positive impact of additional mental health professionals. For many years preceding the pandemic and currently, our students benefit from 5 additional master's level social work interns who meet with students regularly, helping them to feel heard, supported, and more able to engage in their academic work. Before the pandemic, our day-to-day school culture, as well as our graduation rates, are a testament to the positive impact more caring adults can have. Now, with the added stress of the pandemic, schools throughout our district and our state need more support. Of course, if we're going to invest in initiatives to bring more mental health workers to our school communities, we must also invest in the people who will take on these roles. By addressing the economic obstacles facing professionals who seek additional credentials, we can ensure we fill vacancies and meet our students' needs. Thus, the provisions in HB 5001 to offer grants to social workers for the cost of tutoring and examination preparation courses for applications for licensure and scholarships for applicants for licensure in professions that serve mental and behavioral health needs are necessary. Lastly, it is reassuring to see the focus on early childhood as expressed in SB 2. Young children's experiences in the early grades are foundational to how they will experience the rest of their years in our care. Students whose needs are met in these early years will be much more ready to meet the social, emotional, and academic challenges they will face in elementary, middle, and high school. An increased investment in early childhood programs is an increased investment in all levels of our educational system. Our communities as a whole benefit when we work to meet the needs of our youngest children.
Excuse
It is
me,
a
Ms.
relief.
Brato, your time
I'm
is
almost done.
up.
Thank you.
Thank you.
It is a relief to see our representatives at the state level take the current mental and behavioral health crisis seriously and hear the concerns and needs of educators in New Haven and across the state. For our schools to continue to be transformational and educational places, we must first address the social and emotional well-being of our students and our entire communities. SB 2 and HB 5001 both represent this step in the right direction. I thank you for your time this evening.
Thank you very much. We greatly appreciate your testimony. Representative Comey has a question.
Thank you. Hi, Leslie. I don't so much have a question as more just a comment, and I want to just congratulate you. Your colleagues are lucky to have you as their representative, you know, and because you've always been such a great advocate and always children centered in your work, and I've always appreciated and admired that work. I will say that this year was the first year. I represent Branford, just on the suburbs of outside of New Haven, and have raised two kids in the public schools here. And this past year, sent my son to New Haven Public Schools, to a magnet school, and he's loving it. But there is a significant difference in the amount of support staff services that he has available. And, you know, I'm an active parent, so I'm attending the parent-teacher meetings and the other committee meetings, being voluntold for certain certain committee chairs and things like that. But I would, you know, I just hope that with this focus, that we can make sure that all of our kids, you know, here in Branford, you know, it's night and day for the support services between school-based health centers and grade level social workers and counselors and other support psychologist staff, and then to go to a school district that is really overwhelmed with needs and underwhelmed with resources. I just hope that this bill will play an important role, and we need your help in making that happen and shaping that, because everyone deserves the resources, the access to the resources, because it's so important to keeping our children in school. So I just want to say thank you for your work, and if you have any comment on the difference in resources between urban environments and the other suburban or rural.
I do. Thank you for raising it, Robin. I think what you raised is explicitly connected to the teacher shortage crisis as well. We're seeing more and more teachers leaving our urban districts to go to other districts for some of the reasons that you named, not necessarily pay could be part of it, but because they know that there'll be more supports and they will be better able to serve their students in places where supports and resources are higher. So I think if we're going to do something about the teacher shortage crisis, which I believe the legislator wants to, I think it is connected to bills like this, and making sure that the supports in bills like this are spread out in an equitable way. And we know equitable means more resources might have to go to districts like New Haven. And that's in the name of equity, because equitable does not always mean equal. So I appreciate that observation, Robin.
Thank you, Leslie. Thank you, Chairman.
Sure. Thank you, Representative Comey. And seeing no other questions, we thank you, ma'am, for your time. We asked Cephas Nolan, followed by Megan Adams.
Okay. Good afternoon.
Good afternoon.
Senator Anwar, Representative Steinberg, Representative Linehan, Senators Summers and Wang, Representative Pettit, and members of the Children's and the Public Health Committee. I want to thank you for the opportunity to provide testimony on the House Bill 5001 and the Senate Bill 2, an act expanding preschool and mental and behavioral health services for children. My name is Cephas Nolan. I'm the Director of Youth Services for the town of East Hartford, one of 103 youth service bureaus in Connecticut, which provides services to approximately 146 towns and cities in the state. Now, these services include behavioral and mental health services, substance abuse, suicide prevention programming, positive youth development programming for youth, as well as a lot of services helping to divert Connecticut's youth from the juvenile justice system. So when COVID hit back in March of 2020, I think everyone was kind of caught off guard as thousands of kids were away from their classrooms, away from their peers, away from trusted adults for 6 months to 18 months. And we know our children and youth have been hit hard by this pandemic. We still don't know the full impact of this pandemic, what it has been and what it will be on young people. But the behavioral emotional difficulties that have emerged for our youth in East Hartford have been primarily anxiety, depression, and social isolation. And as a youth service bureau, we've seen in the past year a significant rise in the number of requests for behavioral and mental health services for families who are struggling to meet their children's mental health needs. And parents are also feeling overwhelmed by the struggle of how to handle their children's behavioral and emotional needs, while also struggling with the financial needs for the family. So with this increase in need for services, we have at times struggled to keep up with the need for more services and more staff to provide the case management needed to meet the full needs of Connecticut's youth. So it's evident that even when this pandemic is finally fully under control, the emotional effects of the pandemic on youth and families will linger much, much longer. So I want to say I strongly support these two bills to increase and enhance the behavioral mental health services that a youth service bureau can offer, as the needs for the services have risen significantly for Connecticut's youth and families. And with this added funding, youth services bureaus will be in a position to expand in our community services that combat this isolation, this depression, this anxiety, and provide counseling services, substance abuse services, suicide prevention program.
Excuse me, Mr. Nolan, your time is almost up if you summarize. Thank you.
Okay, only 2 more lines. So we have a lot of things that we can do for our youth, as well as any other services that arise in our local community. So I want to thank you for your time and consideration, and I really appreciate all the things that all of you do for the state of Connecticut. So thank you.
Thank you very much. And before I send this off to my co-chair, Senator Anwar, I just wanted to ask a quick question. You said that you've been seeing a lot of depression and anxiety. That's been seen in my towns as well. I'm just wondering, do you know if you've seen any increase in self-harm?
I think that goes along with some of the depression. Things like kids having suicidal ideations or doing some cutting behavior. It goes along with depression. Yes.
Yeah, it's so upsetting, and I think it's something that we don't talk about enough. And we've been in this meeting for hours, and this is the first time we've talked about. And I think that we need to talk about that a little bit more often. So thank you very much for your input. Senator Anwar.
Thank you, Madam Chair. Thank you, Cephas. Good to see you here. Thank you for the work that you and all the youth services bureaus do. I wanted to acknowledge your help as we are working on SB2 and looking at diversion programs. There is really an increased need that we have in our society. I know there's a movement that's out there which says that we need to do juvenile justice, and there's opportunity to look at that, but more what we know about the diversion program's successes. And what you've been able to do is to help us guide through the diversion program successes and the need for social workers, case managers, counselors within the youth services bureaus, and how they can help take care of our children. So data is quite sound about how they work effectively. The question I have for you is, could you touch on how the youth services bureaus are funded and how there's an opportunity to fund it a little bit better or differently and have better formulas going forward? And the second thing was, it appears that the collaboration of social workers and counselors within the school and the youth services bureaus is not as clear across our state. So if you can help us with these two issues, please.
Okay.
Thank you.
The first one, I mean, funding for youth service bureaus, the State Department of Children and Families provides funding for youth service bureaus, but not the total funding. I think for most youth service bureaus get at least $14,000, and then they have to match. The towns themselves actually give a big bulk of the funding for the local youth service bureaus. And of course, we also wind up writing grants, getting funding for local prevention councils and other areas to provide other services. But that's the bulk of our funding. And second part of that was?
Within the first question, the thing was, how can that improve? Because the trauma and the impact on the communities is very different in every community. It's almost like you need a little different amount of funding for different communities.
Well, the formula, which was put together many, many years ago, was based on just population. And all the new ones that came after were only able to put, say, $14,000 to. So, you know, the formula has been in place for a long time. So I don't know. I guess the question of the need varies from town to town, city to city. That may be true, but the way the formula is based on population. I think you did ask about schools and youth service bureaus.
Yes, the second question was that how collaboration between the school social workers and counselors and the youth services bureaus. It's there may be an opportunity that's being missed in many schools.
Well, I think every youth service bureau has a different relationship with their school system. We have a pretty good relationship with our school system. The school social workers, we can pick up the phone, give them a call. They will refer to us. They sit on our juvenile review board or advisory boards. But I think when it comes down to the actual work, you know, school social workers or the school people are really focused on kids' academic, getting them to school. And as a youth service bureau, we think of a child as being, you know, as part of a family, part of the community, and connecting them to their family and community. So we have similar goals, but almost a little different focus.
Okay, this is helpful because there are not enough bodies and enough social workers and help at this time, counselors. So we were just thinking, is an opportunity to share some of that to in the immediate and intermediate term before we get enough people around. So that's the reason I was asking that question, but this is very helpful, Cephas. Thank you again.
And collaboration is one of the things that youth service bureaus do very well.
Yeah. Good. Thank you, Madam Chair. Thank you, Cephas.
Thank you very much. And seeing no other questions, we will move on, please, to Megan Adams. And before we do, I just want to give a brief reminder that we have quite a few more to go. And so a lot of our people testifying here today might notice that there aren't any questions because we want to have a chance to get everybody in and essentially just note, please, that we will all be looking at your submitted testimony if it's shorter than your spoken testimony, and absolutely reach out to you for more elaboration if needed. We just want to make sure that we have the ability to get as many people in as possible. And with that, Megan Adams.
Hello, thank you for having me. So good evening, members of the Public Health and Children's Committee. Thank you for this opportunity to testify on SB2. I am Meg Adams. I'm the Executive Director of Bristol Child Development Center. We've been in business since 1971. We are a NIAC accredited state subsidized program that currently offers care to over 200 families. Additionally, I am the co-president of the Connecticut Association for the Education of Young Children. I'm elated that SB2 calls for additional funding for programs through the Office of Early Childhood. These investments in the early care and education system cannot come soon enough. Centers across the state are amid a fundamental staffing and wage crisis, and many programs are on the brink of collapse. This collapse of the early childhood sector would mean a few things. First, families would be unable to work because of the lack of care, teachers will be out of their jobs, and children are going to lose out on essential educational opportunities, which would ultimately help them in their social emotional development, leading us towards a lower need for early intervention. So because our funding comes through the state of the Office of Early Childhood, we cannot adjust our tuition to help increase revenue. We are a flat funded program and soon to be possibly operating in the red. So this past year, we've talked about, everything going on today, but my center alone lost 12 teachers this past year, all of which left to work for higher wages. 6 of those staff went to Board of Educations as paraprofessionals because the rate of pay is much higher and the responsibility of the job is far less. Our field is on the verge of being depleted, and our staff who once were recognized as champions are finding it hard to stay in careers that they love with little to no return on the time and effort they put in. It should be noted that early childhood educators have one of the most important and influential positions in a child's life between the ages of infancy right up to kindergarten. They're required to meet specific educational requirements and then continue to push them. We continue to push them to continue their education and improve on their practice. It's tragically ironic that the teachers who take out student loans to pursue higher education to better prepare themselves as educators are then forced to leave this field because they cannot financially survive or pay back their loans. In short, early childhood educators cannot afford to be teachers. And the unfortunate part is that this issue is not at the fault of the child care centers. Many, if not most, are struggling to remain open due to the complete lack of funding and are faced with staff shortages that span beyond a few hires. So centers at this point in time are being asked to compromise their expectations of quality since they cannot afford to pay those who are qualified. And what does that mean for our children? The children whose lives are most influenced during these years. As we mentioned earlier, we are an economic necessity so that parents can have quality care while they work. If there were no childcare centers available for families, our economy would essentially collapse. As it is, we've started to force women back out of the workforce to stay home and care for their children because we cannot find teachers to open classrooms, and that's because we cannot pay them what they deserve. At this moment, I do have one classroom that has a wait list of families, but has been closed since August because I can't find staff to open the room.
Excuse me, Miss Adams, but your time is almost up. Thank you.
Of course. So you've heard a lot today about the rate of pay you've heard a lot today about the rate of pay that we receive for subsidized slots, and then that minimum wage is going to be going up to $15 an hour. So I just want you to think about, that in the last 7 years, school readiness and child daycare slots have not received an increase at all, but minimum wage has gone up almost $5 an hour. We're receiving about 50% of what it costs to run a high quality classroom. Our staff are struggling, morale is down, and no one is entering our field. So without the appropriate funding, I foresee a very dim and depressing future for the early childhood field and the educators, as we'll be forced to make budgetary decisions that will begin to jeopardize quality. So we are begging you to please invest the $700 million down payment in the childcare system so that families can enroll their children in quality care. We can pay our educators what they deserve and keep our economy moving in the right direction. Thank you so much for your time today.
Thank you very much. I see a hand up and I don't know if that was left over. Senator Anwar? I think it might have been left over. So seeing none and seeing no questions, thank you very much. We appreciate your time. Moving on now to Madeline Del Greco, followed by Elizabeth Canada. Ms. Del Greco, are you with us today?
Yes, hello.
Hi.
Thank you, chairs and members of the Public Health and Children's Committee for the opportunity to testify in support of HB 5001, an act concerning children's mental health. I'm Madeline Del Greco. I'm an MSW student at UConn School of Social Work, and I am fully in favor of HB 5001, specifically the requirement for schools to adopt an improved trauma-informed truancy intervention model that considers the differences between truancy and school refusal due to mental and behavioral health issues. Truancy is defined as having 4 unexcused absences within 1 month or 10 unexcused absences over the course of a school year, and this is often very damaging to a student's academic career and personal life. Students who are truant are more likely to fall behind academically, drop out of school, use drugs and alcohol, and be involved with the criminal justice system. Truancy must absolutely be addressed, but in doing so, we must recognize the role of mental health, specifically unmet mental health needs, and that they are very often the root cause of truancy. If we really want to address truancy, we must have a process to evaluate the mental health and socioeconomic needs of our students and be able to offer support and services for them. Truancy and mental health disorders often coincide. Research has found that depression, affective and mood disorders, and suicidal ideation have a positive association with delinquency and antisocial behavior such as truancy. This is especially important now because children's mental and behavioral health is under attack. Since the start of the COVID-19 pandemic, rates of depression, anxiety, and suicidality have skyrocketed, and hospitals around the state are seeing a surge in children in need of services. Demand for behavioral health services for children is now 2.5 times what it was pre-pandemic. Children are in crisis and need support and guidance. We must have procedures in place to offer children the appropriate services when we see warning signs such as skipping school and truancy. A trauma-informed truancy intervention model with a mental health evaluation is owed to our state's children. I applaud the legislature for addressing truancy and mental health in HB 5001 and urge this language to be preserved and this legislation to be passed.
Thank you very much. I absolutely appreciate your comments and agree with you on that. Are there any questions? Hearing none, thank you very much for being here and thank you for sticking with us for so long. Elizabeth Kanata from Wheeler Clinic.
Yes, and I thank you for good afternoon, and thank you to each of you for your endurance today and hearing so much important testimony. I really appreciate it. My name is Dr. Elizabeth Kanata. I'm Vice President of Community-Based Family Services and Practice Innovation at Wheeler Clinic, and I'm also the third of the tri-chairs that you'll hear from today for the Children's Behavioral Health Plan Implementation Advisory Board. And as one of the advisory board tri-chairs, I want to thank you for elevating children's behavioral health in the legislative session. And also for including our recommendations from the October annual report to the Children's Committee, and Senator Anwar for your comments this afternoon a little earlier about the tremendous contribution of our state partners and the families and the providers that have been part of the advisory board moving the Children's Behavioral Health Plan blueprint forward. My primary focus in my comments today, and I will be submitting more input, is to really focus on the workforce development and licensing regulations. And I really appreciate the tone in the bill that is emphasizing a focus on recruitment and retention of a more diverse body, a more diverse representative pool of behavioral health clinicians. I also want to underscore that some of the regulations actually current regulations detract from the development of strong clinicians and excellent service system. So in terms of specific recommendations with regard to reciprocity, yes, we should look at reciprocity between states for licensed providers to practice in Connecticut, but not to be limited to telemedicine, because we've been really looking for a more seamless children's behavioral health system. We need providers to really understand the Connecticut service system. They need to be fully versed in what the options and levels of care are. And so we don't want providers who are working remotely or in isolation. We really need them to be part of the service system in Connecticut. With regards to, and this has been talked about a couple of times today, the intermediate level of licensing, and that's sections 2 and 3 of the bill, referencing LMSW, which is really entry-level licensure. It's important, we're not talking about licensure for independent practice. And so I do embrace anything that will make it, because this is a tremendous barrier for many to get this entry level of licensure. And I would actually suggest that we need to eliminate this entry level licensure to come into the field and move to what we have had in place, which is that individuals who have the appropriate level of graduate level degree in a behavioral health service that have met those requirements come into the field supervised by licensed independent practitioners, and that this is really the opportunity for them to develop their skills. The temporary and intermediate licensing regulations actually are a barrier for many entering the field, and they're particularly challenging for providers. It's a very significant risk for us from the point of view both of cost and also program stability to take somebody in, particularly if you think about this in relation to evidence-based treatments. It's very costly to train somebody and then have them not pass the licensure exam right at the point, and this is, again, entry-level licensure, not independent practice licensure. If they fail the exam, and there can be many reasons that are not related to excellence of ability.
Excuse me, Ms. Kanata, your time is almost up if you'd summarize. Thank you.
So we lose them right at the point that they're actually getting good at the model they're being trained in, and it creates disruption for the families that they're serving. So a much better way to develop strong clinicians who will provide better services is to ensure that they're well supervised for the entire time until they're ready to take the independent licensure exam and pass that independent licensure exam. So thank you for your time.
Thank you very much, Dr. Kanata. Are there any questions? Seeing none, thank you very much. I appreciate your time. Now I'd like to ask, please, Deneen Price, followed by Abe Baker Butler.
Hi, how you doing? Thank you for hearing me. Members of the Public Health and Children's Committee, thank you for this opportunity to testify on SB2. My name is Deneen Price, and I live in New Haven, Connecticut. My child is Shamar Shepard, and he attends Harrison Tucker School, which was founded in 1970, and is a member of the Circle, a network of over 40 childhood providers serving children and family of color. The pandemic has taken a huge toll on the mental health of all of us. And for my young child, who has lived most of his life in the pandemic because he's only 5, it has clearly had an impact. The impact was greatly reduced for my family because I had access to Harrison Tucker School. While I have been incredibly lucky that it has not been without challenges, it's been very hard, but programs like Harrison Tucker have helped me through it tremendously through the whole thing. The cost of childcare for good, high quality childcare is very expensive. It's very expensive. That's why I'm glad that SB2 calls for additional fundings for programs throughout the Office of Early Childhood. I call upon members of this committee to increase funding to and expand the eligibility of Care for Kids program to ensure that families like myself can continue to access high quality early care programs like Harrison Tucker, because I receive Care for Kids, so that's how my son is able to go to the program. We need to build up systems of support for families, especially after the pandemic, because you go to work, sometimes you get, hours get cut because the businesses are not going as well as it used to be. We need to build support for families, especially after the pandemic. This year, we need a $700 million down payment on what should eventually be a $2.5 billion system that would enable parents to find quality, affordable childcare in the setting of their choice, meaning good teachers, people we can trust, and safe environments. Promoting food, mental, and physical health of our children that will allow access to social and physical environments of quality. And that's what we're all striving for our children. So thank you so much. And I hope that they can help us and keep the funding going to help parents like me.
Yes, thank you so very much. Are there any questions? Seeing none, thank you very much for your testimony.
Thank you.
Thank you. Bye. Abe Baker Butler from the Yale College Democrats. Are you with us?
Yes, thank you, Rep. Lanahan, and thank you for taking the time to hear from me. I know it's been a long day, so I'll get started right away. As you said, my name is Abe Baker Butler. I'm a first year at Yale, and I'm here to express my strong support for HB 5001 and SB 2. I stand here representing not only the Yale Democrats, but the entire Yale student body and young people across our great state who've experienced firsthand the festering mental health issues that these bills will meaningfully address. I have seen firsthand the effects that the COVID pandemic has had on adolescent mental health. My friends and my peers have experienced crises, and some have even been hospitalized. And the most tragic part is that most of the time, their mental health issues were exacerbated by an ineffective and underfunded mental health care system. There are many extremely meaningful provisions of these bills that will help to ameliorate these problems. But given our limited time, I will focus on just one provision that I think is extremely important: telehealth licensure reciprocity. Prior to matriculating at Yale, I served on the National Board of Telehealth Access for Seniors, a student-led 501c3 composed of over 400 students distributing electronic devices to low-income individuals to enable telehealth during the pandemic. Repeatedly, we saw the promise of telehealth, and what we learned and saw firsthand is that telehealth could be an extremely effective form of mental and behavioral health care, not only for minimizing pandemic infection risk, but also for managing caseloads when doctors are overburdened and for increasing accessibility for patients with limited transportation options and for those with chronic conditions such as mental health and behavioral issues that require frequent medical consultation. During the pandemic, thanks to waivers from governors, including Governor Lamont, many of the 105 medical clinics that we worked with were able to administer telehealth care across state lines and ease mental and behavioral health care burdens. At colleges across the state, including Yale, the licensure reciprocity policy proposed in this bill will have a huge impact by enabling students who are attending school in Connecticut to continue receiving mental health care from their home state providers while they're on their Connecticut University campus, even though that provider is licensed in a different state. This has myriad benefits, including reducing the caseload of extremely overburdened campus mental health professionals, something I've seen myself, and it allows students to continue the strong relationships that they've built with their home mental health care providers. This will have a significant positive impact on mental health care for students. Thank you for taking the time to listen to my testimony today. I urge you to help my friends and peers, the children and teenagers of Connecticut who are in the midst of an unprecedented mental health crisis. As I have described, there are simple ways we can improve our mental health system so that it more effectively provides care to students like me across our state. And I'm confident that these bills will make a substantial impact both in the short term and the long term on improving our state's mental health. I urge you to favorably vote both HB 5001 and SB 2 out of committee. Doing so is imperative to protect the health of my generation and our future. Thank you.
Thank you so very much for your impassioned testimony. It's always great to hear from the younger generation, and I can say that now as an old lady. Are there any questions from the committee? Well, I was hoping someone would step up and say, no, Liz, you're not old, but no one has. So with that, thank you very much, Abe. We appreciate you taking the time. And I'd like to ask, please, Ann Minuski, followed by Christina Mukan Morrissey, and I apologize if I'm ruining the names.
Good afternoon. Yes, Ann Minuski. Thank you very much, Representative Linehan. This is my testimony in opposition to HB 5001, an act concerning children's mental health. Dear Chairman and members of the Public Health Committee, this bill appears to promote mental health in schools, yet does not. Actually, after rereading the bill, I'm very confused why it's in public health and in children's, because if this is supposed to affect our schools, why is this not in education? For 2 years, the Connecticut General Assembly's majority party has held citizens' lives, including our children, under duress of COVID, and continues to do so with the school children to this day in public schools. Our children certainly sadly have mental health issues from the masking. One of the clinical issues of masks is that it keeps respiration in. So the children are breathing in their CO2, which has anxiety producing effects. I don't know if people are aware of that. In keeping with I'm sorry. Our children certainly have mental health issues, but none that the majority party can help, for they are part of the problem. In keeping the Constitution state from life, liberty, and the pursuit of happiness, which freedom is up to the individual to do as one chooses. The Connecticut majority party is in fact a major cause of the mental health issues in and out of the schools. As a former school counselor, I've advocated for and directly impacted school children's mental well-being. As a parent for the past 23 years, I've learned a great deal as to what has happened in public schools. Further devolution of the public education has occurred with Race to the Top, No Child Left Behind, the insertion of Common Core, SEL, CRT, and inappropriate sexualization of our youth in schools. This all has had detrimental effects. A child's mental health is at risk when the school does not meet a child at his or her developmental level. Now the fix, a bill that attempts to have concerns for children's mental health. To the point of this bill's concern, this weaves a complex web of programs and services ranging from children's and behavioral health up through education of specialists and professionals, providers, data centers with no proven data security, telehealth with zero parental input for their children, appoint several unelected commissioners who make far-reaching decisions with grant programs, scholarship programs with $6.5 million at their fingertips, appoints a board of over 40 unelected public officials in health and education, as well as private individuals representing their foundations and their own financial interests, assign unknown amounts of funding from the general fund into supporting residencies and fellowships, hiring and retention regarding mental and behavioral health, emergency psychiatric services, and the same Center for Medicare that gave 15% bonuses to hospitals for a COVID diagnosis.
Excuse me,
Lacks
Ms.
financial
Winooski, your
oversight.
time is almost
Yes,
up.
I lacks a financial oversight that other than the Commissioner of Social Service shall file a report for the study to the Joint Standing Committees to the General Assembly. Reduces the standards for licensing in social work, reimburses anyone to enter a social work program, and even to the hiring of an interpreter in English that's not the candidate's native language. I'm speaking as a former licensed professional counselor in the state of Connecticut. Our public school system is no longer about education, but is about wraparound health care services and data collection. This bill is yet another attempt to usurp the parental rights via the school systems by certain members of the Connecticut General Assembly and their bureaucratic friends. Please vote no on HB 5001. Thank you.
Thank you very much. Senator Anwar.
Thank you, Madam Chair. Thank you for your testimony. Ms. Winooski, do you mind if I clarify, are you speaking personally, or are you speaking on behalf of your organization? And is that your organization's position? I can't hear anything. Can anyone else hear anything, or is nobody
No,
else? Okay.
Ms. Winooski, are you still with us? Unfortunately, it sounds like we may have lost her.
Okay.
So
Sorry,
we apologize.
I just wanted to clarify because she's a president of Connecticut Republican Assembly, and I wanted to clarify if that was the official position of the organization, that we don't have a mental health issue, or I just wanted to clarify that. So, but Madam Chair, sorry. Thank you so much.
Hey, I'll take president, but yeah, thank you very much. Unfortunately, I don't think there's anything we can do about that. So it looks like we're going to move on to Christina Mukan-Morrissey, and then after we'll have, please, Ana Clara Mesquita.
Hello, everyone. Hi, Representative Linehan, Senator Anwar, Public Health Committee members, and the Children's Committee members. Thank you all for doing a marathon of a day. My name is Dr. Christina Mukan-Morrissey, and I am here representing the Connecticut APRN Society. I am a family nurse practitioner and also the director of quality for a local mental health authority that delivers behavioral health and substance use treatment for adults and children. And like so many people here, I've also lost people in my own family to mental health disorders that started with a lack of treatment in childhood. So this is a topic that is near and dear to my own heart, and I think what has driven me largely into the field. I am very pleased to see that Connecticut is giving so much attention to this topic. You do have my written testimony, so I'm not going to go through all of that with you. I do want to call out a couple of different areas where APRNs were specifically omitted that are listed in the written testimony. And some of that includes even the topics of things like loan forgiveness for attracting people to the state or to stay within the state of Connecticut. I'd ask for consideration of those areas, which are very much appropriate for APRNs to be considered in. The other topics that I wanted to specifically talk to you about and bring to your attention were related to the reciprocity for APRNs from out of state and the difficulties related to the collaborative agreement right now. I know that Senator Anwar and I were able to have a good conversation on that recently. For reciprocity from out of state, currently, if an experienced APRN tries to move from a different state, she'd have to find a new collaborative agreement because of the way that the language is stated, which is prohibitive for many people moving here. That's something that many people are just not willing to do or not able to do. So we're asking for a change in the language to update that to allow for experienced APRNs from out of state to have independent practice as other APRNs in Connecticut do. APRNs have been independent practice providers since 2014. And the other topic that I'd really like to call to your attention is the difficulty that's currently experienced related to finding a collaborative agreement with new graduates right now. Many APRNs have their own practices. And in my own case, I don't have an independent practice, but we're largely APRN staffed. And for many years, when we had a new physician or APRN starting, I was the one that was doing the training with them, and I was the collaborating person for them. I did the training on many different clinical topics for physicians and APRNs. And we still, because I wasn't able to sign that collaborative agreement for new graduates, we had to hire somebody on a piece of paper to say that they would be able to collaborate if needed. And it's very prohibitive for being able to increase the services for mental health in the state of Connecticut. As one of the things I really appreciated from Dr. Savronski from CCMC is he highlighted as well that so many mental health for adults and for children really starts in primary care as well. That is where it starts. And without being able to provide those services, we're not being able to meet that need for our patients. In addition to that, APRN,
your time is almost up if you'd summarize. Thank you.
Thank you so much. APRNs also, many psychiatric APRNs specifically, are independent and have their own practices as well as the family providers that see children. One statistic that I think is really important to keep in mind is that the expected growth rate for APRNs is expected to be 45% over the next 10 years, compared to the 3% of physicians. So if we don't fix this problem now, we're not going to be able to meet those needs because we just won't be able to collaborate even to a greater extent that's already an issue. So I'm asking the legislator to consider those changes as we move forward with these bills, because it's going to set us up to be able to provide those services for the future.
Thank you very much for your testimony. Are there any questions? Seeing none, we'll take that under advisement and we appreciate your time. Have a great evening. I would like to call, please, Ana Clara Mesquita, followed by Barbara Vida. Is Ana Clara Mesquita here?
Yes, I'm here. Hi. Hi, Representative Linehan and Senator Anwar of the Children's Committee and Senator Abrams and Representative Steinberg of the Public Health Committee, as well as the vice chairs and ranking members of each committee. Student activism organizations in Stamford and Norwalk have come together in support of several sections of HB 5001. We are grateful for your attention for the role that schools play in supporting students' mental health. My name is Ana Clara Mesquita. I represent the Mayor's Youth Leadership Council at Stamford High School. I will focus on a few sections of the bill. You will hear later today from my friend from the Center for Youth Leadership at Brian McMahon High School in Norwalk. Let's start with Section 17, which addresses the student-to-school social worker ratio, which suggests 3 changes. 1, expand the scope of the survey to include the rates of each social worker employed by a school district. 2, requires school districts to list the services performed by each social worker with an emphasis on trauma care. And 3, require each school district to publish the information on a district dashboard. Next is Section 18, which is a grant program for school districts to hire mental health professionals. First, you may want this section to address the hours of school social workers. As you know, most services require a social worker to pull a student from class, which results in the student missing instructional time. Adjusting the work schedule of social workers so they are available after school on a regular basis may help. Second, we urge school districts to use the grant money to hire mental health professionals of color. Finally, we strongly believe every school district should conduct a social-emotional assessment of every student. So we're happy to see that assessments and services based on these assessments are included in this section. The importance of assessments is reinforced in Section 21, which addresses the issues that may lead some students to become truant. I'll wrap up by letting you know that my student group has asked the Stanford School District to set aside $100,000 of COVID relief money for students to design student-led mental health programs in our schools. Conversations with our superintendent continue. My friend from the Center for Youth Leadership will testify later today on other sections of the bill. Thank you.
Thank you very much. I always love when students come and testify. You did a fantastic job. You made some really great points as well. So I just wanted to let you know that Jean Rienzo, who is the clerk of the Children's Committee, will be reaching out to you via email. We do like to reward students who come with a very special pin that you wear. You can have for testifying in front of the Children's Committee. It is earned and it is not given to everyone. So thank you very, very much. Are there any questions? And seeing none, we look forward to also reading your. Thank you here.
Okay, thank you so much.
Have a great night.
You too, all of you. Bye.
How great is that? I'd like to ask, please, Barbara Vita, followed by Sarah Evans Zaleski.
My name is Barbara Vita. I am the coordinator for the Connecticut Children's Collective, the state's intermediary organization that connects local early childhood collaboratives to the OEC and State Department of Education. Thank you for allowing me to testify today, and thank you so much for diligently working to raise SB2. At birth, a baby's little brain is about a quarter of the size of the average adult brain. Incredibly, it will double in size in the first year and keep growing to about 80% of an adult size by age 3 and 90% by the age of 5. What happens in the first 5 years of life can quite literally make or break a child. The average annual cost of a high-quality infant care in Connecticut is $15,500 or $1,292 per month. Care for Kids helps to offset the cost for quality child care for low-income families, but funding for this program is not sufficient. In addition to the high cost of quality child care, there are simply not enough slots for the number of infants and toddlers needed for us to adequately care for our youngest and most tender members of our population. And many qualified teachers are fleeing the industry altogether. Who then will be caring for our children? We have babies doing their very best to develop, learn, and grow, but we, the adults, are making it nearly impossible for them to do that. Toxic stress is the body's response to lasting and serious stress because of the lack of support from parents or caregivers. This lasting stress can harm a child's body and brain and can cause lifelong health, developmental, and mental health problems. For those who don't know about ACEs, it is an acronym for Adverse Childhood Experiences. Things like poverty, domestic violence, hunger, emotional, physical, and sexual abuse, alcohol or drug-addicted parents, neglect, abandonment, and racism. What can we do to prevent young babies and children from experiencing toxic stress? We can provide high-quality, affordable childcare to every family in Connecticut who needs it. We need to invest $700 million this year as a down payment to stabilize our childcare system, which should include money to providers and living wages to our childcare professionals. We need home visiting programs for our parents who give birth to a child in Connecticut, to watch for maternal depression and developmental issues or concerns regarding the child. We need behavioral health systems of care, strengthened and connected and available to childcare and public school systems. We need more parenting education classes so that parents can know better and do better by improving their parenting skills. We need to train teachers about toxic stress and trauma-informed care. The science of early childhood brain development has been known for decades. We know that
Excuse me, Ms. Dita, your time is almost up. If you please summarize. Thank you.
Yes, ma'am. We know that prevention and quality early care is essential to the physical and mental health of our growing children. We need to finally do right by them. It will require a large investment, long-term sustainable funding that is not based on a business model of production and profits, but rather a public good model whose success is measured by fewer malnourished infants, fewer depressed mothers, fewer 6-year-olds who hit and bite others because that is what's being done to them, fewer middle school students who cut themselves so they can focus on something else other than the sexual abuse they are experiencing, fewer teenagers who experience suicidal ideation, and fewer adults who never learned to break the cycle of abuse that they had experienced from their birth. This investment will yield a more healthy, productive, equitable, and caring society for all. What an exciting and hopeful action to be a part of. Thank you for your time in making this possible. It is appreciated.
Thank you very much. We appreciate your impassioned testimony and all very good points. With no questions, we're going to move on. Thank you very much, Ms. Vita. And I'd like to call, please, Sarah Evans-Zalewski, followed by Subira Gordon.
Hello, and thank you. I am Dr. Sarah Evans-Zalewski, speaking on behalf of the Connecticut Counseling Association. I am also a licensed professional counselor who specializes in working with children and adolescents, a former school counselor, and a counselor educator at CCSU. I have also submitted written testimony for your reference. The Connecticut Counseling Association supports this bill as we do recognize the immediate and significant needs of children and adolescents here in Connecticut. However, the proposed bill as written fails to include licensed professional counselors and licensed professional counselor associates in several key places. Perhaps there is a lack of awareness of what LPCs and LPCAs do. All LPCs and LPCAs are trained in best practices for diagnosing and treating youth and their families. And many LPCs and LPCAs, like myself, work exclusively with children and adolescents. Connecticut law requires licensed professional counselors and licensed professional counselor associates to receive rigorous training in a variety of areas, including diagnosis and treatment of psychological disorders for adults and children, counseling techniques, crisis and trauma counseling, and drug and alcohol intervention, as well as demanding fieldwork requirements. While other disciplines such as social work have a broad focus, professional counselors tend to focus on the development of clinical mental health counseling skills as their primary focus. Specifically, our concerns are: in Section 2.4, LPCs are excluded from a proposed grant program that would assist individuals taking licensure exams. The proposed grant program is indicated for social workers only. Like social workers, licensed professional counselors in Connecticut are required to pass a rigorous and costly exam. SB 5001 would provide this financial assistance only for social workers. It is unjust that they should receive this benefit while other mental health care providers like LPCs and MFTs should not. There should be parity in workforce development among professionals who provide nearly identical services. In Section 18, the Department of Education is asked to support additional mental health practitioners to help provide for the growing needs of students. We enthusiastically support this movement. However, we are concerned that only 5 mental health disciplines are indicated as able to serve in this capacity: school social workers, school psychologists, trauma specialists, behavior technicians, and board certified behavior analysts. LPCs, LPCAs, and school counselors are not included in this. Again, we recognize the great need and are confused why we, trained and ready mental health clinicians, are being excluded. We appreciate your consideration of our testimony and urge the committee to include professional counselors as part of this bill. Thank you for providing me the opportunity to speak.
Thank you very much. Thank you for your testimony, and something that we actually did make known earlier. We've been at this for a while, is that the exclusion was actually just a sort of a drafting mistake, miscommunication, and LPCs are absolutely included, and so are a whole plethora of other mental health professionals. So no worries. So you can consider yourself, you were successful today and it's happening. So thank you very much for your testimony. We appreciate your time, and seeing no questions, we'll move on. So thank you.
Thank you.
Subira Gordon.
Hi, this is actually Hamish Macphail from ComCan. Subira wasn't able to join. She's actually in transit. So I was going to take the helm for this, but she sends her best and she sends her regards. So
thank you.
I'll get going. No problem. Good evening, members of the Public Health and Children's Committees. My name is Hamish Macphail, and I am the Director of Policy and Research for ComCan, and I work alongside Subira Gordon, our organization's Executive Director. Thank you for all you do for the Connecticut children and residents in the state. Today, I'm testifying in full support of SB2 and in general support of HB 5001, as they have immediate and long-term impacts for our student population. At ComCan, we are committed to supporting all students to learn, grow, and reach their full potential. And historically, Connecticut has struggled to provide adequate resources to our neediest students. These two bills seek to change the mental and behavioral health landscape for our children and have the potential to reduce trauma, improve intervention strategies, and enhance educational experiences. Starting with SB2, this bill invests in early childhood education. For us, this is a no-brainer. Too often, students start kindergarten without any formal introduction to school. And having been a kindergarten teacher myself, I know this firsthand. This makes the learning curve steeper and can have negative implications for a child's confidence and self-esteem. Preschool and daycare and childcare help students begin to navigate a social setting with opportunities to build early literacy skills, play-based learning, and sensory exploration. In fact, the more young students learn through exploration, especially in the natural world, the better those skills translate for a K-12 system. SB2 also supports working families to build their economic vitality, which has a positive impact on child health and well-being. ComCan fully supports all measures that expand access to childcare and preschool for children in Connecticut. Given the size of HB 5001, ComCan will focus its testimony on parts directly impacting K-12 education. First, ComCan welcomes the added credentialing flexibility for mental health support staff. Like the teaching profession, aspects of credentialing prevent well-qualified individuals from accessing the field. Connecticut is smart to move towards a flexible model for credentialing, especially given the immediate needs for students and families. Second, it's important that we collect data and publicly report that data on the number of social workers in our schools. In fact, it would be even better to help report all mental health professionals working and their associated ratios working in schools. As a state, we can allocate resources better that way, and the grant process that's outlined in the bill accompanies the data collection is welcome news. Third, the pandemic rapidly accelerated chronic absenteeism rates across the state. By investing in truancy support systems, Connecticut can begin to bring students and families back into the environment by understanding the root causes of that disconnection. We know that missed learning time is associated with lower graduation rates, college attendance rates, and economic opportunity later in life. By preventing chronic absenteeism from expanding, we're making key investments in our collective futures. We do support truancy reduction programs that build trust and communication between schools and families, and hope that HB 5001 fulfills that role.
Excuse me, Mr. Macphail, your time is almost up if you
No problem. I'll finish.
Thank you.
No problem. Our recommendation for HB 5001 is to pressure test all aspects where families interact with government programs. Historically, programs built with good intentions often are experienced differently depending on geographic, income, racial, gender, and background of those individuals. The inconsistency in implementation can actually widen the trust gap between families and government. By pressure testing these ideas with a diverse set of stakeholder groups, we can ensure that there are no implicit biases in the programs. Overall, ComCan is excited to see these bills in coordination with one another. As a state, we've been plagued with the nation's largest opportunity gaps for too long. By investing in mental health of our students, we can close that gap together. Thank you so much for your work and have a great night.
Thank you very much, Mr. Macphail, and we appreciate your testimony. Seeing no questions, we'll move on. Thank you very much. I'd like to now hand it off to the Vice Chair of Public Health, Representative Gilchrist. Thank you so much.
Thank you, Representative Linehan. Next, we will hear from number 92, Gus Marks Hamilton.
Thank you very much, Representative Gilchrist, and thank you, Representative Steinberg, and ranking members, Representative Pettit, Senator Wan, Senator Summers, and other distinguished members of the Public Health Committee. My name is Gus Marks Hamilton, and I work with the ACLU of Connecticut as the campaign manager for the Smart Justice campaign. I'm here to testify in HB 5001, an act concerning children's mental health. The ACLU has also submitted written testimony from our policy counsel, Jess Zaccanino, as well. A core belief of Smart Justice is that Connecticut will be safer and stronger when our state reduces the number of people held in the state's prisons and jails and reunites them with their families in their communities so that they can be successful members of our state. A core value of Smart Justice is that if Connecticut is to chart a new course for its criminal legal system, then decision makers should heed and value the experiences of people who have been directly impacted by the criminal legal system. I want to thank the committee for the good work they have done and put into this bill. While there are many positive proposals that address the mental health needs of young people in Connecticut, which was needed long before the pandemic began 2 years ago and has only grown more severe, we would like to raise some concerns that we have with the bill as it is currently written. We are disappointed that the bill does not remove school resource officers from schools. In fact, sections 21 and 23 of the bill require that SROs be provided peer-to-peer mental health training. Research, and when we listen to the experiences of young people, show that the presence of SROs can be detrimental to their welfare and lead to the criminalization of young people. Connecticut should be eliminating the presence of law enforcement figures in schools and instead be investing in students, peer supports, teachers, counselors, social workers, and other resources that young people need that will put them on pathways to success. Connecticut needs to support, amplify, and validate the experiences of young people, particularly Black and Brown youth. As a society, we have a tendency to only believe the experiences of adults, as if time is the only validation for wisdom and experience. We go on and on about how it's our job to keep kids safe, yet do everything but actually listen to them when they tell us they are unwell or unsafe. Another value at Smart Justice is that your experience is your expertise, and that certainly extends to young people. Young people deserve to be intentionally centered in the proposals in this bill and their contributions be given meaningful investments. We should be doing everything we can to make sure young people have the mental health services they need, with trained professionals that have the capacity to meet them where they're at. The legislature and this committee has the power to do that, but healing cannot happen from the same systems and policies that have also created harm. I hope the committee will take the opportunities to improve this bill, namely by removing the language regarding SROs. Thank you.
Thank you, Mr. Marks Hamilton. Good to see you, and thank you for your testimony. I don't see any questions, so we're going to move on to number 96, Susan Zabahaski. I'm sorry. I know I didn't get that correct.
Can you hear me? I'm sorry.
Yes, we can. Go right ahead.
Okay. I'd like to take a moment to thank you guys for your work on recognizing that there is a children's mental health crisis in Connecticut. However, I'm a little bit concerned first with the idea that more government is what we need to help solve the children's mental health crisis. I am the founder of Families for Freedom, a grassroots group of parents all over the state who advocate for the rights of parents to make decisions that they feel are best for their children. In doing so, I think it's a little alarming to hear about increasing mental health advocacy in the school system. I think the school is not the place for health concerns to be brought up. I think that the idea of these bills should focus on getting parents resources they may need, maybe informing them of a problem. But all throughout the testimony today, which I've been listening since this morning, I've heard people discuss the many problems with having more government, including costs of licensing to get people into the state, making the state more conducive to people not moving out so we don't lose healthcare workers and teachers, et cetera, et cetera. I think if we made our state a little bit more accommodating with less government, we probably wouldn't have the many issues of loss of educators and healthcare workers in the state. I also am concerned about the fact that people keep saying COVID has caused the issue with the mental health care crisis that we are facing in Connecticut. It is not COVID that has caused it. It is the mandates and policies that we have put in place in our school systems in Connecticut that have likely led to many of the issues that we are seeing our children face today. There are many school systems in Connecticut, 5 that I know of. My daughter attends one that did not have or follow the strict mandates that were put in place by the state. And our school systems are not seeing an increase in mental health issues in our children. So I think it's would be wise for this committee to look to those school systems and look to other states where we did not implement such harsh mandates on our children to see how their children are doing. So I would encourage that, and we will be following this bill as it proceeds forward. Thank you for your time.
Thank you for your testimony and your time tonight.
Thank you.
I don't see any questions, so we're going to move on to number 98, Elizabeth Frazier.
Good evening. Good evening, Representative Gilchrist and members of the Public Health and Children's Committees. My name is Liz Fraser. I'm the Policy Director for the Connecticut Association for Human Services, a division of Advancing Connecticut Together. I'd like to thank you for the opportunity to testify tonight on SB2. And I'd like to give a little context to the early care testimony so far. Connecticut now subsidizes just 20 to 25% of the early care programs. And without increases in 7 years, they are in great distress. However, the crisis is much more widespread. The crisis is, in fact, impacting centers and family home providers, for-profit, nonprofit, state-subsidized, and private programs located throughout the state. That is why there is a need for an estimated $700 million, because it is the whole of the early care infrastructure that needs stabilization, not just the programs that are currently funded. If you look at what we spend on the presently funded programs and then extend that same amount to the entire industry, it begins to make a little more sense. As providers struggle, childcare is increasingly unaffordable for most families. The 2020 a United Way of Connecticut ALICE report indicates that a family of 4 with 2 children earning $90,600 per year, which is considered a bare survival budget, spends 24% of their earnings on childcare, yet they do not qualify for subsidies. No parent should be spending more than 7% of their income to be able to work and contribute to the economy. We know that both federal and state dollars will be needed to build a 21st century early childhood system that supports the health and development of children, is available and affordable for families, and is financially viable for providers, and supports the Connecticut economy well into the future. And to do that, we need to start considering early care and education as a public good and invest. There is indication that the investment makes common sense. The Committee for Economic Development estimates that in Connecticut, $718 million in direct revenue is generated within the market-based childcare industry, and it's estimated to support another $674 million in spillover or related productivity in other industries. That's a total economic impact of about $1.39 billion in Connecticut right now. Of note, the $718 million doesn't include the actual cost of quality care. It's just what the market is bearing right now, which isn't enough. It also doesn't include the lack of infant toddler care, estimated at 50,000 slots. And just very quickly, the Economic Policy Institute informs us that meaningful childcare reform, capping families' childcare expenses at 7% of their income, would save a typical Connecticut family with an infant $9,194 on childcare costs, which would free up 13.2% of their annual income to spend on other necessities. And parents would have more opportunity to enter the labor force. There are other figures and facts in my testimony. I'll just stop by saying, while federal funding is greatly needed, there is the real possibility that it might be too little, too late, and we will have a costlier problem. If we want to stabilize the existing early care infrastructure, keep our parents in the workforce, and also attract a young and vibrant workforce to Connecticut, which we need, then we must begin now and value early care and education as a public good. My complete testimony will be submitted. Thank you for your time this evening.
Thank you, Ms. Frazier. Good to see you. We do have a question. Representative Cook.
Hello, Representative Cook.
Thank you, Representative Gilchrist. Hi, Liz. It's great to see you. I just wanted to take a minute. I mean, we've heard all day today, we've heard a variety of different things and the needs. And as you all have been dedicated to early childhood and in making sure that the system is protected, well-funded, could you please, just in a brief moment, I know that we have several people to talk, but you started to allude to it, but then I know that given time you had to stop. Could you please explain just a tad bit more on if we do not invest in these early cares? I mean, we've already seen a significant amount of places closed, whether it be because of the pandemic or the lack of funding or a combination of both. What does childcare early, and then early education look like in the near 5 years if we do not continue to invest? And I think that this also has this conversation about the mental, social, and emotional component of this as well. So if you want to just take a couple of minutes, I would greatly appreciate it. And then Representative Gilchrist, that's my question. Thank you.
Sure, that's a lot, but I will do my best. Without childcare, first of all, let's just face it, many, many more moms are working right now. And let's just think about the mental health of both moms and children. Many of these moms are working, they want to fulfill their own dreams. They want to be part of a workforce. They need to make money to support their families. And they're entering the workforce and handing their children over to strangers, basically. That in itself is stressful for families. When a parent can't afford to feed their children, that is even more stressful. So parents are making choices now about working or not working. Unfortunately, in our state, we need two incomes to be able to support a family often. And so it's a necessity. So that's one thing to consider. Working moms, that they need to work for their own security, for Social Security and all of those things. And they need really good care, quality care that provides what children need to grow and prosper. And that's what they get right now. Lack of funding means that they might not be able to find care. Then children are placed in programs that are maybe not necessarily the best places for them. But because they need to work, parents do that out of necessity. Sometimes those places might be unsafe. Sometimes they might be less than optimal. But those are the types of things that happen when there isn't care available. There's an underground system that becomes available. The other thing is that we need the care to grow the economy, and we have an aging workforce. So what are we going to do to attract young families to this state? Look at it on the other side. If we had a more robust system where no parent paid more than 7%, I can guarantee you that you'll have many young people coming here if Connecticut leads the way, because every other state is going to be trying to do the same thing. This is a crisis across the country. I think that there is so much evidence as well that's in my testimony that is written that goes to the cost, the savings to the state, the investment in the state, and how it contributes to the economy. And there is a report from Canada in one province where they've instituted a really optimal childcare system, and it has paid for itself because of the increased revenues coming in. That's a little rambly. I'm sorry, Representative Cook, you caught me a little bit off guard, and I don't have all my notes right in front of me, but I'm happy to speak at another time as well.
You did fantastic, Ms. Fraser. Thank you. And thank you, Representative Cook. All right, so no other questions? I'm going to call on number 93, Claudia Tucker. You're still on mute. There you
How
go.
about now? Can you, okay?
You're good.
Great, thank you. Good afternoon, Madam Vice Chair, members of the committee. My name is Claudia Tucker. I'm Senior Vice President of Government Affairs for Teladoc Health. In this capacity, I have responsibility for all 50 states and all federal work relating to telehealth. And I'm here today to express our strong support for House Bill 5001. Before I address the specifics of the bill, I want to give you some context relative to our commitment to Connecticut. For those of you unfamiliar with Teladoc Health, we're the world's largest telehealth company. Today in Connecticut, over 4,000 employers use Teladoc Health. We cover over 629,000 Connecticut lives. And last year we performed over 22,000 virtual visits. In addition, we save the healthcare system in Connecticut over $10 million. These are savings to the patient and employers or health plans that pay the bills. All of our providers are licensed in the state of Connecticut, and over half are actually residents there in the state. So our providers are your providers. As members of this committee are well aware, the COVID-19 pandemic has exacerbated the mental health crisis in Connecticut, especially for children and their families. Many patients are experiencing extensive wait times or turned away altogether because of provider shortages. We've all read the stories and heard the pleas from the families about what they do with nowhere else to turn. They show up in the emergency room in an attempt to access the behavioral health care. There is no worse place for these folks to go. This is a healthcare setting that is not designed to effectively treat these issues. Innovative solutions are absolutely necessary to ease this behavioral health crisis and directly address the needs of Connecticut citizens. Since March of 2020, I have watched responses to the pandemic and provider shortages and reaction to hotspots unfold. I can tell y'all that nothing, and I mean nothing, makes an immediate policy impact like licensure reciprocity does. House Bill 5001 is a timely, common sense bill that will address a behavioral health care crisis Connecticut's children and teenagers are currently experiencing. Chief among the bill's proposal is a measure to establish licensure reciprocity rules for licensed out-of-state behavioral health care providers. And if enacted, this measure will immediately expand the pool of available clinicians in the state, reduce the lengthy wait times that patients are currently experiencing, and alleviate the strain on the hospital system and emergency rooms. Licensure reciprocity will permit virtual healthcare platforms like Teladoc to leverage our out-of-state licensed professionals to assist patients anywhere and at any time in Connecticut. Teladoc Health will continue to do everything in its power to provide Connecticut residents with valuable mental health care when and where they need it. Our efforts are made much easier when state policies allow our platform to utilize its vast network of qualified behavioral health care professionals across the nation. It is with this in mind that I urge your support for House Bill 5001. Thank you for the opportunity to provide Teladoc Health's unique insights on this important piece of legislation. I'm happy to address any questions or concerns you may have. And my hat is off to you all. You've had a marathon session, and thank you for what you do.
Thank you, Ms. Tucker. Thank you for the kind remarks and for your testimony tonight. I don't see any questions. We're going to move on to number 99, Olivia Rinks. Ms. Rinks, are you with us? All right. If not, we're going to move on to number 100, Heather Gates.
Good evening. Nice to see everybody. Some of you I saw last night in the appropriations hearing. A long night. I'm Heather Gates. Thank you for the opportunity to testify before you tonight. I'm the CEO of Community Health Resources. We are one of Connecticut's largest behavioral health providers. We are an EMPS provider in Central Connecticut. We have extensive outpatient and in-home services, therapeutic group homes for children, care coordination, school-based outpatient and care coordination within the schools, prevention services, and we offer telehealth services to a number of primary care practices. We deliver these services throughout Central and Eastern Connecticut, meeting the needs of over 8,000 children and families every year. So we have an extensive service system in place already. I want to thank you for your attention to this crisis. I do want to point out this is not a new crisis. There have been access issues and funding issues related to services, mental health services for both children and adults for many years. The pandemic has simply exacerbated it, and it is now a crisis that is genuinely out of control. To give you a couple examples, as a result of workforce shortages in our organization, many of our in-home teams are operating at reduced capacity. The impact of this is that more acute situations coming into our outpatient clinics and being triaged there are putting greater pressure on our crisis teams. It also puts pressure on programs that have reduced staffing and ones that cannot say no to referrals. So this in turn creates higher caseloads, which are overwhelming for our clinicians and leads to burnout. It's a vicious cycle all in all. So we support many of the provisions in this bill, and we're very grateful for that. But we really want to stress it is critical to bolster the existing foundation of the mental health services that are already in place and in existence. There is no way to address this crisis unless you address the chronic underfunding of existing services that have been in the community for a number of years. The legislature's commitment to this has always been strong, and we're very appreciative of that. The impact of this decades of underfunding is that many of the programs we operate have an inability to increase clinician salaries to a competitive level with other providers, including all the telehealth companies that are hiring our staff, I might add, and the overall financial instability at a time when our services are needed more than ever. We are in a position right now of having to make some tough choices about program closures and limiting access to outpatient services in the near future if we are to stem the tide of red ink. As a major provider of children's services and to children's services to kids and families, this will have a dramatic impact. So we urge you to pay attention to the fundamentals of the system right now before you start adding funding to lots of new initiatives. Thank you, and I'd be happy to answer any questions.
Thank you, Ms. Gates, for your testimony and your time tonight. I don't see any questions. Have a great evening.
Thank you.
Next, we'll hear from 101, Beth Hamilton.
Thank you, Representative Gilchrist. Good evening, esteemed members of the Public Health and Children's Committees. Thank you for the opportunity to share our support of SB 2 and HB 5001, and thank you for your important leadership on this critical issue. My name is Beth Hamilton, and I am the Executive Director of the Connecticut Alliance to End Sexual Violence. The Alliance is the state's coalition of community-based sexual assault crisis services centers who provide 24-hour crisis interventions, including hotline services, counseling, support groups, accompaniments in hospital, police, and court settings, and advocacy while navigating complex systems. For nearly 40 years, the Alliance has provided comprehensive, victim-centered, and trauma-informed services to child, adolescent, and adult survivors of sexual violence across our state. 1 in 4 girls and 1 in 13 boys will experience sexual abuse before celebrating their 18th birthday, with 91% of the abuse being perpetrated by someone known to the child or the child's family. It's important for children who are exposed to violence to have access to immediate and comprehensive interventions to reduce the lifelong trauma and mental and physical health outcomes associated with experiences of abuse. However, as you've heard a lot of evidence here today, the available resources in our state have not kept pace with the volume or complexity of the needs of children and families that we work with. Over the course of the last year, we've seen a nearly 12% increase in children under the age of 18 disclosing being victims of sexual violence, and those numbers are only increasing as our advocates continue to be welcomed back into schools and communities. We firmly believe that the measures outlined in these bills will positively impact the survivors that we work with by increasing knowledge, training, services, and interdisciplinary interventions available to children and families. An emphasis on using trauma-informed practices will increase access to compassionate and skilled providers and help to move our state towards policies and services that better support the most vulnerable survivors in our state. Creating a position at the State Department of Education specifically to develop and implement a system-wide trauma-informed care training program to use in our K-12 schools will help to institutionalize the prioritization of trauma-informed care for children. And working collaboratively across systems and disciplines will position these efforts to be successful and ensure that children not only have access to appropriate interventions, but that there's a larger culture shift towards prioritizing the mental health and well-being of children in our communities. The new approaches to youth mental health and truancy being considered will be especially impactful to girls in our state who are most likely to be affected by trauma and long-term mental health impacts post-abuse. Poor responses to truancy contribute to the criminalization of child survivors of sexual violence, especially children of color, who are often missing school or running away due to the abuse that they are experiencing. The most common crimes for which girls are arrested, for example, such as running away, substance abuse, and truancy, are also some of the most common symptoms of abuse. Punitive responses to children's trauma divert accountability away from the person who caused the harm and instead further punish the child. Shifting our response to supporting and understanding children in combination with prioritizing early interventions will create sustainable practices that support lifelong healing and wellness in families and in our communities. Thank you for the work to create interventions and services that give children what they need and what they deserve. And again, we strongly support both SB 2 and HB 5001. Thank you.
Thank you, Beth. Thank you for bringing this perspective and for your work.
Thank you, Representative Gilchrist.
I don't see any questions, so we're going to go on to number 103, Michael Patoda.
Thank you. My name is Michael Patoda. I'm the president and CEO of the Child and Family Guidance Center. I'm going to reiterate a lot of what Heather Gate just spoke about. She was very eloquent in, I think, describing the current stress that a lot. I speak to you tonight as a provider of outpatient mental health and substance abuse treatment for children and families throughout Fairfield County. We see about 4,000 kids a year. I'm testifying in support of SB 2 and HB 5001. As we enter into the third year of the pandemic, we've seen that children and teens are facing worsening emotional and cognitive health. We all know that children with psychiatric needs are overwhelming hospital emergency rooms. The system built to provide outpatient care is stressed and frayed. Throughout the pandemic, our staff have provided critically needed services, both in person at great risk to themselves and virtually. One of the programs we delivered is Mobile Crisis Intervention Services, which is a team of social workers who go out to schools and into the community to lead if possible diversion to hospital emergency rooms through referrals to community treatment resources. This DCF program is intended to provide an alternative to the ER. Because of the dramatic increase in the utilization of mobile crisis and our vacancies in our own programs, our workers are physically and emotionally exhausted and stressed. We've seen
Mr. Patoda, we're struggling a little.
Doubling of the number of children seen in the first of this year. So we've gone from I'm sorry, is it going in and out?
Yeah, do you want to turn off your camera? That sometimes helps.
Is that any better?
Yes, it is.
Okay, I apologize. So we've seen a doubling of the children seen in the first 7 months of this year compared to last year. So we've doubled from 230 to 459. For the children that we serve at Child and Family Guidance Center, the majority of whom are low income and have experienced trauma in the form of either abuse or community violence, the need for culturally relevant and trauma-informed crisis treatment is even greater. The stakes are even higher. That's why I'm speaking in favor of both bills, because they're intended to address the current crisis in children's mental health. In particular, proposed enhancement of 911 and the increase in kid care funding will allow providers to increase the number of emergency mobile crisis staff and expand the geographic area covered by the service. To solve the crisis, we need the state of Connecticut to invest in mental health care and people who provide it. While we're proud to have a talented, diverse, and multilingual team of clinicians and care managers, the community need often overwhelms our existing staff. Our children deserve better. Thank you so much for this opportunity to testify.
Thank you, Mr. Patoda. And we do have a question. Senator Moore.
Thank you, Michael, for your testimony. You're here in Bridgeport. I appreciate the work you do on the mobile crisis.
Thank you so much.
If we could zero in on what is the most important thing for us to get done for you besides funding? It's always, we can always use more money to do more programs, but how else can we support you in this mental health? I'm very serious about this gun violence prevention, and you're like an anchor for me right now to be able to send out clinicians in a moment of crisis. So what do you think it is?
Yeah, it's not one solution. There's a lot in this bill that has a lot of good going for it. Tuition reimbursement is a huge issue for us. We have the National Health Service Corps, which reimburses some licensed clinicians, but we don't have that for master's level clinicians who are not licensed yet. That would be very helpful for us. We have very talented bilingual, bicultural staff. Keeping them engaged and we have monetary rewards and we have non-monetary rewards. I think the challenge for us is recruiting and retaining really talented people. Whatever we can do to do that, I'm happy to have that conversation with yourself or anyone else. This is a big challenge for us right now.
And I've heard that in a couple of places on different platforms about recruiting and recruiting them, getting them to stay here and not go someplace else. So it merits more conversation.
Absolutely. So the challenge for us is we're not able to pay the same salary or comparable salaries to what state institutions can pay, what hospitals can pay, what colleges can pay. So it's a challenge for us. We have a very devoted team of folks, and they stay with us because they're wedded to our mission. So it's wedded to doing really good work in this community. That's really sustains us.
I want to thank you for your contribution.
Thank you so much for the kind words. Thank you.
Thank you, Senator Moore, and thank you, Mr. Patoda, for your work and for your time tonight.
Thank you so much.
We're going to go to Kate Field. Hello, go right ahead.
Thank you. Esteemed members of the Committees of Public Health and Children, my name is Kate Field, and I'm the Teacher Development Specialist at Connecticut Education Association. I want to thank you for this opportunity to testify tonight in support of specific sections of HB 5001. I ask you to refer to the details of my written testimony for the specific sections. When I left the classroom in 2015, it was already pretty evident that mental health problems among children were increasing at an alarming rate. In the 7 years since, the situation has steadily worsened, dramatically so as a result of the pandemic. Meanwhile, our educators are stressed and overextended. Support staff in our schools are woefully insufficient, and mental health programs that are serving our children are under-resourced. These are all things that have to change. CEA is optimistic, though, that despite the magnitude of these problems, together we can do much to begin to resolve them. It's so heartening to see that regardless of political affiliation, we're coming together to tackle these problems. And it's for this reason that I'm here tonight to support, to express support for aspects of HB 5001. Again, I ask you to refer to my written testimony for specific sections that I'm here tonight to support, and I'll utilize my remaining time to speak strongly in favor of Section 19, which calls for expanding access to school-based mental health services. Students are actually 21 times more likely to visit a school-based mental health center than to go anywhere else. And schools that offer these services see all kinds of benefits, including reduced truancy, fewer suspensions, improved academic outcomes, and higher graduation rates, making it easier for children to access these supports and resources is perhaps one of the biggest steps that we can take to alleviate the mental health crisis and enhance the overall effectiveness of our public schools. I want to thank you for your time and consideration. It has been an incredibly long day, and your dedication is very much appreciated.
Thank you, Ms. Field. Thank you for your work and for your testimony tonight. Not seeing any questions, we're going to go on to Michelle Cunningham.
Good evening, Representative Gilchrist and distinguished members of the committees. Thank you for your leadership in bringing these important bills forward and allowing me to testify. My name is Michelle Doucette Cunningham, and I'm the Executive Director of the Connecticut After School Network. I've been listening to the hearing today since it started at 9 a.m., and we've heard hours of testimony on the incredible importance of both of these bills. I strongly support the provision of the full array of mental health, behavioral health, and treatment services for children, but I'm going to use my few minutes tonight to speak on the current crisis in the childcare sector. I don't envy you at all the challenge before you. You have to balance the competing interests of providing treatment to children experiencing mental health crises, as well as that of investing in prevention services that can prevent some of these problems from happening in the future. What is the best use of public dollars? And what's in the best interest of the state? You may be asking yourself how you can leverage other funding and get the best return on this investment. Earlier today, we heard from Commissioner Bai that we have to fix the whole childcare system. And to do so, we have to start with the workforce. And in the same way that early childhood brain development is the foundation upon which future success is built, the staff who work in childcare sector are the foundation of the Connecticut economy. Without them, parents are unable to work, children are placed in unsafe situations, childcare centers close, and things continue to spiral out of control. In a market economy, prices for goods and services are set by supply and demand, but we've heard today over and over that the market for childcare services is broken. There is more demand for services by parents who cannot afford to pay the price that would be set by market forces, and the cost of high-quality childcare is more than the cost of college tuition. On the other side of the equation, providers cannot afford to pay staff wages nor provide health insurance enough to compete for employees in the job market. And caregivers are leaving the field in droves for higher paying jobs with benefits. This is, however, a simple economic problem because it's possible to reverse the downward spiral and instead create an upward one that would bring more people into these childcare jobs, allowing more parents to work and contribute to the economy, which then raises enough money in taxes and economic growth to more than pay for the investment. Research on early care and education programs finds that every dollar spent in investing in these programs generates $8.60 in economic activity. That's an 8-fold return on your investment. Supporting childcare workers is crucial for promoting the quality of the care, and childcare workers in Connecticut have a median wage of less than $29,000 a year. Low pay leads to high turnover and high stress in the profession, which also undermines the quality of the care that the children can receive. Using public funds to support higher compensation would help stabilize the childcare workforce, ensuring that these workers can afford to stay in their jobs.
Time, please.
I joined together with the many people who spoke today, calling for you to invest $700 million up front to invest and stabilize the childcare system and keep the Connecticut economy strong. It's essential for all of us, not just those with young children. I've attached with my written testimony citations for additional on the economic analysis of the investment, if that would be helpful. Thank you for the opportunity to speak today.
Thank you, Ms. Cunningham, for all your work and for being here tonight. I don't see any questions, so I'm going to move on to 105, Mary Jordan.
Thank you very much. Representative Gilchrist, and members of the Public Health Committee and the Committee on Children. My name is Mary Jordan. I'm a teacher certified in social studies and French and president of the Norwalk Federation of Teachers. I'm also a divisional vice president of AFT Connecticut. Our members include more than 15,000 teachers, paraprofessionals, school nurses, including counselors, school psychologists, social workers, and other school personnel across the state. I am speaking to express our support for House Bill 5001, and we expect to enthusiastically also support SB 2. The past few years have taken a toll on educators and a higher toll in many ways on the young people we serve. You've heard all day about anxiety, depression, self-harm, dysregulated behavior, and the increase among young people. There is a great need to rethink and reconfigure services to those who serve children and the services themselves. And for this reason, AFT Connecticut supports HB 5001. We are trying to foster healthy growth and development for our kids so that by the time they're in high school, they are well adjusted and prepared to graduate, ready for the real world. Since early services are highly effective to those in need and our youngest children exhibit great needs, we expect to enthusiastically support SB2 as well. Scholarships and grants to support social workers are much needed. Masters in social work degrees are commonly 50 to 60 credits, while other master's degrees are in the range of 30 credits. Any amount to support these extra years of school and costs in pursuit of this valuable degree will be useful, and we hope will also encourage non-traditional candidates entering the profession. School is exactly the place where we work to support health, healthy students, healthy families, and healthy communities. The role of the typical school social worker is to support the needs of all students and to serve as a liaison from home to school and within the community. Often caseloads are so high in public education and that the needs of mandated counseling for special education students are addressed more readily than counseling for general education population. The grant for the purpose of hiring and retaining additional student mental health specialists, which I'm happy to hear includes a wider variety of specialists, will provide the opportunity for students who need mental health services, who are otherwise not serviced by the school social worker, to receive access to much needed supports. The use of safe school climate specialists to support students who seriously disrupt instruction or cause physical harm to themselves or others is a good idea. We always seek to support students struggling with meaningful interventions. We always seek to support struggling students with meaningful interventions and supports and not penalize them, not hold our breath waiting for another episode, and not divert attention to the needs of one child at the expense of others in the classroom. We are working tirelessly on this behalf, and we appreciate, thank you, Jean, we appreciate all of your efforts to create this legislation, which we think will have a good impact on our school communities and our communities in general. Thank you for your attention and the opportunity to speak.
Thank you, Ms. Jordan, for your testimony and your time tonight. All right, not seeing any questions. We're going to move on to 106, Kim Harris.
Good evening, and thank you, members of the Public Health and Children's Committee. Thank you for this opportunity to testify on SB2. My name is Kim Harris, and I live in New Hallville, a neighborhood within New Haven, Connecticut. I am a second-generation business owner / director / teacher at the Harrison Tucker School. Our center services children ages 6 weeks to 12 years of age. Our center hosts 64 children, and our group home hosts 12 children. Since our inception, we have educated thousands of children who are prepped and ready to go into kindergarten. This has been a feat in itself. And in order to keep this happening, this quality of care, it costs a phenomenal amount of dollars. As you know, there's a growing awareness of social determinants of health, not only the effects on the physical, but also on mental health outcomes, especially in early childhood.
Ms. Harris, I'm sorry to interrupt. We're having a little trouble hearing you. Is there some noise in the background you could turn down?
Yes, I'm sorry.
It's okay. Now you're muted though, and we do definitely want to hear your testimony.
I'm so sorry. That was my 90-year-old aunt.
No worries at all. Thank you.
All right. And just as you know, there's a growing awareness that social determinants of health not only affect physical, but the mental health outcomes, especially in early childhood education. As an early childhood educator, director, and teacher, my entire center, we really focus on the environment. We focus on brain development. But it's so hard and so stressful when we, as directors and owners, can barely afford to pay our teachers, our staff, more than just minimally more than what a retail worker might make. It is essential that you make this investment in the early childhood education. The impact of the pandemic has had a huge toll on our teachers and our staff. At Harrison Tucker, we always talk about our hopes, our dreams, and solutions in the world. We know that one huge solution would be to build up the systems of this profession. This year, we need a $700 million down payment on what really should be the $2.5 billion for this system. The systems can work. We can attract the best. We need your help in making this happen. This industry is so important to how our next generation is going to really be the ones to carry the torch for who we are, what we do, and how we live. I thank you so much for your time and your consideration in making these efforts happen. Thank you.
Thank you, Ms. Harris. Thank you for the work you do and for your testimony tonight. Not seeing any questions, we're going to move on to 107, Roha Yusuf.
Good evening, Representative Gilchrist, Representative Linehan, and Senator Anwar of the Children's Committee, and Senator Abrams, and Representative Steinberg of the Public Health Committee, as well as the vice chairs and ranking members of each committee. You heard earlier today from my fellow student activists in support of several sections of HB 5001. She's from the Mayor's Youth Leadership Council at Stanford High School. My name is Roja Yusuf, and I represent the Student Center of Youth Leadership at Brian McMahon High School in Norwalk. Just about everything I'm going to share with you is taken from a proposal my student group submitted to the Voices for Change program, which is an initiative of the Connecticut Department of Education that funds student voice projects. Let's start with Section 19, which addresses grants for school mental health services to students. As you know, Public Act 21-132 calls for the creation of mental health coalitions on college campuses. You may want to consider similar coalitions for middle schools and high schools, which will allow for student voice in the services provided by schools. Next is Section 23. We offer our strong support of the training for school resource officers in the bill's peer-to-peer support program. We believe every adult who steps into our school needs to understand and support the culture of our school, which includes the needs and rights of students, especially when it comes to keeping them from the juvenile justice system. While we support the trauma care mentioned in sections 24 and 25, we ask that you consider including students among the people in schools who receive trauma training. Students can be a great resource to the professionals who provide care. In addition, we support the update to the school profile to include trauma services, as called for in Section 27. Trauma is a very real and ongoing experience for an increasing number of students. The public sharing of such information will allow parents and students to hold their school districts accountable. Finally, Section 41 and the peer-to-peer support program. This section needs to better address the practice that there should be no program about students without students. We strongly suggest that students be a part of the group that designs the peer-to-peer support program for students in grades 6 through 12. On behalf of student activists in Norwalk and Stamford, we appreciate your attention to students' mental health. Thank you so much.
Thank you, Ms. Yusuf. Thank you for your thoughtful recommendations. I love the work your group does. Even though I am not a member of the Children's Committee, I've caught on that the Children's Committee gives a pin to young people who testify. And so Jean Rienzo will be following up with you to get you a pin. So thank you.
Thank you.
All right, next we're going to hear from number 108, Terry Bedard.
Thank you, Representative Gilchrist, and good evening, Madam Chair Linehan, Chairman Anwar, Steinberg, and distinguished members of the Public Health and Children's Committees. My name is Terry Bedard, and I am here along with my colleagues representing SEEK, Special Education Equity for Kids in Connecticut. And we're here to testify on our position regarding raised House Bill 5001, an act concerning children's mental health. First, I'd like to applaud the really great work that you are all doing on this bill as a very good first step in providing mental health supports. But we believe more needs to be done across every public school in Connecticut. You have all of our SEEK testimonies, so I'm going to really focus in on sections 24 and 25 of the bill. Under these sections, a trauma coordinator from the Department of Education is tasked under the bill with developing, implementing, and training district staff using a train the trainer model, but nowhere in the bill does it discuss the qualifications of the trauma coordinator or the trainers. How can a program provide trauma-informed training without trauma-informed trainers? SEEK advocates for an evidence-based, trauma-informed program with qualified trainers to train all of those along the front lines of student interaction, especially our teachers who naturally come into contact with these kids pretty much every single day. And on the topic of implementation, I'm sure we can all relate to a time where we have received some kind of training, but then we weren't quite sure how to put that training into practice when it came time for implementation. So it's really a world of difference between hearing how to identify students who are struggling with their mental health in a training program, and then knowing how to put that training into practice in the real world. So post-training oversight should be added to ensure the proper implementation of a trauma-informed program with fidelity. And those are the key words, with fidelity. This bill should also include parent training to carry over the trauma-informed programming into the home. This is no surprise, you've been listening to this testimony all day long, but many of our students, especially those with disabilities, were traumatized by the pandemic, and they continue to suffer unprecedented anxiety, stress, depression, just to name a few of their challenges. And many pre-pandemic mental health disabilities are now off the charts for these children and adversely impacting their ability to focus on their education. So in summary, if we are serious about adding much needed mental health programming to public schools, we need to have qualified, appropriately trained individuals to implement evidence-based programs with fidelity to help all children needing mental health supports, especially children with disabilities. And let me add in the few seconds I have left, while we're on the topic of mental health for students, to echo what my SEEK colleague said earlier, we need to change the emotional disturbance special education designation to social emotional disability or deficit. I do have cases where parents and students actually reject a label of emotional disturbance because of the stigma attached to it. And consequently, they don't receive the mental health supports that they need. Thank you for this opportunity to testify.
Thank you, Ms. Bedard, for your testimony and your time tonight. Now we're going to move on to number 110, Stephen Jacobson.
Good evening. My name is Stephen Jacobson, a resident of Bolton.
a Master of Social Work student at the University of Connecticut, an adult with autism spectrum disorder, disability rights advocate, and a constituent of State Representative Robin Green. I'm testifying today in support of Senate Bill Number 2, an act expanding preschool and mental and behavioral services for children. Mental and behavioral health services are invaluable at all points in the lifespan, but early childhood support is especially critical. Increasing funding to support services can not only improve the quality of life for youth and their families, but serve as a protective factor which prevents negative outcomes before they present themselves later in life. I would like to highlight the desperate need for investing in educational resources for school faculty and parents, informing them how to access available mental and behavioral health resources, request support resources, and promote faculty and family involvement, developing and implementing individualized education plans or IEPs. I have spoken to the parents of children with autism, and they feel they don't receive enough information or training without spending significant time advocating for them. Families have reported that many schools are currently unable to provide adequate mental and behavioral health services at all. My own experiences in Connecticut public schools reflect what families are currently reporting. Some have need to go so far as to move to different school districts or advocate for outplacement, which is extremely expensive for schools and families alike, often costing between $60,000 to $400,000 a year for a single student. And because of the 4.5 per student expenditure cap on state reimbursement for mental health programming, schools are paying for most of those services on their own. As the language of the act is written and refined, I ask that you address the inequitable distribution of mental and behavioral health resources across our communities. For all these reasons, I call upon the members of the Children and Public Health Committees to support and build upon Senate Bill 2, an act expanding preschool and mental and behavioral services for children. The Public Health and Children Committees have both been made aware of the ways the pandemic has caused a surge in children seeking mental and behavioral health services, but these critical services were at a breaking point for years. This act alone cannot fully address the needs of Connecticut youth and families, but it is an important stepping stone to better support our families and our youth. Thank you for the opportunity to speak and for your attention.
Thank you, Mr. Jacobson. As a grad of the UConn School of Social Work, so happy you're here, and thank you for your time and your testimony. Next, we're going to hear from 111, Ebony Askew.
Members of the Public Health and Children's Committee, thank you for this opportunity to testify on SB2. My name is Ebony Askew, and I live in Hamden, Connecticut. My children are Amina, Carmelo, and Carly, and they all attend Harrison and Tucker, founded in 1970, and is a member of the CERCLE, a network of over 40 childcare providers serving children and families of color. The pandemic has taken a toll on the mental health of all of us, and for my young children who have lived most of their lives in a pandemic, it has clearly had an impact. That impact has greatly reduced for my family because I had access to Harrison and Tucker School. While I have been incredibly lucky, this has not been without challenges. The cost of childcare to attend a high quality program is incredibly expensive. That's why I am glad that SB2 calls for additional funding for programs through the Office of Early Childhood. I call upon members of this committee to increase funding and expand the eligibility of the Care for Kids program to ensure that families like myself can continue to access high quality early care programs like Harrison and Tucker. We need to build up systems of support for families, especially after the pandemic. This year, we need a $700 million down payment on what should eventually be a $2.5 billion system that will enable parents to find quality, affordable childcare in a setting of choice. Promoting food mental and physical health of our children that allow access to social and physical environments of quality is what I am striving for. Thank you for your time and consideration.
Thank you, Ms. Askew, for being here tonight and for your testimony. Next, we'll go to Maria Amado. Ms. Amado, are you with us?
Sí, muy buenas noches.
Hola.
Buenas noches, senador Andrew, representante Deneen, senadora Brown y miembros del Comité de Niños y de Salud Pública. Estoy testificando en apoyo del proyecto de ley senatorial 2. Mi nombre es María Amado, propietaria y operadora de Greenwood Family Childcare Home, ubicado en Hartford, Connecticut. Las proveedoras necesitamos ayuda para los niños de nuestra comunidad. Para que mi programa se pueda mantener operativo y no haya amenazas de cierre, amenazas que enfrentamos todas las proveedoras. ¿Por qué enfrentamos estos problemas? Por la falta de hijos para completar los espacios requeridos que nos tenemos a través de nuestra licencia de la Oficina de Educación Temprana. Tengo que tener un apoyo para cubrir los gastos básicos, como es pagar las facturas, parte de mi hipoteca que corresponde al espacio que funciona mi programa. Pago de sustituta, renovación y adquisición de materiales para el aprendizaje de los niños. Para nosotras, las proveedoras, COVID no ha terminado, porque los niños son menores de 3 años. Queremos que Connecticut continúe prosperando, y esto es un efecto dominó, porque si a nosotros al darnos nuestros servicios a los hijos de las familias pueden trabajar en paz, sin preocupaciones. Las empresas van a poder permanecer operativas. El Estado va a crecer y todos vamos a estar realmente mentalmente bien, financieramente bien, sin el estrés de un posible cierre de nuestros programas. Necesitamos la ayuda ya urgente. Gracias.
Gracias, Ms. Amado. Next, we'll move on to number 117, Diana Martinez.
Hi, thank you for the opportunity to testify on HB 5001. My name is Diana Martinez. I work with the Middletown Racial Justice Coalition, which is a member organization of the Connecticut Black and Brown Student Union. I'm also a mother and a Middletown resident. There are parts of this act I think could change experiences and outcomes for children. Routing calls for persons experiencing crisis to someone other than law enforcement is a step in the right direction, as are creating pathways for social supports and programming that prevent or address youth mental health crises, and creating incentives for hiring more mental health staff of color. Our communities are in desperate need of mental health and wellness supports for young people and families that operate independently of systems of incarceration. Communities of color have long experienced the ways our systems, sometimes in tandem, label, mislabel, stigmatize, underserve, target, and imprison young people of color experiencing mental illness and race-based trauma. Any efforts that prevent that trajectory are welcome. However, we're deeply concerned that this proposal increases funding, training, and support for school resource officers to take on the role of a behavioral health, peer mentoring, and/or child development expert, as in sections 22 and 25, that it creates systems to address student absenteeism that would criminalize and pathologize truancy by mandating psychiatric and behavioral health examinations, as in section 21, and that it would further overwhelm an agency like DCF with addressing school-based issues, in addition to administering a host of other functions that credible community-based organizations could fulfill instead, such as sections 22, 40, 41, and 43. Overall, we do not feel that this proposal unlinks systems of criminalization from the referral system. The prevalence of mental health issues might be new or heightened by COVID for some communities, and perhaps this bill has such resounding support because mental health has risen to a new level of importance for folks who live outside of our urban, poor, or non-white communities. But for people of color, mental health has been inextricably linked to and exacerbated by poverty, policing, lack of access to jobs, housing, and inequitable education systems for generations. We would like for y'all to acknowledge this and produce legislation that not only takes those realities into consideration, but that also plans to avoid further deepening existing inequity. So further enabling and funding actors our communities are inclined not to trust, who have continuously mismanaged our care, or who surveil, police, or arrest us is not the route to wellness. While it's a great idea to fund hiring mental health support staff of color, doing that does not guarantee that they'll be hired where they're most needed or at rates that are in line with the demographics of the communities that they serve. This is an opportunity to remove police from our schools. Training police as peer-to-peer support is completely in opposition to the goals of alleviating stress or de-escalating crises, particularly for children of color. There are organizations in our communities that are adept at youth development, restorative practice, and alternative forms of youth engagement that would better serve this end than attempting to retrain people who are deeply ingrained in ideologies of discipline. The Black and Brown Student Union has crafted a solution that to many of these gaps that our schools and community service providers have, and we call it a school resource counselor. In my written testimony is a description of what a school resource counselor would look like, and we urge you to reevaluate the ideas and recommendations based on what a SRC could do if implemented and supported in a meaningful way. So for these reasons, we cannot support this bill as is, either I as an individual or us as a coalition. Thank you.
Thank you, Ms. Martinez, for your testimony. We do have a question. Representative Exum.
Thank you, Madam Chair, and thank you, Ms. Martinez. Thank you so much for coming out tonight and being very patient for a long day to wait for this opportunity to testify. And I very much am interested in reading your testimony to learn more about your recommendation for the school resource counselor. And I did just also want to mention the SROs, because I understand that SROs are seen very differently by different communities, and some school districts have them, some do not. And so in the meantime, while there are SROs that are present, the intention is that since they are in the schools and are interacting with students, that to allow them to have a level of training at this point around what can be a behavioral and mental health issue, as opposed to someone acting out or not understanding why they're acting out, or understanding there may be trauma. Allowing the opportunity to have some information and education is what this is trying to address at this present point in time, because there, some school districts will continue to have SROs, and looking at it in that lens, do you think there are any opportunities for school districts that will continue to have SROs in a traditional model? Would you think that there are opportunities to provide a level of training that may help them to help the students? Because I would never support a school to prison pipeline, but I would like to figure out a way that we could, if we're going to have them, to be able to partner in a way that would be beneficial for everyone involved.
I think the assumption that we're going to have them is also challenging. I do not think that we need police in education settings, and I do not think that it is the role of this, of the legislature or of our schools to train them on how to manage mental health issues. I believe that it is the role of the police department to train them on how to handle mental health issues outside of schools. So I do think that, and I also don't think that this bill makes clear that any attempt to train school resource officers is temporary. And I think that involving them and not involving, for instance, counselors or other folks or parents or community-based organizations as part of this training is a mistake. I think any effort to have folks who are armed and whose tools are punitive, like arrest, and calling that an effort of wellness is ill-informed.
And I do want to add that the counselors having the parent piece, we've certainly heard that today. This legislation is still a work in progress, and those voices are very important to be included. Thank you so much for your input.
Thank you.
Thank you, Representative Exum. Thank you, Ms. Martinez. At this point, I'm going to turn it over to Senator Anwar. Thank you.
Thank you, Representative Gilchrist, for your organized approach. Now we are in our 10.5 hour almost in the public hearing, and we are not even halfway done yet. So we will try to make sure that the speakers keep their conversation at 3 minutes, and the questions, if we can limit them. We just want to make sure people don't drop off because of the timeline. With that, I'm going to ask Ms. Lisa Tepper Bates to come and speak. Lisa. Hi.
Hi, Senator Anwar. Thank you so much. And good evening, distinguished members of the Public Health and Children's Committees. Thank you for the opportunity to testify this evening. My name is Lisa Tepper Bates, and I am President and CEO of United Way of Connecticut 211. I'm here to speak before you in favor of 3 items, starting with HB 5001's proposed measure to increase funding for Youth Emergency Mobile Psychiatric Service, or EMPS. 211 Connecticut's Crisis Contact Team provides support over the phone 24/7, 365 for children experiencing a mental health crisis. When needed, 211 can dispatch EMPS to respond. In 2021, 211 handled nearly 14,000 youth crisis calls and referred 93% to mobile crisis. These teams make available, where and when needed, the right people with the right skill sets to de-escalate conflict, address a mental health crisis, get the young person to the right support quickly. When this service is not available, our team's only recourse would be to call 911. We all know, and our partners in law enforcement agree, that 911 is seldom the resource needed in these situations. EMPS is. The governor's proposal of $26.4 million to expand EMPS will ensure that these services are available 24 hours a day, every day. We are pleased to see this expansion reflected in HB 5001, and we thank you for the bipartisan support for that bill. I also want to express support for the bill's intention to help direct callers facing a mental health crisis to appropriate resources for help, including the 211 Crisis Contact Center, rather than to 911. We are concerned, however, that there is too much risk involved in asking 911 dispatchers to make snap decisions on when a mental health call is safe to transfer to a different service, rather than following their existing protocols. We would never want to see a person in urgent need who has called 911 experience being transferred to a different service, only to find that the situation does indeed require 911. Precious time can be lost, and a caller may become more upset and frustrated. We believe the better approach is to provide robust public education to broaden awareness of the 24/7 phone-based mental health crisis support, in tandem with an effort to develop a better public understanding of when it is appropriate and necessary to call 911. Finally, I want to express our support for the aims of SB2 to increase funding to the Office of Early Childhood and Care for Kids. Childcare providers remained open and served working families, many of whom were working to save lives threatened by COVID throughout the pandemic. The childcare industry has faced workforce shortages due to low pay for childcare workers, low enrollments, and health and safety closures and costs. Many childcare providers are on the brink of closure now. These are critically needed investments in our children and families, and particularly important at this time as we seek to draw everyone able to work, including parents of young children, into the labor force to fill gaps. Thank you for your time and attention. I would be happy to answer any questions.
Thank you so much, Ms. Bates, for your testimony, and thank you for the work that you and your entire department does. It's such a life-saving and important work that is such a blessing. So I do not see any questions, so we will move on to our next speaker. Thank you for your time today. And the next person on our list is Stanley Guinell. That's Mr. Guinell. There you are. Good. And you can turn your camera on too if you choose to. You're unmuted. You can start speaking, Mr. Guinell. Can you hear us? Well, while you're trying to figure out, we'll move on to the next person, and then we can see if you're able to fix the sound and the video. The next person on our list is Sarana Carter. Mr. Guinell, is the light turned on? Yes, are you? No, the light turned off. Okay, what we'll do is we'll have Sarana Carter is the next person on our list. All right, I'm not having good luck today. Well, we'll move on to the next person on the list. Can I have Damian Grasso speak, please? Mr. Grasso.
Good evening. I want to thank all of you who have facilitated this critical effort. I'm a licensed clinical psychologist and associate professor in psychiatry and pediatrics at UConn Health. In this capacity, I submit testimony in strong support of House Bill 5001 and SB2. There's no better time to focus state efforts on enhancing resources and evidence-based services to improve mental health among our youth and families. National rates of youth depression and suicidality have been steadily rising over the past decades, and evidence suggests the pandemic has only exacerbated this trend, influenced by the many challenges imposed on our families, including increased family conflict and violence, and fewer opportunities for help, especially given the high burden on our advocates and providers. Across the board, we and our colleagues have noted a significant increase in families seeking mental health services and with limited resources to meet this need. Collectively, we have reached a tipping point at which additional funding and staffing are essential. I'd like to take this time to emphasize that we in the Department of Psychiatry at UConn Health hope to be an active part of this coordinated effort and intend to leverage our clinical and scientific resources and engage our faculty in contributing their expertise in developing effective solutions. I'll mention some aspects of this work that we are well positioned to address. Section 25 specifies tasking a trauma coordinator with developing a system-wide trauma-informed care training program for educators and child-serving professionals across the state. Given increased risk for loss, violence exposure, and trauma among youth and families over the past couple of years, we emphasize the importance of this. UConn Health has several nationally and internationally recognized trauma experts on faculty, which include treatment developers and facilitators of trauma-informed training. Thus, we are well equipped to contribute to this effort. Section 19 specifies that each grant recipient develop metrics to measure program success. We underscore the importance of this, however, draw attention to a lack of training and utilization of measurement-based care among providers. We believe this will require a centralized system integrating expertise across the state to provide site-specific training and support to providers, as well as statewide evaluation. And here too, UConn Health has several faculty with expertise in evidence-based assessment, and we are prepared to assist with this goal if requested, as well as to assist in procuring validated mental health screening tools for use at well child visits and in the context of other systems. Lastly, pertinent to this work, several of our faculty have studied the impact of the pandemic on families and child mental health, and have conceived of a plan to develop a comprehensive child and family resource center to serve local needs and perhaps as a model for similar centers across the state. With necessary funding, such a center would be staffed with clinicians who treat children with complex emotional and behavioral problems, as well as family navigators who support parents and connect families to evidence-based mental health resources. And we see this concept as a great need. In closing, we look forward to being a part of this critical and timely effort and intend to mobilize our academic resources and expertise in assisting with this important work. Thank you for your time and consideration of this position.
Thank you so much for your testimony, Mr. Grasso. We have a question from Dr. Foster. Representative Foster, please go ahead.
Thank you so much, Mr. Chair. I'll be quick because I know we're trying to get through as many speakers as we can swiftly, but I'm really grateful for your feedback. You've raised a concern that I've heard many times in public health hearings from experts at UConn, and that is that a lot of times our state agencies are really good at reporting outputs, but outcome measurement is not the state's strength and forte. I think that this is probably a little more than we need to get into this evening, but I'd be really interested to hearing your feedback on how we could be more robust in an academic public collaboration that would allow us to take robust output measures and share those collaboratively with people who are willing to do the analysis, who it might be helpful in their career trajectories to also have access to that information and that data. So I'd love to, to connect offline, but you've raised a really good point that I sort of would love to flag to my peers, that we can always say we had a number of people who participated in the program. We provided an X number of service hours. We worked with X number of clinicians, but matriculating people through services doesn't tell you how much we lowered suicide risk by. So the actual implications of this policy, I think, are going to be wonderful and robust, but I want to see us really measure the outcomes. And so I think that that's going to take doing the kind of work that Dr. Grasso is sharing here. So I'd love to hear suggestions on how that would be. I know that UConn's psych department has given suggestions as well. So thank you so much for testifying today. I think you're raising an excellent point.
I appreciate it. I mean, that's certainly, those are skills that we have and we're willing to use to help. And honestly, I think, sometimes we're underutilized in these state efforts, and I definitely want to bring us to the table to support this cause. So thanks.
Thank you so much. Thank you for your testimony. Seeing no other questions, we'll move on to the next. Next person is Gwynell Stanley. Sorry, your name was written the other way around. That's why I read it early. So Gwynell Stanley, go ahead.
Yes, thank you. Members, good evening, members of the Public Health and Children's Committee. Thank you for this opportunity to testify on SB. My name is Gwynell Stanley and I live in Hamden. My children are Aiden and Jasir, and they attend Harrison Tucker School, founded in 1970. And we are a member of Circle, which is a network of over 40 child care providers serving children and families of color. The pandemic has taken a huge toll on the mental health of all of us. And for my children who've lived most of their lives throughout this pandemic, it's clearly had an impact. The impact was greatly reduced for my family, fortunately, because I had access to Harrison Tucker School. I've been incredibly lucky, but this hasn't been the case for all families. And the cost of childcare to attend a high quality program is incredibly expensive. That's why I'm glad that SB 2 calls for additional funding for programs through the Office of Early Childhood. I call upon the members of this committee to increase funding and to expand the eligibility of Care for Kids programs to ensure that families like myself can continue to access high quality early childhood care, like from agencies such as Harrison Tucker. We need to build systems of support for families, especially after the pandemic. This year, we need $700 million down payment on what should eventually be a $2.5 billion system. And that would enable parents to find quality, affordable childcare in the setting of their choice. So promoting nutrition, mental health, and physical health for our children that should allow access to social and physical environments of quality is what I'm advocating for. Thank you for your time and your consideration.
Thank you so much for your testimony, and seeing no questions, we'll move on to the next person. Thank you again for being here today. Next person is Dr. Javid Zakeri. Dr. Zakeri.
Good evening. My name is Dr. Javid Zakeri. I'm the chair of psychiatry at the Institute of Living, the chief of psychiatry at Hartford Hospital, and I thank you for the opportunity to testify in support of HB 5001. Although I am new to Connecticut, I've been a practicing child psychiatrist and researcher for over a decade in both the United States and Canada. I've spent my entire career bearing witness to a system that was never built to support the complex mental health needs of children and youth. To effectively address the challenge before us, we must look in the mirror at the systems that we are a part of. We must acknowledge that we are part of the problem, but we also have a role in co-designing a solution. Today, I want to express my gratitude to you all. Between the governor's budget and the legislature, Connecticut is shining a light on the problem and wants to invest in the solution. A few weeks ago, I had the pleasure to meet with Representative Linehan and discuss possible solutions. I shared with her that I am inspired to work with young people, and I truly believe that the solutions to our current state require us to step aside and make space for young people and their caregivers to take the lead in co-designing the system we need. We at the IOL are celebrating our 200th anniversary. We were founded on the principle of moral treatment, which is a more humane approach to mental health care that centers the dignity and humanity of those we serve. We have successfully recruited and retained one of the largest complement of child and adolescent psychiatrists in the state. It is us at the IOL and Hartford Healthcare that supply child psychiatrists to the Connecticut Children's Medical Center. We are ready to partner with the state, young people, and caregivers to think outside the box. As I read the bill, I was very excited about the inclusion of caregiver peer support grants. This is an innovative initiative that allows Connecticut to be an exemplar in the country. Throughout my career, I've led participatory research with youth that demonstrates that they have real-time needs that needs real-time care. Our antiquated models need a radical rethink. There are a few key areas of the bill that I truly appreciate. First, the provision of non-crisis after-hours services that meet young people where they are at. Such services should include drop-ins in evenings and weekends wherever possible. Whenever a young person builds the courage to ask for help, we should be ready and willing to honor their courage. Second, our workforce challenges require all of us to think outside our silos and embrace collaborative models of service. Expanding access to education consultation for primary care providers to the collaborative care model is a step in the right direction. Overall, I applaud the influx of funding, but I have one important caveat. Grants and pilot projects are fantastic, but we cannot forget the need for sustained operational investment over a long period of time. We have witnessed the human consequences of payment inequities, and this is a cost we can no longer bear. Simply put, it cannot be acceptable to disincentivize organizations or professionals from providing evidence-based mental health care for children and youth. Again, thank you for the opportunity to speak, and I'd be happy to answer any questions.
Thank you so much, Dr. Zakeri, for the work that you do and your testimony. It's very helpful. Any issues, any concerns that you have in the bill at this point that you feel could improve? We can probably talk offline as well, but if you have a short answer to that.
I will cede my time to the other speakers who are waiting patiently and be happy to speak at any time with any of you behind the scenes. Thank you so much for everything you do.
Thank you so much for your testimony. The next person is Judith Kobilars-Dillard. I hope I got your name correctly.
Yes, thank you so much. Thank you to the committee, the co-chairs, and the members for this space and your time and consideration for SB 2 and HB 5001. My name is Judy Kobilars-Dillard, and I want to begin by letting you know I've struggled greatly since 9 o'clock this morning, trying to listen and not be able to react with a personal lived experience response to a lot of the things that have been spoken legislatively and by representatives. But I'm also ironically feeling quite validated with the ability to respond with my professional perspective at this point so late in the day, because that's really where I'm coming from. I want to be able to make sure you're aware that this experience and what we're dealing with is we're applying policies and procedures to people and problems. And that is the biggest issue with our system. We're talking about supply and demand, gaps, funding contracts, etc., the numbers, the quantitative and things that need to be seen. But I'm living in the gaps with the qualitative, with the people and problems. And I want to make sure that it becomes transparently aware that language that would prevent each district, each town, each municipality to effectively address their own issues is going to create more gaps. And specifically, that there is no universal communication between the system providers and the siloed entities that would be fighting for this grant money. And the state mandates and the competition for grants just further pushes divisiveness in the communities and not collaboration of services, which is what service care was supposed to be, our wraparound services, our DCF initiatives. We're asking about those beds and all those things, and we're talking about putting people into services, not wrapping services around people. I'm a completely unfunded organization, the sole employee, because as a community health worker, I can't bill out for services. But I have moms calling me from the ED because 211 told them their child needed a higher level of care, and the ED crisis worker told them they're stable enough to go home, even though she is so scared that he's going to tear apart her home and cause a domestic. I show up to IEPs and I'm able to explain to parents that their other co-occurring issues are something they shouldn't be ashamed and stigmatized with. As a peer support person with lived experience, I'm being told by the system that I am not valuable, as a woman with children that DCF gave me because of the system dysfunction before. I'm their third mother. And yet I had to triage our own mental health family services, and my postpartum depression has gone unclinically treated because the children that DCF gave me needed more wraparound services than I needed at that point.
Excuse me, Mrs. Kovalarz, your time is almost up. If you would please summarize. Thank you.
Thank you very much. I want to be in support for SB2 and HB 5001, but make sure that we are actually dealing with people on the ground floor. And equity means what they really need, not what we think they need is going to work. Thank you.
Thank you so much for your testimony. You work at, you're a community health worker?
Yeah, badge 143.
Okay, and I can tell you that SB2 is going to have information about community health workers, and this committee was the one a few years ago was able to put the community health workers going forward. Now the time has come for strengthening the community health workers' capacity and have a mechanism to get paid for it too, because we recognize your value. And we recognize more so in the behavioral health arena as well that there is an opportunity to address that. So we are hoping through, at least in the SB2 component, we will be able to look in how we can unleash your capacity for the communities that truly need the help. So your testimony is very, very helpful to me, and I know my colleagues. So send me an email so we can connect with you more in detail so that we have an opportunity to talk to you in more depth, and would love to read your testimony as well. And I know Representative Wielander has a question for you. Representative Wielander.
Thank you, Mr. Chair. Thank you for speaking this evening. I wanted just to touch upon something you mentioned, because it's a concern that I've had across multiple arenas, is that oftentimes, especially when we're talking about grant programs, the towns or the organizations that are able to already afford someone on staff to write their grants, who have had write the applications, to do the research, they're more likely to be awarded those grants because they've had that experience and they have the ability to focus that time and energy on it, which leaves a bigger gap between the haves and the have-nots. So do you, in your professional opinion and experience, would you think that having someone on the state level who is able to assist in the grant applications and the research process be helpful to the organizations and the people who do fall within the gaps?
On the which level? I'm sorry.
Would having someone on a state level who is able to assist in the research or the application process for these grants be helpful in getting these grants awarded to people who are currently falling within these gaps that you spoke of?
It would be phenomenal to have that, pro bono work, because applying for those systems and legal supports is hard to do. And, with grassroots, but grassroots is where the people trust when you have the relatable experience and you're not a big entity that does afford grant writers. I also feel that creating a mandate of service provider alliances and funding community collaboratives would also address that, where you had to share grant writers.
That's great. Thank you very much for that feedback. I appreciate it. And thank you for your time tonight.
Thank you.
Thank you so much for your testimony. Seeing no other questions, we'll move on to our next person on our list, which is Latoya Brown-Clayton, and followed by Alexia Cousins. So Latoya Brown-Clayton. Hi, Ms. Brown-Clayton. How are you?
Hello, how are you?
Good.
Thank you for having me here, distinguished members of the public health. My name is Latoya Brown-Clayton. I am the owner of Connecting the Pieces, family childcare program, serving children from ages infant all the way to 10 years old. I'm from Hartford. I am submitting my testimony regarding SB2, an act explaining preschool mental health and behavior services for children. I urge the committee to include funding for SB2 to stabilize Connecticut early child care and education sector. Child care providers, including family child care educators like myself, are doing vital work to support growth and emotional well-being for young children every day. Without additional funding for children are in danger of losing their services. I started my program 7 years ago. Currently offer care to children from 1 to 9 in my program currently. 4 of my families have school-aged children who have been with me since infant and toddlers. I live in underserved neighborhood. Families come from all over the region through word of mouth. They know I'm good with children who need support with social and emotional development. As a daycare provider, you wear about 30 different hats. Our job goes beyond that of classroom teachers. We offer safe, high-quality learning environment that nurtures children's mind. And we are constantly watching what's happening with children's behaviors and making sure they are hitting all development milestones. Sometimes children need a hug. They want to be embraced. They look at you for reassurance that they are in a safe space. It's being calmness. It brings calmness to children when they know they have an adult in their lives to give them full attention. Nutrition also plays a part in children's mental health, which is why my daycare serves whole foods, lots of fruits and vegetables, get desserts. They have never had access to whole foods. We work super hard with the children's mental, physical, and emotional growth. As an educator, my job is more than making sure kids are safe. I try to make sure kids are stable, confident going into kindergarten, even if sometimes I have an excess of confidence. This is why I am also an advocate for children outside of my program.
Excuse me, Ms. Brown Clayton, if you could just
I had
summarize.
a child.
Thank you.
Okay. Research shows that happy students learn better. My 4-year-old twins come running up to me, even though they haven't seen me in 12 hours. We want to be one of the best childcare providers in the state. We already face stigma because of where we're located, and in most costs for hire staff so we can be fully present for children. It costs money to outfit spaces and accreditation. Most of my families earn less than $15 an hour and cannot afford childcare that costs over $200 a week. I can change them. I can't charge them anymore. So that being said, to invest $700 million in immediate relief fund for support in early childhood and education sector, provided more relief for families. Thank you. My name is Antonia.
Thank you so much, Ms. Brown Clayton, for your testimony and sharing your lived experience and your words. This SB2 is going to be focused on helping you and others in our state who are providing childcare and childcare centers. So thank you for your testimony. And we will move on to our next person on our list, which is Alexia Cousins, and followed by Naria Velasquez. So Alexia Cousins.
Good evening, members of the Public Health and Children's Committee. My name is Alexia Cousins. I'm a Hartford resident and a UConn Master of Social Work student. I'm also a community organizing intern at Connecticut Citizen Action Group located in Hartford. I also work at a nonprofit organization working with folks who have mental health disorders, such as substance use disorder, major depressive disorder, anxiety, amongst others. I'm here to testify in support of HB 5001 and Act Concerning Children's Mental Health, aim to improve the availability and the delivery of mental health, behavioral health, and substance use disorder treatment for children. I've had numerous social work experience, including being a school social work intern in an urban school district in Connecticut. In this role, it was my job to advocate for the social emotional well-being of students. I would collaborate with teachers and other staff members to create goals for students based on regular weekly meetings and would help suggest approaches to how teachers could adjust their classroom setting to meet the needs of students with learning disabilities, anxiety, ADHD, etc. In this position, I would also teach skills to students such as self-advocacy skills, setting appropriate boundaries, tactics of how to cope with depression or anxiety, conflict resolution, relationship building. There are many students who struggle with how to actively use skills that would cater to their mental health. Based on experience and research, students are much more likely to be academically successful, increasing their chances of being productive members of society when their social, emotional, and health needs are met. Children being able to access mental health services both in schools and within their own communities can significantly promote their overall well-being. By hiring mental health professionals who are culturally competent and can understand cultural differences, children who come from various family dynamics can have their concerns heard as well as understood, thus serving a larger community of people in the state of Connecticut. Also hiring more Black and Brown mental health professionals, especially in schools where students are predominantly Black or Brown, as this could facilitate meaningful relationships among staff and students, and is also important to show appropriate representation. We are aware of the effects of the pandemic and its implications in relation to mental health, leaving it difficult for children and their families to cope with the loss of loved ones, economic instability, trauma associated with COVID-19, and adjusting to a new normal as a result of lives being disrupted due to the pandemic. In statewide meetings facilitated by my internship at Connecticut Citizen Action Group, participants clearly communicated that social, emotional, and overall mental health is a priority in mental schools, and that more mental health professionals should be employed by schools. This would allow school social workers, school psychologists, and counselors to create and continue to build relationships with students, and would allow for more one-on-one time or small group sessions with students by achieving smaller ratios. By prioritizing mental health amongst children, this will have lifelong positive effects and will create opportunities for children to learn how to manage their mental health throughout their lives. Thank you all for your time and consideration.
Thank you so much for your testimony. Very inspiring. So amazing stuff you're doing. You're what we need as a solution going forward. So thank you for your testimony. And thank you for waiting all day today. So seeing no questions, we are going to move on to the next person. Good luck, Alexia. Looking forward to seeing you over here as an elected official at some point. Next person is Naria Velasquez, followed by Javid Stevens.
Good evening, members of Public Health and Children's Committee. Thank you for this opportunity to testify SB2. My name is Naria Velasquez, and I own Bright Minds Learning Center, a childcare center in Stamford, Connecticut. As childcare providers, our mission and passions are to create high-quality teaching environments for the children and families we serve in our communities. The childcare industry is crumbling as we speak due to the underfunding that we've experienced for so many years. With $700 million, we would be able to attract high-quality educators and retain the vast knowledge and experience of our existing workforce. Right now, childcare educators are some of the lowest paid wages in our country. Owners are unable to match the competitive wages of retail stores or fast food restaurants. I am asking to please value all of us in this industry by helping us to build up the systems that recognize early childhood educators as the skilled professionals that we are. We want to continue to create environments for our young children that promote good mental and physical health. Thank you all.
Thank you so much, Naria, Ms. Velasquez, for your very focused testimony. I do not see any questions, but thank you for the work you're doing, and then thank you for your testimony. We're going to move to Javid Stevens, followed by Susie Craig. Ms. Stevens.
Good evening, everyone. Members of the Public Health and Children's Committee, thank you for this opportunity to testify on behalf of SB2. My name is Javid Stevens, and I live in Stamford, Connecticut. I have been a child care provider since 2004, starting as a home daycare provider, now as a center owner. I have 4 centers located in the city of Stamford. The licensed capacity is approximately 118 over the 4 facilities. We service children from 6 weeks to 5 years of age. As an early child care provider, my entire work around center is creating an environment and also provides the need to build child's brain. Sadly, I get paid less than someone who works at a fast food restaurant or a retail store. We will not address nor improve mental health outcomes for children if we do not make the necessary investment in the settling where the children spend their informative years. I have teachers who are furthering their education to be specialists in early childhood education. They have the passion for the work and they want to do the work. I have lost several teachers because of the pay. I cannot compete with retail stores such as Walmart, Target, or different stores in the mall that are offering $17+ an hour plus benefits. These teachers cannot afford to work in the child care field anymore. They cannot make a livable wage to care for their own families. These teachers are teaching and preparing our future, and they deserve to be paid a livable wage. 95% of the children enrolled in my programs receive Care for Kids. Even with that, the parents are still not able to afford the weekly parent fee. Each week we take discounts on what the families owe us. And in turn, we are unable to keep the teachers or open classrooms that we have space for because we can't afford to hire a teacher to work the class. We need you all to see and understand that early childhood educators are important, just as your elementary school teachers. These early educators build the foundation that your elementary school teachers build on. We need you to build up the system of support that recognizes early childhood educators as skilled professionals that they are. Parents for children under the age of 5, they need high quality and affordable childcare. They need to be able to choose the setting that they put their children in. We need you to take the time to really consider the bill to pay the $7 million down payment for our children. This is our future. I thank you, and I thank you for your time and your consideration. Thank you so much.
Thank you so much, Ms. Stevens, for your testimony. I appreciate the work that you're doing, and we're very appreciative for your testimony. Seeing no questions, we're going to move to the next person, who is Ms. Susie Craig, followed by Yvette Young. Ms. Craig.
Thank you, Senator. Great to see so many faces from Public Health and Children's Committees. Thank you so much for your perseverance today. I have been able to listen to most of the other testimonies, which has been really enlightening. I really appreciate your questions and your thoughtfulness and your listening. And I also appreciate where this is headed, because I think it's been recognized today that there are some hot spots and critical areas that need to be addressed today, and that in parallel, we need to work to set up a vision for behavioral health moving forward. So Mental Health Connecticut is a community-based, peer-centered, recovery-oriented, and evidence-based, data-driven organization. We work across the state. And just so you know, we are 18 and up, so we don't service any children, but there's some very specific reasons why I wanted to testify today. But I did want to say some of the things that I heard today that I've been extremely encouraged about that I want you to know that mental health can really get behind are things like reimbursement for collaborative care, investments, truly a deep investment in infrastructure, really looking at where oppression, racism, health inequity intersects with mental health. Community health workers, social and emotional learning, peer support, parity, all of those things that are the future of healthcare are things that Mental Health Connecticut can be a resource for you, and want to make sure that we're continuing that conversation. I wanted to note a couple of things that I have not heard, specifically around young adults. And I would say that Mental Health Connecticut would like to see the name, whatever this bill gets named, to be children's and young adults. There is a gap that we need to address when it comes to young adults and think about, I know many of you have teenagers, I have 3 in my house. Young adults fall into, especially ones that are being receiving services when they come out of DCF. Technically they are adults, right? But they're moving from a system where they had, let's say, for lack of a better term, obligated care, right? So everything was really on a high level of support. And then when they turn 18, they move into a system where there is no structure and everything is voluntary. So you're going from obligated guardianship where soup to nuts, everything is taken care of. And then at 18, they find themselves with a lot of freedom and possibly very little skills. And they tend to fall into some serious gaps. Also, I wanted someone to help me confirm, and maybe we have to go back to DCF on this, but I believe that DCF can keep some young adults in some programs like educational and vocational, but that doesn't allow them to receive other services at the adult level because it's considered double dipping. So this is a problem. We need to really look at the young adults that are really getting slipped through the cracks. And, when it comes to statistics, that's the age when, it is most critical, and obviously for kids as well. It's not a competition.
Excuse me, Ms. Craig, your time is up. You'll have to.
All right, thank you. So I can provide a lot of statistics and a lot of information around, areas to that we can shore up and make sure that we're not losing young adults in the system.
Thank you so much. Thank you so much for your testimony. And I do not see any questions or comments, and we'll follow up with you. Thank you so much for your time today.
Thank you much, Senator. Thank you. Take care.
Thank you. And next person is Yvette Young. Please.
Yeah, I'm here. Hello. Good evening, distinguished chairs and members of the Public Health and Children's Committee. My name is Yvette Young, and I work for the Village for Families and Children. The Village's impact can be found in the 9,615 children who we help to overcome enormous challenges to achieve real and meaningful change in their lives, with help from the treatment services and advocacy of the Village in fiscal year 21. It is these lives and the countless others we have yet to serve that compels me to support House Bill 5001. I'm a licensed professional counselor, and over my 20-year career, I have worked with victims of crime, children, and adults with mental health diagnosis. I have witnessed the acuity level of those we treat increase and the need for services at all points in our continuum of care increase. The mental health needs of our children have been significant for decades. But the COVID added gasoline to an already blazing fire. We can see the manifestation of this crisis in the behaviors of our children and the gridlock in our continuum of care. Pain that is not transformed is transmitted. When children do not receive the necessary support they need to heal from the trauma they have experienced, learn skills to manage their anxiety and depression, appropriately grieve the loss of loved ones, they are not able to transform their pain into healing. If their pain is not transformed, then it will be transmitted, and the transmission of their pain manifests in a multitude of behaviors. We see their pain manifest in car thefts, physical aggression, gun violence, substance abuse, self-harm, suicidality, bullying, and verbal aggression. The unmet mental health needs of our children result in increased vulnerability. This vulnerability leads to further victimization. Often these youth are solicited by predators to be exploited and trafficked or recruited into a life of crime. Through my work at the Village, I have seen children get stuck in residential settings for months past their discharge dates due to a delay in access to services for in-home, outpatient, or intermediate level of care. We have children who are waiting for a foster home as they have no kinship resources and a home is not available. The option to step them down to a lower level of residential care is difficult, as many of our group homes and SFIT respite facilities are closed or closing. The increase in children on discharge delay means the system is not flowing, and children who need to move through the various levels of care gets trapped in the system, further intensifying their mental health symptoms. The strategies outlined in House Bill 5001 will be essential in reducing the wait list at all levels of our system of care. They will also remove insurance barriers and assist in developing our workforce. House Bill 5001 is the beginning of this conversation, but should not be the end. This is a complex issue that will require continuous oversight and resources. What is evident is that it is time we invest more in our children. If we do not, we will continue to lose them to suicide and drug overdose. Our children must not be collateral damage. I appeal to you to support House Bill 5001 so we can begin to heal the pain our children are experiencing. Thank you, and I'll answer any questions if there's any.
Ms. Young, thank you so much for your heartfelt testimony, and thank you for sharing that with us. The next person on the list, I think, is Dr. Tashiana Arma, Dr. Arma, and
yes,
followed by, well, go ahead.
No, go ahead.
Followed by Ms. Forrester. Ms. Foster, so Forrester, sorry.
Well, thank you. Thank you so much. You can hear me okay? Okay. Thank you, distinguished members of the Public Health and Children's Committees, for the opportunity to speak tonight. I'm Dr. Tashiana Arma, Chief Psychiatry Officer at the Community Health Center Incorporated, where we provided mental health care services for over 8,000 children last year alone at 16 outpatient sites and nearly 200 school-based health centers across Connecticut. We train mental health providers through our formal residency programs and as clinical placements for trainees of local universities. I have submitted written testimony in support of HB 5001, but want to summarize some feedback highlighting just 3 key areas of this really important bill. Number 1, school-based mental health care clinics. 2, telehealth and payment reform for integrated care delivery. And 3, workforce development and training of integrated health. When parents in the community ask me how to get mental health care services for their children, I reply with 2 questions. And the first is, what school are they in? Because if we have a school-based health center where they have access to one of the fastest routes to mental health care. That's why Section 53 of the bill is so vital. Section 10, honestly, having to voice telehealth extensions to patients and families just builds anxiety in my clients. Let's declare telehealth audio only and video permanent and at rates in parity with in-person. In Section 65, I'm concerned that conducting a study of parity really doesn't go far enough. There's already evidence that there is not parity between mental health and medical care. But if a study is required, I hope that this bill could include a deadline for reporting on the study's results and recommendations. But there's really no study needed to conclude that prior authorizations specifically for mental health care are unnecessary. And if they went away with this bill, one obstacle to care would already be eliminated. The second question that I ask parents when they're looking for care for their children is have you talked to your pediatrician? And the tremendous quantity of care that we give already as mental health providers is dwarfed by the forced multiplier effect that results when we provide consultations and education to our medical colleagues. However, no one is getting reimbursed. So that's why Section 56 and 57 are critical. I only ask that you look at the current language to consider broadening it. Section 5 on workforce development and training, we hear the need from our patients daily for the need for a more diverse workforce. And I would just point out in Section 72, it's not only hospitals and medical residents that medical residents and child fellows train in. Given that the majority end up going into outpatient, perhaps considering incentivizing universities to partner with integrated care agencies to provide integrated training experiences to residents and fellows. You know, not everyone is going to make the costly investment to train residents and fellows without any financial support. We do. I'm happy to talk more about it. And I want to close by stressing the need to increase mental health care access in a way that will reach more children by treating them where they are before they get to crisis, in their schools, their pediatrician and family practice offices, their homes, by video and phone, and support training mental health care providers on how to do that in all of the settings that I've mentioned, so that we don't end up talking about children's mental health crisis 10 years from now. We had a beautiful instance that illustrates everything that I've talked about here. I didn't put it into my written testimony. I'm happy to share with you anytime. I want to thank you. I am done for very much for your time and the effort that you put into this bill to really tackle mental health for children. I didn't know it could be exciting reading a 100-page and 3-page bill, but there you have it. It certainly was. Thank you very much, and I'd entertain any questions.
Thank you so much, Dr. Arma, and thank you for the work that you do. And you have a written testimony as well for the specifics that you have suggested, right?
I didn't put each section into it, but I did. It's largely the same content, but not with those specifics about each and every section. Okay.
Well, reach out to us in more specific terms if you that would really help us out, because you've invested so much time and you live in that space. And we truly appreciate the fact that you like the bill, because it's a labor of love for many of the colleagues who are here for the past many hours. Thank you again for your time and your testimony.
Thank you so much.
Next, we have Ms. Alice Forrester. Ms. Forrester, please go ahead. And after that, we will have Geraldine Fleming. Go ahead.
Hi, good evening, all of you. Thank you so much for the patience and attention that you've been paying to the speakers all day today. My written testimony actually reviews each of the areas of the bill, HR 5001 and SB 2, but I wanted to focus my testimony today, if I could, on one of our largest crises, which is in workforce. I am a PhD in clinical psychology, as well as the CEO of Clifford Beers, which has offices in the New Haven, Greater New Haven, and Norwalk region. Our workforce is in crisis, as you have identified in the bill, but I want to review a couple of the recommendations we strongly stand behind. One is to provide financial incentive programs or funding to providers to support recruitment, retention efforts. One is to recognize non-wage compensation, that is the sign-on bonuses, retention, tuition reimbursement, loan assistance, as allowable expenditures under the COLA increases. And I hope we do get the COLA increases. Two is develop a state loan forgiveness and repayment program. I know that that's suggested in the Chelsea section of the bill. But if you look at other states, there's some really broader reimbursements that would agree or have clinicians working in a child setting for a couple of years. Washington State and some other states have some great examples. And in my testimony, I put some links to what they have there. I think having tuition reimbursement linked to years worked in a program would be very helpful. Increased paid internship opportunities for social workers and other counseling professionals, especially the BIPOC community. One of the issues that was brought up earlier around social work is the number of social workers who are licensed, but the reality is only about 15% of them are identified as African American descent and 6% Latino. And so in all mental health workers, those are numbers that we need to really move up. And I do have data to back that from the Department of Public Health. The other area that I think would be helpful in optimizing available behavioral health workforce would be expedite the processing of licensing exams and determinations. And I know that DPH has been trying to do that, and you have some indication of that in this bill. I think that it's very important for us to review the licensing examination data and look at failure rates and conduct a disparity analysis and make sure.
Excuse me, Mrs. Forrester, your time is almost up. If you could summarize, please. Thank you.
I think that supporting the paraprofessional, non-traditional peer support specialist is very important, and the provisional license for the year until folks take their license. There are many, many, many beautiful things written into this bill that I think I strongly support, and many of you heard me testify before, but I think focusing on our workforce is something very important. So thank you for your time and all of your energy on this very important issue. I'll take any questions if you have any.
Thank you so much for your testimony, and thank you for being a guide in the early phases of the birth of these bills. So that was very critical. I appreciate your wisdom and time at that time.
Thank you.
Seeing no comments or questions, we'll move on to the next person. Thank you, Dr. Forrester. Next is Geraldine Fleming, followed by Maris Pelkey. Ms. Fleming.
Good evening, Chairman Anwar, Chairwoman Linehan, Chairwoman Darty Abrams, Chairman Steinberg, Senator Kelly, Representative Dauphiné, Senator Somers, Senator Wang, Representative Pettit, and members of the committee. Thank you for allowing me this opportunity to testify. My name is Jerry Fleming, and I am a member of SEEK's Legislative Committee here to support a provision of HB 5001 with the following caveat. While I am heartened to read that this bill includes a trauma coordinator within the Department of Education, I remain very concerned that the qualifications of such a person are not enumerated, especially in light of the recent issues with the Department of Ed's search for a dyslexia coordinator, with no concomitant requirement for expertise in research-based reading interventions. In our state, where 60% of students read below grade level, such expertise matters. I am concerned about the development of a system-wide training program by a coordinator hired by the DOE who may or may not have any expertise in trauma-informed practices. Adopting trauma-informed practices in the schools marks a culture shift within a system that has been for too long overreactive in its response to trauma-induced behavior by students. All too often, situations are escalated to crises because behavior is viewed through a lens that is not trauma-informed. A change like this does not happen overnight, nor does it occur because one is required to attend a professional development workshop. In order for this program to be longitudinally sustained, there will need to be ongoing training and support by trauma-informed clinicians who educate, model, and monitor the practice with students, teachers, and staff. A system of data collection to measure the efficacy and fidelity of implementation will be vital. At least in the first year of implementation, there will need to be regularly scheduled sessions for staff by trauma-informed clinicians to provide feedback and assistance with questions or concerns. The students will need to be universally screened using an evidence-based screener to assess exposure to trauma so as to capture not just those who may be outwardly disruptive, but those who become withdrawn from their traumatic experiences. There will need to be a research-based program of intervention chosen and implemented in the school for the students identified through screening as in need of support. The intervention should initially be implemented by clinicians already trained and familiar with the program. This would be an opportunity for staff to observe the program at work prior to implementing it themselves. For these reasons, I am in favor of procuring the system-wide trauma-informed care training program, which you mentioned in line 1279, whereby trained clinicians implement their research-based model of trauma-informed practice to students while simultaneously training staff in the same.
Excuse me, Ms. Fleming, your time is almost up. If you could summarize, thank you.
Okay, I think that the only way a train the trainer program can work is to have trained clinicians gradually release responsibility for the implementation of the same to them, but continue to oversee the staff.
Thank you. Thank you so much for your testimony, and thank you for your thoughtful comments. They're very valuable to us, and you have a written testimony as well, right?
Yes, I do.
Okay, so we will be incorporating some of these thoughts. I know that they're something that are critical, so we appreciate your insight. Thank you.
Thank you.
And seeing no other comments or questions, we'll move on to next person on our list, Maris Pelkey, followed by Maria Reyes. So Maris Pelkey.
Hi. Good evening, distinguished members of the Public Health Committee and the Committee on Children. My name is Maris Pelkey, and I am the Executive Director of Creative Interventions. Thank you for the opportunity to submit testimony regarding HB 5001 and SB 2. I am testifying today to express my strong support for the programs and services identified in both of these bills. Thank you to both committees for recognizing that families and children in Connecticut are in desperate need of these services after 2 years of the pandemic, which has had a significant negative effect on the behavioral and mental health of children. In addition to supporting the many agencies outlined in these bills, I respectfully request that the committees consider supporting the existing services that the Connecticut Birth to 3 program provides to families. Connecticut Birth to 3 programs work very closely with families to support a range of needs that both foster a young child's social, emotional, and behavioral health, as well as enhance the skills and resources of the adults in that child's life. Addressing these needs through early intervention is crucial. As research has demonstrated time and time again, the earlier we address developmental delays, including behavioral and mental health needs, the better the outcomes for children, families, and society as a whole. My agency, Creative Interventions, provides birth to 3 services to children with social, emotional, and behavioral health needs, including children with autism. Through our contract with the Office of Early Childhood, we currently serve over 500 families across 60 towns and cities. Through our program, we provide services including diagnostic assessments, developmental evaluations, and direct services delivered by licensed and certified professional staff, including behavioral and mental health professionals. Our highly trained providers focus on parent and guardian training, and we follow a coaching model to encourage caregiver implementation of strategies to support the developmental and behavioral needs of children enrolled in our program. Data from fiscal year 2022 has demonstrated that 38% of referrals to birth to 3 programs have documented a social emotional concern. We have addressed this number of social emotional referrals by acting as a resource to families throughout the pandemic, and we have supported families who are struggling with high levels of parental stress, which we know directly impacts child development. Birth to 3 programs have provided these services while being chronically underfunded and struggling with challenges across the workforce, such as increasing salary needs, staff burnout, difficulty with retention and attracting new clinicians, as well as the provision of required staff training and supervision that currently has no sustainable mechanism for reimbursement. All of these challenges result in a delay to much needed services for children and families. Creative Interventions asks that the Public Health Committee and the Committee on Children include support for birth to 3 in these bills by adding an increase to the general administrative payment for every enrolled child in birth to 3. We also ask that you consider including a loan forgiveness program for providers working in birth to 3. These items would help birth to 3 programs continue providing crucial services while meeting the rising social, emotional, and behavioral health needs of young children across the state. I thank the Public Health Committee and the Committee on Children for your time and consideration of this testimony, and I'm hopeful that you will be in support of these items. Thank you.
Thank you. Timed yourself perfectly. And this was very helpful. I think you're touching on something very important. I hear you. I'm sure all of my colleagues are hearing what you're suggesting. Very good points. I don't see any other comments or questions, so we will move on to our next person on our list, which is Maria Reyes, followed by Kaylin Lozier. So Maria Reyes.
Sí, en español, Hispanic. No problem.
How are you?
Okay. Senador Howard, representante Leijna, senador Abrams, representante Esteban y miembro del Comité de Niños y Comité de Salud Pública. Gracias por escucharnos. Mi nombre es María Reyes. Soy una proveedora licenciada de cuidado infantil en la ciudad de Wherever. He servido a mi comunidad por más de 15 años a través de mi pequeño negocio, que es mi daycare de cuidado infantil en casa. También tengo el honor de ser la vicepresidenta de la región noroeste del ECIU Local 201, donde represento a las proveedoras de cuidado infantil. Al principio del 2021, una madre llegó a mi daycare buscando cuidado para sus 2 hijos. Esta madre es soltera y no tiene familia que la apoyen aquí en Wherever. Yo me convertí en uno de sus mayores soportes. Pude ver cómo esa madre se esforzaba a diario para mantener a su familia. Era inevitable que su salud mental no se maltratara. Lamentablemente, yo no tenía todos los recursos en mano para poder ayudarla en todas las maneras posibles. Lo que sí podía hacer era seguir dándole mi apoyo y hacer lo posible para ofrecerle a sus hijos un cuidado y una educación de calidad. Esta no es la única madre que ha pasado por Miracle con necesidades económicas y de salud mental. Como ella, muchas y otras familias necesitan de nosotras la proveedora para poder seguir sosteniendo a sus familiares. Por esa razón, hoy le pido que apoyen el proyecto de la ley del Senado 2 y que apoyen a las educadoras de la educación de primera infancia. Y juntos somos más. Gracias por escuchar mis testimonios. Buenas noches.
Muchas gracias, María. Gracias por su testimonio esta noche.
Thank you very much.
All right, and we will move on to the next person, who is Kaylin Lozier and also Ken Welch. After that.
Good evening, members of the Children and Public Health Committees. My name is Kaylin Lozier. I'm a graduate student in the Social Work Department at Southern Connecticut State University. Today, I'm testifying before this committee to voice my support of Senate Bill 2. I support this bill for the following 3 reasons. First, by extending access to affordable childcare and preschool, this bill will ensure that children will receive high-quality mental and behavior services at a crucial developmental stage. The most critical time period in child development learning is from birth to age 5 years old. Children's initial exposure to school during this time period is foundational to physical, intellectual, and social-emotional development. Affordable quality childcare and preschool will not only ensure a strong start for children, but will unburden parents from being forced to choose between work and their child's safety and learning. Second, the COVID-19 pandemic has disrupted children's connection and engagement with their school communities and support systems. This bill will attempt to mend the impact of the pandemic on children's learning and development with increased stability. For example, increasing access to mentoring and after-school programs, an intervention that's been found to improve overall developmental and academic performance. More than 40% of students who attend after-school programs have exhibited improved reading and math grades, as well as more frequent attendance and participation. Finally, the overarching purpose of this bill, addressing the COVID-19 pandemic impact on childhood depression, anxiety, and developmental delays, is connected to the aims of social work. A primary tenet of the National Association of Social Workers is expanding access to comprehensive medical and behavioral health care, specifically supporting legislation that addresses and focuses on children's behavioral health needs brought on by COVID-19. Accordingly, my support for this bill derives from its aim of accomplishing that very purpose, fostering and bolstering children's academic, social, and emotional learning by ensuring access to affordable quality preschool and childcare. I am confident that this legislation will make a substantial impact that will mitigate the urgent mental health needs of children within our community. Thank you for your time.
Thank you, Ms. Lozier. Very impressive testimony and very thoughtful. And thank you for waiting for a long time to share your thoughts with us. We truly appreciate that. And I do not see any questions or comments, but congratulations for your testimony and your help and support to us. Next person on our list is Ken Welch, followed by Julie Hall.
Good evening. I'd like to thank the Joint Committee on Children's and Public Health Committee, the hard work they've done and the fact that they've hung in there all day for this. I'm here in favor of bills SB2 and HB 5001. I'm the president of the Coalition for a Better Wallingford, a grassroots organization started nearly 10 years ago, propelled on the scene by an explosion of young adult deaths due to substance overdose. In the 3 years leading up to 2013, Wallingford incurred over 50 overdose deaths, 45 of which were under age 30. One of these statistics happened to be my stepdaughter, Taylor, at age 20. Taylor was a mixed race in a town where less than 1% were Black. Wallingford was notorious for its connection with KKK over the recent past. This combination of one-sided culture combined with an overall fear of the race burden created an environment where Taylor seemed doomed. Friends were hard to come by. Social, school, and personal times were overwhelming with unknowns and confusion. Flash forward 10 years. Our organization has worked with virtually every age denomination from all adult ages, high school, middle school, elementary, and preschool, usually preempted by an emergency of some kind of concern over a mental health issue that has manifested itself in daily life. Although our primary mission is to focus on substance abuse, and prevention work, more and more we find ourselves dealing with the root cause of these issues, which is anchored in mental health. Ultimately, as young children grow from infants to adults, they emulate those around them and secretly learn how to self-medicate. Unfortunately, most over-medicate, and these lives need multiple levels of support: friends, family, therapists, hospitalization, or worse. The preschool industry is fraught with potholes, not the least of which is funding. The actual needs and shortcomings are manifold: improperly or inadequate training for administrators and teachers, lack of regulatory understanding and oversight, underfunded organizations, classrooms, aging or non-existent support systems for those undertrained individuals who are saddled with the well-being of our future generations. All too often, the primary goal is to get through the day solely with little or no concern for making tomorrow better. Today is just too tough. It is an eye-opening to see the impact of the epidemic era. Isolationism, where everyone is masked, contamination walls have been erected, locks and gatekeepers are prevalent in every corner. Everyone is a pawn of a fearful and unprotected environment. So where do we start? Let's think out of the box. Legislative repairs and solutions are notorious for being a colossal waste of money and little or no oversight.
Excuse me, Mr. Welsh, your time is almost up. If you could please summarize. Thank you.
Yep. Okay, let's rely on the real world panel to create a battery of indices that drive the funding for services and tools that make a difference. The earlier we improve the performance of our children, the more positive we all will be. And the impact on every support system in every society. Exponential growth occurs both positively and negatively, depending on the support afforded the denomination. Parents, remember, there is a window of opportunity with new parents before they establish unbreakable habits. Choose a path now before it's too late. The conditions of our families needs to improve now. Thank you.
Thank you so much for your testimony, and thank you for sharing your experience, and we're sending you our love. Thank you. I see no comments or questions. We'll move on to our next speaker. We will have Julie Hall, followed by Jamie Rodriguez. Ms. Hall.
Good evening. My name is Julie Hall, and I'm the Senior Director at Sarah Inc.'s Children and Family Services Program. We're a nonprofit organization that provides services to more than 1,400 children and adults with differing abilities across 50 towns in Connecticut. I'm asking for your support for the 19 programs that are providing birth to 3 services in the state of Connecticut. We are a frontline staff working in families' homes, and we may be the first to get a glimpse of mental health or behavioral health challenges within a household at a very young age. This could be the mother who physically can't get off the sofa to engage with her child because of maternal depression, or it may be that parent whose PTSD from domestic violence is being triggered as they try to put on braces onto the legs of their squirming child. Our goal is to directly work with families to help parents build stronger relationships with their children and help their children to develop and grow within their family environment, as well as to connect them to other community supports that they desperately need. Birth to 3 programs have seen a rise in referrals that have social emotional concerns, and it represents 33% of all referrals that are received in this fiscal year to date. That's an 8% increase over the past year. And last year, we supported over 9,400 infants and toddlers and their families, with the numbers still climbing, COVID only exacerbating these concerns. The cost to programs for these services has exceeded the rate of reimbursement in this fee-for-service model. And so we have several issues here. One is that we've been flat funded for 5 years and are looking at another 2 ahead of us before anything could change. We've not received any ARPA funding or stabilization funding for programs during COVID, and we haven't received a cost of living adjustment since 2013. We're facing significant workforce shortages. These have left our agencies having difficulty providing the salaries necessary to attract and retain the highly educated staff needed to provide these services. And we're competing with schools, hospitals, and other settings, as you've heard, where the salaries may be higher, maybe not, benefits better. Programs, including mine, are dealing with vacancy rates of between 15 and 20%, where positions are going unfilled for over a year. maybe even 2. And this is leading to children waiting for longer times to get their therapy, evaluations, and services that they need during this critical period in their development. Clinicians who are working in the field are overtaxed, burned out, and leaving. And without additional funding, 40% of the birth to 3 programs surveyed said they're going to be forced to close or reduce their capacity to serve children. So please help us stabilize birth to 3 providers by investing in funding to early intervention programs that allows for sufficient and predictable rate increases that cover the cost of providing these services, and help us to attract new clinicians into the field through funding where clinicians could enter the early intervention workforce and earn loan forgiveness based on their time of their service provided. I encourage you to review my written testimony, including the Heckman equation document that's attached that speaks to the economics of making this investment in Connecticut's child or early intervention providers. Thank you for your time.
Thank you so much for your testimony. This is very helpful. We'll definitely look into this birth to 3. Thank you again. Seeing no other questions or comments, we'll move on to the next person on our list, Jamie Rodriguez, followed by Sarah Lee Master. So Ms. Rodriguez.
Hello, thank you. Good evening, chairs, ranking members, and members of the Public Health Committee and Children's Committee. My name is Jamie Rodriguez. I'm a licensed marriage and family therapist and the chair of Advocacy Committee for Connecticut Association of Marriage and Family Therapy, CTMFT. I'm a resident of Waterbury and I own a private practice, mental health practice in Woolkit. I'm speaking on behalf of CTMFT in support of HB 5001 and SB 2. CTMFT currently represents over 1,500 licensed marriage and family therapists employed in various settings throughout Connecticut. CTMFT is exceedingly supportive of the many components of HB 5001, including its focus on improving residents' access to care and mental health professional workforce development. However, we encourage the committees to be inclusive of all eligible mental health professionals throughout the various sections of the bill. Specifically, CTMFT requests the inclusion of marriage and family therapist in the definition of mental health specialist designated to work in the schools as in Section 18, and as referenced earlier by the Department of Education's Mrs. Russell-Tucker. We ask that you include all mental health professionals skilled and eligible to work in the schools, including marriage and family therapists and school-related surveys, student-provider ratios to be expanded upon, as well as any employment opportunities noted in Section 17 and 19. We ask that you include mental health professionals, marriage and family therapist and the student to school social worker ratios in Section 17 and rename those ratios to student to school mental health professional. Social workers do make up the majority of school mental health positions. However, MFTs are qualified and do work in the school system, including the MFTs in school specific certification. We ask that you include new language requiring the Department of Education to educate local and regional school boards on the inclusion of MFTs in school-based delivery of mental health specialists to students, as in Section 19. We ask that you include MFTs in the efforts to reduce truancy and identify students with mental health and family system needs as the root cause of truancy, as in Sections 20 and 21. Like other master level clinicians, MFTs are trained to assess, diagnose, and treat individuals. MFTs uniquely have extensive training and assessing and treating individuals, couples, families, and systems as problems arise when the clients progress through the life cycle stages. These skills are especially important when treatment from the more typical linear perspective fails to affect change or there's a multi-systemic impact required. At a time when our healthcare system is in such dire need of mental health providers, we believe that the legislation should be broad in its scope of all the professionals trained and qualified to administer the urgent mental health needs of our children and our families in our state. MFTs are an integral part of this agenda. As so many before me have stated, the need for the larger systemic change to address children's mental health with the families and systems that surround them. We thank you for introducing this bill, HB 5001 and SB 2, another bill we enthusiastically support, and we urge you to make the requested revisions to the bill to ensure MFTs are included in the relevant initiatives. Thank you for your time and your attention to these very important matters.
Thank you so much for your testimony, Ms. Rodriguez. Did you have a written testimony as well?
I did. We have submitted written testimony as well, which is much more lengthy.
Perfect. That will come in very handy when we look at the language. I have Representative Exum who has a question or a comment. Please go ahead, Representative Exum.
Thank you so much. And thank you, Ms. Rodriguez, for your comments.
We did mention earlier today that this is not all inclusive and that we will definitely take your recommendations into advisement. It was an oversight not to include MFTs as well as counselors, so that will be addressed. So we just want to let you know that. Thank you so much, and we really appreciate the role that you play. Thank you.
Thank you so much for saying that, Representative. I did hear that earlier in the day, and we appreciate that. We hope this oversight won't continue, and we hope that you can use us, when we come to the table to form these ideas. Although we have this systemic training, we can be really helpful in the systemic planning of these things.
Absolutely. Thank you so much.
Okay. Thank you for your testimony. Seeing no other questions or comments, we'll move on to the next person on our list, which is Sarah Lemaster, followed by Ann Turkington. Ms. Lemaster.
Good evening, Senator and distinguished members of the the Public Health and Children's Committees. I'm here today to testify on behalf of the Community Health Center Association of Connecticut, and I'd like to thank you, first of all, for raising these two bills. Our health centers collectively serve over 380,000 patients every year, and we don't turn people away based on their ability to pay for services. Patients have access to same-day medical, dental, and behavioral health services at all of our health centers. 20% of our patients identify as Black and 48% identify as Hispanic or Latino. A majority of our patients receive Medicaid benefits. These two bills specifically deal with adding behavioral health services or increasing access to behavioral health services. In 2020, our health centers served over 116,000 children, and they also saw a significant increase in the usage of behavioral health services. This increased from 9.1 encounters in 2019 to 11.4 encounters in 2020. I do not have data from 2021 yet. There's a tremendous need to expand the availability of behavioral health services to children, and we welcome the legislature's enthusiasm to address this issue. Our health centers currently operate over 200 school-based health center sites, and many of these sites do offer behavioral health services. The grant program outlined in House Bill 5001 would give the Department of Education resources to establish school-based mental health services. However, this bill does not indicate whether there will be coordination between the sites that already are licensed through the Department of Public Health, or there will be an effort to avoid duplication of the services available. I believe that in order for the legislature's efforts to be successful, we do recommend that the bill include language to establish a coordination between the Department of Public Health, the State Department of Education, and resources that already exist in schools and surrounding communities. Additionally, this bill includes a continuation of telehealth benefits. Telehealth has been a very powerful tool in increasing the accessibility of behavioral health services for health center patients. We strongly support continued coverage of telehealth services, especially audio-only telehealth, which are very important to making sure that everyone can access telehealth services. Additionally, Section 45 of this bill allows behavioral health providers to access loan forgiveness through the Connecticut Higher Education Supplemental Loan Authority. I would like to note that in House Bill 5040, that's before the Human Services Committee, the state loan repayment program is expanded to include behavioral health providers, which the legislature reinstated in the 2021 budget. This program is used by federally qualified health centers and other providers working in federally designated health professional shortage areas, and offers these providers loan repayment grants after completing 2 years of work. Both of these programs will enhance our ability to recruit and retain behavioral health providers. Thank you for the opportunity to speak and for addressing this important issue.
Thank you so much, Ms. Lemaster. I do not see any questions or comments, but truly appreciate your time and your help in the early phases of formulation of this bill as well. So we want to thank you for that. And
thank you very much.
And we'll move on to the next person on our list, which is Ann Turkington as well. After that, it's Rhonda Knowles. So Ms. Turkington.
Thank you. Good evening, Senator Anwar, or as we know you, Dr. Anwar, and distinguished members of the Public Health and Children's Committee. I represent Eastern Connecticut Health Network, which includes Rockville General Hospital and Manchester Memorial Hospital. We have extensive behavioral health services, both inpatient and outpatient. And most recently in December, we added a dual diagnosis unit, a 22-bed unit, which will help children by helping parents and addressing the addiction crisis. We are working with medication-assisted treatment, and we have a memorandum of understanding with the Root Recovery Center in Manchester. We also just opened on February 8th, the 10-bed adolescent unit at Rockville General Hospital in order to try to help alleviate the problem with the acute care beds. And I would say from sitting through the testimony all day today that in our emergency rooms, when we have children that are stuck there, we don't want to keep kids in the emergency room. We want to send them home with their families and their caregivers. But there are times when they're on what's called a PEC, a physician emergency commitment paper, where they're not safe to leave the facility and they need 24-hour supervision with doctors, nurses, clinicians, and that kind of thing. We can't move the kids out of the ED because we can't get them off the acute care units to psychiatric residential treatment facilities. We would support opening up more beds at SolNet. That would be very helpful to inpatient behavioral health units to have that level of care where kids can go for a lengthy amount of time, but have the kind of care they need when they leave. So we definitely would support that. We would also urge the committees to fund existing programs. Once the pandemic hit, due to social distancing, both in telehealth and in-person services are constricted. If we had a room where we could have a group with 10 people in it, now we can have 5. People have to social distance and mask, but it still takes the same amount of labor. So that automatically reduces the services. I would also encourage any kind of enhanced rates for child and adolescent psychiatry. An adult psychiatrist can see a patient, change a medication, talk to them, educate them about side effects, and they're done. A child and adolescent psychiatrist sees the child, talks the child through it, talks the parents through it, calls the pediatrician, calls the school. The amount of case management for children and adolescents takes time, and time is money.
Excuse me, Ms. Tarrington, your time is almost up. If you please summarize.
Thank you for the warning. I could go on and on, but we definitely support this bill. Thank you.
Thank you so much for your testimony. And then thank you for the work that you do. And I think when there were a lot of children who were waiting for beds, you worked to make sure that the beds were available and you were able to create those beds within the hospital. So thank you for your heroic work at that critical time. And thank you for your testimony today. I do not see any comments or questions right now. So we will move on to the next person. Thank you, Ms. Turkington. The next person on our list is Rhonda Knowles, followed by Caitlin Comet. So Rhonda Knowles.
Good evening. Can you hear me?
Very well. We can't see you, but
I
we
can't
can hear
see
you.
I can't get my camera to work though. Like,
So
what did
in
I
the
do?
left lower corner of your computer screen, you will see a camera. Click on that.
Okay, camera. Okay, but
But you can.
Didn't get me. Okay.
No worries. We can hear you, so you can speak.
Okay.
There
There it is. Okay. All right. Good evening, members of the public health.
I can do IT work too now.
Excuse me?
I was saying I
works?
can do IT work too.
I see that.
Remotely.
Very good, and especially this late in the evening. Okay, good evening, members of the Public Health and Children's Committee. Thank you for the opportunity to testify to support SB 2. My name is Rhonda Knowles. I'm a family child care early educator. I am located in West Haven, Connecticut. I have been in this industry for 32 years. I must start off my conversation with a little disappointment. 2 years ago, when this pandemic came to our state, the governor put the state in lockdown. He asked us to keep our doors open and allow essential workers to come into our program. which we did without hesitation. As each month went by, parents became more afraid and concerned about the pandemic. So some chose to keep their children home, or they lost their jobs and no longer needed childcare. We put our health and our lives on the line at the worst part of the pandemic. Some providers used up their savings. They went into debt with loans and credit cards to keep the mortgage or the rent paid, food on the table. Each month went by without knowing when this pandemic would peak and then start to slow down. Providers had to now become creative, picking up second and third shifts to make ends meet. Some also weekends. We are a unique group of providers. We work unconventional hours because of the need is there. Now, instead of working a 9 or 11-hour workday, they were forced to work a 19-hour or longer workday, trying to catch up on income loss, which also juggling their own family responsibilities. I think it's shameful that a high school graduate can go and get a job with medical benefits, incentive programs, and matching savings and a decent salary as we watch family childcare providers struggle to keep up with rising food costs, utilities, maintenance issues for their programs. I hear the words quality childcare, spoken as if just comes because it was spoken. Quality childcare is expensive. It costs, it comes with a price tag. You can achieve it, but you must support and fund the industry to do so. It took a pandemic for this to be brought out of the shadows and into the light. We have a crisis in our industry. We are asking you to please raise your voices and not just give us a Band-Aid, but give us family childcare providers